So good morning, bachcho. Hopefully I'm audible. So now the exam is approaching. First and foremost thing we do at this point of time is your anxiety. Try to control that anxiety as much as you can. Hopefully the audio visuals are clear. Let me know once. So hopefully everything is clear. Let's begin now. So, few important things, as I told you, you have to control your anxiety at any point of time. सबसे बड़ी बात, you have to believe in yourself कि जितना आप तक पढ़ा है, that is more than enough basically to pass the examination. If you keep on having a focus that ये छूट गया, वो छूट गया, you will never be confident enough to face the examination. You have to believe somewhere कि okay जितना पढ़ा है वो काफी है. And that will be able to reproduce much better in the examination. If you're always doubtful about everything, कि यार ये हो गया, वो छूट जाएगा, ये छूट जाएगा, then things are going to be definitely dangerous. Please remember that. Clear? So please be aware of that. I'll ask them to definitely upload the previous session as well. Don't worry about that. Voice from me in this career basically just check from your side. Because for me there's no issue as such. I've checked it from my device. You have to clear that again. So just check it from your one. Sure. So that is important. So we will discuss about the part two basically, or the base session two basically, the 150 questions. And in these 150 questions, definitely we'll be touching a lot of important previous year topics which have been asked in the examination earlier. So that is our aim basically in today's session. It's not only basically that we have to go for just the question. We have to go for the topics basically which have been asked earlier. Clear? So that is what is important to remember. I have seen online and I'm able to hear properly. So it's from your device basically where you're having an issue. I have checked it twice from my device. There are people who can hear it. So just check from your side. I have seen online and I'm able to hear properly. So that is important. Chalo. Let's start now. So question number 151 it states, beta, we are having a 2-year-old child. Okay, we are having a 2-year-old child who presents with complaints of recurrent episodes of UTI, definitive urinary tract infection, which on culture are found to be due to which organism? E. coli or Escherichia coli beta. Which of the following test is done to determine the etiology of the disease? Clear? So that is what is important to remember. Okay? So please remember that here if they ask you that which among the following, what are you suspecting over here? What is the condition that you are going to suspect over here? A small child basically. A small child definitely beta, that is a 2-year-old child who is coming to you with complaints of recurrent UTI beta. Okay, who is coming to you with recurrent UTI definitely. What are you going to suspect? I'm going to suspect a surgical condition. Yes, very good. And it is going to be PUV. What is PUV? Posterior urethral valve. हमें पता है whenever a male child is going to have a valve in the posterior urethra, obviously that is actually going to cause problem in urination beta, and as there will be difficulty in urination, there will be a severe urine retention, and due to that severe urine retention beta, the child is actually having recurrent UTI. So due to the urine retention due to posterior urethral valve, the child is actually having recurrent UTIs beta. That is what is important to remember. Clear? The child is having recurrent UTI. That is important to remember in this. That has to be kept in mind. Clear? Now next important if I talk about basically, so here beta, please tell me what is going to be your next investigation to be done. We have to determine the etiology. We have to find out the cause of the disease beta. To determine the cause of the disease or the etiology of the disease, what do you think should be the likely investigation? Very good. We know when we are suspecting a case of PUV or a posterior urethral valve, I am definitely going to do a next investigation, and that is option B beta. That is MCU called as micturating cystourethrogram. Those things that it is actually going to be a urine culture. Yes, urine culture can be done, but can it determine the etiology or can it determine the cause of the disease? No, it cannot determine what is the main problem. It can only tell me which organism is causing the infection. And बार बार already हम ये देख चुके हैं कि the recurrent UTIs have been due to E. coli. तो इस बार कर भी लोगे यूरिन कल्चर तो उससे तुम्हें बस urinary tract infection के बारे में पता चलेगा. You are just going to treat the UTI over there. Clear है बात? You are not going to treat basically the main problem or the main cause, and that is posterior urethral valve. And we know investigation of choice for posterior urethral valve has to be MCU or a micturating cystourethrogram beta, where we inject a lot of contrast in the bladder. And once the urinary bladder is full, the child starts urinating, and then we will do a multiple X-rays beta, serial X-rays. That investigation is MCU. Important MCU अगर करोगे posterior urethral valve में, you are able to get a very classical appearance beta. And what is that classical appearance? It is classical keyhole appearance beta. That is what is important to remember. ठीक है? It is classical appearance, that is keyhole appearance which will be seen. Hopefully that's clear to all of you. Please remember that. Now important is, please remember ultrasound KUBP. Yes, ultrasound KUBP can also be done. It can also show us the classical keyhole appearance, but again, it is not confirmatory. Ultrasound kidney, ureter, bladder, and prostate will not be confirmatory for this disease. That's the reason I will not do it as the confirmatory investigation. The RGU, that is retrograde urethrogram. It is a urethrogram, but it is definitely not going to give us the diagnosis. Reason is, if there is urethrogram, we will inject contrast, and that contrast will go inside also. Because this valve is a one-way valve beta, which will allow the contrast to enter. And अगर contrast अंदर चला जाएगा, तो पता कैसे चलेगा कि obstruction है भी या नहीं? Clear? So that is what RGU. Therefore, it is not that is not important. Urine culture, yes, it will be one of the next steps that I do, but it is not going to confirm the diagnosis. That's the reason urine culture will not be the answer. And we know whenever I talk about basically the treatment in patients of posterior urethral valve, what is the first line of the emergency treatment? अगर बच्चा तुम्हारे पास सीवियर यूरिन रिटेंशन लेके आया है डेफिनेटली, तो व्हाट इज गोइंग टू बी द इमरजेंसी ट्रीटमेंट ऑफ दिस कंडीशन? तो इमरजेंसी ट्रीटमेंट इज नथिंग एल्स बट इंसर्शन ऑफ फोरीज कैथेटर बेटा. प्लीज रिमेंबर दैट. That bit of, from my device I have checked it twice or thrice definitely. I am checking my phone itself. I'm not able to get any kind of lag. Yes, there is some kind of echo, but not huge definitely that you're not able to manage at all. I'm continuously checking it from my phone. Just check your device basically. So please remember, beta, emergency management which is there, it is nothing else but Foley's catheterization that you have to do. Okay? Once you insert the Foley's catheter, definitely beta, then what is going to happen? Obviously, the urine will be able to drain, and once the urine drains, then definitely the child is going to get a symptomatic relief beta. Now, this is definitely the emergency management. अगर वो पूछेंगे कि what is the definitive management beta? What is going to be the definitive treatment? Definitive management is going to be TURP. That TURP is nothing else but what? Transurethral resection of valve beta. So with the help of a laser beta, nowadays we can just fulgurate, or I can just remove the valve basically from the posterior urethra of the child. That is what is important to be remembered. Clear? So that is what is important beta. Okay? So do remember this. No issues with this? Ciao. Next important I talk about now. Suprapubic tap also you can do. Suprapubic tap you can do, but initially try Foley's because suprapubic tapping or suprapubic catheter is an invasive investigation. If Foley's catheterization is possible, why do you have to go for any invasive method basically? Right? Invasive methods are avoided. That is important. Next is question number 152. It states beta, we are having a 64-year-old female who complains of pain in bilateral knee beta, and the pain which is there, it increases while the female is going up and down the stairs beta. Okay. The X-ray shows there is bilaterally reduced joint space that you are able to see. What is the most probable diagnosis of the case? What is going to be the most probable diagnosis of the case beta? Yes. Yes, so we know definitely here. First of all, see the age of the patient beta. If it is, she is a 64-year-old female, that is elderly patient is there beta. Apart from that, the second thing that we are able to see, and that is nothing else but we know beta, the patient is having involvement of a joint, the patient is having involvement of the large joints, especially the bilateral knee joint beta. And that is what is important. See the X-ray which is there. They have described the X-ray clearly that there is a reduced joint space. So हमें पता है elderly patient coming to you with knee joint involvement and reduced joint space definitely beta. Okay, in the knee. That is a very classical feature of nothing else but osteoarthritis. So this is the classical case of option A, osteoarthritis beta. Yeah, like now osteoarthritis which is there, it is a degenerative disease. Why I call it as degenerative disease? Osteoarthritis is a degenerative disease basically. Please remember, here there is going to be a friction between, here there is going to be friction between the articular cartilages at the joints, and due to that the articular cartilages are damaged. And if the articular cartilages will be damaged beta, obviously what is going to happen? There will be destruction in the joint, and due to that destruction in the joint space also gets reduced beta. That is what is important to be remembered. As I've told you, the keywords to differentiate osteoarthritis from rheumatoid arthritis beta, and that is first one, that osteoarthritis is more common in elderly patients. Second one, it mainly involves the large joints of the body like the knee joints beta. Whereas if I talk about rheumatoid arthritis, we know that rheumatoid arthritis is the erosive arthritis again, and rheumatoid arthritis, if I talk about definitely, it is an autoimmune disease. What do I mean by autoimmune? Yes, so here there is an antibody mediated damage beta. Please remember, here there is an antibody mediated damage. So if there is an antibody mediated damage, definitely beta, due to that the joint destruction is going to happen, and that is the case of rheumatoid arthritis. We know rheumatoid arthritis is more commonly seen in younger patients beta. That is 25, okay, that is going to be a 25 to 55-year-old female, definitely beta. So younger female is going to have this problem, and which joints of the body are going to be involved? It is usually the smaller joints of the body which are involved beta. Commonly the it is going to be the wrist joint, the metacarpophalangeal joint, or the proximal interphalangeal joint. So small joints of the body beta, like usually the wrist joint, the metacarpophalangeal, and the proximal interphalangeal joint. Which joint is never involved in rheumatoid arthritis? The DIP, or the distal interphalangeal joint, is never involved in cases of rheumatoid arthritis beta. That is important to remember. Important is if they ask you ankylosing spondylitis. We know beta ankylosing spondylitis की अगर मैं बात करूँ, so in this condition, what is going to happen? The patient is actually going to be a young adult male beta, and that patient will come to us with complaints of pain in the lower back beta. Yes, so please remember the patient is going to be a young adult male beta, and that young male will come to us with a complaint of nothing else but low back ache. So there is young adult male along with complaints of low back ache. That is going to be an important feature that you have to keep in mind beta. No issues with this. Next important, if I talk about it, is hemophilia arthropathy. अगर hemophilia का question होता definitely, then what would have been the case? If it would have been a hemophilia case, then obviously they would have given a child beta. Okay, a child definitely who is coming to you with bilateral knee swelling beta. So hemophilic arthropathy, if it would have been there, they would have said there is a child who comes to you with a bilateral knee swelling. Why? Because in patients of hemophilia beta, okay, because in patients of hemophilia definitely, please remember what is going to happen with it. The patient is actually going to have a lot of bleeding inside the knee joint, and when there is bleeding inside the joints beta, that is called as hemarthrosis, and due to that hemarthrosis beta, the joints will get damaged, and that is what is known as hemophilia arthropathy. That is important. Hopefully cleared all of you, all the four options. So that is going to be the presentation that you have to keep in mind. So elderly patient, bilateral knee involvement, reduced joint space is very classical presentation of osteoarthritis itself. Here you are able to see, this is the picture of rheumatoid arthritis. Rheumatoid arthritis, as I've told you, it is going to be mainly the smaller joints beta that are going to be involved over here. So this is the erosive arthritis which is seen. Here there is the erosive arthritis which is going to be seen. No issues with this. So that is what is important to remember. Please remember. No issues with this? Sure. Done with this. Next is question number 153. But if I talk about 153, here we have a lady who presents to us with complaints of sudden painful loss of vision beta, which worsens on ocular movements beta. They are saying that the pain is worsening on ocular movements. As you move the eye, the pain is going to worsen further. Relative afferent pupillary defect is observed beta. That is called as RAPD. The relative afferent pupillary defect is observed on performing the flashlight test. So, what is RAPD? Anybody? A relative afferent pupillary defect. What is that RAPD? Also called as which pupil? Also called as the Marcus gun pupil. And when I talk about Marcus gun pupil, definitely beta or RAPD, क्या होता है इस condition में? Whenever you perform a flashlight test, whenever you flash a torchlight in the patient's eye beta, normally what should happen? Whenever I flash a torchlight in the patient's eye, the pupil should constrict. But in a patient who is having a relative afferent pupillary defect, this happens due to the partial damage to optic nerve beta. So क्या होता है? Whenever I flash a torchlight in the patient's eye, the pupils are not going to constrict. Rather, the pupils are going to dilate, and that is what is called as the RAPD beta. Okay, so please remember, on flashing the light beta in the patient's eye, the pupils which are there, those are going to dilate, and that is what is called as relative afferent pupillary defect or RAPD beta, also called as the Marcus gun pupil. Clear about? And as I've told you, it happens whenever there is a partial optic nerve damage. Okay, so we know that it happens whenever there is a partial optic nerve damage. Complete optic nerve damage होता तो क्या होता है? DAPD. Whenever there is a complete optic nerve damage beta, patient is going to have something called as the TAPD, that is total afferent pupillary defect beta. Clear? So then there is a TAPD which is seen. RAPD is a feature of partial optic nerve defect or partial optic nerve damage, also called as Marcus damage. So along with that, they're saying perimetry. Perimetry is the investigation used to check what? The visual field. Okay, so perimetry tells you about the visual field of the patient. And when we did a perimetry beta, it reveals there is a central scotoma. What is scotoma, anybody? Blind spot. So scotoma on perimetry is nothing else but blind spot beta. That is the site where there is going to be a loss of vision beta. Please remember this. That is what is important to be remembered. Yeah, right now, whenever there is damage to the central part of the retina beta, whenever there is damage to the central part of the retina or the macula, the patient is actually going to have central vision loss, and that central vision loss is called a central scotoma. Okay, so central scotoma is nothing else but central loss of vision beta. It is the central loss of vision that is going to happen. Hopefully clear to all of you now. Now they are asking you what is the most likely diagnosis in this case. Bolo. Very good. So we know beta. First important thing that they have said that there is a painful loss of vision. I have always told you about that table. Gradual painless loss of vision, sudden painless loss of vision, and sudden painful loss of vision. These table के causes you have to remember beta. Please remember that. ठीक है, we know that sudden painful loss of vision which is there beta, it usually happens whenever there is some kind of infection or inflammation, and if there is inflammation of the optic nerve beta, that is actually going to cause a sudden painful loss of vision. So the answer is more likely to be a case of option A, optic neuritis.
कोई प्रॉब्लम नहीं है, मुझे समझ नहीं आ रहा, वो थोड़ा ही जब भी मैं वर्क कर रही हूँ अभी कुछ अभी एक सेशन को चलना है इस पर महेश जी को बात करें जब भी बेहतर भेजो मन के लिए एटलीस्ट सेशन चल रहा है जो एक सेशन में दो काम चलते हैं जो भी मैं आपको भेजो ठीक है जब भी पहन आ रहे हैं उनको बस नीचे ये जो मिरर के नीचे जो ये चलता है ना उसके अंदर ये रखा मेरा माइक रखा पड़ा तो जो मिरर के नीचे एक वाइट बॉक्स है ढूंढ लेना बस तो फोन में वाइट बॉक्स होगा उसमें माइक पे बॉक्स पे मेरे घर पे जाओ शुभ में शर्मा हाँ शर्मा
So we'll get it corrected, don't worry about that. But till that time, let's continue. As I've told you, beta, the patient is having a painful loss of vision, and whenever the patient is having painful loss of vision, beta, obviously two conditions can be easily ruled out from the option, and that is one is CRVO, because CRVO will have a sudden loss of vision, but that is going to be painless, beta. So please remember CRVO, central retinal central retinal venous occlusion में बेटा the patient is going to have painless loss of vision. That has to be kept in mind. So, second important definitely if I talk about retinoblastoma.
और ज़्यादा से अगर आप बोलो वो
क्या बताओ
Next important, if I talk about definitely is retinoblastoma. We know retinoblastoma is a condition beta where again the patient is going to have a gradual painless loss of vision beta. Gradual मतलब धीरे धीरे develop होगा because retinoblastoma is a tumor or a malignancy. So here the patient is going to have a gradual loss of vision, and again that is also going to be painless because obviously retinoblastoma doesn't cause any kind of pain beta. That is important to be remembered. Clear? Next important, if I talk about papilledema. First thing, that papilledema which is there beta, yes, here there is going to be blurring of vision. Loss of vision is not a feature beta. Papilledema mein blurring of vision is only seen. First thing. Second important thing that you have to remember, that in papilledema mein there is not a painful blurring of vision. There is actually going to be a painless blurring of vision beta. Along with that there will be headache. Why? Because papilledema basically happens due to raised ICP. So whenever the patient is going to have a raised intracranial pressure beta, that condition is actually going to cause papilledema. इसीलिए papilledema will present to you with complaints like headache, along with vomiting, along with other features beta like seizures as well. But please remember the loss of vision is going to be, or blurring of vision is going to be painless, not painful. Clear? So these are the three conditions that you can easily rule out by just one word or one sentence in the question itself beta. Yes, the other sentences which are there, that is relative afferent pupillary defect and central scotoma, they obviously confirm your diagnosis further. It is a case of optic neuritis. Now please tell me beta, if they say yes the patient is having optic neuritis beta and they will give you this kind of a picture, so what is your likely diagnosis then? Very good. So यहाँ पे in the MRI beta, what I am able to see in the gadolinium enhanced MRI, we are able to see this gliosis, and this gliosis is called as which fingers? Very good. These are actually called as the Dawson fingers or the Dawson fingers, what we call it as. So we know that my optic neuritis in a patient, okay, optic neuritis in a patient along with Dawson fingers basically on the MRI beta is a classical diagnosis of nothing else but multiple sclerosis. We know multiple sclerosis means there is demyelination beta, and due to demyelination definitely the neurons which are there, those are damaged beta. Due to demyelination beta, obviously the neurons are going to be damaged. As the optic nerve gets demyelinated, we know now only two cranial nerves are myelinated, first and second, olfactory and the optic nerve. As the optic nerve will get demyelinated beta, it will undergo inflammation causing an optic neuritis. That is the reason for the sudden painful loss of vision or RAPD in this patient. Second important, multiple sclerosis is also characterized by two more symptoms. And what are those? If the motor neurons are damaged, definitely the patient is going to have the motor symptoms, and those motor symptoms are nothing else but something like muscle weakness or paralysis beta. So motor symptoms like muscle weakness or paralysis are going to be seen. Apart from that, definitely beta, patient is going to have damage to the sensory neurons, and if the sensory neurons are damaged, patient is going to have sensory symptoms, and sensory symptoms are something like paresthesia, that is decreased sensation. So any patient who comes to you with motor symptoms along with sensory symptoms along with features of optic neuritis has to be a case of nothing else but multiple sclerosis beta. And we know that definitely multiple sclerosis may, if they ask you what is the pupillary defect, so hopefully I am clear that it is a case of RAPD, also called as Marcus gun pupil beta. No issues to anybody? Clear? Chalo. Next important, this is the classical picture. क्या है ये? This was again a PYQ. Very good. Here you are able to see a white abnormal pupillary reflex beta. This white pupillary reflex which is there is basically called as leukocoria. Leuko means white, coria means pupil beta. And PYQ was, this picture was given and they asked you what is the most common cause beta. So leukocoria का most common cause, I hope all of you are quite aware, it is nothing else but RB. What is RB? Retinoblastoma beta. So we know the most common or the leading cause of leukocoria is going to be retinoblastoma. Important to be remembered beta, retinoblastoma is a benign tumor or a malignancy. We know that retinoblastoma, though it is an oma beta, it is going to be a malignancy. That is what is important. It is actually the most common intraocular malignancy that you have to remember beta. It is the most common intraocular malignancy in adults or children? In children. It is the most common intraocular malignancy in children. That has to be kept in mind. One point to be remembered. Second point that you have to remember beta, and that is basically, that is nothing else but, if I talk about retinoblastoma, majority cases are sporadic or familial. Majority cases of retinoblastoma sporadic or familial. Majority cases are going to be sporadic beta, that is in any person anywhere in the world at any point of time. That is called as sporadic. Okay, familial cases are definitely lesser, And familial cases which are there, beta, those familial cases are commonly due to which gene mutation? Anybody? So we know, beta, that the familial cases are mainly due to the RB gene mutation. So whenever there is a RB gene mutation or a retinoblastoma gene mutation, patient more commonly has a familial retinoblastoma. Another condition that I would like to ask you, and that is, ये जो RB gene mutation होता है बेटा, due to this RB gene mutation, the most common cancer that is associated, or the most common malignancy that is associated, all of us are quite aware it is retinoblastoma. But second most common malignancy अगर पूछा जाए RB gene mutation के साथ after retinoblastoma, second most common malignancy, if they tend to ask you, beta, what is going to be the likely answer for that? Very good. Then definitely the second most common malignancy that is associated with RB gene mutation is actually going to be a bone cancer or a bone malignancy, beta, called as osteosarcoma. That is actually going to be a osteosarcoma, beta. That is what is important to be remembered. Hopefully clear to all of you now. Chalo. Next important, if I am able to see, beta, this is the classical picture. And क्या दिख रहा है इस picture में? All the malignant cells which are there, beta, those malignant cells are surrounded basically in a rose petal like manner. And this is classically called as which rosettes? Very good. So histopathological examination, beta, in patients of retinoblastoma is actually going to show me a very classical rosettes called as the flexner intestinal rosettes, beta. So flexner intestinal rosettes which are there, those are classically seen in a patient who is having a retinoblastoma. So flexner intestinal rosettes. Hopefully clear to all of you now. Chalo. So these are the important things that you need to remember. Take the flexner intestinal rosettes are going to be classically seen. Done with this? So these are the important things to be remembered. For retinoblastoma, what is going to be the treatment? Anybody? So treatment of retinoblastoma, yes, it can be enucleation, or another is a chemotherapy regime. That chemotherapy regime is called as CEV regime, beta. That is cisplatin, etoposide, and vincristine, beta. So CEV regime can also be done. Clear? Next important, if I talk about, is question number 154, dermatology, beta. Here you are able to see a case now where we are having actually a 13-year-old boy, beta, and this 13-year-old boy comes to us with a complaint of patchy depigmented skin in the right flank. So the child is having a patchy depigmented or whitish region, beta, in the right flank and in the upper thigh, beta, in a segmental distribution. That is, only a particular segment is definitely a like a particular segment is actually going to show this depigmented or hypopigmented lesion, beta. They are asking you that the depigmentation started 1 year ago but has been starting for the last 4 months. Mother reports use of topical steroids also, which was ineffective. That means the patient's condition did not definitely get treated, beta. What is the likely diagnosis? Answer would be very good. This has been a common question in your examination. So we know whenever they say patchy depigmented skin, that means they are talking about depigmentary disorders. When I talk about depigmentary disorders, beta, the common ones can be, first is going to be vitiligo, another is going to be albinism, third is going to be pyroidism. At least these are the things that should come to your mind immediately, beta. And here if I talk about, here I am able to see that there is a depigmentation or a hypopigmentation in a specific dermatome of the skin or in a specific segment of skin only. So it has to be a case of segmental vitiligo, beta. That is important. This has to be a case of segmental vitiligo. Important is if they would have said that there is a vitiligo or a hypopigmented or a depigmented lesion, beta, in both the limbs or in both the upper, like in both the lower limbs or in both the upper limbs, beta, or on both sides of the trunk, then it would have been a case of, अगर bilaterally symmetrical होता vitiligo, then it would have been a case of, if it would have been a bilaterally symmetrical vitiligo. Then it was a case of vitiligo vulgaris, beta. Please remember, vitiligo vulgaris will be what? The most common type of vitiligo, because vulgaris itself means most common, beta. So vitiligo vulgaris का मतलब होता है nothing else but most common type of vitiligo, beta, and that is going to be actually bilaterally symmetrical vitiligo. That is what is important to be remembered. Clear? If the vitiligo would have been involving only the hands, the feet, and the face of the patient, only the face, hands, and feet, beta, then it would have been called as acrofacial vitiligo, beta. Acro means corners of the body, so only the face, hands, and feet agar involved hote, then we would have called it as acrofacial vitiligo. At least remember the important ones. Clear? Vitiligo happens due to decreased melanin synthesis or absence of melanocytes. What is the reason behind vitiligo? So please remember, beta, this vitiligo which is there, it happens definitely due to absence of melanocytes. What are melanocytes? We know melanocytes are going to be the melanin producing cells, beta. Melanin is the skin pigment which gives color to the skin. So if these melanocytes, the pigment producing cells are absent, obviously the patient is actually going to have depigmentation or hypopigmentation over that side, beta. That is what is the reason. Important is absence of melanocytes is seen in one more condition, beta. And that condition where there is an absence of melanocytes, that condition is going to be this one. What is this? This is a classical picture of pyroidism. And when I talk about pyroidism, beta, यहाँ पे भी there is an absence of melanocytes itself, which is going to be seen. But in patients of pyroidism, whenever there is absence of melanocytes, it is not seen throughout the body at all, beta. Okay, here it is not seen throughout the body, which it is usually seen on the specific sides of the body. Like you are able to see, beta, it is seen on specific side of the forehead, beta. Apart from that, it is also seen in the forelock of hair. So this whitish hair which are there now, this whitish area of the hair basically is called as the white forelock of hair, beta. This is classically known as the white forelock of hair. So I am able to see, beta, a depigmented lesion on the skin. Along with the depigmented lesion on the skin, beta, we are able to get the classical white forelock of hair. That is what is classical over here. Okay? That is the case of nothing else but pyroidism, beta. Hopefully clear to all of you now. Sure. So that is important to remember. If they would have asked pyroidism, as I've told you, pyroidism which is there, it is usually seen over only a specific area of the skin, and it is also associated with the white forelock of hair, beta. That is one thing. Second important, if I talk about hypomelanosis of Ito, beta, usually the nevus of Ito which is there, basically it is not a hypomelanotic spot, it is a hypermelanotic spot, beta. Matlab it is not a depigmented or hypopigmented lesion, it is a hyperpigmented or a dark lesion which is seen. ठीक है, कहाँ होता है? Anybody? Where is the nevus of Ito seen? So nevus of Ito जो होता है basically, beta, please remember, I am just writing nevuses. So याद रखना, nevus of Ito का location is going to be the yes, so on the shoulder, beta, basically, or the back here. So please remember, on the shoulder or on the upper back, which is that is the site of nevus of Ito. Next, nevus of Ota का होता है? Nevus of Ota is basically seen on the face, beta, in the trigeminal nerve distribution, basically, beta. ठीक है? So definitely on the face we are able to see the nevus of Ota. That is what is important to remember. Whereas if they say, beta, yes, there is a nevus or a dark lesion, beta, along with that dark lesion we are also having hair, then it is a case of Becker's nevus, beta. Very good. So we know that Becker's nevus is also a dark lesion basically, or a hyperpigmented nevus, beta. But important difference is, in cases of Becker's nevus, beta, you are also going to have hyperpigmented lesion on the shoulder or the back, beta. Here also I am having the hyperpigmented nevus on shoulder and back. But there is not only a dark lesion, beta, but along with that dark lesion we are having hypertrichosis or a lot of hair, beta. That is what is important to be remembered. Hopefully that's clear to all of you now. So do remember this. At least remember these three important nevuses, beta. That is nothing else. Nevuses are hyperpigmented or hypopigmented lesion. These are all the ones that we have discussed. These are the hyperpigmented lesions, beta. There are also hypopigmented nevuses, and those hypopigmented nevuses will be, one is nevus anemicus and second is nevus hypochromicus, beta. So nevus anemicus, nevus hypochromicus, उनके तो नाम नहीं समझ में आ रहा है ना. So definitely these type of nevuses are hypopigmented or whitish lesions, beta. That is what is important to be remembered. No issues with this? Sure. So these are the important points that you have to keep in mind, beta. Done with this? So these are the important nevuses that you have to keep in mind. Next important is question number 155, beta. If they ask you about question 155 here, we are having a drug addicted patient, beta, and this drug addicted patient present to us with complaints of agitation and ulceration on skin, beta. Patient comes to us with agitation and ulceration on skin. The patient is having severe itching, beta, and scratch marks on the body. This is a keyword of the question. Patient is having severe itching and scratch marks on the body. On examination, there is presence of tachycardia, there is mydriasis, that is dilated pupils, and there is hypertension, beta. So sympathetic or parasympathetic activity, we know, na? that if there is tachycardia, hypertension, mydriasis, it has to be a sympathetic activity beta. So sympathetic activity is there. Likely substance basically they're asking you which is responsible for all these symptoms. Has to be nothing else but cocaine. One is sympathetic activity beta, which is the reason for cocaine. Another reason is going to be yes. So this itching and scratch marks are suggestive of what? Very good. So we know beta that these scratch marks which are there on the patient's body beta, they are very classical of nothing else but tactile hallucinations beta. And tactile hallucinations happens in cases of cocaine intoxication. And in this tactile hallucination, the patient is going to have a feeling as if bugs are crawling under the skin beta or insects are crawling under the skin. And as the patient gets this feeling that the insects are crawling under the skin, patient is going to have a lot of itching and patient will continuously keep on scratching beta. That is the reason why these are multiple scratch marks which are going to be seen. Hopefully clear. These tactile hallucinations seen in patients of cocaine intoxication beta, yes, will be called as which phenomena? So one is called as cocaine bus. Apart from that, very good. It is known as Magnum symptom or formification beta. Please remember that they can use as alternative terms. That is what is the problem. So please remember formification. Okay, Magnum symptoms, cocaine bus. These are all the tactile hallucinations beta, which are usually seen in a patient who is intoxicated with which substance? Cocaine, which is that is what is important to be remembered. And yaad rakhna, cocaine mein there is a sympathetic overactivity. Reason is why there is a sympathetic overactivity in cocaine intoxication. I hope all of you are quite aware. Cocaine is a potent vasoconstrictor beta. As cocaine is a potent vasoconstrictor, which is that's the reason why cocaine intoxication is going to cause sympathetic overactivity beta. Okay, that is important to be remembered. So यहाँ पे अगर वो पूछेंगे answer has to be option A, that is cocaine beta. Now important is if I talk about cannabis, in cannabis intoxication, sympathetic overactivity or for that matter beta, the itching and the scratch marks are not usually seen. That is what is important to be remembered.
ओबीएस को आपको चेंज करना पड़ेगा. इस पे एक बार चेंज कर लीजिए. Audio capture.
Hopefully now all those online, please let me know definitely if the audio is clear. I have connected a mic though. Let me know. Hopefully now the audio is fine. Hopefully now all those online, please let me know definitely. Sure. So now please remember beta, cannabis mein neither there is sympathetic overactivity beta, nor the patient is actually going to have any kind of cocaine bugs or tactile hallucinations, which that is important. Okay, cannabis mein one important feature is going to be there beta, and the patient is actually going to have nothing else but what? Cannabis intoxication mein. So please remember definitely beta, in patients of cannabis intoxication, the patient is going to have a run amok beta. Run amok matlab person has stabbing spree beta after getting intoxicated. Patient wants to kill someone. Okay, so that is what is important to be remembered beta. Whereas second is LSD beta. LSD mein the patient is going to have a major symptom, and that is going to be flashbacks. LSD is nothing else but lysergic acid diethylamide beta, and here the patient may have flashbacks definitely. That is important to be remembered. Heroin is nothing else but, heroin is which type of substance? Heroin is nothing else but a type of opioid beta. Now let's talk about now opioid बच्चे. ठीक है, तो heroin is nothing else but a type of opioid beta. Now opioid जब opioid toxicity होगी, तो please tell me in opioid intoxication or opioid toxicity, what are going to be the features in the patient beta? The first one, the patient is actually going to come us in which state, beta? The patient will come to us in a comatose state because opioids are known to cause sedation, beta. That is one point to be remembered. Second important, if I talk about beta, in patients of opioid intoxication, the patient will have decreased GI motility, and due to decreased GI motility, patient is actually going to have definitely constipation, beta. The patient is actually going to have constipation, beta. That is what is important to be remembered. Apart from that, third important feature, in patients of opioid toxicity, beta, patient is going to have euphoria. And what is euphoria? Excessive happiness without a reason, beta. कोई मतलब नहीं है तो भी patient हंसे जा रहा है पागल जैसा, ठीक है? So definitely the person is very happy, beta. That is euphoria is going to be there, ठीक है? Apart from that, most important feature, and the patient is actually going to have respiratory depression. And when I talk about respiratory depression, beta, here the patient's respiratory rate is actually going to decrease, beta. The patient's respiratory distress is actually going to decrease. That is what is important to be remembered. And the last and the most important point, that the patient will have severe meiosis, beta. And that severe meiosis is actually called as which pupils? Pinpoint pupils, beta. The patient is going to have severe meiosis, that is nothing else but the pinpoint pupils which are going to be seen. Clear? So coma, constipation, euphoria, respiratory depression, pinpoint pupils. If these features are there, I would think about opioid toxicity, beta. This has been a repeated question of FMG examination. And if the patient is intoxicated with opioid, what is the treatment? Bolo. The drug of choice definitely, or the antidote of choice for opioid toxicity is an opioid antagonist, and that opioid antagonist is IV naloxone, beta. ठीक है, तो IV naloxone is an opioid antagonist that is considered as the antidote of choice or the treatment of choice in patients of opioid intoxication, beta, that you have to keep in mind. Apart from that, if they ask you for maintenance, what is the drug of choice? Yes, so initially you will give IV naloxone, beta, and then you will do a maintenance with the help of an oral drug, and that oral drug is nothing else but called as naltrexone, beta. Okay, that maintenance will be done with the help of an oral drug called as naltrexone. Hopefully clear to all of you. That was about opioid toxicity. Do remember about opioid toxicity properly. Clear about? So that is what is important. These are the few points that you have to remember. First is definitely cannabis, beta. We know cannabis is nothing else but your ganja, beta. Okay? So cannabis is nothing else but rope, joint, weed, marijuana, grass. These are all the names of cannabis itself. That is what is important to be remembered. Okay? We know that cannabis can be available in various forms, beta. One is definitely ganja. What is ganja? It is the dried leaves, beta. So the dried leaves of that plant is basically called as ganja, definitely. Please remember that. Apart from that, we are also going to have bhang. What is bhang basically? Bhang is going to be the fresh leaves of the plant basically. That is going to be bhang, beta. That is what is important. We also have something called as hashish, and we have charas, beta. So hashish and charas is also going to be there. These are the various forms or various types of cannabis that we have. We know that, please remember, beta, cannabis is going to be the most commonly abused substance. But which kind of substance? Legal or illegal? Illegal. So it is the most common type of illicit or the most common type of illegal substance that is abused. The most common type of illicit or the most common type of illegal substance that is abused, beta, is going to be cannabis. Which is the most common substance abused overall? So the most common type of substance abused overall will be, very good, caffeine. The most common type of substance that is abused overall, beta, has to be caffeine, that is tea or coffee. If that's not an option, then definitely it is going to be alcohol, beta. Okay, then that is going to be alcohol. Which is the most common substance abused in India? So the most common type of substance that is abused in India, beta, it is nothing else but tobacco. That has to be remembered. Okay? Active principle of cannabis is nothing else but THC, beta, and THC is nothing else but tetrahydrocannabinol, beta. So THC is nothing else but tetrahydrocannabinol, which is the active principle of cannabis, beta. Please remember that. Apart from that, the patient is actually going to have which kind of smell in cases of cannabis intoxication? Burnt rope smell. This is important from definitely forensic medicine, beta. Yaad rakhna. Forensic medicine, so this is important to be remembered. The person is actually going to have a burnt rope like smell. That is what is important. If the patient has died due to cannabis toxicity, beta, that is important. ठीक है, तो चलो बाकी भी बता दो एक दो. Burnt rope like smell, we know it is due to cannabis. It is due to death due to cannabis, beta. Another, if I ask you, smell of bitter almond. So we know, beta, smell of an bitter almond or a bitter almond oil like smell, basically, beta, it is nothing else but cyanide poisoning or cyanide toxicity में होता है. ठीक है. Apart from that, garlicky odor. So if they ask you about garlic odor, beta, garlic odor is seen in phosphorus toxicity. One is phosphorus toxicity, which can cause garlic odor. Second is going to be arsenic. Arsenic is also one of the reasons, beta, which will cause a garlic odor. Apart from that, it is anybody, huh? It is zinc phosphide mein there can be a garlic odor, beta. Clear? So these are the conditions definitely jahan pe you are able to get a garlic odor. Apart from that, garlic odor can be seen in multiple other conditions as well, but at least remember these important ones. Clear about? So that is what is important to be remembered, beta. No issues with this? Chalo. Next important, as I've told you, in patients of cannabis intoxication, patient is going to have an amotivational syndrome. Amotivational matlab patient has no desire to do anything, beta. Patient will keep on lying on his bed basically for weeks together, not taking bath, not taking care of himself, not going outside, not attending classes, nothing. कोई फर्क नहीं पड़ता उसको, ठीक है? So a lot of people in Gautam Nagar you will find, ठीक है? So that is amotivational syndrome, beta. Next important if I talk about is nothing else but run amok or stabbing spree, which है. So run amok or stabbing spree, as I've told you, person has an irresistible desire to kill somebody, beta. ठीक है, किसी को मारने का मन करता है पेशेंट को. दैट इज व्हाट इज इंपॉर्टेंट. इन कैनबिस इंटॉक्सिकेशन ऑल्सो द पर्सन विल हैव अ फ्लैशबैक फेनोमेना. व्हाट इज फ्लैशबैक? Now the person is not intoxicated. Now the person has not taken cannabis, but still he is able to experience beta that condition when he has taken cannabis. मतलब जब उसने cannabis लिया था last time बेटा, उस टाइम पे जो हुआ था वो पेशेंट को अभी महसूस हो रहा है या फील हो रहा है अपने आसपास. That is what is called as a flashback phenomena beta. That is important. And as I've told you, the various types of preparations from cannabis or definitely your weed beta, it is going to be bhang, ganja, charas, hashish, majoon, sinsemilla. Okay, so definitely these are the various preparations of cannabis. Next is cocaine, as I've told you. Cocaine we have discussed, beta, it is this white powder known as cocaine. Fatal dose is going to be 1 gram oral, beta. Important is, we know it is usually intoxicated by which route, anybody? It is intoxicated by a nasal route. And what is that method of substance abuse called as? Sniffing or snorting. So when you roll a dollar, beta, and then you make a line and then you inhale it, that is classically called as snorting, beta. So yaad rakhna, the method of substance abuse in cocaine is nothing else but called as snorting. That has to be kept in mind. We know in patients of cocaine intoxication, beta, as it is a vasoconstrictor, therefore the blood vessels in the nasal septum will be constricted, beta, causing decreased blood supply to the nasal septum, leading to ulceration and ultimately perforation of the nasal septum. हमें पता है that cocaine intoxication or cocaine snorting for a longer duration of time is known to cause ulceration of the nasal septum, beta, or ultimately perforation. Important is there is going to be a classical feature called as cocaine bugs that we have discussed, called as formification or Magnum symptom, and this is nothing else but the tactile hallucinations which are seen in cocaine, beta. And definitely, as I've told you already, that cocaine is going to be a sympathomimetic and a vasoconstrictor drug, beta. That is what is important to be remembered. Okay? So yaad rakhna, this is the snapshot from the FMG snaps. Definitely, please remember this has got replicated a number of times now. Okay, so that is important. मेरे से टाइपिंग में कुछ गलतियाँ हुई है, वो सेम गलतियों के साथ ये छपा हुआ है हर जगह जहाँ जहाँ छपा है. तो प्लीज रिमेंबर, शायद मेरे हिसाब से वन प्रॉब्लम इज डेफिनेटली HSV का जो कॉर्नेलोमा एक्यूमिनेटा का, इंस्टेड ऑफ राइटिंग HPV इट हैज बीन रिटन एज HSV. तो वो क्लियर करेक्ट कर लेना डेफिनेटली, क्योंकि जब वो कॉपी हुआ है, जब रेप्लिकेट हुआ है, वो गलतियाँ सुधारी नहीं गई है. तो बी अवेयर ऑफ दैट. क्लियर? Next important, if I talk about question number 156, here we have a case, beta, where a patient undergoing surgery was given halothane, beta, for the purpose of general anesthesia, and now the patient has developed rigidity and hyperthermia, beta. Okay? These symptoms are more likely due to which iron they are asking you. What is the likely diagnosis? पहले ये बताओ मुझे. Very good. So here definitely, beta, we know that the patient has taken an anesthetic drug, and that anesthetic drug is known as halothane, beta. Okay? It is an inhalational anesthetic agent, and we know after taking that drug, patient is having these features of rigidity and hyperthermia. Very good. It is a pharmacogenetic disease, and that pharmacogenetic disease is called as malignant hyperthermia. Okay, malignant hyperthermia mein the patient will have a classical triad, beta. And that is usually seen after taking which kind of anesthetic agents, beta? One is definitely after taking halothane, beta, and second is a muscle relaxant known as succinylcholine. Anybody? Succinylcholine is the depolarizing or the non-depolarizing muscle relaxant? It is the only depolarizing muscle relaxant. Beta yaad rakhna, the only depolarizing muscle relaxant that we have is succinylcholine. All others which are there, curiums and curoniums, those are non-depolarizing muscle relaxants. Clear है बात? इसीलिए. So please remember, halothine or succinylcholine के बाद the patient is going to develop a classical triad of symptoms, and that is, first the patient will have hyperthermia beta, ठीक है, more heat production of fever. Second, the patient is going to have muscle rigidity, and as there is so severe muscle rigidity beta that even the muscles are going to be damaged beta, and if these muscles will be damaged, an enzyme from the muscles is released beta, and that enzyme is actually called as CPK. What is CPK? Creatinine phosphokinase beta. So definitely the CPK levels or the creatinine phosphokinase levels are going to be elevated beta. That is what is important. This is the classical triad in a patient suffering from malignant hyperthermia beta. Hopefully clear. अब हमें पता है why this happens, because in malignant hyperthermia beta, which receptors are actually the problem? The rhinodine receptors beta. बराबर. So please remember, it is basically the rhinodine receptors which are the problem. A lot of people have sent me a question recently जहाँ पे succinylcholine receptor was given in one of the options. Please remember beta, it is not a problem with the succinylcholine receptor, it is a problem with rhinodine receptors. कहाँ होते हैं rhinodine receptors? These rhinodine receptors are basically present on the sarcoplasmic reticulum. Sarcoplasmic reticulum is nothing else but the endoplasmic reticulum inside a smooth muscle cell beta. Now, whenever these rhinodine receptors are going to be damaged beta, what is going to happen? The calcium will get released, but that calcium is not taken back beta into the muscle, into the sarcoplasmic reticulum. If the calcium doesn't go back into the sarcoplasmic reticulum, that calcium stays inside the muscle cell, and if the calcium stays in the cytoplasm of the muscle cell, the muscle will stay contracted beta, and that's the reason why there is muscle rigidity beta. So here it is actually a defect beta. Here it is actually a defect with the which receptor? Rhinodine receptor beta. तो rhinodine receptor का defect होता है in patients of malignant hyperthermia. Don't make a mistake, don't mark any other receptor. Answer is rhinodine. And therefore, what is the drug of choice? We know beta, the drug of choice for this malignant hyperthermia is nothing else but dantrolene beta. Either we call it as dantrolene or dantrolene sodium. That is the drug of choice. Now हमें पता है if the rhinodine receptors are defective, which ion will not go back into the sarcoplasmic reticulum? Calcium. Okay, so here the problem is mainly due to calcium. That calcium stays inside the cytoplasm and it leads to muscle contraction causing muscle rigidity beta. Clear about? So answer has to be option C. Another condition, अगर मैं बोलता हूँ, if I say I have given you a history of some typical antipsychotic beta. Typical antipsychotic means I have said that the patient has taken any kind of haloperidol like drug. So haloperidol, okay, or flufenazine, or definitely beta thioridazine, these kind of drugs my patient has taken, and after taking typical antipsychotic, same features are there beta. Same features, that is hyperthermia or fever, muscle rigidity beta, and the third feature is going to be the elevated CPK or the creatinine phosphokinase levels. What will be the likely diagnosis then? Then the side effect is basically called as neuroleptic malignant syndrome beta. Then this is basically called as nothing else but neuroleptic malignant syndrome beta. That is what is important to be remembered. Hopefully clear to all of you now. So yaad rakhna, don't mark malignant hyperthermia over there. Okay, the name of this will be different. It is going to be a case of neuroleptic malignant syndrome beta. That has to be kept in mind. Here also the drug of choice is same. That is nothing else but dantrolene beta. So here also the receptors are same. Here also the calcium is same. Here also the drug of choice is same. That is nothing else but dantrolene sodium. Two important questions basically I would like to add up over here, and that is one thing. If they ask you beta, whenever I talk about the non-depolarizing muscle, whenever I talk about the depolarizing muscle relaxant, that is succinylcholine beta. I hope all of you are quite aware that succinylcholine is also called as choline. It is also known as succinylcholine beta. So succinylcholine, choline, succinylcholine are all one and the same thing. This succinylcholine or choline beta, this drug which is there definitely, it is going to have the fastest onset of action and it is having the shortest duration of action beta. Okay? So please remember, it has the fastest onset of action and the shortest duration among all the muscle relaxants beta. Clear? So अगर वो muscle relaxants की बात करते हैं, a lot of time what happens is you get so
invested into that non-depolarizing ones. That उन्होंने बस पूछा है कि which is the fastest and shortest acting muscle relaxant. Clear? ये बता रहा हूँ कल की I feel I've got this question from yesterday's तुम्हारा CMS exam itself. ठीक है? A lot of students asked me. तो what is important बेटा याद रखना definitely that fastest and shortest muscle relaxant अगर पूछा जाए तो answer has to be nothing else but scoline or succinylcholine बेटा. That is what is important to be remembered. Clear है बात? Okay. If they ask you non-depolarizing में, then non-depolarizing में बेटा you have two options. One is gantacurium and second is rocuronium बेटा. ठीक है, those are non-depolarizing ones. For overall muscle relaxants में पूछा जाए तो answer has to be succinylcholine or scoline beta. That is what is important to remember. No issues with this anybody? Sure. So that is important. Next important, if I talk about question number 157. A patient was diagnosed with CHF beta. What is CHF? Congestive heart failure. Now the patient was diagnosed with CHF and the patient was started on which drug? Oral inotropic drug beta. ठीक है, what is inotropic anybody? वेरी गुड. तो वी नो सबसे पहले CHF में क्या होता है? CHF और कंजेस्टिव हार्ट फेलियर में बेटा द हार्ट इज नॉट एबल टू पंप and if the heart will not be able to pump the blood definitely we have to give a drug beta which can increase the pumping action or which can increase the contractility of heart and that the drug that increases the contractility of heart is known as inotropes or inotropic drug. There is only one inotropic drug which is orally available. Answer is digoxin. Only oral drug beta that is inotropic in nature, that is digoxin, because all other inotropic agents which are there, whether it is norepinephrine also known as noradrenaline or it is isoprenalin or it is definitely beta your dobutamine, all of them are going to be given via injectable route. The only oral inotropic agent is going to be digoxin. She experiences dizziness, palpitation and syncopal attacks. I hope all of you are quite aware. Dizziness, palpitations, syncopal attacks, diaphoresis, these are all the symptoms of arrhythmias beta. Dizziness, palpitations, syncopal attacks are all symptoms of arrhythmias. याद रखना है बात, ठीक है? तो ECG reveals every other beat is what? Every other beat is going to be a PVC. What is PVC? Premature ventricular contractions beta. So they are saying ECG पे हर दूसरी beat abnormal है बेटा. Every other beat is a abnormal beat or a premature ventricular contraction बच्चे. Now they are asking you what is the likely treatment. We know if every second beat is going to be abnormal beta, if every second beat is actually going to be a premature ventricular contraction or abnormal beat, this type of arrhythmia is called as ventricular bigeminy beta. This kind of arrhythmia is basically called as a ventricular bigeminy beta. And I hope all of you are quite aware that ventricular bigeminy is actually going to be the most common digoxin induced arrhythmia beta, right? The most common digoxin induced arrhythmias की अगर वो बात करें बेटा, so digoxin induced arrhythmia if I talk about, so please remember digoxin induced arrhythmias में बेटा the most common digoxin induced arrhythmia is going to be ventricular bigeminy. That is important. Now most characteristic बताओ. Most common digoxin induced arrhythmia, all of us are quite aware, it is ventricular bigeminy. If they ask you most characteristic, बोलो. Most characteristic digoxin induced arrhythmia or most specific digoxin induced arrhythmia. बोलो most characteristic or most specific. Anybody online? So it is going to be classically beta NPAT with AV block beta. ठीक है? What is NPAT with AV block? It is non-paroxysmal atrial tachycardia with AV block beta. So non-paroxysmal atrial tachycardia with AV block which is there. Okay, just NPAT with AV block याद रख लेना. This is the most characteristic or the most specific arrhythmia beta due to digoxin toxicity basically. Or this is the most characteristic digoxin induced arrhythmia that has to be kept in mind beta. No issues with this. Now we know in this condition of ventricular bigeminy beta, in this condition of ventricular bigeminy, what is going to be the treatment of the patient? So we know डिफिकल्ट क्वेश्चन आंसर करने की इतनी आदत लग जाती है हमें कि हम आसान क्वेश्चन को भी डिफिकल्ट सोच लेते हैं. Ventricular bigeminy is a digoxin induced tachyarrhythmia, and if it is a digoxin induced tachyarrhythmia, I have to decrease the heart rate, and that is the reason I have to give a sodium channel blocker. And that drug of choice for digoxin induced tachyarrhythmia is a sodium channel blocker called as IV lignocaine. The answer has to be nothing else but option C beta. The answer is option C, that is lignocaine. That is important. ठीक है. Please remember digibind which is there beta, it is definitely the drug of choice for digoxin toxicity. अगर वो बस बोलते कि digoxin toxicity है, they would not have given definitely beta, okay, they would not have given any kind of arrhythmia over there. If they would have only asked me that what is the antidote, okay, for digoxin toxicity beta, then yes, I would have marked it as a case of digibind. Second, PYQ in NEET PG, and that question was in the recent NEET PG beta 2023 I feel. And that was basically beta कि the patient has taken digoxin, but due to that the patient is having a bradyarrhythmia now, and bradyarrhythmia की वजह से the patient's heart rate, okay, is going to be 52 beats per minute. It was a case of third degree AV block or third degree heart block. तो अगर patient में digoxin toxicity है या फिर patient में which kind of arrhythmia है, bradyarrhythmia है, then my antidote of choice or then my treatment of choice has to be digibind beta. That is important. But if they ask you beta that person is having a digoxin induced tachyarrhythmia, so obviously with a digoxin induced tachyarrhythmia mein I have to decrease the heart rate, and for that I need a sodium channel blocker known as IV lignocaine. If that's not an option, then mark it as IV phenytoin, because phenytoin is also a sodium channel blocker, can also be used for digoxin induced tachyarrhythmias itself beta. This can also be used, but definitely as lignocaine was there, lignocaine is considered better drug as compared to phenytoin. Clear about amiodarone which is there? Amiodarone is a potassium channel blocker beta. It is not used in digoxin induced arrhythmias, it is used in arrhythmias otherwise. Okay? Otherwise in arrhythmias definitely we can use amiodarone beta. Now if I talk about amiodarone, amiodarone is used for which kind of arrhythmias beta? Atrial or ventricular? Both. Atrial fibrillation mein just to do a chemical cardioversion. Don't you give amiodarone? We give, right? So please remember beta that amiodarone which is there, it is usually used for chemical cardioversion. Now what is cardioversion? Whenever I have to correct the heart rhythm beta, whenever I have to correct the heart rhythm with the help of any drug, that is called as chemical cardioversion. तो अगर किसी ड्रग की मदद से अगर तुम्हें पेशेंट का अरिथमिया ठीक करना है या हार्ट रिदम ठीक करना है बेटा, that is called as a chemical cardioversion. And the drug that we commonly use for chemical cardioversion is nothing else but the longest acting antiarrhythmic drug called as amiodarone beta. We know that amiodarone is basically a potassium channel blocker beta. So amiodarone is nothing else but a potassium channel blocker. Apart from that, amiodarone के major side effects बताना जरा कोई? Very good. One of the major side effect of amiodarone beta is going to be a lung or a pulmonary fibrosis which can happen beta. Apart from that, very good. So we know in patients of amiodarone beta, the patient will have thyroid disorders. Now when I talk about thyroid disorders, why I am writing only thyroid disorders? It can be hyperthyroidism, it could be hypothyroidism beta, any of that could happen. That is important. Apart from that, a special feature जो ऑफ्था से इमेज बेस्ड क्वेश्चन पहले आ चुका है, कॉर्नियल डिपॉजिट्स बेटा. ठीक है, कॉर्नियल डिपॉजिट्स हो सकते हैं. amiodarone definitely will lead to corneal deposits beta. That is what is important to remember. ठीक है. Apart from that, liver toxicity, myocardial depression, these are other side effects. Peripheral neuropathy is one of them, and most important, a photosensitive rash called as which syndrome? Blue man syndrome beta. A photosensitive rash called as the blue man syndrome. In the recent FMG examination there was a question, which among the following is not a side effect? All other options were given. One option given was gynecomastia. Does amiodarone cause any kind of gynecomastia? No. But gynecomastia is definitely caused by which drug? Digoxin, definitely beta. Barabar. Digoxin is one of those disco drugs which are actually known to cause gynecomastia beta. That is important. So digoxin toxicity. Why digoxin toxicity happens? Because digoxin is a narrow or wide therapeutic index drug. Narrow, and as digoxin is a narrow therapeutic index drug, therefore chances of digoxin toxicity are very very high beta. Important in patients of digoxin toxicity, what is the commonest side effect? PYQ again. अरे मैग्नीशियम सल्फेट थोड़ी चल रहा है भाई. Most common side effects of digoxin toxicity, PYQ. Those over in QR शर्म कर लो, बोलो. वेरी गुड, शाबाश. नाउशिया एंड वॉमिटिंग बेटा. तो मैंने बोला था कि डेफिनेटली वी थिंक ऑफ अ लॉट ऑफ थिंग्स, बट एक्चुअली द मोस्ट कॉमन साइड इफेक्ट ऑफ डिगॉक्सिन इज नथिंग एल्स बट नाउशिया एंड वॉमिटिंग, which is that is important to remember. समझे बात? तो नाउशिया एंड वॉमिटिंग हैज टू बी द कॉमनेस्ट साइड इफेक्ट ऑफ डिगॉक्सिन टॉक्सिसिटी. पेशेंट में आल्सो येलोइंग ऑफ विजन, एंड दैट येलोनेस ऑफ विजन इज कॉल्ड एज xanthopsia. Yes. So yellowness of vision is known as xanthopsia, and the third important side effect is nothing else but gynecomastia. So याद रखना, these are the common side effects of digoxin toxicity. One of the dangerous side effect is arrhythmia. I've told you most common arrhythmia is ventricular bigeminy, and the most characteristic arrhythmia is NPAT with EV block. Digoxin toxicity के लिए antidote or drug of choice will be digoxin. Digoxin induced bradyarrhythmias के लिए drug of choice is again digoxin. But digoxin induced tachyarrhythmias पूछा जाए तो answer has to be IV lignocaine followed by IV phenytoin. Clear digoxin? That is important. तो digoxin and amiodarone मैं हमेशा बोलता हूँ, अगर इस पॉइंट पे तुम्हें ड्रग्स टच करने हैं तो डोंट ट्राई टू टच ईच एंड एवरी ड्रग. एट दिस पॉइंट इट्स मोर इंपॉर्टेंट दैट व्हिच इज द मेजर ड्रग. टच दैट ड्रग प्रॉपर्ली. अब इस पॉइंट पे हर एक चीज नहीं पढ़नी होती. फार्मा जाओ, नोट्स में से बस इंपॉर्टेंट ड्रग्स देखो. दैट इज व्हाट इज द एम. क्लियर? Next important, if I talk about beta, here we are having बच्चे a 4-year-old boy who drank a full bottle of iron syrup. सरकारी question. तो 4-year-old boy beta who drank a full bottle of iron syrup and has been brought to you in the casualty with vomiting. What is the antidote for this case? तो we know beta iron syrup पिया है बच्चे ने पूरा. So definitely beta this is a case of iron toxicity beta. And whenever the child is actually suffering from iron toxicity beta, that is important to be remembered. ठीक है? Please remember iron toxicity अगर है बच्चे में तो definitely what has to be the agent? It is nothing else but option C, that is desferoxamine. नाम में ही उसके क्या है? Ferroxana. Ferrous is iron. So desferoxamine is an injectable antidote of choice beta for iron toxicity. It is used in acute iron toxicity or acute iron poisoning beta. Chronic iron toxicity में बताओ जरा. Very good. तो acute iron toxicity में the drug of choice is definitely desferoxamine beta. If they ask you about chronic iron toxicity or a chronic iron overdose, then we tend to give an oral drug, because if it is chronic beta, it is not feasible to give an injectable drug. Then we have to give an oral drug beta, and that oral drug is nothing else but deferriprone beta. Anybody, which are the patients जहाँ पे there will be a chronic iron toxicity? Thalassemia patients who receive recurrent blood transfusion beta. So those children can have a chronic iron toxicity, and for them we have to give an oral drug known as deferriprone beta. Clear है बात? BAL, or that is British anti-leukocyte, also called as dimercaprol. That is the antidote given in patients of 3 important. BAL से ही याद रख लेना, BAL demonic. So BAL or British anti-leukocyte is an antidote used in 3 poisonings. One is bismuth, second is arsenic, and third is lead. याद रखना, bismuth, arsenic and lead poisoning बच्चे, these are the 3 poisonings of toxicity where BAL or British anti-leukocyte can be used beta. That is important. EDTA is the antidote of choice in lead poisoning beta. We know that EDTA is antidote of choice in lead poisoning. लंबम बोलते हैं lead को इसीलिए बस. ठीक है, lead poisoning. And D-penicillamine is the antidote of choice for copper toxicity beta. So D-penicillamine is the antidote of choice for copper toxicity. Hopefully that's clear to all of you. These are few important antidotes beta. I'm just marking the important ones. First is acetaminophen. Acetaminophen is what? Yes, so another name for paracetamol beta. So acetaminophen is nothing else but PCM or paracetamol, and the antidote of choice is called as N-acetylcysteine. We know normally N-acetylcysteine is used as a mucolytic agent beta. That is important. Now PCM का पूछा था, in PCM toxicity which is the most common organ damaged? Answer would be liver. PCM is hepatotoxic beta. Liver is the commonest organ damage, and mechanism पूछा था. So please remember beta, definitely PCM toxicity or acetaminophen toxicity causes a oxygen free radical induced damage or a free radical injury beta in the liver. Therefore when we give N-acetylcysteine, what is the mechanism of action? It is going to increase the amount of antioxidants in the liver. And acetylcysteine increase the amount of antioxidants like glucuronides in the liver beta. Okay? So that is what is done. Next important, if they ask you, is anticholinesterase beta. Anticholinesterase definitely. Okay, in this conditions definitely beta, what is going to be given? It should not be anticholinesterase बोलो या फिर cholinergic poisonings बोलो. Make it easier. तो anticholinesterase या फिर cholinergic poisonings बेसिकली. Anticholinesterase मतलब क्या होता है? OPCs. Clear? तो organophosphates which are there beta. तो organophosphates are irreversible acetylcholinesterase inhibitors beta. Clear है बात? So that is important, and therefore they will cause excessive rise in the acetylcholine levels, and as they cause excessive rise in the acetylcholine levels beta, therefore we call it as a cholinergic poisoning. So organophosphate poisoning is a cholinergic poisoning beta, and we know in all cholinergic poisonings we have to give an anticholinergic drug, and that anticholinergic drug of choice is atropine. So atropine is a muscarinic blocker or a nicotinic blocker? Muscarinic. So atropine is an anticholinergic agent. It is a muscarinic blocker beta, and it is a drug of choice for cholinergic poisoning. कोई भी cholinergic poisoning होने दो, especially organophosphate. Apart from this, atropine is also the drug of choice for which conditions? Atropine, I have always told you to remember in the morning beta. Atropine, which is the drug of choice in conditions like ABC, OPC. Now when I say ABC, OPC, ये क्या मतलब होता है? तो ABC, OPC beta. So ABC, A stands for which block? AV block beta. So in patients of AV block, the drug of choice can be atropine. Second, B stands for bradycardia. Very good. In patients of bradycardia, we give atropine as the drug of choice. And C stands for cycloplegia beta. In adults or children? In children. So cycloplegia in children. Cycloplegia is relaxation of the ciliary muscles beta, so that you can examine the eye of the patient. So whenever you want to examine the eye of the patient beta, we have to definitely give some cycloplegic drops, and children with that cycloplegic agent of choice is atropine. Adults with that cycloplegic agent of choice will be, it is pilocarpine meiosis करवाते हैं midway assessment. Cyclopentolate or tropicamide. Very good. Tropicamide is there beta. The tropicamide is used as a cycloplegic of choice in adult patients beta because it is shorter acting. Okay, so that is important to remember. So cycloplegics are the drugs which are going to cause two things. First, dilatation of pupil called as mydriasis, so that you can examine the eye, and second, relaxation of the ciliary muscles beta. PYQ again from pharma. Which is the only cycloplegic beta which does not cause any kind of, which is the only agent beta or only drug which causes mydriasis but does not cause any cycloplegia, does not cause any relaxation of the ciliary muscles beta. So only mydriasis, no cycloplegia. बराबर, close, बोलो. Mydriasis without cycloplegia अगर बोलेंगे तो आंसर क्या होगा? A mydriatic agent without cycloplegia. Answer is, this was a PYQ and FMG exam. Answer is phenylephrine beta. So phenylephrine is the drug definitely जहाँ पे patient is going to have mydriasis or dilatation of pupil beta, but there is not going to be any kind of cycloplegia or the palsy of the ciliary muscles beta. Hopefully clear. ख्याल रखना, mydriasis without cycloplegia, answer has to be phenylephrine, and we have discussed that atropine is considered as a drug of choice in conditions known as ABC, OPC. A for AV block, B for bradycardia, C for cycloplegia in children, and OPC, by the name it is evident, OPC poisoning or the OPC toxicity beta. Hopefully clear to all of you now. Chalo. So these are the conditions that you have to remember. Next important antidotes, if I talk about anticholinergic agents which are there beta. Anticholinergic agents like atropine or anticholinergic agents like atropine or dhatura. So we know atropine toxicity or dhatura toxicity beta. ठीक है, atropine or dhatura toxicity में drug of choice is going to be physostigmine. So anticholinergic poisons which are there or anticholinergic toxicity like atropine toxicity or dhatura toxicity, the antidote of choice is physostigmine beta. Next important, if I talk about, is anticoagulants. Anticoagulants like warfarin. Warfarin के लिए the antidote of choice is going to be vitamin K. तो warfarin के लिए antidote of choice is injection of vitamin K. Heparin के लिए antidote of choice is protamine sulfate. Heparin के लिए antidote of choice will be protamine sulfate beta. That is important. Another one, that is benzodiazepines beta. Benzodiazepines के लिए antidote of choice will be flumazenil beta. ठीक है, तो flumazenil which is there definitely, which is that is considered as antidote of choice for benzodiazepine toxicity. Next, beta blocker toxicity. Antidote of choice is glucagon beta. So beta blocker toxicity, the antidote of choice is glucagon. Even in calcium blocker, even in calcium channel blocker poisoning beta, the antidote of choice will be glucagon itself. Next is cyclophosphamide. So to stop the side effects of cyclophosphamide, the drug that is given is known as Mesna beta. To stop the side effects of cyclophosphamide, we give Mesna. We have discussed about digoxin or digitoxin beta. Digitoxin is not in practice now. So digoxin toxicity meant definitely we give digoxin immune FAB. This is how definitely beta the drug was written in the recent PG when the question came. Digibind ऐसे लिखा हुआ था. ठीक है, so that is nothing else but digibind itself. Clear about? Next important, if I talk about important ones I'm marking, please remember beta, apart from that, if they ask you heparin, we have already discussed it is protamine sulfate. Next, iron, we have already discussed it is deferoxamine beta, okay, that is given. Isoniazid, we know isoniazid is known to cause vitamin B6 or pyridoxine deficiency. इसीलिए isoniazid toxicity में we should give pyridoxine or vitamin B6 to the patient beta, that is important. Methotrexate toxicity, another important one. Methotrexate toxicity में patient is given leucovorin beta. So leucovorin calcium is given in methotrexate toxicity, and this leucovorin is also called as which acid? Folic acid or folinic acid? Folinic acid. So please remember beta, this leucovorin, which is the antidote of methotrexate toxicity, it is also called as folinic acid beta. That is what is important to be remembered. Clear about? That has to be remembered. We have discussed again about opioid toxicity or the opioids poisoning beta. The opioid toxicity में the drug of choice that is given is known as naloxone beta. So IV naloxone has to be the antidote of choice in opioid poisoning or opioid toxicity beta. Clear? Next important PYQ of FMG exam, that is TCN. They said patient is the known case of depression and currently taking some tricyclic antidepressants beta. And now the patient has taken all the tablets which were there beta in the blister pack. So patient has come to you after taking 10 or 15 of the tricyclic antidepressant tablets. What should be the antidote of choice? We know answer has to be soda bicarbonate or sodium bicarbonate. Why? Because tricyclic antidepressants are actually known to cause metabolic acidosis. As TCAs are known to cause metabolic acidosis, therefore to neutralize that beta, we have to give soda bicarbonate or sodium bicarbonate beta. And lastly, we have discussed about warfarin. Warfarin is, okay, the antidote is nothing else but vitamin K beta, that is phytadione. Clear? So these are the antidotes that you have to remember. Next is question number 159. Which 159 mein here the question says the reflex that is shown below beta, they are asking you it disappears by what age? The reflex what is shown below. First of all, what is the reflex that is shown over here? When you definitely beta stimulate the cheek of the baby turns his face towards the same side beta and baby opens the mouth. And this reflex actually helps us in the process of breastfeeding beta. What is this reflex called as? Rooting reflex beta. Please remember this reflex which is there, bache, it is nothing else but rooting reflex. And if they ask you the rooting reflex beta, please remember that this rooting reflex is going to appear by what age? So rooting reflex usually appears by the 32 weeks of intrauterine life beta, and it disappears by what age? It disappears 1 month of postnatal life beta. So after birth it is going to disappear by 1 month of the postnatal life. That is what is important to remember. Clear about? So answer to this question has to be nothing else but option A, that is 1 month beta. The below given rooting reflex is going to disappear by 1 month of age. That is what is important. Okay? Which is the reflex that never disappears? Parachute reflex is the one beta which is never going to disappear. That is important to be remembered. Next is, please remember beta, if I talk about this reflex over here, what is this reflex called as? So here, whenever the baby feels like as if he is going to fall beta, the baby immediately performs extension and abduction followed by flexion and adduction. So extension and abduction followed by flexion and adduction beta is classically called as Moro's reflex beta. That is what is important to be remembered. Moro's reflex appears by what age? So we know beta that Moro's reflex which is there, it starts appearing beta. Okay, it starts usually appearing by 28 weeks of life, completely appears by around 36-37 weeks of intrauterine life beta, and it disappears by what age? So it usually disappears beta around, it is going to disappear beta around 3 to 6 months of postnatal life. Okay? So around 3 to 6 months or 4 to 6 months of postnatal life beta, the Moro's reflex is going to be disappearing. Two important questions that I would like to ask in Moro's reflex beta. First question is that Moro's reflex which is there beta, it is going to be exaggerated in which condition? Now chalo, I'll make it easier for you. In which stage of HIE? What is HIE? Hypoxic ischemic encephalopathy. So in cases of hypoxic ischemic encephalopathy, in which stage there is an exaggerated Moro's reflex? Exaggerated matlab ye. Okay, this is the exaggerated Moro's reflex. That is going to be seen in stage 1 HIE beta. Reason, stage 1 HIE में you have to remember what is going to happen. The tone of muscle is going to increase, and as the tone of muscle increases, beta, therefore in stage 1 of HIE there is an exaggerated morose reflex which can be seen. Stage 2 में there will be a diminished morose reflex, beta, which is seen, diminished हो जाएगा, and completely absent morose reflex is seen in. So completely absent morose reflex is usually seen in stage 3 of HIE, beta. Completely absent morose reflex is usually seen in stage 3 of hypoxic ischemic encephalopathy. That is what is important to be remembered. No issues with this, anybody? Clear है बात? तो याद रखना, exaggerated in stage 1, absent in stage 3, बेटा. Asymmetrical morose reflex, anybody? एक ही हाथ में दिख रहा है, दूसरे हाथ में नहीं दिख रहा. Erb's palsy, very good. Erb's palsy अगर है definitely बेटा, तो there is an asymmetrical morose reflex because in one hand there is a paralysis which has happened. ठीक है? तो Erb's palsy में there is an asymmetrical morose reflex. Do remember these points. Next important, what is this reflex? Yes, this is the classical parachute reflex. Whenever a person feels like as if he is going to fall, beta, immediately that person is going to extend his upper limbs, beta. Why? So that as the person extends his upper limbs, he is going to support his body basically, beta, with the extended arms. Clear? That is called as parachute reflex. Which is, if I talk about parachute reflex, it is going to appear at what time? Very good. So parachute reflex is going to appear, beta, by the 7 to 9 months of intrauterine or postnatal life. Postnatal life. So this is a reflex which appears after birth, beta. So parachute reflex is going to appear after birth definitely. It appears by 7 to 9 months of postnatal life, beta, and it disappears by what time? So please remember, beta, it never disappears. ठीक है? तो याद रखना, only reflex which never disappears is parachute reflex, beta. Hopefully clear to all of you now. That is important. Another important question I can ask you, and that is going to be that जब भी पेशेंट में सेरेब्रल पैल्सी हो जाएगी बेटा, whenever a person will have a cerebral palsy, all the primitive reflexes are going to reappear बेटा. जितने primitive reflexes है वो वापस आ जाएंगे except morose reflex. Very good. Only morose reflex is the one बेटा which never reappears once it is gone. एक बार चले जाए तो morose reflex वापस कभी नहीं आ सकता. That is what is important to be remembered बेटा. Which is the earliest reflex to appear, anybody? Very good. Earliest reflex to appear is going to be palmar grass reflex, beta. हमें पता है the earliest reflex which is there to appear is going to the palmar grass reflex. मतलब बच्चे के हाथ में कुछ भी लो बेटा, patient is immediately going to form a fist and hold that with the help of his palm, beta. That is the palmar grass reflex. That is the earliest reflex to appear. It appears by what age? Appears by what age? It usually appears by 28 weeks of intrauterine life, beta. So याद रखना, palmar grass reflex appears by the 28 weeks of intrauterine life, and that's the reason why it is the earliest one to appear. Reason is morose reflex also starts by 28 weeks, but it completely appears by 36-37. Easily we cannot call it as the earliest one. Earliest reflex is the palmar grass reflex and disappears by what age? Now your answer will be 3 to 4 months of the postnatal life, beta. So it disappears by the 3 to 4 months of postnatal life. That is what is important. जिसके बाद बच्चा मुट्ठी खोलना शुरू कर देता है. Clear है बात? That is important. Which is the earliest reflex to disappear? Earliest to disappear, beta, is going to be nothing else but the rooting reflex. Reason is, you can see rooting reflex is going to disappear as early as 1 month of postnatal life. There is no other reflex, beta, which disappears immediately after 1 month of the postnatal life or 1 month of birth, beta. That is what is important to remember. Hopefully that's clear to all of you. At least remember these important primitive reflexes, beta, the neonatal reflexes for your examination. Again, what you have to touch in the last row, I'm again trying to tell basically those topics जो चीजें तुम भूलते हो बेटा. Don't try to study a topic जिसके concept तुम्हें already पता है. ठीक है, कॉन्सेप्चुअल चीजें तुम नहीं बोलते हो, रट्टे वाली चीजें बोलते हो. रट्टे वाली चीजें देख के जाओ क्योंकि वो फोमो देती है एग्जाम में. एंड दैट इज फ्रॉम माय पर्सनल एक्सपीरियंस. मैं ऐसे ज्ञान नहीं करता फालतू का. ठीक है, आई नो डेफिनेटली मुझे छोटे छोटे सब्जेक्ट जो याद नहीं रहते हैं, ये सब्जेक्ट ज्यादा फोमो देते हैं. राइट, सो डेफिनेटली टच ऑल द लाइक touch definitely important points of pharma, touch important points of microbiology, touch important points from anatomy. Physiology I would not say, the only reason is कितना भी पढ़ो अभी कॉन्सेप्ट नहीं समझ में आने वाले. तो अल्टीमेटली अब इस पॉइंट पे टच करके भी आंसर नहीं मिले तो फिर दिमाग खराब होता है, यार पढ़ा तो भी आंसर नहीं आ रहा. दैट इज इंपॉर्टेंट. तीसरा पॉइंट पीडियाट्रिक्स से बेटा यू हैव टू स्टडी द प्रिमिटिव रिफ्लेक्सेस. अपार्ट फ्रॉम दैट एक बार जो भी है मेनली तुम्हारे माइलस्टोन्स जो होते हैं, मेन इंपॉर्टेंट माइलस्टोन्स देख लो. ठीक है, न्यूनाटोलॉजी देखिए, दैट इज इंपॉर्टेंट फ्रॉम पीडियाट्रिक्स, क्लियर। फॉरेंसिक मेडिसिन से बीएनएस पे दिमाग खराब करने की कोई जरूरत नहीं है, एक आधा क्वेश्चन आया तो आएगा और उसके चक्कर में तुम पूरा फॉरेंसिक मेडिसिन छोड़ दोगे, डोंट डू दैट, ठीक है, सो दैट इज इंपॉर्टेंट, नो इश्यूज विद दिस। नेक्स्ट क्वेश्चन नंबर 160 back him. Ammonia is formed in the brain beta and that is converted by transamination and transported to the liver in the form of which amino acid? So we know beta that ammonia from all over the body is transported in the form of option A, glutamine beta. That is what is important. हमें पता है that whenever I have to excrete nitrogen from the body beta, we know जब भी proteins break down होंगे, there will be production of amino acids. And whenever amino acids break down होंगे, there will be production of nitrogen or ammonia beta. And we know this ammonia is toxic or non-toxic? Toxic, highly toxic. Therefore, we cannot let it collect in the body. Therefore, we have to throw out this nitrogen or ammonia from the body. 3 steps में करते हैं. सबसे पहले, we have to convert all the amino acid into a common amino acid. And conversion of all amino acids into common amino acid is known as the process of transamination beta. It is known as the process of transamination. Done by the liver enzymes SGOT and SGPT, right? Next is the process जहाँ पे when these amino acids are transported to the liver, in liver they will come and they will donate the nitrogen or they will donate the ammonia. That process is known as oxidative deamination beta. Donation of ammonia basically is known as oxidative deamination. And third step, this ammonia which has been donated beta, it will be converted into the water soluble form and excreted out. That water soluble form is nothing else but it is urea beta. So definitely the third step of nitrogen excretion will be the urea cycle. Hopefully clear. Urea cycle is known as Krebs cycle or the Krebs-Hanslet cycle. So we know beta urea cycle, the another name is going to be Krebs-Hanslet cycle. Krebs cycle is another name for the TCA cycle or the citric acid cycle beta. That is important to be remembered. Hopefully that's clear to all of you now. So yeah, these are the 3 steps. Please remember, yes, by process of transamination, all the amino acids are definitely converted into glutamate first. But then that glutamate is further converted into glutamine beta. Clear? Then that further is converted into glutamine and then glutamine is transported across the body beta. From all the organs of the body, ammonia is transported or nitrogen is transported in the form of glutamine itself beta, except skeletal muscles. Only from skeletal muscle it is transported in the form of alanine beta. Only from skeletal muscles बच्चे it is usually transported in the form of alanine. तो याद रखना, from all over the body the ammonia or the nitrogen is transported in the form of glutamine itself, except from the muscles beta where it is transported in the form of alanine beta. Answer has to be option D then. So sorry, here the answer has to be option. Clear है बात? चल. So that is what is important to be remembered. No issues with this. If I talk about beta, एक बार बता देना, यूरिया साइकिल में डेफिनेटली which is the most common and what is the rate limiting enzyme? 3 चीजें पूछ रहा हूँ मैं. First, rate limiting enzyme of urea cycle, CPS1 beta, that is carbamyl phosphate synthetase 1 beta. Okay, CPS1 is the rate limiting enzyme present in the mitochondria. Second, urea cycle happens in which compartment of the cell? Cytoplasm or mitochondria? Both. Very good. Urea cycle is one of those pathways beta which occur in both the compartment of cell, mitochondria as well as the cytoplasm beta. Okay, it starts in the mitochondria, continues in the cytoplasm. 3 pathways which occur in both the compartment of the cell. Remembered by the mnemonic HUG. H for heme synthesis beta, U for urea cycle, and G for gluconeogenesis beta. 3 pathways which occur in both the compartment of the cell beta. That is what is important to be remembered. Clear? Next important, if I talk about urea cycle, let's say, please tell me, normally we know there are total 5 enzymes in urea cycle. PYQ in your FMG exam was 6th enzyme of urea cycle. तो हमें पता है बेटा, the 6th enzyme of urea cycle is which? NAG synthase beta. So NAG synthase which is there, it is considered as the 6th enzyme of the urea cycle beta. And third important question from urea cycle I would like to ask, and that is, which is the most common enzyme deficiency beta? Which is the most common urea cycle defect, or which is the most common enzyme deficiency of urea cycle? The most common enzyme deficiency in urea cycle is the OTC deficiency beta. OTC is the second enzyme called as ornithine transcarbamylase. So OTC is the second enzyme of urea cycle called as ornithine transcarbamylase. This enzyme is the commonest one to be deficient in cases of urea cycle defects. At least remember this. Hopefully clear to all of you now. Chalo, so these are the points beta that you have to keep in mind. Done with all of this? Next important, if I talk about beta, is question number 161 that states, here we are having a 28-year-old mother beta who was diagnosed with mild depression. She has a 3-month-old child now. Which among the following therapies beta should be prescribed to this female? Now पहले तो diagnosis बनाओगे तुम लोग, क्या है? 28-year-old mother coming to you with complaints of mild depression beta, and she has how many month old child? So diagnosis will be postpartum psychosis में डिप्रेशन के सिम्टम्स होंगे. गजब है, नाम में साइकोसिस लिखा है, उसमें डिप्रेशन के सिम्टम्स होंगे क्या? नहीं. So that is ruled out any which ways. So the diagnosis is a case of postpartum depression. Why not blues? Blues also has mild depression. Because please remember that postpartum blues are going to start within the postpartum blues are going to start usually after 3 to 5 days of delivery, and it will maximum usually happen within the first 2 weeks. ठीक है, postpartum blues maximum happens in the first 2 weeks after delivery. यहाँ पे they are saying that the child is 3 months old, so it has been seen after months of delivery beta. So obviously it is a case of postpartum depression. And postpartum depression, yes, there is a severe depression, but not always. There would be some females of postpartum depression where there can be mild symptoms, and the treatment has to be what? The treatment has to be option B, that is CBT, that is cognitive behavioral therapy, along with antidepressants beta. दोनों start करना पड़ता है, cognitive behavioral therapy along with antidepressants. That is important to remember. Clear about? Here you are able to see this is baby blues, also called as the postpartum blues beta. As I've told you, it usually starts 3 to 5 days or 2 to 4 days after birth beta. ठीक है, and maximum it starts or maximum it lasts for a span of less than 2 weeks. So it will occur only in the first 2 weeks after delivery beta, not after that. Here the patient will have symptoms of mild depression. Mild depression, like the patient will have mood swings, the patient will want to cry beta, that is tearfulness is there. ठीक है, we know this is mild depression and this condition is self-limiting beta. ठीक है, and does any treatment is required over here? No treatment is usually required for postpartum blues or baby blues beta. Next important, if I talk about, is the case of postpartum depression. Postpartum depression usually starts within 4 to 6 weeks after birth beta. Usually 4 to 6 weeks after birth, postpartum depression may start, and it can usually have a duration of several months. It can last for months together beta after the delivery. Patient is going to have a persistent sadness. Patient हमेशा दुखी रहेगी beta, and the patient will have loss of interest. That is called as anhedonia. So definitely anhedonia will be there, persistent or pervasive sadness will be there. She will definitely want to do suicide beta, so suicidal thinking will be there. ठीक है, we know here in cases of postpartum depression, patients are usually going to have moderate to severe symptoms of depression beta. There will be a significant impact on the functioning of the patient beta. ठीक है, and she will be treated with CBT, that is cognitive behavioral therapy, along with medications, that is antidepressants. Next is a case of postpartum psychosis. Postpartum psychosis usually starts after how many weeks of birth? It usually starts after 1 to 2 weeks of birth, especially after 2 weeks of birth. ठीक है, so it usually starts beta usually 1 to 2 weeks after birth, and please remember it can also last for weeks to months. If it is not treated, it can last up to weeks to months. Here also the patient may have severe mood swings beta, but along with that patient will have psychotic symptoms like hallucinations or delusion. The hallucinations or delusion, just psychotic symptoms will be there in the patient. And here also we know beta that this condition is extremely severe and urgent treatment or urgent intervention will be required over here. Patient is definitely going to have an extreme impact on the day-to-day life beta. ठीक है, patient कोई काम नहीं कर पाती यहाँ पे. And here not only medications are required, but rather we have to admit the patient. Hospitalization is necessary. Hopefully clear अभी सबके बारे में. That is what is important to remember. Clear? Just बता दो, if I talk about depression beta, depression happens due to deficiency of which two neurotransmitters mainly? Main neurotransmitters which can cause depression beta, one is serotonin. So we know serotonin, also called as 5-hydroxytryptamine beta, that is one of the main reasons. Second one is going to be norepinephrine, and the third one is dopamine beta. Okay, the main one is serotonin, second is norepinephrine, and third is dopamine beta. That is the reason definitely you might have seen what is the treatment or drug of choice in case of mild depression. If they ask you for mild depression, what is the drug of choice? Answer is definitely SSRIs. SSRIs are nothing else but selective serotonin reuptake inhibitors beta. These are selective serotonin reuptake inhibitors, drugs like all the Zetans, except which is the only Zetan which is not SSRI? Duloxetin beta. Please remember, duloxetin is the only Zetan which is not SSRI. It is a SNRI beta. That is important. A major side effect of SSRI. Commonest side effect of SSRI अगर पूछेंगे तो answer is again nausea and vomiting. Very good. GI upset which is there beta. The commonest side effect of SSRI is going to be GI disturbances, that is nausea and vomiting. Important side effect is going to be premature or delayed ejaculation. Delayed ejaculation. As SSRIs are actually known to cause delayed ejaculation, they are used as a drug of choice in premature ejaculation. So SSRIs, as they cause delayed ejaculation, they are considered as the drug of choice for premature ejaculation. Single best drug will be Depoxetin beta. Single best drug which is used for premature ejaculation, answer has to be Depoxetin beta. Clear about? Next, what is the drug of choice for severe depression? Very good. The drug of choice for severe depression beta is nothing else but SNRIs. SNRIs are nothing else but serotonin norepinephrine reuptake inhibitors beta. Serotonin norepinephrine reuptake inhibitors. These are usually the drugs like venlafaxine. That was a PYQ. That venlafaxine belongs to which among the following groups of drug? Answer was SNRI beta. So venlafaxine, milnacipran, duloxetin. These are the important drugs which are SNRIs. Bache. That is important to remember. And lastly, if they ask you severe depression along with suicidal thoughts, what is the treatment? Whenever a patient has severe depression along with suicidal thoughts, very good. The treatment is ECT beta. What is ECT? ECT is nothing else but electroconvulsive therapy beta. Now, when I talk about ECT or electroconvulsive therapy, one important question that comes to my mind, and that is, in India now, we perform a direct or indirect ECT. Very good. In India, beta, only an indirect ECT is performed, where you are going to sedate the patient first by giving IV lorazepam, and followed up at that you are going to perform the ECT or electroconvulsive therapy, or you will give a shock. Direct ECT is banned according to the Mental Health Care Act beta. Clear? That is important. 162. Here we are having a 25-year-old woman beta who visits the labor room. And how many weeks of gestation? At 37 weeks period of gestation beta, patient has mild labor pains beta for the last 10 hours bache, and the cervix which is there, it is persistently 4 centimeters dilated beta. What is the appropriate management? That is important to remember. So what is the appropriate management? The answer has to be option D, that is sedation and observation beta. Only sedation and observation can be done. Reason is definitely beta. Okay, we know that her cervix is 4 centimeter dilated beta. It has not yet gone into which phase? Active phase. अभी वो female कौन से phase में labor के? Latent phase. So she is in the latent phase of the first stage of labor beta. And as she is in the latent phase of first stage of labor, definitely. I hope all of you are quite aware beta that how much time is till how much time we can wait basically. In a primary gravida, if she is definitely pregnant for the very first time, in a primary gravida, we can wait for a span of 20 hours beta. In a primary gravida, you can wait for a span of 20 hours. And in a multi-gravida or multi-gravida, you can wait for a span of 14 hours. In a multi-gravida, you can wait for a span of 14 hours. Have they mentioned primary or multi? No. But definitely beta, it is neither beyond 14 hours nor beyond 20 hours beta. So you can easily wait. Clear? So answer has to be option D, sedation and observation. Now, another one basically, if they ask you beta, is a question that I have commonly got. At least almost 20-30 students have sent me. There's been a question, I'm not sure which platform, but there has been a question where they said that the patient is having a labor pains beta since 20 hours. Okay? And still definitely we are going for sedation or wait and watch in that question basically. What is the reason for that? तो तुमने बस फर्स्ट टाइम पढ़ा and you are thinking कि we are going for definitely sedation and wait and watch. Reason is beta, in that question in the second line they have clearly mentioned that the cervix is 1 centimeter dilated and not effaced at all. So when the cervix is only 1 centimeter dilated and no effacement is seen, that means it is a case of false labor pains. That is the basic reason. And अगर false labor है तो क्यों करवानी है तुम्हें डिलीवरी? लेबर ही नहीं है उसको तो अब तक. These are just false labor pains. समझे बात? How to differentiate false labor pain? If they ask you, beta, we know. If I talk about the contractions or the labor pains, beta, so please remember false labor pains में the contractions are regular or irregular. They are going to be irregular or arrhythmic, beta. Okay, so these are going to be irregular or arrhythmic contractions, and they are mild or severe. Mild contractions are there, beta. Whereas if I talk about in true labor pains, obviously the contractions are irregular or regular. So there will be regular or rhythmic contractions which are seen in true labor, beta. Apart from that, it is mild or severe. Severe contractions are going to be seen. Clear about that is important. Second important is now if I talk about beta, that cervical dilatation and effacement. ठीक है, cervical dilatation and effacement if I talk about, तो please remember beta, जब भी true labor pain शुरू होता है, the cervix starts opening up or the cervix starts dilating, beta, and it starts moving upwards, and the upward movement of cervix is effacement. So cervical dilatation and effacement is only and only seen in true labor pain, beta. It is absent in case of false labor pain. So if they have said only cervix is 1 centimeter dilated and no effacement is seen, that means it is a case of false labor. 20 घंटे का labor pain के बाद अगर cervix dilate नहीं हो रहा है, efface नहीं हो रहा, मतलब it is not true, it is false labor. क्लियर बात? And false labor है तो कोई ट्रीटमेंट नहीं करना है, ठीक है? And अगर फीमेल बहुत जल्दी false labor में आ रही है, right? The female is having a false labor at around 33-34 weeks basically, beta. You can just sit there and wait and watch. अगर ज़्यादा हो रहा है definitely, and if you don't want to deliver, then you can give tocopherol as well. Clear? So that is important to remember. Hopefully clear to all of you now. याद रखना, जब भी patient first stage of labor में आती है बेटा, you can wait up to 20 hours in primary gravida and 14 hours in a multi gravida female. If condition, it is a true labor pain. Clear? So यहाँ पे it is true labor pain. Why it is true labor pain? Cervix is 4 centimeter dilated, beta. Therefore, it is a case of true labor pain. That is what is important to remember. Clear about? That is important. No emergency LSCS is required. No artificial rupture of membrane. Artificial rupture of membrane is required for what? हाँ, but क्या करने के लिए? डिलीवरी. कौन सी डिलीवरी? वजाइनल डिलीवरी. उसके लिए तुम्हें लेबर स्टार्ट करवानी है, ऑगमेंट करवानी है. I know now, this is the garbage. So please remember, option C is wrong. Induction of labor with oxytocin. Is induction of labor done with oxytocin? No. Then induction of labor, which is the drug that is used. Induction of labor क्या होता है? Starting the labor, beta. If female is having no labor pains at all or no uterine contractions or at all, beta, you have to start the labors. That is what is called as induction of labor. Induction of labor is done by two routes, beta. Mechanical induction of labor can be done by ARM, that is artificial rupture of membrane. And second, medically the induction of labor can be done with the help of a drug called as prostaglandin analog known as dinoproston. So dinoproston gel or the cerviprime gel is inserted per vaginally, beta, to cause induction of labor. Oxytocin is actually known to cause augmentation of labor. Augmentation of labor क्या होता है? Here already the female is having labor pains, beta, but the problem is those labor pains or those uterine contractions are not very severe. We have to make those labor pains or the uterine contractions more severe or more intense, beta. तो मैं उनको definitely contractility बढ़ानी है. For that we tend to use oxytocin, let's say. Hopefully clear now. The difference clear. तो the induction और augmentation दोनों में बहुत difference होता है. Done with this? So next important if I talk about question 160. सेकेंड स्टेज में डेफिनेटली बेटा सेकेंड स्टेज मतलब डिलीवरी स्टार्ट हो चुकी है, तब ऑब्जर्वेशन नहीं करते, तुम डिलीवरी की दे देते हो ना फीमेल को. एक्टिव फेज में जाती है तभी पेशेंट को शिफ्ट कर देते हैं हम तो. क्वेश्चन नंबर 163 if I talk about, here we are having a 26-year-old beta G4, okay, that is gravida 4, presents with bleeding per vaginum, beta, and there is a history of previous 3 mid-trimester abortions, beta. Presents to us at 22 weeks period of gestation, beta. Ultrasound reveals there is which kind of cervix? A U-shaped cervix, beta. Okay. What could be the possible cause of recurrent abortion in this female? Very good. So bolo, is it cervical incompetence or Amplar syndrome? Very good. Why cervical incompetence? Very good. 3 abortions तो है, but all these 3 abortions are mid-trimester abortions, beta. That is in the second trimester. And second trimester abortions are not usually caused by APLA beta. APLA syndrome usually causes first trimester abortions, and that too less than 10 weeks. Clear? तो इसीलिए if it is a case of mid trimester abortion or second trimester abortion, it is more likely to be a case of nothing else but anatomical defects. हमें पता है ना that the most common cause of second trimester abortion is nothing else but anatomical defects beta. And the leading anatomical defect which is actually known to cause second trimester abortion is a cervical incompetence, that is a short cervix or an incompetent cervix beta. If I talk about the short or an incompetent cervix बच्चे, please tell me short or incompetent cervix मतलब length of the cervix is going to be less than, it is less than 25 mm बोलो या less than 2.5 centimeter बोलो, it is one and the same thing. Clear? So cervical incompetence has to be the cause of recurrent second trimester abortions beta. So answer to this question has to be option B बच्चे. And cervical incompetence है और बार बार second trimester abortions हो रहे हैं, so what should be done for prevention? Very good. Here you can see we are going to hold the cervix and we are going to apply which kind of suture around the cervix? We are going to apply which kind of suture? ऐसी गड़बड़ मत करो. Circular suture that we definitely take around the circular wound is called as. अरे suture का नाम पूछ रहा हूँ बस surgery से. What is the type of suture that we are taking all around the cervix? Purse string suture. So purse string suture, दादी माँ की पोटली, clear? So that is the suture that we take in cervical incompetence beta. And yes, this purse string suture if you take and you tighten the cervix beta, this purse string suture that you are able to see around the cervix is classically called as nothing else but, very good, yes. So it is nothing else but a case of which cerclage? McDonald cerclage beta. It is a McDonald cerclage. ठीक है? So that is what is important to remember. Hopefully clear? So cervical incompetence is usually prevented or treated by McDonald cerclage, which can be applied after. It can be applied after 12 weeks beta, and it has to be removed after 37 weeks. So please remember beta, you have to apply it at 12 weeks or after 12 weeks, and you have to remove it only at 37 weeks beta or at term basically. In some conditions though you can remove it earlier also, but usually we tend to remove it at 37 weeks beta. Hopefully clear to all of you now. See, this is definitely the criteria for APLA syndrome. Bolo, APLA syndrome ki what is the name of criteria? APLA is what? Antiphospholipid antibody syndrome beta. Antiphospholipid antibody syndrome is known as APLA syndrome. And can I say that APLA syndrome is the single most common cause of recurrent abortions? Yes, na? So please remember, APLA is going to be considered as the single most common cause of recurrent abortions. If I only ask you most common cause of recurrent abortion, answer would be endocrinopathies beta. Please remember, अगर मैं पूछता हूँ बस only most common cause of recurrent abortion. The most common cause of recurrent abortion will be endocrinopathies, that is all the endocrinal disorders beta like diabetes mellitus or hypothyroidism. Okay, but single most common cause, because endocrinopathies is a group of disorders basically. So single most common cause of recurrent abortion, if they ask you beta, the answer has to be nothing else but APLA syndrome beta. That is important to remember. Clear? It has to be APLA syndrome or antiphospholipid antibody syndrome. That is what is important to remember. No issues with this. For diagnosis of APLA syndrome, the criteria that we tend to use beta is called as the Sapporo criteria. So Sapporo criteria is used for the diagnosis of APLA syndrome, and according to APLA syndrome according to Sapporo criteria beta, at least we should have one clinical and one lab criteria beta to make a diagnosis. We should have at least one clinical and one lab criteria beta to make a diagnosis of APLA syndrome or antiphospholipid antibody syndrome beta. Clear about? Now lab criteria mein at least one antibody should be present beta. Okay, the antibodies seen in APLA syndrome will be, the first one is lupus anticoagulant, second is anticardiolipin antibody, and third is anti-beta 2 glycoprotein antibody. These are the three antibodies beta. Out of them at least one antibody should be there. Next, one clinical feature. What are the clinical features? At least one of them should be present. When I say clinical feature, first, patient should have any kind of thrombosis beta. Patient may give you a history of DVT, patient may give you a history of embolism, patient may give you a history of MI, patient may give you a history of stroke. कुछ भी type का thrombosis होना चाहिए. या फिर pregnancy related complications should be there. Pregnancy related complications में patient may have a abortion or a miscarriage beta at more than 10 weeks, when the child was absolutely normal. So in an absolutely normal child, if there was an abortion beta after 10 weeks, or there was more than equal to 3 unexplained abortions or miscarriages beta, all less than 10 weeks, तो 3 या 3 से ज़्यादा अबॉर्शन हुए लगातार एक के पीछे एक बेटा, एंड तीनों के तीनों बच्चे 10 वीक से कम में गए हो, तो दैट इज व्हाट इज अनदर क्लिनिकल क्राइटेरिया. और थर्ड क्लिनिकल क्राइटेरिया विल बी प्रीमेच्योर डिलीवरी और प्रीमेच्योर बर्थ बिफोर 34 weeks due to causes like preeclampsia. So due to preeclampsia, the female has delivered before time, before 34 weeks beta. That is what is important. Out of these 4 features, at least one clinical feature should be there beta. Hopefully clear to all of you now. Chalo, so that is what is important to be remembered. No issues with this? What is the treatment of Apla syndrome? Bata do. Treatment of Apla syndrome. We know now it is a case of thrombosis which is going to cause blockage of the blood vessel. So we have to give anticoagulant, and the anticoagulant of choice in pregnancy is low molecular weight heparin. So we have to give an injection of low molecular weight heparin beta. Along with injection of low molecular weight heparin, I have to add another drug, and that is antiplatelet called as aspirin. Along with low molecular weight heparin beta, you have to add aspirin. After delivery, I will discontinue low molecular weight heparin, but I will continue the female on low dose aspirin beta. I will continue the female on low dose aspirin lifelong. Clear? So that is important. Anticoagulant in pregnancy, एक बार वो बता देता कुछ चीज़ें, and that is definitely a PYQ, so PYT. So please remember beta, if they ask you anticoagulants in pregnancy, one thing that you have to remember, if they say beta first trimester of pregnancy, what is the anticoagulant of choice in pregnancy? So we know first trimester mein it is low molecular weight heparin. If they ask you near term, what should be the anticoagulant of choice? So 36 or 37 weeks के बाद, it has to be again low molecular weight heparin beta. So याद रखना, in the first trimester or around 36 to 37 weeks, that is around term beta, the anticoagulant of choice should always be injection of low molecular weight heparin बच्चे. But if they ask you बच्चे in the second or third trimester, then what we can do? तो हमें पता है बेटा, in the second and third trimester में the anticoagulant of choice in pregnancy, the anticoagulant of choice in pregnancy should be a oral drug. Reason, heparin is an injectable drug, it is not feasible to continue it for a so long time beta. So better is to shift to a oral drug, and that oral drug is nothing else but warfarin. In second and third trimester of pregnancy, we can give warfarin. Can warfarin be given in second or third trimester? Yes, absolutely beta, because warfarin only causes problem in the first trimester of pregnancy when organogenesis is happening. Otherwise, it will not cause any problem. Why we are stopping warfarin at term? Because if the female goes into labor with ongoing warfarin therapy, the female will have a very high risk of bleeding, that is PPH or postpartum hemorrhage. So PYQ again from NEET, and that PYQ was nothing else but beta, a female comes to you with ongoing labor beta, female with ongoing labor, and she is currently taking which drug? Warfarin beta. So female with ongoing labor taking warfarin. What has to be the next step? Mode of delivery क्या करोगे तो? तो female with ongoing labor taking warfarin. First step is definitely to stop warfarin beta. The first step is definitely to stop warfarin बच्चे, and along with that, what we have to do? तो अभी we have to just stop warfarin. I don't want to do anything as of now. I will just stop warfarin. वो डिलीवरी के बाद देखेंगे अपन. अभी के लिए तो मैं warfarin स्टॉप कर रहा हूँ. उसके बाद मोड ऑफ डिलीवरी, शी इज इन ऑनगोइंग लेबर, तो मोड ऑफ डिलीवरी क्या होगा? एनवीडी या सी सेक्शन? C-section, because if she has come to you beta with ongoing warfarin therapy, she will have high risk of PPH. अगर NVD के लिए ले जाओगे तो better is go for a C-section where the chances of PPH are going to be lesser. Clear about? So that is what is important beta. This has been a PYQ that you need to take care of. No issues with this anybody? Clear about? Chalo. Apart from that, in another PYQ in FMG examination, they asked you that a female comes to you at 8 weeks of gestation or 8 weeks of pregnancy, and she is currently taking warfarin. What should be your advice to her? So when a female comes to you in first trimester of pregnancy with the warfarin therapy, your advice should be switch to heparin beta. You have to shift the patient from warfarin to low molecular weight heparin, because she was in which trimester? First trimester of pregnancy. Clear about? So that is what is important. Now another question is, I will just add up about another repeated question, and that is anti-epileptics. क्योंकि तुम दोनों में गड़बड़ कर देते हो एंटीकोएगुलेंट कंटिन्यू कर देते हो और एंटी एपिलेप्टिक स्टॉप करवा देते हो प्रेगनेंसी में, एंड दैट शुड नॉट बी डन। क्लियर है बात? तो प्लीज रिमेंबर एंटी एपिलेप्टिक्स इन प्रेगनेंसी की अगर मैं बात करूं तो एंटी एपिलेप्टिक्स इन प्रेगनेंसी बेटा, व्हाट इज द सेफेस्ट एंटी एपिलेप्टिक्स टू बी गिवन इन प्रेगनेंसी? वन इज लेवेरा, दैट इज लेवेटिरासिटाम। तो वन इज डेफिनेटली लेवेरा बेटा, दैट इज लेवेटिरासिटाम, ओके, एंड सेकंड इज lamotrigine beta. So levetiracetam and lamotrigine are the safest anti-epileptics to be given in pregnancy, which is, that is what is important to be remembered. अब अगर question आता है, the PYQ again I am telling you, a female definitely comes to you beta, a female comes to you beta with ongoing valproate, ठीक है, if she comes to you with ongoing valproate therapy beta in first trimester of pregnancy, what is going to be your advice? If she comes to you with ongoing valproate therapy, we know valproate is a sodium channel blocker and it is a dangerous anti-epileptic drug beta. It is known to cause neural tube defects in the fetus or the baby. Bolo. Your advice has to be continue valproate. तुम बोलोगे sir first trimester, yes, even then we have to continue valproate. Reason is, please remember beta, you cannot change an anti-epileptic drug during pregnancy. If you want to change an anti-epileptic drug, that has to be changed prior to pregnancy, before the female conceives beta. If you try to change it during the pregnancy, क्या हो जाएगा? We are not sure whether the new drug is going to suit the patient or not beta, and due to that the female may have seizures, and if the female will get seizures during pregnancy, she will have an abortion. Clear है बात? So that is what is important. So don't discontinue any anti-epileptic drug during pregnancy. Doesn't matter how dangerous it is beta, continue it. Along with that, one more thing that I'll just do is increase the dose of folic acid beta. Very good. So we have to just increase the dose of folic acid to prevent the neural tube defects. And please remember beta, the dose of folic acid should be made up to, it should be 4000 micrograms or 5000 micrograms. It has to be 4000 micrograms per day beta. Please remember 5000 micrograms per day is given in patients of another PYQ. Sickle cell anemia में the dose of folic acid is going to be 5000 micrograms per day or 5 milligrams per day. ठीक है? A female who is currently taking anti-epileptic is just a high-risk pregnancy beta, and high-risk pregnancy में the dose we know it is going to be 4000 micrograms per day beta or 4 milligrams per day. Hopefully clear to all of you now. So that is what is important to be remembered. Question 164 beta. Here they say a woman with history of previous cesarean section beta has presented to us in a prolonged labor beta. Now they are saying she is definitely hypotensive beta and the fetal heart rate is not audible on the Doppler. Fetal parts are easily palpable on an abdominal examination. What is the likely diagnosis? Very good. What is the keyword? The keyword of the whole question is nothing else but fetal parts are easily palpable. We know when the uterus will rupture, the baby will come into the abdomen beta, and therefore you will be easily able to feel and palpate all the fetal parts of the baby. So the keyword of this question has to be fetal parts are easily palpable, and therefore the diagnosis has to be option A, that is nothing else but uterine rupture. Another keyword of the question was history of a previous cesarean section, because whenever there is a previous cesarean section or a previous myomectomy surgery, there has been a scar on the uterus beta, and whenever there is a previous scar on the uterus, definitely beta, the risk of rupture is actually going to be very very high. So cesarean section की history या myomectomy की history, ठीक है, so previous scar on the uterus is going to be a risk factor for uterine rupture, that has to be remembered. बाकी all the features are going to be common between uterine rupture and abruptio placentae beta. If it was a case of placental abruption, one of the important risk factors they would have mentioned in placental abruption, and that would have been hypertension. ठीक है, तो hypertension is one of the important risk factors of abruptio placentae beta. Apart from that, another thing that they would have mentioned, that fetal parts are easily palpable or not palpable. So please remember beta, fetal parts are not palpable or not easily palpable will have been the difference that you have got basically in a case of placental abruption beta or abruptio placentae. Hopefully that's clear to all of you now. So that is what is important to be remembered. No issues with this. So these are the keywords to remember that. Polyhydramnios होता था, polyhydramnios का keyword क्या होता है? Diabetic patient, okay. Baki. GI anomalies, these are causes. Diabetes mellitus, GI anomalies in the fetus, ठीक है. Or definitely beta, or definitely the patient is having twin pregnancy. All of these are causes. I want to know the keyword in the examination. Fundus क्या होता? ज़्यादा होता. Very good. So please remember beta, the uterine size which is there or the fundal height which is there, it should have been more than period of gestation beta. So whenever the uterine size or the fundal height is more than period of gestation बच्चे, that means definitely it is more likely to be a case of polyhydramnios. तुम बोलोगे it is increased in other size, other cases also. Yes, uterine size can be more than period of gestation beta in other cases like abruptio placentae as well beta. But over there, the uterus will be tender or non-tender? Tender. In abruptio placentae. In abruptio placentae, it will be extremely tender or painful, but in polyhydramnios, it is going to be absolutely non-tender or painless beta. That is what is important to remember. Clear about? So do remember these points. Amniotic fluid embolism, very classical. बोलो क्या होता है? Keyword पूछ रहा हूँ मैं question के. At this point, I just want to know the keyword. Unexplained shock after delivery. Unexplained shock after delivery का मतलब patient has delivered vaginally beta, but there is no problem. No massive bleeding was there. Okay, no uterine inversion was there. Nothing, no problem was there beta. And even if there was no problem, still the female has gone into shock. So whenever there is an unexplained shock after delivery, when everything is shown normal beta, along with that she may have some respiratory distress beta. This is a classical case of nothing else but amniotic fluid embolism beta. Hopefully clear. So these are the 4 common questions that come. So be aware of this. Clear? So yeah, next important, if I talk about beta, is a question number 165 where they say a couple presented to you beta with infertility, and the woman which is there beta, the woman also complains of pain in the lower abdomen. The patient also complains of pain in the lower abdomen bache, and the patient is having menorrhagia bache, okay, or excessive menstrual blood loss. Her husband's semen analysis which is there beta, it is absolutely normal. I've told you, whenever a couple comes to you with infertility, what is the first line investigation? Husband semen analysis beta, that is what is important. But here they are saying the semen analysis is absolutely normal. And on HSG, what is HSG? Hysterosalpingography beta, there is distal dilatation of the tube. Okay. What is the most likely cause of this condition? Very good. Why salpingitis? तो सबसे पहले तो यहाँ पे देख सकते हैं बेटा, distal dilatation of the tube which is there बेटा. Distal dilatation of tube is due to collection of fluid inside it, and that collection of fluid inside the fallopian tube is classically called as hydrosalpinx beta. ठीक है? So hydrosalpinx which is there, it commonly happens whenever there is any kind of infection beta. बराबर, whenever there is going to be any kind of infection beta, that is the reason why there will be a hydrosalpinx which can happen. An infection of the fallopian tube is called as salpingitis, which is a type of PID. What is PID? Pelvic inflammatory disease beta. That is the reason definitely the diagnosis of this case has to be more likely option D, salpingitis. But हमें पता है that hydrosalpinx can be commonly seen in patients of genital tuberculosis or a tubercular PID. Why not tubercular PID is going to be the answer over here. So please remember, history of TB can be given in genital TB. That can be one of the important reasons. But still, another reasons. Second important beta, chronic history will be there in patients of TB beta. There should be constitutional symptoms of TB, low grade fever, weight loss, anorexia, night sweats, कुछ भी नहीं लिखा, not even a single thing. And most important reason, TB is usually seen in young unmarried female. TB is very commonly seen in basically adolescent or young unmarried females. It is common beta. Okay, so that is what is important. TB is not common in married females. It is more commonly seen in unmarried females. And here they are saying a couple comes to you definitely. Okay, so that's the reason my more likely diagnosis would be option D beta. Now if they ask you tubercular polyp, bolo HSG or hysterosalpingography पे tubercular polyp क्या दिखाएगा? If there is a polyp inside the fallopian tube, that tubal polyp will show you what? Very good. A filling defect. मतलब the site basically beta where we are having the tubal polyp, that site पे there is no contrast beta. So filling defect if it is seen, okay, emptiness inside the tube अगर कहीं दिखता है, that is what is a picture of tubal polyp. Tubal spasm अगर होता बेटा, so the spasm which is there, it is usually seen at which side beta? It is seen at the interstitium itself. Tubal spasm जो होता है ना, corneal spasm is very common बेटा. The most common site of tubal spasm is the cornua, basically cornua or the horns. And अगर tubal spasm यहाँ पे cornua पे हो जाता है बेटा, why the distal end will be dilated then? Clear? So that is what is important to remember. Clear है बात? तो अगर tubal spasm होता है बेटा, तो then the fallopian tube is not visible because if the tubes are going to undergo spasm बेटा, मतलब ये देखो, ये वाला हिस्सा जो है ना, this part which is there beta, it is undergone spasm. If this part of the tube or the cornua has undergone spasm beta, will the contrast go in the tube? No. यहाँ पे तो दिख रहा है कि contrast is going into the tube. Clear? So that is what is important beta. So here it is nothing else but a case of salpingitis that you have to remember. Can you see these filling defects? So these are the filling defects inside the uterus beta, and whenever there are filling defects in the uterus, whenever there are filling defects inside the hysterosalpingography, we know it is more likely a case of tubal polyp beta. Next important question number 166, if they ask you, we are having an elderly diabetic lady beta who presented to us with complaints of purulent discharge from the right ear for a few weeks, and now she also has drooping of mouth beta like this. ठीक है, she is having drooping of mouth. Otoscopic examination shows granulation tissue inside the ear basically beta. What is the most probable diagnosis of the case? Very good. So we know elderly diabetic patient, that is immunocompromised patient, coming to you with complaints of purulent discharge. Purulent discharge from the ear is a feature of otitis externa or otitis media. Otitis externa. Otitis media में कौन से टाइप का डिस्चार्ज होता है? इन्फेक्शन में कैसे सीरियस डिस्चार्ज होता है? Otitis media में which kind of discharge will be there? Mucopurulent. I've told you two things. Mucopurulent discharge होता है. याद रखना, whenever it is a case of an otitis externa, doesn't matter whether it is localized otitis externa, diffuse otitis externa or malignant otitis externa. In these patients, there is going to be a purulent ear discharge beta. Apart from that purulent ear discharge, the patient is going to have which sign positive? Very good. Which sign is positive? Tragal sign is positive. When I say tragal sign, what does that mean? Whenever I press basically the tragus beta, patient experiences a lot of pain. So tragal sign or tragal tenderness is positive. These are the signs of external ear infections or otitis externa. अगर middle ear infection होता beta, that is otitis media होता, so definitely the patient should have which kind of ear discharge beta? Mucopurulent ear discharge should be there. The patient should have a mucopurulent ear discharge. Apart from that, the patient may also have definitely tragal sign positive or negative? Negative. Tragal sign or tragal tenderness will be absent beta. There is no tragal sign or tragal tenderness if it is a case of nothing else but otitis media or a middle ear infection beta. Hopefully that's clear to all of you now. So these are the keywords to differentiate whether it is otitis externa or otitis media beta. And here there is otitis externa and clear by the purulent ear discharge they have given. And they are saying the patient is immunocompromised. Apart from that, they have added two things. First, drooping of mouth. Drooping of mouth is suggestive of which palsy? So we know beta it is a case of facial palsy, also called as the seventh cranial nerve palsy beta. Barabar, it is a case of facial palsy or the seventh cranial nerve palsy that you have to remember which is. Apart from that, they have also added one more thing, and that is granulation tissue in the ear beta. So we know that facial palsy or granulation tissue in the ear, that means it is a severe form of external ear infection or a severe form of otitis externa, and severe otitis externa has to be called as option D, which is that is malignant otitis externa. It is a classical case of option D, that is a malignant otitis externa beta. Hopefully clear. Reason is malignant otitis externa mein beta, the infection spreads to the skull base, and as the infection spreads to skull base beta, in this patient there will be multiple cranial nerve palsies which is. So in patients of malignant otitis externa, there will be multiple cranial nerve palsies that are going to be seen. Hopefully clear to all of you now. So that is what is important. So granulation tissue, cranial nerve palsies has to be a malignant otitis externa. Localized otitis externa में patient will only have earache beta and maximum discharge करेंगे. Most common cause of localized otitis externa will be localized Staph aureus. Most common cause of localized otitis externa, because localized otitis externa is nothing else but infection of the hair follicle beta, that is furuncle. And we know the commonest cause of localized otitis externa or any furuncle in the body is always Staph aureus or Staphylococcus aureus beta. Most common cause of malignant otitis externa अगर पूछेंगे तो answer is Pseudomonas beta. Most common cause of malignant otitis externa if they ask you, then definitely the answer is Pseudomonas aeruginosa which is. Pseudomonas aeruginosa, which color colonies? Green color colonies beta. Which agar? cetrimide agar beta. Pseudomonas के लिए the agar or the culture media that we use is called as the cetrimide agar. Another PYQ, old one, but yes, cetrimide agar is going to be there. Hopefully clear to all of you now. So that is important. Treatment, obviously, it is antibiotics that we have to give. Question number 167 beta. Here there is a lady who is a known case of Graves disease beta. A lady comes to you who is a known case of Graves disease. Graves disease is the most common cause of hyper or hypothyroidism. So we know, yaad rakhna, Graves disease is the leading cause of hyperthyroidism. What is the leading cause of hypothyroidism? The leading cause of hypothyroidism is going to be Hashimoto's thyroiditis beta. In developing countries, leading cause of hypothyroidism will be iodine deficiency. So developing countries mein the leading cause of hypothyroidism will be iodine deficiency, but otherwise overall it is Hashimoto's thyroiditis. Important patient is a known case of Graves disease and has been diagnosed with atrial fibrillation. Q. Hyperthyroidism mein there is excess production of thyroid hormones, that is T3 and T4, and I hope all of you are quite aware beta that T3 and T4 which are there, they are sympathetic or parasympathetic in nature. हमें पता है बेटा T3 and T4 are going to be sympathetic in nature beta, and as they are sympathetic in nature they are known to cause tachyarrhythmias beta, right? So as they are sympathetic in nature, that obviously can lead to tachyarrhythmias in the patient, and one of the tachyarrhythmias can be atrial fibrillation beta. One of the tachyarrhythmias can be atrial fibrillation. ठीक है, today she presents to you with sudden arterial occlusion beta of the lower limb vessel. ठीक है, which one of the following is the last sign to appear? Now मुझे बताओ sudden arterial occlusion होता क्या है? Thrombosis or embolism? So sudden arterial occlusion, if it happens, sudden arterial blockage अगर होता है बेटा, that is basically called as an embolism. See, if the clot or the blockage is developing in a vessel for a longer duration of time, then it is called as thrombosis. But if it causes sudden occlusion beta, it is known as embolism. क्यों होता है embolism atrial fibrillation के patients में? In atrial fibrillation, we know atria is just twitching beta, and as the atria is just twitching, definitely it is not able to pump out the blood. And if it will not be able to pump out the blood beta, the blood will undergo stasis in the heart, and due to that there will be high risk of clot formation or thrombus formation. So atrial fibrillation के patient में a lot of clots or thrombuses are formed in the heart. One fine day that thrombus or the clot will go and block suddenly a blood vessel beta, causing embolism. समझे बात? तो अभी embolism definitely का last sign क्या होगा? So we know beta pallor and pain are the earliest signs which are seen in cases of embolism. Pulselessness or paralysis? Answer has to be option C, pulselessness. This has been a PYQ beta. Don't mark it as paralysis. Reason: paralysis is weakness of muscles beta, and weakness of muscles happens due to decreased blood supply to them. But pulselessness happens due to no blood supply at all. Clear? The paralysis happens due to decreased blood supply, and pulselessness happens due to no blood supply. So therefore, pulselessness will be last feature beta that is going to appear. Hopefully that's clear to all of you now. Embolism के cases में last is pulselessness. We know embolism is characterized by the 6 P's beta. 4 are written over here: pallor, pain, paralysis, pulselessness. Apart from that, we have decreased sensations called as paresthesias, and we have coldness called as poikilothermia beta. So pallor, pain, paresthesias, poikilothermia, paralysis, and last pulselessness beta. This is what is important to be remembered. The last sign to appear is always pulselessness. That has to be kept in mind. No issues with this. Other embolism have to, obviously we have to definitely go for duplex scan beta, and that is going to confirm my diagnosis, and treatment has to be anticoagulants. तो याद रखना, investigation of choice अगर पूछेंगे embolism में, तो we know it is nothing else but duplex scan or a color Doppler. Duplex scan or color Doppler is the investigation of choice for central vessels or the peripheral vessels of the body. So whenever peripheral vessels of the body are blocked beta, for all the peripheral vessels of the body, the investigation of choice is duplex or a color Doppler, whereas for central vessels, the investigation of choice is CT angiography beta. CT angiography is the investigation of choice for all the central vessels, मतलब head, neck, chest and abdomen. In vessels के लिए we have to go for a CT angiography beta. Hopefully that's clear to all of you now. So that is important. Treatment is nothing else but we know anticoagulant. Now I would like to ask you beta that this patient this patient definitely is suffering from hyperthyroidism or Graves disease beta. Okay, if that patient suddenly becomes hemodynamically unstable and that patient suddenly starts having a severe tachyarrhythmia beta, That means the patient has gone into a complication. And what is that complication called as? Thyrotoxicosis. So when basically a patient of hyperthyroidism suddenly has a tachyarrhythmia where it becomes hemodynamically unstable. Okay, then means the patient has landed up into thyrotoxicosis beta. And thyrotoxicosis mein the first drug to be given is one-liners mein jo the they know. First drug to be given propanolol. Please remember, reason is definitely the patient is having what? Sympathetic overactivity beta. And sympathetic overactivity है तो उसको रोकने के लिए we have to give beta blockers beta. The first drug to be given definitely is nothing else but propanolol beta and thyrotoxicosis to be remembered. Next important, if they ask you, what is going to be the drug of choice for thyrotoxicosis? Very good. Drug of choice for thyrotoxicosis will be PTO, that is propylthiouracil beta. Reason is we know that PTO or propylthiouracil is the drug of choice for hyperthyroidism or thyrotoxicosis in emergency beta. Otherwise, the drug of choice for hyperthyroidism, if they ask you, normally if they ask you what is the drug of choice for hyperthyroidism, then the better drugs definitely will be carbimazole or methimazole. So carbimazole or the methimazole like antithyroid drugs are considered as the drug of choice for hyperthyroidism beta. But in emergencies we tend to give PTO or propylthiouracil. PTO or propylthiouracil is also preferred during pregnancy. So propylthiouracil is also the drug of choice for hyperthyroidism during pregnancy beta. याद रखना pregnancy में पूछा जाए तो answer has to be again PTO or propylthiouracil in first trimester of pregnancy. Second and third may you can shift back to carbimazole and methimazole. Why carbimazole or methimazole is avoided in the first trimester of pregnancy? PYQ. So we know that carbimazole or methimazole like drugs are avoided in the first trimester of pregnancy because they can cause side effects like cutis aplasia beta. That is, the skin of the baby is not going to form. Here right now there will be side effects like cutis aplasia, or the second one is guinal atresia. Okay? Hopefully that's clear all of you now. Next, I'll just add up the management of atrial fibrillation. Reason is AFib ka management has been asked in the recent NEET PG as well as recent FMG examination. So questions on atrial fibrillation ka treatment or management is very common in your exam. Okay? They give statements, they give anything. So related to that, we know beta atrial fibrillation or atrial flutter ka management can be remembered with the mnemonic RACE beta. And when I talk about RACE, basically R stands for rate control beta. You have to definitely decrease the atrial rate of the patient, and to decrease the rate we can give beta blockers like IV, esmolol, or we can give calcium channel blockers beta. Calcium channel blockers like carvedilol can also be given. Beta blockers like esmolol, labetalol, carvedilol, this can be given. Apart from that, calcium channel blocker they सकते. कौन सा CCBs can be given? Very good. Only drugs like verapamil or diltiazem. Reason is याद रखना, the dipins which are there, nifedipine, nimodipine, nicardipine, these drugs are known to increase the heart rate, so they should never be given in case of arrhythmias. But arrhythmia के लिए CCBs used are verapamil or diltiazem. Clear? Those drugs are used for hypertension. Dipins जो होते हैं वो arrhythmia में नहीं, hypertension में use होते हैं. Clear है? Next important, if I talk about beta, A stands for what? Anticoagulation. Just now we have seen the problem that in case of atrial fibrillation there is a very high chance of coagulation beta. So we have to give anticoagulants, and the oral anticoagulant that we can give beta, or oral novel anticoagulant, that can be drugs like dabigatran beta. We can give an oral anticoagulant called as dabigatran. Apart from dabigatran you can give injectable ones also beta. That is important. Okay? Next, C stands for what? Chemical cardioversion. मतलब you want to correct the rhythm of the heart beta with the help of a drug. So that is chemical cardioversion, and chemical cardioversion is usually done with drugs like amiodarone beta. So usually drugs like amiodarone definitely are given beta for chemical cardioversion. Apart from that, we know amiodarone is a potassium channel blocker. We can also give a sodium channel blocker like ibutalide, dofetilide. Okay? These kind of sodium channel blockers can be given. And lastly, E stands for electrical cardioversion beta. Electrical cardioversion is nothing else but DC shock that we have to give. Electrical cardioversion is a DC shock. Hopefully that's clear to all of you now. Next is question number 168 beta. Here we are having a 70-year-old man who came to you with complaints of low back ache, and he has been diagnosed with a cancer. On PET scan beta, they are saying we have found definitely there was a metastasis to which vertebra? Lumbar vertebra beta. What is the likely route of spread for this cancer? Recent question of your examination. Yes, it is Jan 2025 for question. The only thing I've changed is definitely instead of breast cancer, I've given a case of prostate cancer. That is important. Clear about? So yaad rakhna. So here I've said 70-year-old man along with low backache and the patient may be having urinary symptoms beta. So I have always told you three things. Yaad rakhna. First, any young adult male comes to you with low backache, think about ankylosing spondylitis. Any elderly patient, male or female doesn't matter. Any elderly patient comes to you with low backache along with anemia and renal failure. Think about any elderly patient, male or female doesn't matter, comes to you with problems like low backache along with anemia or renal failure. Think about multiple myeloma. And when any elderly male, only male, when any elderly male beta comes to you definitely with complaints of low backache and lower urinary tract symptoms. So low backache along with lower urinary tract symptoms, think about metastatic prostate cancer beta. Then think about metastatic prostate cancer. समझे बात? तो यहाँ पे there is an elderly male who has come to us with low backache and they have given that there is a cancer. So we know only cancer which can cause a low backache in an elderly male is nothing else but a metastatic prostate cancer. And for metastasis beta, I hope all of you are quite aware. What is the investigation of choice? For metastasis, we have to do a whole body scan, and that whole body scan that we do is nothing else but a PET scan. What is PET? Positron emission tomography scan beta. Two questions that have been asked on PET scan. So we know it is the investigation of choice for distant metastasis beta. Okay, it is the investigation of choice for distant metastasis. It is a whole body scan beta. Second important, what is the agent that we use or the contrast that we use in PET scan? So we know beta that the contrast that we should use for PET scan is nothing else but 18 FDG or 18 fluorodeoxyglucose with a half-life of definitely around 110 minutes beta. With the half-life of around 110 minutes. So 18 FDG or 18 fluorodeoxyglucose beta. Important to be remembered is what test should be done before going for a PET scan? Radio se question aa sakta hai. Very good. So please remember beta, blood glucose monitoring should be done definitely. Okay, blood glucose should be checked before the test. So blood glucose test should be done prior. Okay, so that is what is important beta. These are the three questions that you can remember from the PET scan or the positron emission tomography scan beta. Now important is metastatic prostate cancer and metastatic prostate cancer. Whenever the prostate cancer spreads to the bones beta, it mainly spreads to the lumbar vertebra. And in lumbar vertebra beta, when it spreads, that is the reason why it is causing low backache. It causes osteoblastic or osteolytic metastasis. We know beta bone forming दिख रहा है ना यहाँ पे. So prostate cancer is mainly known to cause osteoblastic metastasis. See, we know similar things will be seen in breast cancer also, but breast cancer mainly causes osteolytic metastasis. So याद रखना, breast cancer and prostate cancer दोनों में the most common site of distant metastasis are the bones, mainly the lumbar vertebra. ठीक है? Via which plexus of veins? Via the Patterson's plexus of veins beta. The only difference is in patients of breast cancer, mainly we are able to see beta osteolytic metastasis, and in patients of prostate cancer, we are mainly able to see osteoblastic metastasis. That is the difference. So here we know beta that the most common route of spread answer has to be option A. That is nothing else but vein beta. Okay? So that is what is important to be remembered about this one. 170 तो कर लो. Question number 169 beta. Here we are having a 20-year-old male beta who presents to you with sudden onset pain and swelling beta in the right inguinoscrotal region beta. On examination, the swelling is higher up in position and it is tender on palpation. What is your likely diagnosis? So, first important thing, we know beta, first of all they are saying that the patient is having a pain and swelling beta. तो जैसे ही पेन बोल देते हैं बेटा वो व्हाट इज द कंडीशन दैट यू कैन रूल आउट हाइड्रोसील यूजुअली व्हेनेवर इट इज अ प्राइमरी और सेकेंडरी हाइड्रोसील बेटा हाइड्रोसील्स आर यूजुअली पेनलेस दे विल कॉज स्वेलिंग बट दे आर नॉट गोइंग टू कॉज पेन बेटा कॉमनली क्लियर तो सेकेंडरी हाइड्रोसील आई कैन कीप इट असाइड बेसिकली नाउ we are having a young patient beta that is 20-year-old male that is 10 to 25 years of age group is commonly affected beta ठीक है and they are saying there is pain and swelling in which region right inguinoscrotal region beta that is important to be remembered. Now जैसे ही जैसे inguinoscrotal region में pain and swelling है what is the another condition that I can rule out? epididymoarthritis, because epididymoarthritis है बेटा, तो I understand the pain and swelling in the scrotal region बेटा, but not in the inguinal region basically. Clear? तो inguinal region में again pain and swelling is another reason why it is not here. Another reason to rule out epididymoarthritis. उसका भी reason दे रहा हूँ, that is swelling is higher up. मतलब the testis has been pulled upwards बेटा, and testis getting pulled upwards, no logic in epididymoarthritis. It is just an infection ना, वहाँ swelling why the testis will get pulled upwards, क्या logic है उसका? That is important to remember बेटा. So as they are saying swelling is higher up in position, we know it is not a case of epididymoarthritis beटा. Now it could be a case of testicular torsion or it could be a case of strangulated hernia beटा. What is more likely to be seen in a 10 to 25-year-old younger patient? So chances of option B, testicular torsion, are going to be much higher beta as compared to a strangulated inguinal hernia. That is what is important. And सबसे बड़ी बात to rule out hernia. Very good. Sudden onset. hernia की swelling sudden onset नहीं होती. hernia की swelling पिछले 3 महीने से present होगी, जिसका अचानक से pain शुरू होगा. Clear? Here they are saying pain and swelling both are sudden onset. अगर वो ये बोलते हैं कि the swelling has been there for the last 3 months and the pain has suddenly started, I would have thought about strangulated inguinal hernia. But here they are not saying that the swelling was present prior. They are saying swelling is also sudden onset. So sudden onset swelling can never be a hernia. अचानक से थोड़ी hernia होता है एक दिन में. Clear? So it has to be a case of testicular torsion, which is an emergency beta. Testicular torsion में which investigation I need? Transillumination test you can do, but logic नहीं बन रहा उसका कोई, ठीक है? Any which ways, apart from that, French test is there बेटा. French test will help me to differentiate between epididymoarthritis and torsion. After lifting of the scrotum, if the pain is relieved, then it is a case of epididymoarthritis. And after lifting of the scrotum, also the pain is not relieved. It is a case of testicular torsion beta. So torsion में the French test is negative. That is important. Pain does not get relieved beta. Torsion is a clinical diagnosis beta. I usually don't. Okay, so please remember, torsion is a clinical diagnosis बच्चे. I usually don't need any kind of investigation to make a diagnosis of torsion. If you are diagnosed it as a torsion, you can directly go for a surgical exploration beta. If you want to support your diagnosis, then you can definitely go for an ultrasound to support your diagnosis or to see the vascular status of the testis. For that, definitely I can go for a ultrasound बच्चे. That is what is important to remember. No issues with this anybody? And treatment क्या करोगे in testicular torsion? If the testis is viable, मतलब if the patient was presented to me early beta within 6 hours and now the testis is completely 100% viable, I can save the testis. Then I am going to derotate the testis beta and then I will go for orchidectomy or orchidopexy. I should go for an orchidopexy because यहाँ पे the testis is still viable beta, it has not yet undergone necrosis बच्चे. Clear है बात? Apart from that, if they ask you non-viable अगर है, non-viable है बेटा, then in those conditions what I have to do? I have to remove the testis called as orchidectomy beta. I have to do an orchidectomy. Whether you should go for a derotation and orchidopexy or you go for orchidectomy, what we have to do in the opposite side? A contralateral orchidopexy or orchidectomy should be done on the other side. A contralateral orchidopexy has to be done beta in the same surgery on the same sitting बच्चे. That is what is important to remember. Hopefully clear to all of you now. ये question कर लो and then you can take your break. The question states beta, we are having a 45-year-old male presents to you with complaints of pain abdomen along with vomiting and diarrhea beta. On examination, a mass is palpable in the right iliac fossa beta. What is the likely substrate which will be detected in the patient's urine? Very good. So यहाँ पे you are able to see beta a patient who comes to you with pain, abdomen, vomiting and diarrhea. Important is a mass palpable in the right iliac fossa. Mass palpable in the right iliac fossa is arising from which organ? Appendix. So we know it is more likely to be a case of appendicular mass or appendicular tumor beta. ठीक है? So it is more likely to be a case of an appendicular tumor, and the most common appendicular tumor. In yesterday's this one also there was a question on this. I feel CMS में कल में question था. What is the most common appendicular tumor? Answer would be carcinoid beta. The most common appendicular tumor are carcinoids, and I hope all of you are quite aware. Carcinoids are considered as the neuroendocrine tumors beta. Carcinoids are considered as neuroendocrine tumors. What are neuroendocrine tumors? Those which secrete some neurotransmitter beta. And the neurotransmitter secreted by carcinoids is going to be serotonin. So there will be excess production of serotonin by carcinoid tumor beta causing a serotonin syndrome. Whenever a patient has serotonin syndrome, patient will have problems like diarrhea, flushing and wheezing. The diarrhea, flushing and wheezing like symptoms are seen due to serotonin syndrome beta. Now, recent FMG का क्वेश्चन था मेटाबोलाइट और नीट पीजी का क्वेश्चन था ड्रग ऑफ चॉइस. नीट पीजी में बस कार्सिनोइड की जगह हिस्ट्री दी गई थी फॉर डेफिनेटली ओवर इनटेक ऑफ एसएसआरआई. So that was the only difference over here. So serotonin syndrome जब भी होता है पेशेंट में, we know that serotonin is broken down into a metabolite called as 5-HIAA beta. That is nothing else but 5-hydroxyindolacetic acid. And those levels, when you check in the urine, those 5-HIAA levels will be grossly elevated. This was a NEET FMG PYQ. And the drug of choice for serotonin syndrome, NEET PG PYQ. Answer will be very good. It is going to be a cyproheptadine beta. So cyproheptadine is considered as the drug of choice for serotonin syndrome. Hopefully clear to all of you now. So that is what is important. So answer of this question. We know which among the following substrate will be likely detected in patient's urine sample. Answer has to be option B. That is hydroxyindolacetic acid. That is HIAA. Metanephrine levels you should detect in a case of. Very good. We know metanephrines are a breakdown product of catechol amines, and therefore beta urinary metanephrine levels. I should check if a patient was suffering from pheochromocytoma. Pheochromocytoma में will there be a mass in the right iliac fossa? No, there will be a mass in the lumbar region बेटा. ठीक है, बाहर से कहाँ palpable होगा तो lumbar region में और flanks में. So if there is a mass in the lumbar region or the flanks, then I would have thought about pheochromocytoma, which is a adrenal tumor बेटा. समझे बात? That is important. Even VMA or vanillin mandelic acid, इसका भी level I will check in pheochromocytoma because VMA is also a metabolite or a breakdown product of catecholamines itself बेटा. Phenyl ketones, I will check the levels in. Yes, whenever a patient was suffering from PKU or phenylketonuria beta, in those patients I should check for the levels of phenyl ketones like phenyl lactate, phenyl acetate or phenyl pyruvate beta. Clear enough? That will give which kind of odor to the urine. So we know phenylketonuria or PKU में beta, there is a mousy or a musty odor to the urine and the body beta. The mousy or a musty body odor or a mousy or a musty urine odor is a classical feature of PKU or phenylketonuria beta. Which test is done for phenylketonuria? Ferric chloride test is done beta for the urine, and when we add a ferric chloride reagent, the urine of the patient turns green, black or blue. Green beta. In phenylketonuria, whenever you add definitely the ferric chloride reagent, due to phenyl ketones beta, the urine is going to turn green in color. So green urine will be there. Clear? So that is what is important to be remembered. No issues with this. Apart from that, we know beta, in patients of phenylketonuria, yes, there is a feature of mousy or musty body or urine odor, but apart from that, the patient appears like of which ethnicity? अरे कौन सी ethnicity का लगता है patient? Russian beta. ठीक है, so definitely patient is going to have a fair complexion beta. Patient is going to have blonde hair beta, and the patient is going to have blue iris. सबको थोड़ी होता है Russians में. ठीक है, तो fair complexion, blonde hair and blue iris will be there, and yes, definitely some of them will, मतलब phenylketonuria में all of them will have mental retardation. Clear about that is important to remember. Green urine is a feature of phenylketonuria. Black urine will be a feature of. Very good. हमें पता है that whenever the urine turns black on standing or whenever there are black or grey color diapers beta. Yeah, so black urine on standing or whenever there are grey or black color diapers, it is a classical case of alkaptonuria beta. Alkaptonuria is due to a defect in the metabolism of which amino acid? Alkaptonuria happens due to defect in the metabolism of which amino acid? Tyrosine amino acid के metabolism में अगर defect है, then the patient will have alkaptonuria beta. Yes, there will be excess amount of homogenesic acid which will be collected and excreted out from the body beta. Apart from that, patients of alkaptonuria will have blackish discoloration of the sclera and pinna called as. Patient will have blackish discoloration of sclera and pinna known as ochronosis beta. That is important. So ochronosis along with urine turns black on standing is a feature of alkaptonuria. That has to be kept in mind. No issues with this. Last two questions definitely. One is alkaptonuria. What is the enzyme deficiency? Yes, so it is that enzyme deficiency that is seen in alkaptonuria is known as होमोजेंटिसिक ऑक्सीडेज और होमोजेंटिसिक एसिड ऑक्सीडेज, जो भी तुम्हें बोलना है. So homogentisate oxidase or homogentistic acid oxidase is one and the same thing that will be deficient in patients of alkylphenuria. What is enzyme deficient in PKU or phenylketonuria? PAH, that is phenylalanine hydroxylase beta. So we know PAH, also known as phenylalanine hydroxylase beta. This enzyme is actually going to be deficient in patients of PKU or phenylketonuria. Hopefully that's clear to all of you now. Clear? So these are the important topics again from biochemistry that you have to keep in mind. चलो टेक योर लंच ब्रेक डायरेक्टली, इट्स 1, तो 40 मिनट्स, ठीक है ना? हाँ, तो 40 मिनट का लंच ब्रेक ले दो. 40 मिनट का ब्रेक ले लो एंड देन विल गेट बैक आफ्टर 40 मिनट्स. ग्रुप में दोनों टेलीग्राम ग्रुप्स में आफ्टर द सेशन आई शेयर दोनों रिकॉर्डेड वीडियो जो फिर अगर वो अपलोड हो सकता है बात करते हैं.
सर ब्लू यूरिन किस में दिखता है?
ब्लू यूरिन हार्टनम्स में दिखता है.
मल्टीपल माइलोमा में हमने क्या बताया था? बैक है,
लो बैक एक अलॉन्ग विद अनीमिया और साइंस ऑफ रीनल फेलियर. देखने के लिए कौन से मेरे ग्रुप में तक लगे हुए आंसर्स, उसके बाद तुझे अभी तो कंप्लीट नहीं है. हाँ तो मैं वही बोल रहा हूँ, यही PDF चाहिए ना, तो वो शेयर है मेरे ग्रुप में, टेलीग्राम ग्रुप में, एक बार देखता हूँ. मेरा वाला टेलीग्राम ग्रुप कनेक्ट में हार्टनम्स डिसीज. आणि तू काही ॲड करते म्हणजे कॉन्जुगेशन करतो, अटॅच करणं नाही, त्याला कॉन्जुगेशन म्हणतात. एवढं टेन्शन नसते. It is in the group itself, in the Telegram group, either my or the FMG Telegram group. You can just check. The PDF has been shared. इसको बस इस पर डाल दीजिए ऊपर, एंड स्क्रीन पे जो है ना, एंड स्क्रीन पे है ना लास्ट वाला जो पहला कॉलम है उसमें ऊपर वाला कर दीजिए। मैंने एंड स्क्रीन पे डाला हुआ है ना, एंड स्क्रीन के ऊपर वाली जो स्क्रीन होगी ना उसके ऊपर डालो। और एयर सर्वर ऑन कर दीजिए, एयर सर्वर ऑन कर दीजिए बाहर जाके। एयर सर्वर वाला जो स्लाइड क्वेश्चन वाला, चेक कर लो, चेक कर लो। चलो लेट्स स्टार्ट। Hopefully I'm audible. All those online, let me know if the audio visuals are clear once, then we can begin. Here we are having a 75-year-old policeman beta who comes from duty with complaints of pain in the right leg bache, and also the patient is having difficulty in getting a penile erection. Difficulty in getting penile erection is basically called as impotence beta. Whenever a person is not able to get a penile erection, that is known as an impotence. The patient is actually having impotence. Along with that, the patient is having pain in the right leg beta. Apart from that, the patient on examination beta is having a pulse in the pulse in the right popliteal fossa which is there, it is absent. We know if the pulse is absent beta, that means there is a blockage in the artery beta, right? If the artery is getting blocked, that's the reason why the pulse is going to be absent. So they are saying that the pulse in the popliteal fossa or the popliteal pulse which is there beta, it is going to be absent. Okay? Now they are also saying beta that the patient is actually having pain in the right buttock. Okay? Pain in right buttock, whereas in left side beta it was absolutely normal. The block is present at which level, they are asking you. What is going to be your answer? In this condition, definitely if they say. See, if it was a iliac block, definitely I would have agreed that right side ki iliac artery is going to be blocked. Due to that, that right leg is not receiving enough blood supply, causing a pain inside the right leg beta or absent popliteal pulse. Okay? That is important. Okay, even pain in the right buttock can be explained by the iliac blockage. But problem is beta impotence जब वो बोलेंगे, we know if only the right iliac artery was blocked beta. So definitely, please remember, will the patient will have complete impotence? No, na. So in that condition, definitely the patient will get a penile erection, right? So penile erection, or the person will only not be able to get a penile erection, or the person will only have impotence beta when definitely the obstruction is at the level of option C, that is aortoiliac beta. So aortoiliac obstruction called as which syndrome? Lyric syndrome beta. Whenever there is an aortoiliac obstruction called as the Lyric syndrome, in that condition impotence is going to be there. Yes, pain in right buttock, pain in the right leg, and the absent popliteal pulse, all of them were suggestive of iliac obstruction, but only impotence was the reason beta. Why did I mark it as aortoiliac obstruction or Lyric syndrome beta? Clear about? So that is what is important to be remembered. We know whenever there is Lyric syndrome or aortoiliac obstruction, bache, please tell me beta, what is going to be the treatment in this condition? What should be the treatment in this condition? We know we have to use a Dacron graft repair. So whenever beta there is a aortoiliac obstruction, definitely in that condition, the treatment which is there beta, I have to go for a Dacron graft repair. So Lyric syndrome or aortoiliac obstruction, I should go for a Dacron graft repair. That has to be kept in mind. No issues with this? Sure. Next important is question 172 beta. Here they say a neonate was brought to you in the casualty bache with complaints of which kind of breathing? Noisy breathing. I hope all of you are quite aware. Noisy breathing is called as stridor beta. The patient is having noisy breathing or stridor, and stridor happens whenever there is an obstruction of upper airway or lower airway. Upper airway. Whenever there is an obstruction of upper airway, the patient will have a noisy breathing called as stridor. And please remember, this noisy breathing or stridor, it is mainly heard on or mainly heard during inspiration. So it is which kind of a stridor beta? Inspiratory stridor. Important is inspiratory stridor happens whenever there is obstruction at the level of Very good. So whenever there is obstruction at the level of either pharynx or at the level of the supraglottis beta, patient is actually going to have a inspiratory stridor beta. So whenever there is a supraglottic obstruction, patient has an inspiratory stridor. They are saying that the cry sound of the baby or the cry sound of the child is absolutely normal. Yes, we know beta that cry sound will only be affected whenever there is problem with the true vocal cords, that is glottis beta. Yahan pe the problem is not with the true vocal cords, so the cry sound of the child is normal. What is the probable diagnosis? Very good. We know beta the most common congenital anomaly of larynx, okay, known as laryngomalacia, which is seen in the neonate beta, and it is the most common cause of stridor in neonate beta. Answer has to be option D, that is laryngomalacia. In patients of laryngomalacia beta, as the larynx or as the epiglottis is weak beta, it will fall down, causing an supraglottic obstruction beta. Apart from that, this loose epiglottis is going to give me a very classical shape called as. Very good. You are able to see beta the classical omega shaped epiglottis. We know that whenever there is a omega shaped or whenever there is a floppy epiglottis beta which is seen on laryngoscopy, it is a classical picture of laryngomalacia. What is the treatment for laryngomalacia? So we know beta, if they ask you what is going to be the treatment of laryngomalacia, we know it is nothing but reassurance beta. We just have to go for reassurance beta. No treatment is required in this condition because it is self-limiting bache. And important is, this reassurance should be done up to what age? 2 years. Up to 2 years of age beta. So up to 2 years of age in patients of laryngomalacia, I can just go for reassurance beta. But after 2 years of age, what is the surgery that we do? Either we can go for a supraglottoplasty beta or epiglottopexy. So after 2 years of age, if the laryngomalacia doesn't get treated beta, then in those conditions I go for a supraglottoplasty or epiglottopexy. We know laryngeal papilloma which is there beta, please remember that. This is a condition where there will be papillomas or warts inside the larynx, and especially on which side? Vocal cord beta. Barabar, we know na papillomas or warts are usually seen arising from the squamous epithelium, and in the whole larynx the stratified squamous epithelium is only and only present on the true vocal cords or the glottis beta. So if true vocal cords or the glottis would have been affected beta, the patient would have hoarseness of voice, but here they are saying the cry sound of the baby is absolutely normal. Next is acute epiglottitis beta. We know acute epiglottitis is a bacterial infection beta arising from the larynx, and as it is a bacterial infection bache, that is the reason why the child is going to have other features, like there should be a high grade fever, there will be difficulty or pain while swallowing, there will be drooling of saliva, the child will also have an inspiratory stridor, along with which kind of voice? A hot potato voice, and most important, respiratory distress. These are the features which are not seen over here. Next important is laryngocele. Laryngocele is usually seen in which players? Trumpet players beta, and whenever there is going to be a trumpet player having a neck swelling beta, that would be a case of laryngocele. In laryngocele, stridor is not a common feature beta. Clear? Important is, what is this X-ray showing? This is the X-ray soft tissue neck lateral view. This X-ray soft tissue neck lateral view shows me a classical thumb sign, which is due to the swollen epiglottis beta. We know that this thumb sign, which is seen due to swollen epiglottis, is a classical feature of which condition? Acute epiglottitis beta. That is what is important. So it is a classical feature of acute epiglottitis. Okay. Please remember beta, in normal children the leading cause of acute epiglottitis is nothing else but Streptococcus pneumoniae beta. So strep pneumonia or Streptococcus pneumoniae is the leading cause of acute epiglottitis in normal children beta. Streptococcus pneumoniae, also called as pneumococcus. But whenever they say beta unimmunized child, very good. Whenever they say unimmunized child beta, unvaccinated child, then definitely your answer has to be HIV beta, that is Haemophilus influenzae type B. Samjhe baat? A lot of confusion has come across this question again. I'm not sure. These kind of controversies keep on arising again and again and again. Okay. पीडिया वालों में भी डेफिनेटली स्ट्रेप्टोकॉकस निमोनिया लिखवा है. संदीप सर ने क्लियरली क्लास में स्ट्रेप्टोकॉकस निमोनिया लिखवा है. पहले HIV था, पहले OP Ghai used to write HIV. Now it is not HIV, it is strep pneumonia. Even in the pedia books, there is some END faculty who has given HIV as the leading cause. But so please remember beta, that is important. The most common cause is always streptococcus pneumoniae in overall children. Most common unimmunized बच्चे में पूछा जाए तो answer is HIV. That is what is important. Clear? Acute epiglottitis mein beta definitely you have to remember that the treatment is nothing else but we have to take care of the patient's airway. The airway management is a priority. Followed by that you have to give IV antibiotics because it is a bacterial infection. Uske alawa you can give bronchodilators like a nebulization of epinephrine. And last you can give steroids beta to reduce the inflammation and edema. Clear? Next important is this case beta where you are able to see narrow subglottis, and this narrow subglottis is classically called as which sign? Steeple sign. So narrowing of subglottis or stenosis of subglottis gives us the classical steeple sign, and steeple sign on X-ray soft tissue neck AP view is a classical feature of croup beta. Very good. It is a classical feature of croup, and croup is nothing else but another name for acute LTB beta. We know now croup is another feature of acute another name for acute LTB, that is acute laryngotracheobronchitis. So croup or acute laryngotracheobronchitis, the leading cause is going to be which organism? So please remember beta, the most common cause is going to be the parainfluenza virus. So we know croup is basically due to an organism known as parainfluenza virus beta. That has to be kept in mind. Clear about? Important is in patients of croup or acute LTB. Again, the child may have respiratory distress. The child may have a low grade fever. The child will have a very classical cough called as, very good, the child will have a classical barking cough or a brassy cough which will be seen beta. Okay, and the child is going to have which kind of stridor? Biphasic stridor beta. Yes, the child will have a classical biphasic stridor. In patients of acute epiglottitis, which kind of stridor was there? Inspiratory. So we know in cases of acute epiglottitis there is an inspiratory stridor, whereas in croup there is going to be a biphasic stridor. In cases of acute epiglottitis, the child is going to have hot potato voice, which is never seen in patients of croup beta. Rather in croup there will be a barking or a brassy cough. So these are the keywords of the question that you can remember for the examination. Hopefully that's clear to all of you. We know croup or acute laryngotracheobronchitis is a viral infection, and as it is going to be a viral infection, here the first line management is again airway because child will have respiratory distress. Second, we have to give steroids over here beta. Steroids are considered as the drug of choice for acute LTB or croup. And third, we have to give bronchodilators like nebulization of epinephrine again. Important, antibiotics have no role in the primary management of croup. Antibiotics are only given to prevent the secondary bacterial infection, not for the management of croup. Clear? Next important is this picture, X-ray soft tissue neck beta, showing you definitely a dilated saccule. Okay? And this dilated saccule is nothing else but a picture of laryngocele beta. And whenever patient comes to us with a laryngocele, we know the common history that they give is the patient is a trumpet player beta and comes to us with neck swelling. Important is whenever I am going to press the neck swelling beta, air goes out of the neck swelling making a hissing sound. Very good, shout. So theek hai. So if I talk about beta, a hissing sound which is there, that is known as Brice sign or Boyce sign. That is classically known as the Brice sign. Whenever I press a swelling and I am able to hear a gurgling sound, this kind of sound, that is known as Boyce sign. And Boyce sign is a feature of Zenker's diverticulum. The gurgling sound or Boyce sign is a classical feature of Zenker's diverticulum, but hissing sound of Brice sign is a classical feature of laryngocele. And the treatment of laryngocele is nothing else but surgical excision beta. You have to remove or you have to surgically excise beta the dilated saccule. That is the treatment of laryngocele. These four are very common conditions or very common questions of ENT that you have to keep in mind. Clear? Next is question 173. Which of the following cartilages beta does not undergo calcification? So we know beta those cartilages which do not undergo any calcification are called as which type of cartilages? The cartilages which does not undergo calcification are called as hyaline or elastic? We know these are called as the elastic cartilages beta. And we know that if I talk about the elastic cartilages in larynx beta, the most important one is going to be option A, that is epiglottis. Apart from epiglottis, the other two rudimentary cartilages are also elastic in nature. The rudimentary cartilages will be cuneiform and corniculate. So cuneiform and corniculate cartilages are also elastic in nature beta. But the other cartilages which are there, the cricoid, arytenoid and thyroid, all of them are usually hyaline cartilages beta. And as they are going to be hyaline cartilages in nature, all of them are actually going to ossify with age beta. All of them are going to ossify with age. That is important to be remembered. Important is beta. If they ask you which are the 3 unpaired cartilages of larynx, so we know 3 unpaired cartilages of larynx will be thyroid, cricoid, epiglottis. So thyroid, cricoid and epiglottis are unpaired cartilages. The 3 paired cartilages of larynx will be arytenoids, corniculate and cuneiform. So arytenoids, corniculate and cuneiform will be the paired cartilages of the larynx beta. Hopefully that's clear to all of you now. No issues with this. So do remember this. Clear? Next important, if I talk about this question number 174 beta, that states we are having a 2-year-old bottle fed child beta presents to the PHC or the primary health center. He seems to be irritable beta and extremely thirsty since the past 2 days. He has a history of 14 episodes of loose stools beta. The child is having 14 episodes of loose stool in the last few days. Since the child is eager to drink beta, okay, what should be the next best management for this child? We know it is nothing else but a case of diarrhea and dehydration. So as they are saying the child is having loose stools beta, it is a case of diarrhea and dehydration. Whenever a case of diarrhea or dehydration will come to you as a medical officer at the level of PHC beta or a primary health center, we have to follow which guidelines? Very good. We have to follow the IMNCI guidelines, and whenever I say IMNCI, it is integrated management of neonatal and childhood illnesses beta. So integrated management of neonatal and childhood illnesses will be the IMNCI guidelines, where depending on the signs in the child beta, I will classify the child into one of the 3 categories, either the green, yellow or the pink category beta. That is what is important to be remembered. No issues with this, so that has to be kept in mind. Okay. Now important is to be remembered beta. See, if the child is having any 2 of the following signs. What are the 2 of the following signs? First one, either the child appears to be lethargic or unconscious beta, or the child is having very sunken eyes beta, the child is not able to drink, or the child is drinking very poorly beta, or the skin pinch goes back very slowly beta. So whenever the skin pinch goes back very slowly beta. So any of these 2 signs beta, if they are present, we know it is a case of nothing else but severe dehydration. So the child will be classified into the pink category. And if the child is categorized into the severe dehydration, then we have to treat the child according to plan C of dehydration. Plan C of dehydration is nothing else but beta. How much amount of fluid should be given? 100 ml per kg of fluid should be given beta. Oral or IV? So we know 100 ml per kg of fluid should be given over a span of 3 hours or 6 hours beta. If the child is less than 1 year of age, then give it slowly over a span of 6 hours. If the child is more than 1 year of age, then give it faster within a span of 3 hours beta. And that should always be IV fluids, because it is a case of severe dehydration beta. Hopefully clear. Next, if I talk about beta, is nothing else but the yellow category. Now here, if the child is having any 2 of the following signs, what is that? Either the child is restless or irritable beta, or the child is having sunken eyes, or the child drinks very eagerly, or the child appears to be very thirsty, or the skin pinch is going back slowly, then it is going to be a case of some dehydration beta. And that means the child is going to be categorized under which category? Yellow category. The yellow category of some dehydration mein agar bachcha hai, we have to treat the child according to which plan? Plan B of dehydration. And plan B of dehydration mein we have to give 75 ml per kg of fluid beta to the child, 75 ml per kg of fluid to the child over a span of 4 hours basically beta. And that should be given IV or oral. Preferably we should give ORS or IV, ORS or orally beta. But if the child is persistently vomiting, then we have to give IV fluids. So it depends whether the child is vomiting or not. Agar bachcha vomit kar raha hai, to give IV. Otherwise you can just give orally beta. And last is definitely the green category of no dehydration. Here, if the child is not having enough signs to be classified into the yellow or the pink category, you will classify the child into the green category of no dehydration. And green category of no dehydration, if the child is there, then we will treat the child according to plan A of dehydration, where we have to give 5 to 10 ml per kg of fluid beta. We have to give 5 to 10 ml per kg of 5 to 10 ml per kg of fluid beta after every loose stools, and that should be preferably ORS beta or the oral rehydration solution. Hopefully that's clear to all of you now. Chalo, so that is important to be remembered. Now if they ask you, definitely beta, here the child will be classified into which category? Why? The child appears extremely, first of all, the child seems to be irritable. Second, the child is extremely thirsty. Then the child is definitely eager to drink. All of these are the signs beta that the child will be in the yellow category of some dehydration. And if it is a case of some dehydration, we have to use the plan B, that is nothing else but 75 ml per kg over 4 hours. Is the child vomiting over here? No. So can we give ORS? Yes. The answer has to be option A beta. So we can give option A as the answer. ORS 75 ml per kg over a span of 4 hours. Hopefully clear to all of you now. Chalo. Next is question number 175 beta. It states, young lady presents to you with lacy lesions beta inside the oral cavity which is, and her proximal nail fold which is there. That proximal nail fold has extended onto the nail bed beta. She has a history of dental amalgam. That dental amalgam is important risk factor beta. Okay. What is the likely diagnosis of the case? First of all, yes, you are able to see beta these classical lacy lesions inside the oral cavity beta. Okay. These kind of lacy or reticulate lesions are usually seen inside the patient's oral cavity which is, that is what is important. Apart from that, patient is having proximal nail fold extending up to the nail bed. What is this called as? Very good. This proximal nail fold extending up to the nail bed beta is classically called as a finding known as pterygium. And we know pterygium is the most characteristic nail finding seen in patients of lichen planus. So it is the most characteristic nail finding seen in patients of lichen planus beta. So yes, it is more likely to be a case of nothing else but option C, lichen planus. And we know lichen planus में a history of dental amalgam is going to be usually there beta. Clear है बात? Psoriasis होता तो are oral lesions common in psoriasis? No. Psoriasis में oral lesions are very rare beta. That is important to be remembered. Second important thing, psoriasis में yes definitely beta there can be a rash on the body which is seen, but the rash in patients of lichen planus which is there beta. Do you remember that rash is going to be which kind of rash beta as you are able to see over here? It is going to be in case of lichen planus the rash which is there beta. The lichen planus. Lichen planus में the rash which is there beta. It is definitely going to be purple, plain topped, pruritic papules beta. So there will be purple, plain topped, pruritic papules. These are the features of lichen planus. अगर वो कोई psoriasis होता है बेटा, in patients of psoriasis, then there are not purple, plain top, pruritic papules. Rather, there are going to be definitely rash beta with which kind of scales? Silvery scales. If it was a case of psoriasis, then the patient should have had rash with silvery scales beta. That is a keyword of psoriasis definitely. And third, nail finding. We know in patients of in patients of lichen planus beta, the nail finding that we have discussed was pterygium which has been described. But agar psoriasis hota, so psoriasis mein most common nail finding will be? Most common. Most characteristic hai. Most common anybody? Thimble nails beta. The most common nail finding which is there, it is pitting off nails, na? That is thimble nails definitely beta. And yes, the most characteristic will be oil drop sign. So thimble nails, your oil drop sign definitely, if these were the features, then yes, we would have thought about psoriasis as the answer beta. That is important to remember. Leukoplakia, yes, leukoplakia is a whitish lesion inside the oral cavity. It is a whitish patch in the oral cavity beta. But is it associated with dental amalgam? No. It is commonly associated with problems like smoking, tobacco, betel nut, areca nut. ये वाली history होती, so I would have thought about leukoplakia. And second important, is leukoplakia associated with pterygium in the nail? No. So that is out of question. Oral candidiasis. Oral candidiasis में lacy lesions are not seen in the oral cavity. Curdy white patch is seen beta in the oral cavity. There is a curdy patch inside the oral cavity beta. And what history should have been given? Very good. They would have said that the patient is a known case of bronchial asthma, currently taking steroids beta. So here definitely they would give a history of a patient of asthma beta on treatment. So they will say a patient of bronchial asthma who is currently taking the treatment, that means taking the inhaled corticosteroids. We know if the person takes inhaled corticosteroids in asthma, that causes local immunosuppression, increasing the risk of fungal infections like oral candidiasis or oral thrush, commonly repeated FMG and DPG PYQ. इसीलिए what should be the advice whenever you prescribe the inhaled corticosteroids to a patient of bronchial asthma? So whenever you prescribe inhaled corticosteroids in a patient of bronchial asthma beta, you have to remember one thing, that we have to definitely prescribe we have to tell the patient to rinse or wash the mouth after taking the inhaler beta. That is important to remember. Clear about? So These are definitely the features that have to be remembered. Okay, so that is how you rule it out. Now, okay, done with all of this. Chalo. Lichen planus is an autoimmune disorder, so treatment will be steroids. So treatment has to be steroids. Question number 176 beta. Here we are having a 5-year-old which is suffering with chronic epiphora. What is epiphora, anybody? Excessive watering from the eyes is basically called as epiphora beta. So excessive watering or excessive lacrimation from the eyes is known as epiphora. We know whenever there is excessive watering or excessive tearing from the eyes beta, that means the patient's nasolacrimal duct has been blocked. Clear? The patient has been brought to the clinic beta. What is the next step in management they are asking you? So we know beta the child is more than 4 years of age. Whenever the child is more than 4 years of age beta, we know what are we suspecting over here. If a child is having chronic epiphora or excessive watering from the eyes, we are suspecting that the nasolacrimal duct is blocked, and due to which the child can have definitely a dacrocystitis. Whenever the nasolacrimal duct is blocked, obviously beta the tears are not able to drain, and due to that the lacrimal sac will get infected, classically known as dacrocystitis beta. And if it is a case of dacrocystitis, obviously what should be done in this condition beta? We have to go for nothing else but option B, that is dacrocystorhinostomy, that is DCR surgery. Dacrocystorhinostomy or DCR surgery mein beta, we have to create a new opening for the nasolacrimal duct. Now I am asking you, normally the nasolacrimal duct opens in which meatus? Normally. So we know beta that normally the nasolacrimal duct opens in the inferior meatus. But in the DCR surgery, when we create a new opening, that should be made in. Very good. The new opening that is created beta for the nasolacrimal duct, it has to be created in the middle meatus. That is what is important to remember. Next important, syringing is usually done. Syringing or probing is usually done when the child is between 1 to 4 years of age beta. So please remember, probing ho ya syringing ho, both these are usually done when the child is going to be between 1 to 4 years of age beta. That has to be remembered. Clear? Whereas if they ask you definitely beta, that sac massage, that is a regular sac massage, it is usually done when the child is less than 1 year of age. So whenever a child having NLD blockage is less than 1 year of age beta, in those conditions we tend to go for a regular sac massage beta. Hopefully that's clear to all of you now. Chalo. Done. Next important, if I talk about, is question 177 beta. Here they are asking you, a new drug is introduced in the market. A new drug is introduced in the market beta, before which phase of clinical trials? So please remember beta, before which phase of clinical trial? Answer has to be option D, that is phase 4. अब याद रखना y PYQ इसीलिए नहीं रखना होता कि in a PYQ they have asked you that drug is launched in the market after which phase of clinical trial? After phase 3 but before phase 4. Clear? So obviously that is important. No? I have just changed one word. That is what is important. Clear? So that is important. Phase 1 which is there of clinical trial is done on patients or healthy humans. So we know beta, phase 1 of clinical trials is usually done on the healthy human volunteers. And what is the aim of phase 1? Phase 1 ka aim is nothing else but very good. Phase 1 will tell you about the safety of a drug or the maximum tolerable dose. The maximum tolerable dose or the safety you get to know from phase 1 of the clinical trial. Next, phase 2 is done on patients or healthy humans. We know beta that patients are taken in the phase 2 basically, and phase 2 is done for efficacy determination. Whenever you have to determine the efficacy of the drug beta, you will definitely carry out the phase 2. Next is phase 3. Phase 3 is again done on patients. So we know beta phase 3 is also done on patients. And what we do in phase 3? So we know beta that phase 3 may you have to compare the new drug with an existing drug beta. Okay? So comparison with an existing drug is done in phase 3 with the help of which study? RCT beta, with the help of RCT, that is randomized controlled trial beta. That is important. And last is phase 4. What is done in phase 4? So please remember beta, in phase 4 we have to carry out the post-marketing surveillance. So post-marketing surveillance is carried out in phase 4, and that is done to know about various side effects beta. So to know about the long term and the rare side effects of the drug beta, we have to carry out phase 4, that is a post marketing surveillance. Hopefully that's clear. Maximum failure, PYQ, maximum failure is seen in which phase of clinical trial? Very good. So please remember beta, maximum failure is usually seen in phase 2 of the clinical trial beta, where we determine the efficacy. Next important, what is the most important phase of clinical trial? So please remember, the most important phase of clinical trial is phase 3, because RCT is carried out in the phase 3 of clinical trial beta. That is important. Which is the longest phase of clinical trial? Phase 4 beta. Phase 4 is considered as the longest phase of clinical trial. Remember these 3 one-liners, they are important. Hopefully clear to all of you now? Clear? Sure. Next important, if I talk about now, that was all about your clinical trials. Phase 0, which is there, it is added for microdosing. Phase 0 is done in healthy human volunteers, and it is usually done for microdosing. Question 178 beta. Here we are having a patient who underwent a hysteroscopic procedure which is for the purpose of septal resection. This procedure took more time than the expected beta. Procedure took more time than expected, and the patient after the procedure or after the surgery has altered sensorium beta, along with vomiting and seizures after few hours of surgery. Patient has altered sensorium, vomiting and seizures after few hours of surgery. What might be the underlying electrolyte disturbance responsible which is? So what is the likely disturbance responsible? I have taught you this in surgery itself. I hope I have told you that this is not only applicable for TERP, it is also applicable in any surgery wherever we want to use irrigating fluid. Clear? So यहाँ पे for hysteroscopic procedure beta, for septal resection, we might have used irrigating fluid beta. Now the irrigating fluid that we should use at the surgical site during surgery beta, it should be isotonic, hypotonic or hypertonic. So it should be isotonic beta. So the best fluid used for irrigation beta. The best irrigation fluid that is used beta, it is usually isotonic glycine. Barabar? Isotonic glycine is going to be the best fluid. Isotonic means same concentration as that of plasma. So if a fluid is having same concentration as that of plasma, it's called as isotonic. And we know best fluid should always be isotonic fluids beta, like isotonic glycine, so that there is no movement of water beta across the membrane. Okay? But in case beta, if you use a irrigating fluid which is hypotonic in nature, hypotonic means more or less concentration than plasma. So hypotonic fluid का मतलब the fluid which has less concentration than plasma beta. Less concentration मतलब something like 5% dextrose or a distilled water. So 5% dextrose or distilled water, these are considered as hypotonic fluids. Now, if you are going to use a hypotonic fluid बच्चे, okay, during irrigation or during a surgery, what will happen? A lot of that fluid gets absorbed inside the blood vessel. In simple terms, I am telling you, a lot of fluid gets absorbed in the blood vessel अगर वो hypotonic होगा. And if a lot of fluid will get, a lot of water will get absorbed in the blood vessels, plasma will get diluted or concentrated. So if a lot of fluid is absorbed inside the blood vessel, plasma will get diluted beta. And see, if a lot of water has come in the plasma and the plasma has got diluted, so the water level has increased, but the sodium level is still the same beta. And due to dilution, it appears as if there is a dilutional or a relative hyponatremia. Actually sodium की level normal ही है, but उस dilution की वजह से, वो ज़्यादा पानी की वजह से ऐसा लगता है बेटा that if the sodium levels are low. So due to use of the hypotonic fluid beta, there is definitely going to be water intoxication, because a lot of water gets absorbed inside the vessel beta, and due to this water intoxication there is dilution of plasma causing a dilutional hyponatremia. And due to dilutional hyponatremia beta, the patient is going to have features like altered sensorium, confusion, disorientation, seizures, nausea, vomiting. समझे बात? So answer has to be nothing else but option A, that is hyponatremia beta. Hopefully clear to all of you. तो surgery के बाद इतना याद रख लेना, after surgery they are saying that the patient is having CNS related symptoms along with nausea and vomiting. Think about dilutional hyponatremia as the cause beta. ठीक है? So that is what is important to be remembered. We know, जो potassium बोल रहे थे, मुझे बताओ potassium, does potassium cause any CNS related side effects or what? No. तो अगर hyperkalemia या hypokalemia कुछ भी होता, my patient would have muscle weakness. right? Muscle related symptoms are common with potassium, तो muscle weakness, fatigue, ऐसे कोई features या heart related features अगर होते हैं तो I would have thought about potassium, ठीक है? Here तो there is no role of potassium at all, clear है बात? So that is important. No issues with this. Treatment should be what? जब भी patient में there is a water intoxication or a dilutional hyponatremia, the treatment is fluid restriction. You should not give a lot of fluid because already a lot of fluid has got absorbed inside the blood vessels and the patient is having excessive water in the blood vessel beta. So fluid restriction has to be done. And if there is severe hyponatremia, sodium levels are appearing to be very low, then you can give sodium from outside. Sodium rich fluid is 3%. Hypertonic saline. Then you can give definitely a 3% hypertonic saline, which is a fluid rich in sodium beta. Hopefully clear? So yeah, next important is question 179 beta. Here they are saying that a female got accidentally pregnant beta and wanted to get a MTP done. Favorite question of your examiner nowadays. MTP is nothing else but medical termination of pregnancy. Now, again I am telling you one thing. Yes, MTP is a very favorite question of the examiner. Yes, we expect MTP to be there in the examination, but that doesn't necessarily mean that in each and every examination you will get MTP. Because I've seen a lot of times you go with some expectations in the examination hall. ये तो आएगा ही, ज़रूरी नहीं होता. Clear? There would be some common topics. Doesn't necessarily mean every time the same topic is going to be repeated. Clear? So even if you are not able to find these kind of questions, there will be some other easy topics or the other repeated topics. ठीक है? So be focused over there. Don't just get depressed कि नहीं वो तो पढ़ा था इतना अच्छे से वो आया नहीं. That's fine. होता है. 300 ही questions आएंगे. ठीक है? So that is important. एक एग्जाम ऐसा था जिसमें एक भी CG का क्वेश्चन नहीं था, एक भी ABG का क्वेश्चन नहीं था. 2022 जून. ठीक है? That's fine. Now important is we have got like the female wants to get a MTP done. Which among the following beta is the condition? Which among the following condition में we cannot perform a MTP beta? That is what they are asking. So very good. We know beta, is maternal distress an indication? Yes. If maternal distress is there or if mother's life is in danger, we should go for a MTP or a medical termination of pregnancy. Is eugenic grounds an indication? Yes. What is eugenic grounds? Fetal chromosomal anomaly is basically called as eugenic grounds beta. ठीक है? So please remember, whenever there are fetal chromosomal anomalies, so if there are fetal chromosomal anomalies beta on the eugenic grounds, can I do MTP? Yes, MTP or medical termination of pregnancy can be done on eugenic grounds as well beta. That is what is important to be remembered. Clear about? Next important, failure of contraception beta. Failure of contraception, is it the indication? Yes, we can also do MTP beta if there is a failure of contraception. But if I compare all the options which are available over here, large family size doesn't seem to be a correct option beta where we can get a MTP done. So answer has to be option B. That is option B is the condition beta where we will not perform a MTP based on the options that are given. Clear about? Now important is हमें पता है MTP which is there beta, it can be done up to maximum what time according to the recent MTP Amendment Act in 2021. So please remember beta, MTP can definitely be done up to 24 weeks beta. MTP can definitely be done up to 24 weeks beta according to the recent MTP Amendment Act that we have to keep in mind. Which are the conditions जहाँ पे we can go for a MTP up to 24 weeks? 3 conditions. First is definitely maternal distress beta. Second is definitely maternal distress or mother's life is in danger. Second is fetal anomalies beta. So any chromosomal anomaly in the fetus which is deadly. Okay, any lethal fetal anomalies beta. Or third will be humanitarian grounds. Humanitarian grounds like example will be rape victim, incest victim, or the victim is very minor beta. Barabar, in these kind of conditions. Important is in cases of contraceptive failure, we can go for MTP only up to how many weeks? So we know that in case of failure of contraception beta, MTP is usually only done up to the span of 20 weeks beta. That is important to be remembered. One thing. Second important, if I talk about beta, that is which is the condition where MTP can be done beta even after 24 weeks and without any permission of medical review board. Even after 24 weeks without any permission from the medical review board. What is that condition? Very good. Maternal distress or mother's life in danger. So if mother's life is in danger beta, I don't even need any permission from the medical review board. As a life-saving measure, I can perform MTP even after 24 weeks. Next important is beta if I talk about is which is the condition where you can do an MTP even after 24 weeks, but with the permission of medical review board. Fetal anomaly. So fetal anomalies is a condition where MTP can be done even after 24 weeks, but only and only with the permission of the medical review board. Beta. Who are the 4 members in medical review board? First is obstetrician and gynecologist. Second is a pediatrician. Third is radiologist, and fourth is a government appointed officer. Beta. Any government appointed officer. Lawyer is not a part of the medical review board. That is important to remember. Recently, like you thought. Clear about? Hopefully, no issues with this. Chalo. Question number 180, if I talk about beta, here we are having a pregnant female who has been brought to us at 33 weeks period of gestation beta, and she is a known case of gestational hypertension, and she was brought to the casualty or emergency now beta with a history of seizure episode at home, and she was started on treatment, but you suspect beta that she has landed up into a drug toxicity beta. What is the first sign that you are going to expect? मुझे पहले ये बताओ डायग्नोसिस क्या हुआ फीमेल का? डायग्नोसिस किसके लिए उन्होंने ड्रग स्टार्ट करी? तो वेरी गुड. पेशेंट वाज अ नोन केस ऑफ जेस्टेशनल हाइपरटेंशन. मे बी द पेशेंट्स ब्लड प्रेशर वुड हैव सडनली स्पाइक बेटा. उसके साथ साथ उन्होंने बोला द पेशेंट इज हैविंग जनरलाइज्ड टोनिक क्लोनिक सीजर्स. So it can be a case of eclampsia. What is the drug of choice for eclampsia? We know beta that the drug of choice for eclampsia which is there, it is nothing else but MgSO4. And if I talk about MgSO4, it is given IV or IM? It is given both beta, IV plus IM, called as which regime? Pritchard's regime beta. So IV 4 grams and IM 10 grams beta. According to the Pritchard's regime, 14 grams of loading dose has to be given to the patient beta. Okay, so that is important. Magnesium sulfate is not only the drug of choice for eclampsia, it is also the drug of choice for which type of arrhythmia? Very good. Torsades de pointis. Torsades de pointis or polymorphic ventricular tachycardia may be the drug of choice is MgSO4 or magnesium sulfate. Important is magnesium sulfate is a narrow or wide therapeutic index drug? Narrow. So chances of MgSO4 toxicity are very, very high. So that's the reason the patient has landed up into a drug toxicity. So the patient is actually landed up into nothing else but MgSO4 toxicity. And what should be the normal level of MgSO4 in the blood? 4 to 7 beta. It should be 4 to 7 milliequivalents per liter. But if the magnesium exceeds more than 7 milliequivalents per liter, patient will develop magnesium sulfate toxicity. And the earliest feature for that has to be option B, that is loss of patellar reflex. Either you will say loss of patellar reflex or loss of deep tendon reflexes beta. The loss of deep tendon reflexes will be the earliest feature of MgSO4 toxicity. That has to be kept in mind. इसके बाद patient may have respiratory compromise and ultimately the patient may also have beta a cardiorespiratory arrest as well. That is important. ठीक है? So yes, respiratory depression can also be seen. Okay. Or even hypotension or low BP can also be seen, but definitely beta even oliguria can be seen, but they are late features beta. The earliest sign is always loss of patellar reflex. That is important to be remembered. Clear? What is the drug of choice in patients of MgSO4 toxicity? It is IV calcium gluconate beta. We know if there is more amount of magnesium, you have to just give calcium gluconate beta, which is the drug of choice for nothing else but MgSO4 toxicity. Now, if they would have said beta that the patient is a case of eclampsia, matlab they would have said patient is having high blood pressure, patient is having proteinuria, patient is having generalized tonic-clonic seizures, and the patient is having end organ damage. In those conditions, what should have been the first step in management? So, a case of eclampsia hai, high BP, proteinuria, end organ damage and seizures. What is the first step in management? Very good. So, answer is nothing else but basic resuscitation. The first step in the treatment beta to be done in case of eclampsia is always basic resuscitation. It is neither termination of pregnancy, it is nor magnesium sulfate. Samjhe baat? First line treatment is always basic resuscitation. That is take care of the patients A, B, C. That is airway, breathing and circulation. That has to be a priority. Okay. So that is important beta. So basic resuscitation or ABC has to be taken care of. Either they will give airway management, basic resuscitation, or shift the patient into left lateral position in the option. That has to be the next line or the first line treatment in eclampsia. Drug of choice is FMGEJULY2025. And lastly, definitive management agar wo puchenge, final treatment will be what? Then the answer is termination of pregnancy. And termination of pregnancy is usually done by which route? Whether you will go for a NVD or a C-section. So please remember, termination of pregnancy in case of eclampsia will be done by cesarean section. For example, a female is less than 34 weeks period of gestation. A female is less than 34 weeks period of gestation. What is the definitive management? Steroids दे दो उसके बाद. Definitive management will be termination of pregnancy. So even a female of eclampsia, if she is even less than 34 weeks, beta, doesn't matter. Always the treatment has to be termination of pregnancy or a cesarean section. Eclampsia is an obstetric emergency. You cannot leave the female undelivered. Clear about? So treatment is always a termination of pregnancy or a cesarean section, beta. Hopefully clear to all of you now. So that is important. Next is question 181, beta. Here they are asking you definitely. We are having a 14-year-old girl, beta, who presents to you with well-developed breast. Okay? So she is having well-developed breast, beta, and there is presence of pubic and axillary hair also, beta, according to Tanner stage 4. Okay, her mother is worried as she has not got her periods yet, beta. If a female has not got her periods, that is a case of primary amenorrhea, beta. Okay, if menses have never started, it is a primary amenorrhea. If there were regular menses which have stopped, then that is secondary amenorrhea. So when menses never start, it is primary. When the regular menses have stopped, it is secondary. Most common cause of secondary amenorrhea will be? It is pregnancy. Most common cause of secondary amenorrhea will be pregnancy, beta. That is important. Most common cause of primary amenorrhea, anybody? Turner syndrome, that is nothing else but gonadal dysgenesis. So most common cause of primary amenorrhea will be gonadal dysgenesis. Conditions definitely, beta, where the gonads are not properly formed. Conditions like Turner syndrome, or the another one will be Swyer syndrome, beta. Now primary amenorrhea ka diagnosis will be done based upon, beta, the secondary sexual characteristics. Secondary sexual characteristics is nothing else but the breast and the pubic hair, beta. Okay? So you will check for the breast development and you will check for the pubic and axillary hair development. If they say, beta, that the secondary sexual characteristics, that is breast, pubic hair and axillary hair, all of them are definitely, beta, absent, then we will diagnose primary amenorrhea after age of 13 years. Then you will diagnose primary amenorrhea after age of 13 years, beta. But whenever the secondary sexual characteristics, that is the breast development, pubic hair and axillary hair, all of them are present, you will diagnose primary amenorrhea after the age of 15 years, beta. So here definitely they are saying that the patient is having the secondary sexual characteristics. They are saying there are well-developed breast. They are saying there is pubic and axillary hair. In which stage? Almost Tanner stage 4. There are total 5 stages. So it is in Tanner stage 4, matlab well-developed pubic and axillary hair, beta. So obviously we know it is a case of this one when the secondary sexual characteristics are normally present. And we will diagnose primary amenorrhea only after the age of how many years? 15 years. Is she 15 years of age? No, she is still 14-year-old girl, beta. So can we wait for some time? Yes, we can wait definitely, beta, for some time, and therefore the answer has to be option B, that is reassure the mother. Just do a reassurance of the parent, beta, that yes, she will get her periods in due time. Clear? If she would have been more than 15 years of age, if they would have said that she is a 16-year-old girl having primary amenorrhea with a normal secondary sexual characteristic, then my next step would have been very good. If she would have been more than 15 years of age, basically, beta, then my next step answer would have been option A, that is ultrasound pelvis, beta. That is what is important. Okay? Ultrasound pelvis ke saath, if you are not able to get any diagnosis properly, then you can definitely go for the serum LH and FSH levels also. That is what is important. Hopefully that's clear to all of you now. Sorry. If I talk about the next one, that is question number 182, beta. Here we are having a 2-month-old baby who is having a watery discharge from the umbilicus. This is most likely due to which problem? Anatomy and pediatric. बोलो. अरे तुम्हें सब्जेक्ट नहीं पूछा, वो मैं बता रहा हूँ कि एनाटॉमी या पीडियाट्रिक क्वेश्चन है ये. I am asking. So please remember, this 2-month-old baby basically having watery discharge from the umbilicus. What is the basic problem, beta? So we know watery discharge from umbilicus is urine or meconium. So you definitely urine is coming out from the umbilicus beta. And whenever urine is coming out from the umbilicus, we know beta that definitely a connection is there between the urinary bladder and the umbilicus. The connection between urinary bladder and umbilicus is called as the allantois or the urachus beta. So यहाँ पे क्या हुआ है that the allantois or the urachus has not got closed or it has not disappeared, and therefore beta the urine is coming out from the baby's umbilicus. So complete patency, okay, or failure of involution of the allantoid duct or the urachus is the reason for this beta. If they would have said that the meconium is coming out from the baby's umbilicus, then what would have been the answer? A, B, C, D. Barabar. If they would have said beta that meconium is coming out from the baby's umbilicus, then there would have been an abnormal connection between the midgut, that is intestine, and the umbilicus beta. And that connection which is there is called as vitello-intestinal duct, also called as omphalomesenteric duct. That should disappear. But if there is failure of involution, or if that omphalomesenteric does not disappear beta, then definitely the baby will have meconium beta. Then definitely the baby will have meconium coming out from the umbilicus. Very good. The baby is going to have meconium from the umbilicus beta. Hopefully clear to all of you now. Chalo. So that is what is important to be remembered. Done with this. Next important if I talk about beta is question number 183. It states we are having a 35-year-old recently divorced male beta who is suffering from palpitations along with headache and diaphoretic episodes. What is diaphoresis? Excessive sweating is known as diaphoresis. On a recurrent basis, he has visited psychiatrist multiple number of times beta. What should be the next best step for the management of this case? Very good. We know this is a classical triad, that is palpitations, headache and diaphoresis beta. It is a classical triad of which condition? Very good. The provisional diagnosis of this case is nothing else but pheochromocytoma beta. We know that pheochromocytoma is a neuroendocrine tumor mainly arising from the adrenal cortex or medulla. So we know pheochromocytoma is mainly a tumor arising from the adrenal medulla, which are known to secrete excess amount of catecholamines beta. And as they secrete excess amount of catecholamines beta, we know catecholamines are sympathetic or parasympathetic in nature. As catecholamines like epinephrine, norepinephrine and dopamine beta, they are sympathetic in nature. Patient will have all the sympathetic symptoms, like there will be a episodic hypertension causing episodic headache definitely. Patient is going to have tachycardia causing palpitations, and the patient is also going to have definitely beta excessive sweating called as diaphoresis. Pheochromocytoma follows which rule? Recent NEET PG PYQ. So we know beta it follows the rule of 10. Based on this there was a PYQ NEET PG beta. They asked you which among the following statement is false. So yeah, that now rule of 10 mein we know that pheochromocytoma it is 90% cases mein benign, only 10% cases are malignant. Next, 90% cases are seen in adults, only 10% cases are seen in children. 90% cases of pheochromocytoma are adrenal in origin, only 10% cases are extra adrenal beta. Clear about? And only 90% cases are going to be unilateral, only 10% cases will be bilateral. That is the rule of 10 we follow for pheochromocytoma beta. No issues with this. If they ask you what is the screening test, it is definitely we have to go for 24-hour urinary. So 24-hour urinary metanephrine levels or PMA levels or catecholamine levels. तीनों में से जो भी ऑप्शन में you can mark beta. Metanephrine will be a better choice. So if 24-hour urinary metanephrine, VMA or catecholamine levels beta, that is considered as the screening test for pheochromocytoma. And what is the investigation of choice for pheochromocytoma? Very good. So we know beta the investigation of choice for pheochromocytoma is plasma fractionated metanephrines beta. So plasma fractionated metanephrines is actually considered as the investigation of choice in the patient of pheochromocytoma or repeated PYQ and FMGEJULY. Okay, they are more interested in asking you the investigation of choice for pheochromocytoma. So please remember, investigation of choice बच्चे पूछे तो answer has to be plasma fractionated metanephrines. To localize the tumor, you can go for MRI abdomen beta. Clear? Now important is, यहाँ पे we are suspecting pheochromocytoma, therefore the next step has to be option B, that is check for the catecholamine levels of the patient. he should be started on behavioral therapy. No beta, first try to make a diagnosis. It doesn't seem to be a psychiatric disorder, it seems to be a case of pheochromocytoma. Next test, क्यों हमने psychiatric disorder सोचा होगा या क्यों patient psychiatrist के पास गया होगा? So obviously palpitations, headache, ठीक है, and a divorced male, ठीक है. So obviously after divorce if he is getting palpitations, headache, diaphoresis, beta, they can think about definitely beta any kind of stress disorder or anxiety disorder. ठीक है, इसीलिए that is the reason they would have given this. Next important option C says check for serum TSH to rule out hyperthyroidism. No, hyperthyroidism में there should be other features beta which will be there. There should be diarrhea due to increased GI motility. The patient definitely should have heat intolerance. The patient should be extremely thin. There should be weight loss which will be seen beta. ठीक है, other features should be there. No other feature is there apart from sympathetic overactivity. So that is the reason beta. Option D says increased dose of anti-anxiety medications. So again beta, it doesn't seem to be a case of anxiety disorder, it seems to be a case of pheochromocytoma. Hopefully that's clear to all of you now. That is important. Chalo. Now in treatment we know pheochromocytoma के लिए mainly the treatment is surgical or medical. So mainly treatment of pheochromocytoma is surgery or surgical resection of the tumor beta. Important to be remembered. अगर वो पूछते हैं question of pharmacology in your FMG exam, preoperative hypertension, drug of choice. तो preoperative preoperative hypertension beta, drug of choice for pheochromocytoma will be phenoxybenzapine. What one thing I have observed in class or even in online people is you all know these topics really well, but you are so afraid, you are so anxious at this point of time that you are not able to recall things. Just curb down your anxieties. मैंने तुम्हें पहले भी बोला, अगर एंशियस रहे रिजल्ट खराब जाएगा. तो एक बार जो नहीं पढ़ पा रहे हो दैट्स फाइन, नहीं मत पढ़ना, कुछ क्वेश्चंस करो चलेगा, बट मोर इम्पोर्टेंट इज मैनेज योरसेल्फ. इफ यू आर नॉट एबल टू मैनेज योरसेल्फ इन दिस लास्ट 4 days बेटा, दैट विल डेफिनेटली नॉट हेल्प यू. ठीक है, दैट विल रादर वर्सन व्हाट यू हैव स्टडीड अंटिल नाउ. ठीक है, तो अभी बस तुम्हें याद है सब चीजें, बट प्रॉब्लम है तुम कंफ्यूज हो रहे हो, तुम्हें नहीं याद आ पा रही है बिकॉज ऑफ योर एंजाइटी. प्लीज कंट्रोल एंजाइटी. Okay, focus on it, focus on yourself, make things that definitely do things that make you happy. इसका मतलब ये नहीं दारू लेके बैठ जाओ, but still definitely just calm down and focus on yourself, your mental health and mental sanity at this point of time. Clear? So preoperative hypertension में बेटा drug of choice is nothing else but phenoxybenzapine बेटा. Next important if I talk about what is the drug of choice for intraoperative hypertension. तो वी नो इंट्राऑपरेटिव हाइपरटेंशन की अगर मैं बात करूँ तो द ड्रग ऑफ चॉइस इज IV फेंटोलामीन बेटा. सो IV फेंटोलामीन इज द ड्रग ऑफ चॉइस फॉर इंट्राऑपरेटिव हाइपरटेंशन. एंड इंट्राऑपरेटिव हाइपरटेंसिव क्राइसिस के लिए वी कैन गिव सोडियम नाइट्रोक्लोराइड. फॉर इंट्राऑपरेटिव हाइपरटेंसिव क्राइसिस वी कैन गिव सोडियम नाइट्रोक्लोराइड बेटा. दैट इज इंपॉर्टेंट टू रिमेंबर. क्लियर? चलो नेक्स्ट इज क्वेश्चन 184 बेटा. It states on post-operative day 2, routine X-ray was performed which appeared normal beta in this patient. ठीक है, the patient is complaining of mild respiratory distress and the patient is comfortable beta in the hospital bed. On bilateral auscultation बच्चे equal air entry is heard. That is equal amount of air is going in both the lungs beta. SpO2 level of the patient which is there beta, it is normal on room air. मतलब the saturation of oxygen is absolutely normal. What is the next step in the management of this patient? So answer is nothing else but option A, wait and watch. Patient is having mild distress beta, patient is comfortable in his position, patient is having a normal SpO2 on room air. क्यों कुछ करोगे तुम? हाँ, तो एक्सरे वॉज परफॉर्म्ड, एक्सरे भी नॉर्मल है. वो तो दिया ही नहीं था ना क्वेश्चन में. व्हेन आई गिव द क्वेश्चन बेसिकली देयर वाज नो एक्सरे गिवन इन द क्वेश्चन. सो दैट इज इंपॉर्टेंट. अगर सब कुछ नॉर्मल है बेटा तो ऑब्वियसली वी डोंट हैव टू डू एनीथिंग इन द पेशेंट, जस्ट वेट एंड वॉच. देयर इज जस्ट माइल्ड रेस्पिरेटरी डिस्ट्रेस बेटा, नथिंग टू बी डन ओवर हियर एज ऑफ नाउ. क्लियर है बात? सो दैट इज इंपॉर्टेंट. याद रखना, lot of times in the post-op period, I'm not saying always, but sometimes it is just the patient's perception that he is uncomfortable at times. ठीक है, a lot of times nothing happens. Maximum अगर करना होता है कुछ, अगर patient में distress शुरू भी होता है but SpO2 normal लगता है, then in those cases we give some oxygen or we give some nebulization. That's it. ठीक है, so that is what is important. Yes, it could be a case of tension pneumothorax which can occur, and tension pneumothorax अगर होता the patient would have a severe respiratory distress बेटा, ठीक है, patient would have severe respiratory distress, and apart from that when I do a percussion the patient would have which features? Pneumothorax is collection of fluid or air? Air, and when there is air collection you will get dullness, na? Then hyperresonance, very good. So please remember beta, tension pneumothorax is any pneumothorax which can cause a hemodynamic compromise in the patient beta, ठीक है, so definitely the patient will have a severe respiratory distress. Second important beta, the patient will definitely have low blood pressure beta, or the patient will have hypotension. Third important, the patient will have congested neck veins or rise in the jugular venous pressure beta. Clear, but these are the usual features. Now when I definitely do a percussion beta, please remember percussion pe there will be hyper resonance which will be noted, and when I do an auscultation pe what will be there? Affected side mein there will be more air entry or less air entry. So definitely when you do an auscultation beta, there is definitely absent air entry or a decreased air entry beta on the affected side. So absent air entry and absent breath sounds are usually seen beta on the affected side. That is what is important. So auscultation is the most important feature beta. If auscultation shows you absent air entry and absent breath sounds on the affected side, it is a case of tension pneumothorax. And if auscultation tells you muffled S1 and S2 or muffled heart sounds, it is a diagnosis of. Because बाकी जितने features देखे मुझे बताओ, are they common between tension pneumothorax and cardiac tamponade? Yes. That's the reason auscultation will be very important to be done beta. Auscultation में अगर absent air entry and breath sounds है, it is a diagnosis of tension pneumothorax. And auscultation में beta, if there are muffled heart sounds or muffled S1 and S2, that is a case of cardiac tamponade. Clear? बाकी features can be seen. Chest X-ray and tension pneumothorax will show you this white shadow, and that white shadow is nothing else but collapsed lung beta. On affected side there is more blackening or more whitening? On affected side there is more blackening called as hyperlucency beta. Apart from that there is a deep costophrenic angle called as which sign? Deep sulcus sign beta. So chest X-ray shows you a deep costophrenic angle, classically called as the deep sulcus sign on the X-ray. And the trachea is shifted to the same or opposite side? The trachea will get shifted to the opposite side beta. That is important. These are the features on chest X-ray in a patient of tension pneumothorax. What is the emergency management for tension pneumothorax? So we have to insert a wide bore needle basically beta inside the intercostal space so that the air from the pleural cavity is able to escape beta. That is needle thoracocentesis. Now again, recently there was some YouTube session, and again people told me or people sent me a question, sir, thoracocentesis and thoracostomy both are there in option and all of that. So please remember beta, definitely when you make a wide opening, that is what is called as thoracostomy. ठीक है, तो thoracocentesis बोलो या thoracostomy बोलो, it is basically one and the same thing. The only thing is, if there is in that option, one option was thoracocentesis and another option given was a wide bore needle thoracostomy. So obviously with a thoracocentesis or wide bore needle thoracostomy में, the wide bore needle thoracostomy seems to be a specific option, इसीलिए उसके लिए गए थे. ठीक है, तो thoracocentesis बस pleural effusion के लिए होता है, ऐसे कोई लॉजिक नहीं. सॉरी, ठीक है, thoracocentesis is ultimately insertion of needle. वो तुम pleural effusion के लिए करो या pneumothorax के लिए करो, it is called as thoracocentesis. Clear? That was just the option which was slightly better, and इसीलिए that option was preferred. Clear? So don't get, मैं इसीलिए बोलता हूँ definitely, if you try to get so anxious कि नहीं ये अलग कुछ बता दिया, नया कुछ बता दिया, don't trust on anything else. Your notes are the ultimate source. ठीक है? Always have to be remembered. So needle thoracocentesis or needle thoracostomy has to be done beta, and that is done in adults in which space? Fifth intercostal space. Just anterior to which line beta? Anterior to the mid axillary line. The fifth intercostal space anterior to the mid axillary line, that has to be remembered beta. Next, children it has to be done in which space? Second intercostal space. On which line? Mid clavicular line beta. Now needle thoracocentesis or a needle thoracostomy has to be done along which part of which rib? along the upper border of lower rib. That is important. Along the upper border of lower rib you have to insert it. Otherwise you are going to damage the neurovascular bundle. Samjhe baat? So that is what is important to be remembered. Hopefully clear. What is the definitive management in cases of tension pneumothorax? The definitive management is ICD tube insertion. So ICD is nothing else but beta. It is intercostal drainage tube. So intercostal drainage tube or ICD tube insertion has to be done. And ICD tube insertion will be called as thoracotomy or thoracostomy. It is going to be called as thoracostomy. You are creating an opening. Are you closing it back? No, na. So it is a thoracostomy. So ICD tube insertion is nothing else but thoracostomy. वापस ये पढ़ के अचानक से चौक मत जाना. ये क्या बता रहा है? तो एक ही चीज है. ठीक है. तो ICD tube insertion is what is called as a tube thoracostomy बेटा. ठीक है. Needle thoracostomy या tube thoracostomy एक ही चीज है. ठीक है. So that is what is important to remember. बस thoracocentesis और ICD insertion का अलग नाम है. ठीक है. That is important to be remembered. It is done in which space again? Fifth intercostal space beta. Okay. In which triangle? Triangle of safety. So this is the ICD tube beta. Okay. So either of that. Either there can be a container or there can be a bag. Hopefully clear? Chalo. So important is in this condition beta, obviously elective intubation, thoracostomy, thoracocentesis doesn't make any sense beta because the patient is absolutely normal as of now. That's the reason. Question number 185 beta. It states we are having a patient who has been brought to the casualty after a road traffic accident and now the patient complains of chest pain along with respiratory distress beta. Chest x-ray has been performed and it has been given below. What will be the expected breathing pattern to be observed in this case beta? क्या है case? Yes. So after road traffic accident or after trauma, the patient has been brought to you with chest pain and respiratory distress. If you see the chest x-ray beta, chest x-ray pe definitely there are multiple fractures which are going to be seen beta. So multiple fractures are seen definitely, and if multiple fractures are going to be seen beta, it is nothing else but a case of which chest? Flail chest. And if I talk about flail chest beta, we know that which kind of breathing pattern is observed in flail chest. So breathing pattern observed in flail chest, answer has to be option B. That is a paradoxical breathing pattern beta. Paradoxical breathing pattern is nothing else but the flail segment will go always in opposite direction to rest of the chest wall. That is what is paradoxical chest wall movement or a paradoxical breathing. Batao, physiologist है, Barrett's breathing is seen in. बोलो. Brainstem damage. So whenever the patient is actually going to have a brainstem damage beta, the patient will have an irregular breathing pattern and that irregular breathing pattern is called as Biot's breathing beta. Next is Kussmaul's breathing is a feature of DKA beta, that is diabetic ketoacidosis. In patients of diabetic ketoacidosis, as there is a metabolic acidosis in the body beta, that's the reason definitely the patient will have a hyperventilation and that is what is called as Kussmaul's breathing, acidotic breathing that we call it as. Next is Cheney-Stokes breathing is a feature of. Cheney-Stokes breathing is a feature of. Cheney-Stokes breathing is an irregular breathing pattern observed in patients of bradycardia, hypertension and Cheney-Stokes breathing. Very good. Raised ICP beta, that is raised intracranial pressure. So whenever the patient will have a raised ICP or a raised intracranial pressure, कौन सा triad दिखता है? Cushing's triad. Cushing's triad is B for bradycardia, H for hypertension and C for Cheney-Stokes breathing beta or Cheney-Stokes respiration. That is a Cushing's triad which is seen in patients of raised intracranial pressure. Majority patients of flail chest beta will go for a conservative management or a surgical management. Majority cases of flail chest will go for a conservative management beta. We don't need surgery in majority cases of flail chest, that has to be remembered. And conservative management, main symptom of the patient is pain. That's the reason beta we have to give painkillers, that is analgesics. Along with that, as the patient will have as the patient is having respiratory distress, we can provide some oxygen support. Very few cases of flail chest beta will need a surgical repair. Very few, extremely few cases. Clear about? Chalo. Somebody says CRR, but CRR is not Kussmaul's breathing, it is Kussmaul's sign. That is different. बता दो अभी फिर Kussmaul's sign which is there. What is Kussmaul's sign? ये बताओ पहले. It is paradoxical rise in JVP beta during inspiration or expiration. Very good. Normally on inspiration JVP should fall. ठीक है, but here there is a paradoxical rise in JVP beta on inspiration. That is what is called as a Kussmaul's sign, which is Kussmaul's sign is seen in CRR. What is CRR? C for constrictive pericarditis beta. So C for constrictive pericarditis, R for restrictive cardiomyopathy, and third R for right-sided congestive heart failure beta. Hopefully that's clear. So C, R, R are the conditions जहाँ पे the patient will have a classical Kussmaul's sign beta. Hopefully clear. So that is important to remember. Done. Next important, if I talk about basically beta, is question number 186. A mother has brought basically a 3-week-old child beta, 3-week-old neonate with complaints of projectile vomiting and failure to thrive, not able to gain weight. Which of the following electrolyte abnormality beta is seen in this child over here? A, B, C, D. So it is nothing else but what you are suspecting whenever a 3-week-old child has been brought to you with complaints of projectile vomiting. So we know beta, it is a classical diagnosis of nothing else but CHPS, that is congenital hypertrophic pyloric stenosis beta. So it is a case of hypertrophic pyloric stenosis, and hypertrophic pyloric stenosis है. So obviously the child is going to have a gastric outlet obstruction, and due to that gastric outlet obstruction, child has projectile vomiting, which is bilious or non-bilious? It is going to be a non-bilious vomiting. Bilious vomiting is seen in duodenal atresia. So bilious vomiting is seen in duodenal atresia basically beta. That is important to remember. Clear? Now as the child is basically having vomiting beta since birth, we can go for X-ray, and when we go for X-ray beta, child will have a classical sign called as single bubble sign beta. So single bubble sign on X-ray abdomen is a feature of CHPS or hypertrophic pyloric stenosis. But double bubble sign on X-ray abdomen is a classical feature of. Very good. So double bubble sign on X-ray abdomen, if they show you beta, that is a classical diagnosis of duodenal atresia or annular pancreas. At least remember two conditions जहाँ पे there is a double bubble sign on X-ray abdomen. One is duodenal atresia, second is annular pancreas. As the child is having chronic vomiting, all the acid from his stomach is lost, causing metabolic alkalosis. So option D and C both have been ruled out easily because there is metabolic acidosis over there. Now we know beta, answer has to be option A, that is hypokalemic, hypochloremic, metabolic alkalosis with hyponatremia, and the patient is also going to have paradoxical aciduria beta. Clear? So that is important. Hypernatremia can be seen, but in later stages after compensation. Clear? No issues with this? If they ask you in patients of CHPS, as the child is having so much amount of vomiting or so many metabolic disturbances, what is the fluid of choice to be given over here? So fluid of choice that we give beta is half normal saline plus 5% dextrose plus minus KCl or potassium chloride. So half normal saline plus 5% dextrose plus minus KCl has to be the fluid of choice. Not an option, go for normal saline, which was a PYQ in your examination. In that examination beta, this option was not there. Agar ye option hota to this should have been the answer, but as this was not there, therefore in the PYQ the answer was normal saline beta. That is important. तो इसीलिए मैं अगर बोल रहा हूँ, अगर दोनों ऑप्शन में होंगे, my answer would be preferably half normal saline. Clear है बात? Next, if they ask you which fluid has to be avoided in patients of CHPS, very good. The fluid that we avoid in patients of CHPS, answer is RL or Ringer's lactate, because lactate when broken down can cause metabolic alkalosis, and the child is already having metabolic alkalosis. इसीलिए. And the treatment of choice for CHPS will be Ramsted's pyloromyotomy beta, right? So Ramsted's pyloromyotomy definitely is the surgery of choice that we do for CHPS. Question number 187. Here we are having a 5-year-old boy beta who has presented to us with multiple episodes of hematemesis. What is hematemesis? Blood in the vomitus. It is suggestive of upper GI or lower GI bleeding? It is suggestive of an upper GI bleeding beta. On admission they are saying his vitals are stable and splenomegaly has been noted beta. The mother tells at birth the boy had developed jaundice beta. So at birth the baby had developed jaundice and an exchange transfusion procedure has been performed that time. What is the likely cause over here? मुझे बताओ सबसे पहले डेफिनेटली बेटा, it is a small child who is coming to you with hematemesis. That is a feature of upper GI bleeding beta. बराबर? It is a case of upper GI bleeding. What is the cause of this upper GI bleeding in this child? We know upper GI bleeding which is there, it happens in a child due to esophageal varices. So here the cause of upper GI bleeding in this child is esophageal varices. How did esophageal varices develop in the child? Portal hypertension. As the child had portal hypertension beta, therefore the vessels inside the esophagus got dilated and they may have ruptured beta, leading to cause upper GI bleeding. Now they are asking you what is actually reason for the portal hypertension in the child. Most common cause of portal hypertension in babies. Most common cause of definitely beta portal hypertension in babies is nothing else but non-cirrhotic portal fibrosis beta. So non-cirrhotic portal fibrosis which is there, it is actually considered as the most common cause of portal hypertension in children beta. Hopefully clear to all of you. And if there is a non-cirrhotic portal fibrosis in the portal circulation beta, matlab if fibrosis has happened in portal circulation beta, will the portal vein be able to drain? No. Therefore the pressure in the portal vein increases, causing portal hypertension, and that's the reason there is congestion of blood inside the spleen, causing splenomegaly as well beta. Clear beta? So that is important to remember. Yes, if non-cirrhotic portal fibrosis was not an option beta, my second best answer would have been option C, that is portal vein thrombosis. But as non-cirrhotic portal fibrosis was there, better answer for a child is going to be a non-cirrhotic portal fibrosis followed by portal vein. Sinusoidal fibrosis is not the cause, but Chiari syndrome is not the cause beta. That is important to remember. Clear about? No issues with this. Important is whenever a patient is brought to you with esophageal varices, what is the first step management? Bolo.
Basic resuscitation.
Very good. The first step in management of a bleeding esophageal varices is always beta basic resuscitation. Start IV fluids in the child so that the child will be hemodynamically stable. Second important, what is the drug of choice? So we know beta, either we can give IV octreotide beta or a better agent would be terlipressin. So IV octreotide or terlipressin can be given to stop the bleeding. If that doesn't help, we should go for endoscopic banding beta. If that doesn't help, we should go for endoscopic banding, or another option is sclerotherapy. So banding or sclerotherapy, and last option is with surgery. TIPS. So last option is the surgery known as TIPS, transjugular intrahepatic portosystemic shunt beta. Hopefully clear to all of you now. Okay? So do remember, first line is always basic resuscitation, drug of choice is octreotide or terlipressin. Followed by that we should go for banding or sclerotherapy, and if nothing helps then the last option is always TIPS surgery beta. Clear about? Sure. So that is what is important to remember. Question number 188. Here the question is beta, a person presents to you OPD with complaints of visual disturbances bache, and the perimetry was performed to assess the visual field of the patient. We have discussed now perimetry will tell you about the visual field of the person beta. Below given pattern was observed. What is the probable site of lesion beta over here? तो अब सबसे पहले देखते हैं अभी यहाँ पे we know the black area which is there beta, that is nothing else but the blind spot, and we know blind spot is known as scotoma also beta. So this is the blind spot or the scotomas which are seen. मतलब here the patient is having loss of vision. Now in this eye the patient is having loss of vision in the left half. In this eye also the patient is having loss of vision in the left half. Whenever there is loss of vision in same halves of both the eyes or different halves of both the eyes. So there is vision loss in left halves of both the eyes, matlab there is vision loss in same halves of both the eyes. If there is vision loss in same halves of both the eyes, it is a homonymous hemianopia or a heteronymous hemianopia. We know it is a homonymous hemianopia beta, that is what is important to remember. One thing is clear कि okay, it is a case of homonymous hemianopia. Now whenever there is a homonymous hemianopia beta, we know the damage is above the optic chiasm or below the optic chiasm. whenever there is a homonymous hemianopia or a same-sided vision loss, beta, we know it is a case of damage below the optic chiasma. So damage is below the optic chiasma. Below optic chiasma का मतलब either it is optic tract, the lateral geniculate, body, optic radiation, or the visual cortex. Any of this side is damaged, beta. That is damage below the optic chiasma. Now important is, beta, मुझे बताओ, damage below optic chiasma is always contralateral or ipsilateral? So damage below the optic chiasma will always be contralateral. मतलब if the patient is having vision loss in left halves of both the eyes, the damage is actually on the right side. The vision loss is in left half of both the eyes, मतलब the damage is on the right side, beta. It is always contralateral. And definitely, it is on the right side, beta. So right side, my answer has to be option D. That is right optic radiations, beta. That is important to remember. Clear? Now we know, beta, if left optic tract would have been damaged, yes, the patient will have a homonymous hemianopia. Okay, but that will be right-sided vision loss or left-sided vision loss? So the patient would definitely have vision loss in right half of both the eyes, beta. Clear? That is what is important. Visual cortex would have been damaged. The visual cortex, yes, the patient would have a homonymous hemianopia, beta, but with or without macular sparing? With macular sparing, beta. That is important. So जब भी visual cortex is going to be damaged, beta, patient will have a homonymous hemianopia. Patient will have a homonymous hemianopia, beta, along with macular sparing, basically. That is one thing to be remembered. Second important, here have they mentioned right or left visual cortex? No. So that would be a very non-specific term, beta. Okay? So definitely visual cortex would not be a better answer because here definitely it is very non-specific. They have not mentioned whether it is right or left. Which sided visual cortex would have been damaged? अगर ये visual cortex का damage होता, तो which sided visual cortex should have been damaged again? The right sided, beta. क्योंकि again visual cortex is below optic chiasma and it should be contralateral again. अगर optic chiasma का damage होता तो क्या होता? तो optic chiasma का damage होता तो bitemporal hemianopia would have been there. Bitemporal hemianopia में it is homonymous or heteronymous? So please remember, bitemporal hemianopia, beta, will be heteronymous hemianopia. That is vision loss in different half of both the eyes. That is, in one eye, beta, there would have been a vision loss in the right half, and in another eye there will be vision loss in the left half. That is important. Clear? So yaad rakhna, whenever there is any damage below the optic chiasma, that is to the optic tract or the lateral geniculate body or the optic radiations or the visual cortex, the vision loss is always seen in same half of both the eyes. That is called as homonymous hemianopia. And this damage is always and always contralateral. Matlab, when they say there is vision loss in left halves of both eyes, that means definitely the damage is always be on the contralateral, the opposite side, that is right side. Hopefully that's clear. Macular sparing important is, beta, initially it is because definitely the optic radiations which are there, they are damaged. तो ऑप्टिक रेडिएशन डैमेज है, इसलिए ये भी तो पार्ट में डैमेज हो गया अब तक. ऑप्टिक रेडिएशन जब डैमेज होती है तो ऑप्टिक रेडिएशन इज नॉट अ सिंगल ट्रैक, इट इज फाइबर्स. तो पूरे फाइबर्स डैमेज नहीं हुए, इसकी वजह से डेफिनेटली बेटा इवन दीस फाइबर्स आर नॉट गेट डैमेज. दैट्स द रीजन. एंड अगेन आई टोल्ड यू, विजुअल कॉर्टेक्स जब डैमेज होता तो एकदम क्लियर कट ये विजन लॉस होता और बस मैकुलर स्पेयर होता. तो ये यहाँ पे वो क्लियर कट विजन लॉस नहीं दिख रहा है. सेकंड इंपॉर्टेंट थर्ड रीजन आल्सो दैट विजुअल कॉर्टेक्स हैव दे मेंशन इज इट राइट और लेफ्ट. So it is going to be a very non-specific answer for this question. Yeah, that is important. So better answer is always option D, that is the right optic radiation. Beta, please remember optic radiations में there are two fibers basically, superior group and inferior group. If only the superior group is damaged, then the patient has an inferior quadrant myopia called as pie on the floor. And if inferior group is damaged, then the patient will have a superior quadrant myopia called as pie in the sky up here. Clear? Here both the fibers are damaged, but he is not completely damaged yet. Question number 189, beta. Here you are able to see a patient is a tourist guide on Mount Everest, beta. Patient is a tourist guide on Mount Everest. After one of the trips when he came down, beta, there were multiple blisters on his foot with excruciating pain, beta. The foot shows there is erythematous changes, beta, which are seen, and it is tender to touch. Which of the following is not useful for the management of this patient? See, all the 4 drugs can be used. But if they have given definitely to find an exception, then we have to find the least useful drug. So what do you think? First of all, diagnosis क्या होगा? A patient who is going on Mount Everest having multiple blisters on his foot with a lot of pain. Excessively cold and excessively cold temperatures now with a dry cold, right? So definitely it could be a case of frostbite basically, and frostbite hai. So obviously what should be given? We know. Can we give oxygen? Yes, we have to give oxygen because now in frostbite there is necrosis or the gangrene which is occurring beta. Barabar na? Due to frostbite there is gangrene which is happening, and if you want to prevent that gangrene or if you want to stop the gangrene basically beta, obviously you have to give oxygen beta. Adequate oxygen should be given. Aspirin, yes beta, it will help in relieving the blockage. Definitely it is an antiplatelet drug which can be given. Even warfarin is given, but again not a first line agent. Vasodilators like pentoxifylline, yes, absolutely. We know pentoxifylline is a vasodilator beta, and as it is a vasodilator, I have to definitely give pentoxifylline like drugs which will improve the blood flow to the site. So among the following option which is the least useful, then answer has to be option C, that is warfarin. अगर इससे भी कोई useless drug होती, then I would have marked that. But among the following option, warfarin is the least useful, then I have to mark warfarin. Hopefully that's clear to all of you. Done. Next important if I talk about, and we know frostbite में treatment क्या होता है? Apart from giving oxygen, aspirin, vasodilators like pentoxifylline, what is the definitive treatment? We have to go for rapid rewarming beta. And when we have to go for rapid rewarming, we will ask the patient definitely to dip the sides basically beta, like the foot or the hands in the warm water bath. How much should be the temperature of warm water bath? So the temperature of warm water bath beta for rapid rewarming should be around 42 degrees Celsius beta. 42 is written in Delhi, okay, but usually they tend to use between 40 to 42 degrees Celsius. Hopefully that's clear to all of you. इसके अलावा we have to give a lot of painkillers or analgesics to the patient beta, because during rewarming the patient is going to experience a lot of pain beta, and that is important. And if gangrene is there, you should go for a early surgery or a delayed surgery. If there is gangrene beta, then you should go for a delayed surgery. You wait for the line of demarcation to appear clearly between viable and non-viable tissues beta. Then only you amputate. Clear about question 190 beta. Here we are having an elderly patient who presented to us with complaints of resting, tremors beta along with limb rigidity, and the patient is also having mask-like facies beta. He has extreme slowness in movements beta. The patient is having extreme slowness in movements. Which of the following therapy is not indicated? PYQ. What is the likely diagnosis? So we know beta there is a classical triad. First, elderly patient is affected with a classical triad of resting, pen rolling, tremors. There can be limb rigidity beta. Upper limb rigidity is called as cogwheel, and the lower limb rigidity is called as lead pipe. The cogwheel or the lower lead pipe like rigidity along with mask-like facies. And this extreme slowness in movements is called as bradykinesia beta, okay, which is the most classical features in patients of Parkinsonism. So we know beta this is a classical presentation of nothing else but Parkinson's disease beta or Parkinsonism, okay. And we know whenever there is Parkinson's disease or Parkinsonism, stoop posture, mask-like facies, muscle rigidity, okay. Apart from that beta, patient having resting, pen rolling, tremors, okay. Apart from that, patient is actually going to take short shuffling gait called as, the short shuffling gait is known as the festinating gait, which is going to be seen. Classical features of Parkinsonism. We know Parkinsonism the main problem is deficiency of which neurotransmitter? Dopamine beta. So you have to give drugs which can increase the amount of dopamine in the patient beta. The most effective drug is levodopa and carbidopa. But what is the drug of choice in young patients of Parkinsonism? The young patients of Parkinsonism, the drug of choice has to be pramipexole and ropinirole. These are dopamine agonists beta. These are definitely preferred in the young patients of Parkinsonism. Yes, old patients or elderly patients of Parkinsonism beta, we can give levodopa and carbidopa. They are avoided in younger patients because of a side effect called as on and off phenomena. Due to the on and off phenomena beta, levodopa carbidopa combination is not preferred in younger patients of Parkinsonism beta. Next, amantadine is an antiviral drug. Can we use it? Yes, we know amantadine is also used in the management of Parkinsonism beta. Okay, can we go for deep brain stimulation?
Yes.
Yes, deep brain stimulation can be done beta if the patient is having a refractory Parkinsonism. Refractory का मतलब when the patient does not respond to any available treatment beta, that is called as refractory case. उसमें deep brain stimulation can be done. मुझे बताओ rivastigmine increases the level of dopamine or acetylcholine? So it is used in the treatment of Alzheimer's disease beta. That was the PYQ, exact same options were there. Clear? So rivastigmine is going to be an exception that you have to keep in mind beta. It is used for the management of Alzheimer's disease. What is the drug of choice in Alzheimer's? Donepezil beta. Yes, the donepezil is the drug of choice for Alzheimer's beta, but even rivastigmine is also used in the treatment of Alzheimer's disease beta. That is what is important to remember. Hopefully that's clear to all of you now. So do you remember this? No issues with this. Answer has to be nothing else but option B beta. Done? Next question number 191 beta. Here we are able to get a question, and that is 20-year-old male who is on a low dose oral corticosteroid therapy beta for the last 10 years now. Long dose steroids the patient has been taking beta. Okay? Now they are saying he now developed beta progressive loss of vision in both the eyes beta. What is the most likely type of cataract which will develop in this patient? So we know beta that definitely steroid therapy अगर लेता है patient, तो patient is actually going to develop a steroid induced cataract beta. So due to the steroid therapy, patient can develop a steroid induced cataract. We know na that the most common drugs known to cause a cataract are going to be the steroids itself beta. ठीक है? So steroid induced cataract is the diagnosis of the patient beta, and that is the reason why the patient is having the progressive loss of vision. Which is the most common type of cataract due to steroids? Yes, so it is going to be option A beta, that is nothing else but subcapsular cataract. Anterior or posterior? Posterior. A PHC, that is called as posterior subcapsular cataract. It is the most common type of cataract. It is the most common type of cataract due to steroids also, and most importantly PYQ, it is the most visually disturbing cataract beta. तो अगर पूछा जाए बेटा that which is the most visually disturbing cataract, answer has to be nothing else but posterior subcapsular cataract is the most visually disturbing cataract that has to be kept in mind beta. No issues with this, so do remember this. Okay, next important if I talk about the other ones beta, the common ones. What is this? This is nothing else but the snowflake cataract beta. And if I talk about the snowflake cataract, it is seen in patients suffering from diabetes mellitus beta. So those patients who are suffering from diabetes mellitus, in them we are having the snowflake cataract. It is due to deposition of sorbitol. That was a PYQ again. So whenever there is excess deposition of sorbitol in the lens beta, that leads to formation of this classical snowflake cataract beta. That is what is important to remember. Hopefully clear. Next important picture, if you are able to see beta. Next important picture. We know this is a classical presentation of oil drop cataract, and if they ask you about the oil drop cataract beta, please tell me. Oil drop cataract is basically seen in patients suffering from galactosemia. The patients who are suffering from galactosemia beta are going to have the classical oil drop cataract, and we know the galactosemic or the oil drop cataract happens due to excess deposition of galactitol, also called as dulcitol. The excess deposition of galactitol or dulcitol beta has to lead to formation of oil drop cataract, which is the reversible or irreversible cataract. So हमें पता है बेटा that oil drop cataract which is there, it is the only reversible cataract. That is, if you stop giving galactose to the child beta, the child's condition will get back to normal. So it is the only reversible cataract that you have to keep in mind beta. Next, Sarkari picture repeated a lot of times in FMG exam. So here you are able to see beta the classical rose petal like appearance of the cataract. This is a classical picture of rosette cataract. Rosette cataract definitely happens due to a blunt trauma or a penetrating trauma to the eye. Very good. So please remember beta that rosette cataract which is there, it happens basically due to blunt trauma to the eye. Whenever there is a blunt trauma to the eye, patient may develop a rosette cataract. Hopefully clear all of you now. Sure. Done. Next is question number 192 beta, and if I talk about definitely the question 192, here they are saying we are having a 2-year-old child बच्चे and this 2-year-old child has presented to the emergency room beta with ongoing generalized tonic-clonic seizures. Okay, the child is having generalized tonic-clonic seizures beta. They are saying airway have been secured. We know na ongoing seizures mein the first step is again basic resuscitation. Secure the airway so that the child does not have aspiration beta. So airway has been secured, but the child is still having seizures beta. What should be the initial therapy to control seizures in the child beta? So please remember beta, a 2-year-old child definitely, okay, is having seizures beta. Now important is the child is still having seizures, they are saying. The child has been brought to you with ongoing GTCS beta and child is still having seizures definitely. Is it easy basically to insert a IV cannula in the child? No. Is it easy basically to insert a IV cannula during a seizure? Absolutely not. Okay? That's the reason it's better to use definitely another route beta. See, lorazepam, no doubt it is the best drug beta. But the problem is it is given IV. The problem is lorazepam will be given IV, and if the child is not having any cannula beta, it will be extremely difficult to give IV lorazepam in the patient. Clear about? So in those conditions definitely beta, either we should go for diazepam or we should go for midazolam beta. Barabar na baat? So IV route definitely we have to give lorazepam itself, but definitely if lorazepam cannot be given, then definitely we have to give for option A, that is diazepam. Diazepam, why? Because it can be given even rectally in children beta. In small children, diazepam can be given even via the rectal route. Easily. Valproate is not the first drug to be given. In a recent PVIQ NEET beta, they asked you the sequence, in which sequence you give it. Please remember beta, we don't give anti-epileptic drugs first, we give benzodiazepines first to calm down the child, and then followed by that we give anti-epileptics. Clear है बात? तो पहले कोई भी benzodiazepine दो, either lorazepam or diazepam, and definitely then go for anti-epileptics like either valproate or lamotrigine. Clear about? That is important. Phenobarbital is usually given for which kind of seizures? Subtle seizures, which are neonatal seizures beta. So please remember neonatal seizures या फिर subtle seizures जो होते हैं उसके लिए the drug of choice if they ask you beta, answer is nothing else but phenobarbital. If they ask you what is the drug of choice for infantile seizures or salam seizures beta, हमें पता है infantile spasms or salam seizures beta. Infantile spasms or salam seizures के लिए the drug of choice will be injection of ACTH. When they will say beta that the patient is a known case of infantile spasms or salam seizures and he is also having tuberous sclerosis, then the drug of choice will be vigabatrin beta. So infantile spasms in a patient suffering from tuberous sclerosis, the drug of choice is vigabatrin beta. That is what is important to remember. No issues with this? Okay? So these are the important things that you have to keep in mind. Drug of choice का absence seizures भी बताए दो. Absence seizures is more commonly seen in school age children beta. We know it is more commonly seen in school age children definitely beta. Okay, when the child will have vacant stares basically at one point. एक ही जगह पे देखता रहेगा. ठीक है? So absence seizures may depends on the age of the child beta. If the child is less than 4 years of age, we tend to give a safer drug called as ethosuximide beta. So less than 4 years of age, we have to give a safer drug बच्चे called as ethosuximide, which is a calcium channel blocker beta. Whereas if the child is more than 4 years of age beta, then we have to give a stronger drug, and that stronger drug is nothing else but anybody? Valproate. So after 4 years of age, you tend to give valproate. Hopefully that's clear. So at least remember these drugs basically for seizures beta in the patient. Done? Next important is question 193 beta. Recent question FMG Jan 2025. A 22-year-old unmarried female presents to you with menstrual irregularities बच्चे. She had irregular and 7 to 9 cycles a year beta. Okay, so the menstrual cycles were irregular and only 7 to 9 cycles per year will be called as अरे 7 to 9 cycles per year will be called as oligomenorrhea. Only 7 to 9 cycles per year, that is less amount of menstrual cycles, will be called as oligomenorrhea. Sanjay baat? So here the female is actually having oligomenorrhea beta. She has also gained over the last few years beta. She has definitely gained weight beta and has excessive facial hair growth. That excessive facial hair growth is known as hirsutism. So we know beta that there is a young female having oligomenorrhea beta There's a young female having hirsutism. There's a young female having weight gain beta. It has to be nothing else but a feature of PCOD, also called as PCOS beta. So it is a classical diagnosis of nothing else but PCOS or PCOD, that is polycystic ovarian disease beta or polycystic ovarian syndrome. And when I talk about PCOS or PCOD beta, what is the classical appearance on ultrasound pelvis? So we know beta in patients of PCOS or PCOD, there are multiple small follicles in the periphery of the ovaries beta with a thick ovarian stroma. This is a classical string of pearl or a necklace of pearl appearance. So ultrasound ovaries beta will give us the classical string of pearl or the necklace of pearl appearance. That is important to remember. Hopefully clear. Which is the criteria used for the diagnosis of PCOS? We know beta there is a classical Rotterdam's criteria used for the diagnosis of PCOS. First feature is anovulation. Second feature is hyperandrogenism. And third feature is PCO look on ultrasound. So anovulation, hyperandrogenism and PCO look on ultrasound are the three features of the Rotterdam's criteria used for the diagnosis of PCOS or PCOD. What is the first step in management of this case? So we know beta PCOS is commonly treated by lifestyle modification. Answer has to be option A beta to this question. Lifestyle modifications when you will ask the female to go for weight loss, and by weight loss majority of the females will have a spontaneous ovulation. अपने आप ovulation हो जाता है. If that doesn't help, then what is the drug of choice? So drug of choice definitely has to be letrozole beta. Please remember letrozole is considered as the drug of choice for PCOS. Reason? It is effective for both beta. It helps in ovulation as well as it helps in decreasing the insulin resistance. इसीलिए. What is the best drug for ovulation induction? Clomiphene citrate. What is the best drug to reduce insulin resistance? Metformin. We are at now letrozole is neither the best drug for insulin resistance nor the best drug for ovulation, but still it is the drug of choice for PCOS beta. That is important. Clear? So that is important to remember. No issues with this? Now next important if I talk about beta. तुम्हारे इसमें exam question में was ultrasound given? My answer would change to option D, that is nothing else but ultrasound pelvis. So yes, first line management is definitely option A beta, that is lifestyle modifications beta. ठीक है? The first line treatment is obviously lifestyle modification, but here did they ask you about the first line management? No, they asked you the first step in this case beta, and first step in this case has to be ultrasound to be done. Once you do an ultrasound and confirm the diagnosis of PCOS, then you start with the treatment beta, and for that you have to give lifestyle. For that definitely you should go for lifestyle modifications beta. Hopefully clear to all of you now. So that is what is important to do. Next is the classical picture. So here definitely you are able to manage history दिया कोई? तो OHS is this. So please remember beta, basically there are large follicles. हाँ अब बताओ. The female had recent pregnancy beta. After that she comes to you with definitely a lot of pain in the abdomen beta or in the pelvis, and when ultrasound was done beta, this kind of feature was seen where there are large follicles inside the ovaries of the female, even in the center. Diagnosis. Pregnancy history बोल रहा हूँ मैं. They have given a history of pregnancy beta, and after that there is the classical picture. So large follicles are दिखता है. If there are large follicles that are definitely seen inside the ovaries beta, okay, large follicles in the ovaries definitely. That can be a case of either a theca lutein cyst, and theca lutein cyst का अगर case होगा, so definitely it is a case of history of pregnancy. Whenever history of pregnancy would be given along with this kind of a picture beta, it seems to be a case of theca lutein cyst. If they would have given large follicles beta on the ultrasound, yes, and they would have given you a history of IVF or ovulation induction, then my diagnosis will be OHSS, that is nothing else but ovarian hyperstimulation syndrome beta. That ovarian hyperstimulation syndrome में they will give a history of IVF, and for IVF we have to do an ovulation induction either with injections like HMG. What is HMG? Human menopausal gonadotropin, or with the agent like clomiphene citrate. समझे बात? So that is what is important to remember. So such kind of a picture where there are large follicles in the ovaries, if it is seen, it could be a diagnosis of theca lutein cyst, or it could be a diagnosis of ovarian hyperstimulation syndrome. If there is a history of IVF, go for OHSS as the answer. If there is a history of pregnancy only, then go for theca lutein cyst as the answer. Clear about? Next is question 194 beta, and that states we are having a 30-year-old man who works in a glass factory beta, and that patient has definitely presented to us with complaints of progressive shortness of breath on exertion beta. He is predisposed to develop which among the following condition? मुझे बताओ सबसे पहले तो if a person is working in the glass factory beta having shortness of breath is going to develop which pneumoconiosis? Silicosis beta. The patient is actually going to develop silicosis because in glass factory we have the most dangerous form of silica called as quartz silica beta. Important is patient mein when I do a chest x-ray beta, on the chest x-ray I'll be able to see a classical feature called as the classical snowstorm appearance is seen beta. As you are able to see now, the small reticular nodular opacities. These small reticular nodular opacities beta, they give you a classical appearance of a snowstorm basically. And along with that I'll be able to see which kind of calcification? Eggshell calcification. So there is a snowstorm appearance beta, or there is a classical eggshell calcification which is actually going to be seen on chest x-ray in patients of silicosis. And जब silicosis में ये appearance दिखता है, we know it is a case of silicosis. So silicosis में definitely beta, which is the most common disease associated. So we know beta the most common disease that is associated with silicosis. Answer has to be option B, that is tuberculosis beta. In a PYQ, the same question was given, but it was even bigger than this. And they asked which among the following statement is correct for all the workers working in a glass factory beta. And one of the option which was given is regular or frequent screening for tuberculosis should be done in these workers. Yes, that is a true statement because the most common disease associated will be TB beta. Okay, that is important. Kaplan syndrome is nothing else but a combination of two things. One is coal workers pneumoconiosis, and second is rheumatoid arthritis. So whenever there is coal workers pneumoconiosis and rheumatoid arthritis beta, that is a case of Kaplan syndrome. So Kaplan syndrome is associated with coal workers pneumoconiosis or anthracosis beta. Next, mesothelioma is the most specific cancer associated with. मुझे पता है that the most specific cancer associated with asbestosis is going to be mesothelioma. Most common cancer associated with asbestosis, it is going to be adenocarcinoma lung beta. ठीक है, most specific is mesothelioma, most common is adenocarcinoma beta. That is important. Don't make a mistake. Clear? चलो, so that is what is important to remember. No issues with this. This is the classical appearance. क्या लिखना है यहाँ पे? This whitish patches that are seen, that is the pleural plaque or the pleural calcification beta. These are basically the pleural plaques or calcification. Which is the pneumoconiosis जहाँ पे there will be pleural plaques of calcification on chest x-ray. The type of pneumoconiosis जहाँ पे pleural plaques of calcification on chest x-ray is the keyword. Answer is asbestosis. Asbestosis is the condition जहाँ पे pleural plaques or pleural calcification will be the keyword behind the question that has to be remembered. We know asbestosis is usually seen in those industry workers who work in the shipyard industry beta. So asbestosis is usually seen beta in the shipyard industry workers, or can also be seen in cement industry workers beta. So shipyard or the cement industry workers when there is asbestosis. Mainly involves upper or lower lobes of the lung. Mainly involves the lower lobes of the lung. All other pneumoconiosis involves upper lobes except asbestosis, which involves the lower lobes of the lung. And we know the common cancer is adenocarcinoma and specific cancer is mesothelioma. Hopefully done to all of hopefully done with this. Clear? Usually it is going to take around 10 to 20 years basically for silicosis itself to develop. Okay? That is important. 20 years of minimum exposure is required for silicosis to develop. Question number 195 beta. We are having a 50-year-old female beta who presented to you with morning stiffness of joints beta along with pain in the smaller joints of the body. The physician is thinking to start a DMARD. What is the diagnosis? Very good. Whenever a 50-year-old female is having morning stiffness and pain in the joints beta, it is more likely to be a case of RA. And we know that rheumatoid arthritis mein, there is involvement of the smaller joints. And the special drugs basically beta used for the treatment of rheumatoid arthritis are called as DMARDs, that is disease modifying anti-rheumatoid drugs. Please tell me rheumatoid arthritis mein what is the screening test? Screening test for RA factor, screening test for rheumatoid arthritis is RA factor beta. RA factor will be positive. What is the investigation of choice? Which antibodies? In rheumatoid arthritis beta, what is the investigation of choice? Yes. Anti-CCP antibodies beta. Anti-cyclic citrulline peptide antibodies. Anti-CCP antibodies are considered as the investigation of choice beta in patients of nothing else but rheumatoid arthritis beta. That is important to remember. अब मुझे बताओ definitely. So we know the treatment or the drug of choice is nothing else but DMARD. What is the DMARD of choice to be started? So the DMARD of choice definitely that we start beta is going to be methotrexate beta. Okay, it is going to be methotrexate. If they ask you that if the female is pregnant, then what is going to be the DMARD that we have to start? So then it is hydroxychloroquine beta. Hydroxychloroquine is the DMARD of choice whenever the female is going to be pregnant beta. So rheumatoid arthritis in pregnancy or SLE in pregnancy, दोनों के लिए the drug of choice will be hydroxychloroquine. Okay. Now they are saying some DMARD was started in the patient and regular monitoring of visual acuity and fundus examination is advised beta. ठीक है? Regular monitoring of visual acuity and fundus examination is advised. Which among the following DMARD has to be which among the following DMARD was likely started beta in the patient? If they recommend regular monitoring of visual acuity and they recommend regular monitoring of fundus examination, which DMARD was started? Very good. Answer has to be option A, that is hydroxychloroquine. Why? Because chloroquine or hydroxychloroquine is going to have a side effect and that is called as, very good, in the macula beta there is going to be damage due to chloroquine or hydroxychloroquine, called as which maculopathy? Bull's eye maculopathy beta. So the classical bull's eye maculopathy which is there, it is actually a side effect associated with hydroxychloroquine. Now few things beta that you have to remember. ठीक है, तो बुल्स आई मैक्यूलोपैथी याद रखना, इट इज कॉमनली एसोसिएटेड विद हाइड्रोक्सीक्लोरोक्विन इनटेक बेटा. तो अगर आफ्टर स्टार्टिंग अ डीमार्ड दे आर रिकमेंडिंग बेसिकली they are definitely asking the patient beta to undergo regular visual acuity and fundus examination. That means it is a case of hydroxychloroquine which has been given to the patient which is hopefully clear about. That is important. इसके अलावा दो तीन चीजें और बता रहा हूँ. One is definitely beta, please remember tofacitinib is a JAK-STAT inhibitor given in cases of rheumatoid arthritis. Again, leflunomide is also immunosuppressant or immunomodulator drug beta. That is also included in DMARDs. Important is if they ask you beta regular fundus examination, so you know now it is hydroxychloroquine. अगर वो पूछेंगे बेटा regular LFT monitoring, then which anti-cancer drug is there? Very good. So regular LFT monitoring beta is usually advised after starting a DMARD or anti-cancer drug known as methotrexate. तो अगर ये बोलते हैं कि regular LFT monitoring is advised, then I would have gone for the answer as methotrexate, because methotrexate causes a lot of hepatotoxicity or liver damage beta. Next important, if they would have advised that the female has to go for regular CBC monitoring, which antipsychotic drug I would have considered? Antipsychotic की बात चल रही है, clozapine. Very good. So regular CBC monitoring, if they say beta, I would definitely consider that the drug which has been started is clozapine, because clozapine is an atypical antipsychotic beta, and this atypical antipsychotic known as clozapine is known to cause a dangerous side effect called as agranulocytosis, and therefore beta we have to go for regular CBC or a complete blood count monitoring of the female. Clear? At least remember तीन चीजें: fundus monitoring, LFT monitoring and CBC monitoring. ठीक है? Done with this. Question number 196 beta. A pregnant female comes for an antenatal scan beta, that is the ultrasound during pregnancy, and the ultrasound image has been shown below. What is the best time they are asking you to confirm the given gross congenital anomaly? Now first of all we have to see which is the given gross congenital anomaly beta. Very good. Here you are able to see beta that the head or the cranial cavity of the baby is not formed, and as the head and the cranial cavity of the baby is not formed, it is a classical picture of anencephaly. I hope all of you are quite aware beta that anencephaly is the first gross congenital anomaly beta which can be picked up on an ultrasound. So the first gross congenital anomaly that we can pick up on ultrasound is anencephaly. It can be picked up as early as 10 weeks beta. It can be picked up as early as 10 weeks bache, and best picked up by 14 weeks beta. Now right now earliest picked up अगर पूछते तो answer would have been 10 weeks. They have asked you it is confirmed picked up what time, the answer has to be 14 weeks. The best time to confirm that it is a case of anencephaly or not beta, answer has to be option B, that is 14 weeks beta. So best time to confirm anencephaly is 14 weeks. Earliest time अगर पूछा होता तो my answer would have definitely been 10 weeks. Clear about? So that is what is important to remember. No issues with this? Chal. If they ask you beta, anencephaly gives which kind of appearance on the ultrasound? Frog eye appearance or Mickey Mouse appearance. So frog eye appearance or the Mickey Mouse appearance which is there beta, that is classically seen in patients who are suffering from anencephaly beta. So frog eye appearance or the Mickey Mouse appearance is classically seen beta in patients who are suffering from anencephaly. Clear about? So that is what is important. And what is the most common marker for anencephaly or any of the neural tube defects? The most common marker for anencephaly or any of the neural tube defects, most common. Alpha fetoprotein beta. Please remember, alpha fetoprotein is actually considered as the most common marker beta in patients of neural tube defects like anencephaly. If they ask you which is the most specific or the best marker to confirm a case of neural tube defect, the most specific or the best marker to confirm a neural tube defect, answer would be acetylcholine esterase beta. Then the answer is going to be acetylcholine esterase. Hopefully that's clear to all of you now. So at least remember these important points beta. Done. Next is question 197 beta. We are having a 68-year-old known diabetic patient who is currently taking insulin. Have been brought to the hospital beta. He complains of headache and vomiting beta since the last few hours and his son is giving history that he has slept in the bathroom 2 to 3 weeks ago. Sarkari. NCCT head has been given below beta. Take what is the most probable diagnosis of the case? So we know beta, first of all, elderly patient who sleeps in the bathroom beta. It is a very classical diagnosis of SDH, that is subdural hemorrhage. और हमें पता है whenever the patient is going to have a SDH or a subdural hemorrhage beta, there will be which kind of hyper or hypodensity? Concavo convex beta. Here you are able to see the hypodensity which is there beta. It is concavo convex, also called as crescent shape. So there is a concavo convex or a crescent shape. This is hyper or hypodensity. So here something is appearing black. So it is a concavo convex hypodensity. If something appears black, it is a hypodensity. And please tell me beta, concavo convex hypodensity will be a feature of acute SDH or a chronic SDH? So we know beta, it is a classical case of chronic SDH definitely beta, because here also they are giving a history of trauma 2 to 3 weeks ago beta. And याद रखना, जब something appears more black basically or hypodense, it has to be a case of chronic SDH beta. If it would have been acute SDH, then there should have been a recent history of trauma beta along with whitish opacity, that is called as hyperdensity. So this is the picture that you are able to see. Can you see this one? So यहाँ पे there is something more white. So here definitely it is a concavo convex hyperdensity or a crescentric hyperdensity. So concavo convex hyperdensity or a crescentric hyperdensity is seen in this picture, and we know this is going to be a case of acute or chronic SDH? Acute. If this would have been a picture, then I would have said okay, it is a case of acute SDH or acute subdural hemorrhage beta. Hopefully that's clear to all of you now. So that is what is important to remember. Done with this? Next important if I talk about beta. Okay. Next important if I talk about, यहाँ पे जो पिक्चर दिख रहा है, what is this picture? यहाँ पे the hyperdensity which is seen beta, it is by convex, and we know whenever there is a biconvex or there is a biconvex or a lenticular hyperdensity. So biconvex or a lenticular hyperdensity is a classical feature of nothing else but EDH, that is extradural hemorrhage, acute or chronic basically. Why acute? Because it is a hyperdensity or it is going to be a whitish appearance. So it is a classical diagnosis of acute EDH or acute extradural hemorrhage. Hopefully that's clear to all of you now. So that is important to remember. So here it is a classical case of nothing else but option D, that is chronic SDH. In the recent NEET PG there was the same question. Just in the first 3 lines they confused you so much with the patient is a known case of MI, the patient is suffering, the patient had a history of stroke, the patient is currently taking aspirin, and तीसरी line आके they have said that the patient had a history of fall from chair 3 weeks ago. And then a picture was given which was showing a concave or convex blackish appearance or hyperdensity. And then they asked you what is the probable diagnosis. The answer was again a chronic hematoma or a chronic SDH. Clear enough? So that is what is important. They actually wanted to confuse you with ischemic stroke, nothing else. Done with this? Sure. So if it was chronic EDH, then it would have been a biconvex or a lenticular hypodensity beta. Subdural empyema, the empyema is a pus collection or fever. Sorry, empyema is a pus collection beta. So here there should have been a history of some unsafe CSOM in the patient, followed by which the patient should have had fever, pain, these kind of features beta. Clear है? Ischemic infarct होगा. So ischemic infarct में beta the hypodensity is seen, but that hypodensity is going to be seen inside the brain tissue beta. That blackish appearance is seen inside the brain tissue, not in the meninges. Clear? Next is question 198 beta. Here we are having a 32-year-old man who presents to you with complaints of sudden onset pain in the back region beta. The patient is having sudden onset pain in the back region which is radiating to the left leg beta. MRI spine of the patient was done and it has been shown below. What is the likely diagnosis? So here you are able to see there is a sudden onset pain in the back radiating to the left leg. Matlab it can be due to nerve compression beta or it can be due to a radiculopathy. If you see the MRI, what is the likely diagnosis? क्या देख रहे हैं? हाँ? So please remember beta, here there is nothing else but are you able to see a bulge basically over here of the intervertebral disc? Clear है? So definitely at this level beta, you are able to see a bulge of the intervertebral disc बच्चे, ठीक है, which is compressing the nerve fibers. So the nerve fibers which are going out of the spinal cord beta, those are compressed basically due to the bulge. ऊपर और नीचे compare करो, you will basically understand. ठीक है? So definitely there is a bulge of the intervertebral disc beta which is actually compressing the nerve fibers beta. That is important to remember. So it is a classical diagnosis of which condition? PIVD, that is prolapse of the intervertebral disc. So please remember PIVD is nothing else but prolapsed intervertebral disc. So whenever the intervertebral disc is going to hang beta or whenever it is going to bulge out beta, that is called as the PIVD or prolapsed intervertebral disc. Clear about it? And PIVD, I hope all of you are quite aware, it is very common. Disc prolapse is common definitely. PIVD or prolapsed intervertebral disc. What is the commonest site? The commonest site for prolapsed intervertebral disc will be yes, it is going to be L4, L5, and the other common site will be L5, S1 beta. The another common site will be L5, S1. So definitely it is L4, L5 along with L5, S1. These are the common sites beta for a prolapsed intervertebral disc. That is what is important to remember. Clear about decompression of the nerve fibers is done beta by surgery. That is what is important. What is spondylolisthesis? That was a PYQ again. This is spondylolisthesis. What is spondylolisthesis? Nothing else but क्या दिख रहा है? Are you able to see the line is not, the curve is not properly formed over here? Q, because you can see beta that this lumbar vertebra which is there beta, it has got slipped. Okay, so please remember definitely here you are able to see beta that there is a subluxation between the lumbar vertebra. Subluxation is partial dislocation. So here there is a subluxation or a partial dislocation of the lumbar vertebra and that subluxation is basically called as spondylolisthesis. That subluxation is basically called as spondylolisthesis beta. Here the spondylolisthesis is at which level, anybody? L4, L5 beta. Here the spondylolisthesis is at the level of L4, L5. याद रखना, अगर नहीं पता तो ये हमेशा sacrum देखा करो. Always see the sacrum. We know above the sacrum we have the L5. उसके ऊपर L4, L3, L2. That is how you count. Clear है? So that is important to remember. No issues with this. चलो. Next is question 199 beta. Here you are able to see which among the following statement is false regarding beta the condition which have been visualized on the X-ray KUB. So here there is an X-ray of kidney, ureter and bladder, and on this X-ray kidney, ureter and bladder basically beta you are able to see this picture. मुझे बताओ, on X-ray kidney, ureter and bladder, definitely if you are able to see something white or a calcification beta, that can be either calcification of the kidney or it can be a stone inside the pelvis beta. तो यहाँ पे the calcification is in the form of kidney or in the shape of pelvis? तो यहाँ पे the calcification is in the shape of pelvis. Whenever there is a calcification in shape of pelvis, is it a case of putti kidney or staghorn calculi? Whenever there is a calcification in the form of pelvis beta, we know it is a case of staghorn calculi. Staghorn calculi is actually which type of urinary stone beta? Very good. So staghorn calculi is the triple phosphate stone or the struvite stone. So whenever there is a triple phosphate or a struvite stone, definitely that will grow very huge in size beta, and that is called as the staghorn calculi which is. Now important is they are asking you what is actually going to be false regarding this condition. Option A says usually it is associated with the urinary tract infection by Proteus mirabilis. Is it true? Yes. Absolutely, and a recent question also in the examination. So Proteus mirabilis infection is very commonly associated beta with the staghorn calculi or the triple phosphate stones. Clear about? Next important, needs to be treated with PCNL? Yes beta. Such a huge stone which is there, you cannot remove it by ESWL definitely. You have to remove directly called as PCNL or a percutaneous nephrolithotomy beta. Usually associated with genitourinary TB? No. Genitourinary TB के साथ what is commonly associated is the putti kidney beta, not the staghorn calculi. Clear about? Bare pause sign is seen on CT scan? Yes beta. If you do a CT scan, you are able to see a sign like a bare paw beta. That is important to remember. The answer has to be nothing else but option C. Clear? This is the classical picture where you are able to see X-ray KUB where there is calcification in the form of kidney beta, and whenever there is calcification in the form of kidney, it is called as putti kidney, and we know putti kidney is a classical feature of renal tuberculosis beta. Please tell me renal tuberculosis or genitourinary tuberculosis mein keyword of the question. Very good. So please remember beta, अगर वो बोलते हैं कि पुट्टी kidney या renal TB या genitourinary TB में, the keyword of the question answer is going to be sterile pyuria beta. Reason is in the urine microscopy beta, bacteria is going to be absent, pus cells are going to be present, that is sterile pyuria. No other urinary tract infection causes sterile pyuria except TB. So this is the keyword of the question. Hopefully clear to all of you now. So that is important to remember. Question number 200, it states beta, we are having a 58-year-old female beta who presents to us with complaints of infrequent dysphagia beta, and she is also having regurgitation of food whenever she lies down. She also complains of chronic cough. Which among the following will be the next step to be done in this patient beta? Now मुझे बताओ, she is definitely a 58-year-old female beta who has come to us with complaints of infrequent dysphagia which along with regurgitation of food. ठीक है, and she is also having chronic cough beta. Which among the following is the next step to be done? Was image given in your question? No. No, image was not given. The patient's complaint is what? Dysphagia. Whenever any patient comes to you with dysphagia, the first line investigation is nothing else but barium. Any patient of dysphagia coming to you, first line investigation is always a barium swallow to be done beta. So obviously here my next step has to be option D, that is a contrast study. My next step has to be option D, that is a contrast study first. Let me do the contrast study, then I will understand whether it is a motility disorder or it is a case of GERD or it is something else. Clear? वो देखने के लिए I have to go for a barium swallow where there will be a sharp narrowing or a smooth tapering which is seen, and the smooth tapering appearance that you are able to see beta, it is classically called as the bird beak appearance. So smooth tapering which is seen beta, it is classically known as the bird beak appearance, the pencil tip sign. And this bird beak appearance which is there definitely beta on barium swallow is a classical feature of which condition? Achalasia cardia. If this will be seen on the contrast study or if this will be seen on the barium swallow, then I will suspect it to be a case of achalasia cardia. And when I suspect it to be a case of achalasia cardia, then to confirm my diagnosis, my investigation of choice has to be nothing else but esophageal manometry beta. My investigation of choice for that has to be nothing else but option A, that is esophageal manometry. Clear है बात? So that is what is important. So dysphagia अगर बस बोलते हैं तो first step is always a contrast study like a barium swallow beta. And हाँ क्या क्या? किसके लिए? सेम अगर सिम्टम्स दिए हैं तो डेफिनेटली उन्होंने नेक्स्ट स्टेप पूछा है. तो डिस्फेजिया में बेस्ट स्टेप पूछा तो मैनोमेट्री वुड बी द आंसर टू डायग्नोज. बट यहाँ पे नेक्स्ट स्टेप पूछा है तो नेक्स्ट स्टेप में डायरेक्ट मैनोमेट्री नहीं करोगे. पहले लेट्स सी बेसिकली व्हाट इज द अपीयरेंस सीन एंड डिपेंडिंग ऑन दैट आई डिसाइड माय नेक्स्ट स्टेप. मे बी इफ इट इज अ केस ऑफ GERD, राइट, देन इन दोज काइंड GERD का कॉम्प्लिकेशन भी हो सकता है, right? So definitely if it is a case of GERD, I may have to go for endoscopy or I may have to go for definitely a 24-hour pH monitoring. So that depends basically what is going to be seen on barium swallow. Depending on that, I will decide my next step. Clear? So investigation of choice. If it was achalasia cardia, I would have gone for esophageal manometry. If it was a case of GERD beta, then definitely what will be the investigation of choice? PY2 repeated in your exam. Upper GI endoscopy. Investigation of choice for GERD is the upper GI endoscopy and not 24-hour pH monitoring. 24-hour pH monitoring is a gold standard investigation, not the investigation of choice. It is only done in those conditions where upper GI endoscopy fails to make a diagnosis. Clear है बात? याद रखना. तो GERD में अगर investigation of choice पूछे, it is endoscopy. Gold standard पूछे, then it is 24-hour pH monitoring. Clear? Lifestyle modification and PPIs is again the treatment for GERD beta. So that is what is important to remember. Achalasia cardia में the best treatment has to be which myotomy? Heller's myotomy. We know beta the best treatment for achalasia cardia is nothing else but the Heller's myotomy surgery beta. That is important to remember. Hopefully clear. Next, this is the classical picture beta. In this classical picture, you are able to see irregular or shaggy appearance on the barium swallow of the contrast study. And this irregular filling defect is basically this irregular tapering is classically known as rat tail appearance beta. So this irregular tapering or the irregular filling defect that I am able to see beta is the classical rat tail appearance, and rat tail appearance on barium swallow is a classical feature of esophageal cancer. So whenever there is rat tail appearance on the barium swallow beta, it is a classical case of esophageal cancer. Hopefully clear to all of you now. So that is important. So irregular filling defect, all we know beta is seen in esophageal cancer. Anybody smooth or regular filling defect, which was a recent option in FMG exam. Smooth or a regular filling defect. Smooth filling defect or a regular filling defect. ऐसा वाला. If there is a smooth or a regular filling defect. Anybody, which condition? Smooth filling defect or definitely a regular filling defect is a feature of. It is a feature of benign tumor in the esophagus called as esophageal leiomyoma. It is a classical condition, benign esophageal tumor called as an esophageal leiomyoma. Esophageal leiomyoma होता तो definitely I would have been able to see a classical smooth filling defect beta or a regular filling defect. Hopefully that's clear to all of you now. So that was an option given in the recent FMG examination. So please remember that smooth filling defect is a feature of esophageal leiomyoma. Done with this. Next is question 201 beta. Here we are having a 20-year-old female who has a unilateral headache beta, which is associated with photophobia, that is irritation to light, along with nausea and vomiting beta. Which drug can be used to prevent the future episodes? What is the likely diagnosis? So we know younger female coming to you with episodic headache beta associated with phonophobia, photophobia, nausea and vomiting is a classical diagnosis of migraine beta. We know that it is usually seen in younger females बच्चे, ठीक है, and we know that migraine is usually a unilateral headache. Which is the criteria used for diagnosis of migraine? So pound criteria is used for the diagnosis of migraine beta. And whenever I say pound criteria, P for pulsatile in nature beta. So P for pulsatile in nature, O for one day illness beta. It is one day illness, usually symptoms last for 24 hours. U for unilateral headache beta. N for nausea and vomiting beta. And D for disabling in character. इतना severe होता है कि काम नहीं कर पाता patient, that is disabling in character. At least 4 symptoms out of it beta will be required to make a diagnosis of migraine beta. And if I talk about it is a case of migraine, the drug of choice for prevention they are asking you, or prophylaxis they are asking you. Answer has to be, so we know option D, beta blocker known as propranolol is the drug of choice for prevention or prophylaxis of migraine beta. If they would have asked beta, what is the drug of choice in the acute attack of migraine? So in acute attack of migraine beta, the treatment or the drug of choice has to be NSAIDs, that is non-steroidal anti-inflammatory drugs, something like naproxen beta. Clear? Whereas if they ask you about acute severe attack of migraine, so we know beta acute severe attack of migraine which is there, it is mainly due to a group of drugs known as triptans beta. And when I talk about triptans, basically I hope all of you are quite aware. Triptans act on which receptors? So they are 5-HT1B 1D agonist beta. The 5-HT1B 1D agonist are going to be triptans. Commonest triptan that is used, sumatriptan beta. The commonest triptan that we tend to use for management is sumatriptan. Important to be remembered, the other group of drugs basically which are also used in the treatment of acute severe attack of migraine beta, okay, but that is known to cause peripheral vasoconstriction or gangrene. What are those drugs? Another drugs which are used in the severe acute attack of migraine beta, PYQ repeated 2-3 बार का FMG का question है. And patient of migraine definitely has been taking a drug which is known to cause peripheral vasoconstriction like tingling, numbness, paresthesias in the periphery, which can even lead to gangrene. Ergotamines beta, ergotamines like dihydroergotamine, okay, their major side effect is a peripheral vasoconstriction which can even lead to gangrene in the patient beta. It can even cause gangrene in the patient. Very very important to remember. Clear बात? तो याद रखना. So therefore ergotamines are not preferred. This has been a common question in examination. Be aware of that. ठीक है? तो ergotamines are known to cause gangrene. Done with this? चलो. So that is important to be remembered. Next is question number 202 beta. Here we are having a patient after getting operated beta for a case of appendicitis. The patient has developed confusion and the person appears to be disoriented to time, place and person beta. He also complains that he is able to see snakes around him beta. Okay? His wife informed that he takes alcohol occasionally beta. What could be the possible cause for his condition? चलो ऑप्शंस में अगर दो चीज़ें होती, इट इज डेलीरियम एंड डेलीरियम ट्रेमेंस. आंसर वुड बी, ऑप्शन में दो चीज़ें हैं. आई एम गिवन यू डेलीरियम ऑल्सो एंड डेलीरियम ट्रेमेंस ऑल्सो. आंसर वुड बी डेलीरियम. डिड दे टॉक अबाउट एनी लास्ट अल्कोहल इनटेक कब हुआ तुम्हें पता है? तो कैन यू से इट इज ड्यू टू अल्कोहल विड्रॉल? ही टेक्स ओकेजनली ना, दैट इज इंपॉर्टेंट. वी आर नॉट श्योर डेफिनेटली कब हुआ, क्या हुआ, वो अल्कोहल विड्रॉल की वजह से है भी या नहीं है. ठीक है, बट वन थिंग इज दैट्स फॉर श्योर एंड दैट पेशेंट हैज गॉट ऑपरेटेड फॉर अपेंडिसाइटिस बेटा. ठीक है, and therefore the person might be in the hospital, and a lot of people when they are in the hospital basically beta they tend to develop delirium. Delirium is an acute mental disorder which develops all of a sudden beta, and usually it can be associated with a history of surgery or something. Okay, a history of illness, history of surgery, that is very commonly associated with delirium beta. And we know delirium mein the patient is going to have confusion, the patient is going to have disorientation to time, place and person, and the person will have psychotic symptoms like hallucinations beta. So it is a classical diagnosis of nothing else but option D, delirium beta. Delirium is nothing else but clouding of consciousness. So whenever the patient is not conscious beta, so whenever there is clouding of consciousness, that is what is important to remember. crowding of consciousness, disorientation to time, place and person, altered sensorium. These are the keywords of delirium. That is important. ठीक है, उसके साथ साथ delusions and hallucinations can be seen. Important is delirium will have acute onset or chronic onset. Acute onset always beta, it will start all of a sudden or very abruptly. Important beta, delirium में the patient delirium में beta in this patient there is a classical phenomena. Symptoms become more severe in the evening hours called as sundowning. Very good. So sundowning phenomena is going to be seen. Sundowning phenomena is nothing else but symptoms actually become more severe beta in the evening hours. That is a classical feature of delirium which is associated. Hopefully that's clear to all of you now. So do remember this. And what is the treatment of delirium, anybody? Delirium के लिए क्या करोगे? You can give benzodiazepines or SSRIs beta basically. That is important to be remembered. ठीक है? Next important is dementia. If I talk about dementia is what? In simple terms, dementia means memory loss beta. In simple terms, dementia is memory loss. Acute onset or chronic onset? Chronic onset beta. Dementia is always going to have chronic onset. Now, apart from that, will there be any kind of clouding of consciousness or disorientation? No beta. Please remember, the patient will be conscious. Okay, the consciousness will be present bit over here. Now why I am telling you this? Because a lot of times in the examination they try to confuse you with two things beta. One is definitely delirium and second is dementia. याद रखना, dementia is going to have chronic onset. Dementia when the consciousness of the patient is absolutely intact or normal beta. There is no disorientation to time, place and person bache. There will be no other symptoms like hallucinations or delusions commonly. But if it is a case of delirium, so delirium में clouding of consciousness or altered sensorium along with confusion and disorientation will be present beta. Here it will have an acute or a sudden onset bache. That is what is going to be seen. अब memory loss is a feature of both. क्योंकि delirium में भी patient will not be able to recall the events बेटा, इसीलिए मैं बता रहा हूँ. समझे बात अभी? Why I am telling you this differences? Because memory loss can be present in both the condition and that will be described in both intentionally, just to confuse you. तो इसीलिए बात है. So do remember that. No issues with this? Chalo. Now important is acute psychotic disorder is when patient is having delusion and hallucinations lasting for a minimum span of less than 1 month. So whenever this hallucination and delusion like psychotic symptoms are lasting for a span of less than 1 month beta, it is a case of acute psychotic disorder. 1 to 6 months ho to schizophrenic form disorder beta, and more than 6 months ho to schizophrenia. That is important to remember. So schizophrenia mein these psychotic symptoms should last for a span of more than 6 months. Then we diagnose it as a case of schizophrenia. Another favorite question of FMG examiners, and that is alcohol withdrawal. They will say that the patient is a chronic alcoholic beta and the patient might have taken the last alcohol the last intake of alcohol beta was few hours ago. Now if they say patient's last alcohol intake beta was 6 to 12 hours ago, now the patient will start developing minor withdrawal symptoms, PYQ, which is the most common withdrawal symptom of alcohol. Very good. The most common withdrawal symptom of alcohol beta is going to be tremors. Apart from that, patient will have tachycardia or palpitations. Patient may have some respiratory distress. Patient's temperature may increase as well. Next, 12 to 24 hours after the last intake. So 12 to 24 hours after last intake, patient will develop alcoholic hallucinosis beta. So there will be alcoholic hallucinations which are going to develop with it. That is what is important to remember. Next, 24 to 48 hours after the last intake. So 24 to 48 hours after the last intake, patient is going to develop generalized tonic-clonic seizures beta. These are called as withdrawal seizures. And 48 to 72 hours later, 48 to 72 hours after the last intake, patient is going to develop delirium. Same features of delirium will be present. Clouding of consciousness, disorientation, confusion, along with psychotic symptoms at times. Clear? So that is what is important. This is a favorite question of your examiner. Next, treatment अगर वो पूछेंगे बेटा, what is the treatment for alcohol withdrawal? Not only for delirium tremens but for all the types of alcohol withdrawal. What is going to be the treatment? बोलो. The treatment for alcohol withdrawal are benzodiazepines beta. So benzodiazepines are actually considered as the treatment for alcohol withdrawal. Either you can give drugs like lorazepam वगैरह, or an important drug is known as chlordiazepoxide beta. You can give a drug like chlordiazepoxide. So yeah, that was the PYQ linked ones. So chlordiazepoxide, which is there beta, it is a benzodiazepine used in the management of alcohol withdrawal. Done with this? How much is the legal limit of alcohol for driving? 30. So 30 milligram, 30 milligram per deciliter is the legal limit of alcohol beta or blood alcohol concentration for driving. That is important. Next question is going to be, which among the following is the most radiosensitive bone tumor beta? So we know out of the following, the most radiosensitive bone tumor is going to be option B, that is the Ewing's sarcoma beta. Now हमें पता है basically, see, most of the other bone tumors are radio-resistant. The most radio-resistant bone tumor will be osteosarcoma. Very good. The most radio-resistant अगर पूछा जाए बेटा, then definitely answer is osteosarcoma. तो osteosarcoma में is radiotherapy useful? Not at all. There is no use of radiotherapy beta in the treatment of osteosarcoma. That has to be kept in mind. No issues with this. Can osteosarcoma develop due to radiation? Yes, osteosarcoma develops due to radiation beta. That is important to remember. Clear? Now important is यहाँ पे जो picture दिख रहा है. First of all, just see. First thing is, what side of the bone is involved beta? It is the metaphysis, diaphysis or epiphysis? It is the shaft of the bone, that is diaphysis of the bone is involved beta. Second important is, okay, which bone is involved over here? It is the femur that is involved over here beta. That is important to remember. Clear? And I say definitely the age of the patient which is there now, it is usually less than 20 years of age. That is a child or a young patient is there beta. Okay, what, and X-ray is this one. What is the likely diagnosis? Ewing's sarcoma. What is seen definitely, these are multiple layers beta. And these multiple layers will be called as which appearance? Onion peel appearance beta. So whenever the X-ray of a long bone shows you the classical onion peel appearance, and three important features, that the site involved is diaphysis in the femur bone and child less than 20 years of age, has to be a classical diagnosis of Ewing's sarcoma. Ewing's sarcoma, patient will have fever, patient may have pain, patient may have swelling and redness over the site. So pain, swelling, redness over the site along with fever. It looks like a bone infection called as osteomyelitis. हमें पता है ना, Ewing's sarcoma is going to mimic or it is going to be very similar to a bone infection known as osteomyelitis beta. That is important to remember. What is the marker for Ewing's sarcoma? Tumor marker. Very good. The tumor marker for Ewing's sarcoma is going to be CD99 beta. That is also called as MYC2. So MYC2 definitely or CD99 is considered as a tumor marker for Ewing's sarcoma beta. That is important to remember. Clear? Next picture देख सकते हो. Now here, which side of the bone is involved? Metaphysis, diaphysis or epiphysis? It is the neck beta. Neck involved है ना? So neck is nothing else but metaphysis beta. First thing, which bone is involved? Again it is the femur. The lower end of femur is going to be involved over here. And again I say the patient is usually between 10 to 20 years of age, or the patient is more than 40 years of age beta. Either 20 है या फिर more than 40-45 है. दोनों में से एक केस होगा. Okay, what is the likely diagnosis? Very good. It is definitely the most common primary bone malignancy called as osteosarcoma beta. If I talk about osteosarcoma, so we know beta osteosarcoma mein there are going to be the two classical presentations which will be seen. The first one which is there beta, yes. So here you are able to see this classical sun ray or the sunburst appearance beta. बराबर. So either you can call it as the sun ray or the sunburst appearance which can be seen beta. ठीक है. Next important, if they ask you what is this triangle over here, where the peritoneum is where the periosteum is lifted up, that is called as the Codman's triangle. So whenever this, can you see definitely the periosteum gets lifted up due to the periosteal reaction, this is known as the Codman's triangle. याद रखना, whenever there is a sun ray or a sunburst appearance along with the Codman's triangle beta, it is a classical case of an osteosarcoma. That is important to be remembered. Osteosarcoma is associated with which gene mutation? Very good. RG or the retinoblastoma gene mutation. It is also associated with the previous exposure to radiation exposure. Secondary osteosarcoma बोलेंगे फिर उसको. Clear है बात? So that is what is important. तीन चीजें जो bone tumors में important है. Site of the bone, exactly which bone is affected, and age of the patient. These are the only three things जो bone tumor में देखने होते हैं. और तीसरा जो bone tumor तुम्हारे examiner का favorite है, and that is nothing else but a patient after 30 years of age or after skeletal maturity beta comes to you, and the patient is going to have involvement of definitely the metaphysis beta, which is going up to the epiphysis. मेटाफाइसिस से लेके एपिफाइसिस तक इन्वॉल्वमेंट होता है बेटा and they will say definitely that the sites which are involved are going to be lower end of femur, upper end of tibia, followed by distal end of radius. These are the common sites beta, lower end of femur, upper end of tibia and distal end of radius. ठीक है, तुम्हारे एग्जाम में ये आता है कॉमनली, बट प्लीज रिमेंबर इट इज नॉट द कॉमनेस्ट वन. कॉमनेस्ट इज लोअर एंड ऑफ फीमर. क्लियर? याद रखना. एंड वी नो दिस इज अ क्लासिकल डायग्नोसिस ऑफ GCT. व्हाट इज GCT? Giant cell tumor beta, and this giant cell tumor is also known as osteoclastoma beta. It is also called as an osteoclastoma. Which kind of appearance on the X-ray? Very good. So osteoclastoma or definitely the giant cell tumor gives you a classical soap bubble appearance on X-ray. Now in a PYQ बेटा एक बार बहुत घुमाया था. August was the question जहाँ पे they definitely did a lot of twisting and turning beta in the question. But one thing was there and they mentioned after removal of the mass beta that was sent for histopathological examination which revealed multinucleated giant cells. So multinucleated giant cells on histopathology has to be a case of giant cell tumor. Obviously giant cell tumor was not an option, it was osteoclastoma which was clear about. So please remember that. No issues with this? Sure. Next important beta, easy question. While performing beta an appendectomy, which the surgeon encounters a lesion 2 feet proximal to the iliocecal junction. This was a recent question in FMG examination. Okay, what is the most probable diagnosis? तो हमें पता है बेटा it is 2 feet proximal to the iliocecal junction beta. It is more likely nothing else but a case of Meckel's diverticulum. And if you see the picture, obviously an outpouching is there seen from the intestine. Mesenteric or anti-mesenteric border? Very good. Anti-mesenteric border पे बेटा you are able to see this outpouching. It is nothing else but a case of option D, Meckel's diverticulum beta. Meckel's diverticulum, if I talk about बच्चे, it follows which rule? We know Meckel's diverticulum follows the rule of 2 beta. And when I say the rule of 2, that is, it is seen in 2% of the population beta. It is going to be 2 inches long. It is 2 feet proximal to the iliocecal junction. And 20% patients will have an ectopic mucosa. PYQ. Most common ectopic mucosa in Meckel's diverticulum. Very good. So most common ectopic mucosa in Meckel's diverticulum beta is nothing else but gastric mucosa. The most common ectopic mucosa in Meckel's is going to be the classical gastric mucosa followed by pancreatic. Clear about? Important is between Meckel's diverticulum. What mostly the patients are symptomatic or asymptomatic? Majority patients are asymptomatic. And अगर presentation है तो क्या होगा? PYQ again. Most common presentation in patients of Meckel's diverticulum. Most common presentation. Very good. It can be not melena exactly, but yes, there would be a bleeding per rectum beta. That is what is important to remember. So bleeding per rectum is the commonest presentation beta in patients of Meckel's diverticulum. What is the investigation of choice? Technetium 99 हो गया. आगे बोलो. कितनी बार बोला है कि technetium 99 is nothing else but the contrast of the agent that we use over here. It is not the investigation. Investigation is per techniques. क्योंकि technetium 99 में किसी भी investigation के आगे लगा सकता हूँ. Clear है बात? That is important. ठीक है, तो technetium 99 per technique scan has to be the investigation of choice बेटा. Technetium 99 system scan is done for parathyroid gland. Recent question again in FMG. The technetium 99 system scan is done for the parathyroid gland pathologies beta. That is important to remember. Treatment of Meckel's diverticulum is only done if it is narrow or wide. So treatment of Meckel's diverticulum is only done when it is very narrow in size, and we have to go for removal beta. And removal is nothing else but diverticulectomy beta. You have to just remove the Meckel's diverticulum called as diverticulectomy. And Meckel's diverticulum is due to partial patency of which embryological structure? So Meckel's diverticulum is due to partial patency of the vitello-intestinal duct beta. So vitello-intestinal duct अगर partially patent है, that leads to formation of Meckel's diverticulum बचे. Next important, what is this case? Very good. So here you are able to see the intestine is basically gone. तो एक तो please remember anatomy के question देख के डर जाओ images, that I understand. सर्जरी के पिक्चर्स देख के डरो मत. बेसिकली देयर विल बी अ लॉट ऑफ थिंग्स व्हिच विल बी इजियर. ठीक है, वो कोई तुम्हें कैंसर वैंसर नहीं पूछने वाला दिखा के. हाँ ऑगस्ट में पूछा था गॉल ब्लैडर का, बट अदरवाइज दे डोंट, ठीक है। तो यूजुअली वो इजी पिक्चर्स देते हैं, मेकल्स दे देंगे, मेकल्स डायबिट, सॉरी इंटरसेप्शन दे देंगे, इंटेस्टाइनल परफोरेशन दे चुके हैं, दीज काइंड ऑफ क्वेश्चंस दे गिव यार, ठीक है। अगर सर्जरी का कोई क्वेश्चन आता भी है ना, प्लीज रिमेंबर इट विल बी इजी, image based. This is a classical picture of intersusception beta, when one part of the bowel goes into the adjacent part beta. Intersusception is common in children less than, intersusception is more common in children less than 2 years of age. Okay, it is most commonly seen at which site, which junction? हमें पता है इलियोसेकल जंक्शन बेटा is the commonest site where we are able to see intersusception beta. कौन सी vaccine is commonly associated with intersusception? So we know beta that the rotavirus vaccine which is there beta, it is commonly associated to cause intersusception beta. That is important to remember. This has been a PYQ. Be aware of that. Important is in intersusception patients basically beta. Please remember. So intersusception, if they ask you definitely in patients of intersusception, what we have to do? We know the children are going to come to us with complaints of bowel obstruction beta. Apart from bowel obstruction, which kind of stools will be there? We have the classical red currant jelly stools. We know red currant jelly stools is a feature of intersusception. Red currant jelly sputum will be seen in Klebsiella pneumonia beta. We know that red currant jelly sputum is a feature of Klebsiella pneumonia beta. ठीक है. Whereas patient will have a shaped lump, sausage shaped lump beta. So sausage shaped lump is a feature of intersusception. Olive shaped lump is a feature of CHPS. Sausage shaped lump is seen in patients of intersusception beta. Olive shaped lump will be a feature of CHPS or hypertrophic pyloric stenosis. Clear है बात? Important intersusception में, if I do an ultrasound, which is the investigation of choice beta, on ultrasound I am able to see a classical sign called as तो target sign or cross sign FSL. Target sign or donut sign basically will be seen beta. So target or the donut sign which is there, it is classically seen beta on ultrasound abdomen in a child suffering from intersusception. Gold standard investigation. The barium enema is the gold standard investigation for intersusception, and which sign will be seen on that? Cross sign beta. So the cross sign or the coiled spring sign will be a classical feature on barium enema in a child suffering from intersusception beta. That is important to remember. Intersusception with the treatment is nothing else but we have to go for a hydrostatic or a hemostatic reduction. So hydrostatic or hemostatic reduction should be always tried first beta. If that doesn't help or if there are complications, then we go for a manual reduction. Okay, we initially always try hydrostatic or hemostatic reduction beta. Clear है बात? ये कर लो and then you can take your break. Question number 205. A patient sustains a RTA or a road traffic accident and is taken to the emergency room beta, where he is found to have a pelvic fracture. On examination beta, blood is seen at the tip of the external urethral meatus and the pain is there in the suprapubic area. What is the next best step in the management of the patient? Bolo. What are you suspecting? तो जब भी वो pelvic fracture बोलेंगे बेटा, in pelvic fracture there are two things that can happen. One is the patient may have an extraperitoneal bladder rupture. The patient may have an extraperitoneal bladder rupture. हमें पता है that this extraperitoneal bladder rupture which is there बेटा, it is commonly associated with which urethral injury? Anybody? Anterior or posterior? Posterior. The extraperitoneal bladder rupture beta, it is commonly associated with a posterior urethral injury or a membranous urethral injury beta. So whenever they will say extraperitoneal bladder rupture along with the posterior urethral injury, patient will not be able to pass urine, patient will have bleed at the tip of the external urethral meatus and there will be pain in the suprapubic area. तो यहाँ पे उन्होंने next best step पूछा है, तो next best step has to be nothing else but option C, that is nothing else but suprapubic catheterization. I should definitely insert a suprapubic catheter directly into the urinary bladder so that the bladder can drain beta. And if the bladder will drain directly, the bladder and the urethra will get time to heal. That is what is important to remember. Clear है बात? If the bladder and the urethra cannot heal, then we go for a surgical repair beta. That is important. ठीक है? Foley's insertion अगर try करोगे, so if you try Foley's insertion when there is a urethral injury, the rupture can actually increase beta by insertion of the Foley's which है. Emergency repair is done in cases of intraperitoneal bladder rupture beta when there is peritonitis, and for that we have to go for a laparotomy बच्चे. That is important to be remembered. Clear है बात? यहाँ पे you are able to see this classical picture. क्या दिख रहा है? As you can see here, there is an extraperitoneal bladder rupture and a urethral injury. Therefore you can see the urine is actually leaking out, or the contrast is actually leaking out beta. That is what is seen over here. समझे बात? And due to that, the cystogram will give you a very classical appearance of bladder called as teardrop bladder beta. Sunburst appearance is seen in intraperitoneal bladder rupture जब ये ऐसे फैलता है, ठीक है? तो sunburst appearance is seen in intraperitoneal bladder rupture. Here there is a extraperitoneal, so it is a classical teardrop appearance of the bladder beta which will be seen. Hopefully that's clear to all of you now. So take your break and then we'll start. Chalo, let's start now. Chalo, let's start. Now, question number 206, beta. If I talk about question number 206, it states, according to imaginary hypothesis, beta, of the renal autoregulation, the afferent arterioles which are there, beta, they are going to contract in response to the stretch which is induced by which of the following actions? The answer has to be option B, beta, that is opening of calcium channels. So we know, beta, that kidney is one of those organs, beta, which can auto-regulate the blood supply. Matlab, it will decide, beta, how much blood should enter inside the kidneys basically. So kidney itself is going to decide that how much blood should enter inside the kidney. What is going to happen? Please remember, if definitely the kidneys want more blood to enter inside them, beta, agar kidneys ko chahiye that more blood should enter inside them, obviously they will cause vasodilatation, beta, of the afferent arterioles, and whenever they want that less blood should enter inside them, they will cause vasoconstriction of the afferent arterioles, and that is done either by definitely, beta, the dilatation, that is done either by the relaxation of the contraction of the smooth muscles, beta, and whenever we have to relax or contract the smooth muscles, beta, that is usually dependent on which channels? Calcium channels. So whenever the calcium channels are going to open up and there will be a calcium influx, beta, obviously that is going to cause what? Contraction or relaxation? Whenever the calcium channels will open up and that will cause a calcium influx, that is known to cause contraction basically, beta. That is actually going to cause contraction and that will lead to constriction of the afferent arterioles, beta, which will decrease the blood flow to the kidneys. Whenever we don't want more blood flow to the kidneys, क्या हो जाएगा? The calcium channels are going to close basically, beta, and due to that definitely now the muscles are going to relax, बच्चे, and that will dilate the afferent arterioles, increasing the blood flow to the kidneys. That is what is important to remember. So याद रखना, it is basically based upon the opening or closing of the calcium channels. Important is release of nitric oxide, which is there, beta. Yes, it can act as a vasodilator again, but please remember it is not going to be helping in renal autoregulation. Important is nitric oxide से question आता है बार बार. First of all, beta, that nitric oxide is prepared from which amino acid in the body? So we know, beta, L-arginine is the amino acid, beta, from which we are going to prepare definitely nitric oxide in the body. One thing is that you have to remember. Second important point that you have to remember, beta, is nitric oxide which is prepared definitely, beta, it is going to act by increasing the amount of with secondary messengers. Nitric oxide definitely activates an enzyme called as guanylate cyclase, due to which there will be increase in the levels of cyclic GMP, and when there will be increase in the levels of cyclic GMP, that is going to cause vasodilation, beta. That has been a PYQ in your examination, so be aware of that. Okay, so it is derived from L-arginine and it is going to increase the level of cyclic GMP, beta, to cause vasodilation. Hopefully that's clear to all of you now. So that is what is important. Next is question number 207, beta. It states a genetic analysis was performed, beta, and the male patient was found to have a bar body. What is bar body, anybody? Inactivated X chromosome, beta. An inactivated X chromosome or a condensed X chromosome is called as a bar body, beta. Now they are asking which is the likely condition described. So we know that the patient is a male patient, beta, and he is having one bar body. Important is normally in an adult male and normally in an adult female, if I want to find the number of bar bodies, beta, how that will be calculated? So the bar body is calculated as number of X chromosome minus 1. So number of X chromosome minus 1 when you do beta, you will get the number of bar bodies in the patient. That is important to remember. Now, if I talk about beta, a normal female has a genotype of 46 XX beta. So therefore a normal female will have how many bar bodies? 2 X chromosome are there, so there will be a 1 bar body beta in a normal female. That is what is important. In a normal male, what is the genotype? In the normal male beta, the genotype is nothing else but 46 XY beta. And if the genotype is going to be 46 XY beta, do remember that definitely how many bar bodies are there in a normal male? 0. Because only 1 X chromosome, so 1 minus 1 is going to be 0 beta. Now if there is a female beta who is having definitely 1 bar body, that is a case of, if a female is having a 0 bar body, that is a case of. Very good. Why? Because Turner syndrome may be, you know, the genotype is 45XO, that is only 1 X chromosome is there, and therefore the number of bar body which is there beta 0. So definitely only female with 0 bar body is going to be a female of Turner's syndrome. Only male with 1 bar body will be Klinefelter syndrome, because the genotype of Klinefelter syndrome is 47 XXY beta. So 2 X chromosomes are there, and therefore there will be 1 bar body. The only male with bar body beta is going to be a case of Klinefelter's syndrome. As I have said, the patient is a male and having a bar body. Answer has to be straightforward, option D. Klinefelter syndrome. If there is a super male, the super female is common beta, and super female which is there, that is going to be triple X. So that super female is going to have how many bar bodies? 2. So super female will have 2 bar bodies because she has 3 X chromosomes beta. That is important to remember. Hopefully clear all of you now. So do remember this. Important is definitely if they ask you about question number 208. Here they are saying a patient has suffered from stroke beta and he had a dense hemiplegia. Hemiplegia is what? Paralysis in half body beta, right? So paralysis in half of the body is called as hemiplegia. Paralysis of the upper and lower limb only on one side will be called as paralysis of right arm and right leg. That is called as diplegia. So paralysis of 2 limbs is called as diplegia beta. Paralysis of all the 4 limbs is called as quadriplegia. And paralysis of only the lower limbs, both the lower limbs if they are paralyzed, नीचे का हिस्सा paralyzed हो जाता है, paraplegia. So pair paralyzed है, so that is going to be paraplegia beta. That is important. So here a patient has suffered from stroke and due to that the patient is having a dense hemiplegia. Workup reveals there is an involvement of corticospinal tract beta. All of the following findings are seen due to a lesion at the level of corticospinal tracts, except which one of the following beta is not a lesion. So which one of the following is not a feature? If they ask you beta, the references, we know if there is an upper and a lower motor neuron lesion. Upper motor neuron lesion means if there is any kind of damage to the brain of the spinal cord. So if there is any damage of the cerebral hemispheres, any damage to the cerebellum, or any damage to the brainstem or the spinal cord is considered as the upper motor neuron damage beta. Lower motor neuron damage basically beta whenever there is a damage to the anterior horn cell beta, or if there is damage to the nerve roots or the peripheral nerves beta. That is what is considered as a lower motor neuron damage. Important is, please remember, in patients of upper motor neuron damage beta, patient will have increased or decreased tone of muscles. Increase. Patient has increased tone of muscles beta. That's the reason patient is going to have spasticity, or the patient is going to have rigidity beta. But the lower motor neuron damage mein patient has decreased tone of muscles, and due to that the patient will have hypotonia. Okay? And due to hypotonia the patient is actually going to have flaccidity beta or a flaccid paralysis. That is important to remember. Clear? Fasciculations are absent in upper motor neuron lesion. They are usually present in lower motor neuron lesion. Fasciculation is twitching of the muscles. That is important. Tendon reflexes beta. The tendon reflexes are exaggerated in upper motor neuron damage because the tone of the muscles is high in upper motor neuron damage. So there is a hyperreflexia or brisk reflexes beta. But in lower motor neuron damage beta, the tone of the muscles is low. So therefore either there is hyporeflexia or there is areflexia. That is, the deep tendon reflexes are either diminished or they are completely absent. That is what is important. So now here if they ask you definitely beta that which among the following all of the following are seen due to corticospinal tract damage except corticospinal tract, if they are damaged, it is upper or lower motor neuron lesion. Corticospinal tracts if they are damaged, it is a upper motor neuron lesion beta. So they are asking you which among the following is not a feature of upper motor neuron damage beta. See again, if I talk about all these features which are there beta, those usually can be seen in upper motor neuron damage bache. That is important to be remembered. But if I want to do an exception, one option A says spastic paralysis. Do we see that? Yes. Next, brisk reflexes or exaggerated reflexes. Do we see that? Yes, that's very clear. Now we are left with option B and C beta. Now option B which is there beta, it is plantar extensor response. What is the plantar extensor response basically? Whenever definitely we strike a pen beta, or whenever we strike the sole of the foot, the patient will have fanning of fingers basically beta. That is called as the plantar extensor response. We know that plantar extensor response is also called as the sign. Babinski sign beta, and Babinski sign is present in upper and lower motor neuron damage. So Babinski sign is also a feature of upper motor neuron damage beta. That is what is important to remember. Okay, so that is also a feature. Even rigidity is a feature, but the cogwheel rigidity term which is there beta, that is more specific for a case of Parkinsonism. Clear? Rigidity hota, so yes, it would have been a feature. Cogwheel rigidity is more specific for a case of Parkinsonism. Therefore, we can mark option C as an exception beta. Clear about? So that is important to remember. Done with this? Next is question number 209 beta. If I talk about question number 209, it states we are having a 13-year-old boy, and this 13-year-old boy has come to the casualty beta with complaints of which kind of pain? Migratory right iliac fossa pain beta, which started or which originated from the umbilicus. Matlab the pain in the abdomen has started from the umbilicus and now has migrated into the right iliac fossa. Lab workup reveals the patient is having leukocytosis or increased WBC count, and we are suspecting a case of acute appendicitis. What is the dermatome responsible beta for the migration of pain in patients of acute appendicitis? Very good. So we know in acute appendicitis, whenever there is a migratory pain from the right iliac fossa beta, which originated from the umbilicus, that pain migrates to the right iliac fossa due to a dermatome known as option B, T10 beta. So T10 dermatome is responsible for the migration of pain in acute appendicitis. In acute appendicitis, what is the score that we use to suspect whether the chances of appendicitis are there or not? We know it is known as the Alvarado score beta, and that Alvarado score is also known as Mantrose score beta. So either we call it as the Alvarado score or the Mantrose scoring system. If I talk about Mantrose, we know Mantrose is an abbreviation beta of all the 8 parameters that we have in the scoring system. If I talk about first of all, M stands for migratory right iliac fossa pain. P stands for anorexia, that is loss of appetite. N stands for nausea and vomiting beta. T stands for tenderness in the right iliac fossa. Okay. R stands for rebound tenderness beta. Okay, rebound tenderness or the Blumberg sign. E stands for elevated temperature. Elevated temperature, that is fever. L stands for leukocytosis, and S stands for shift to left beta. Shift to left come under more amount of immature WBCs or immature neutrophils will be there. Clear? Important is beta. Which are the 2 parameters having a score of 2 over here? Only LT have a score of 2 over here, which is, when I say LT, L stands for leukocytosis and T stands for tenderness. These are the 2 points beta which have a score of 2. That has to be kept in mind. No issues with this. Next important, if they ask you beta, that whenever the patient is having a score of less than 5, then we say appendicitis is unlikely beta. Whenever the patient is going to have a score of more than equal to 7, then we say appendicitis is likely beta. Whenever the score is more than equal to 7, we say there is likely chances of appendicitis. Investigation of choice is nothing else but all children, abdominal problems के लिए बेटा this rule usually follows in majority cases. All the children के लिए the investigation of choice has to be ultrasound abdomen beta, and all adults के लिए the investigation of choice has to be CECT abdomen or the contrast enhanced CT scan abdomen. Clear about? That is important. Treatment of acute appendicitis is always and always surgery. That is an appendectomy or appendicectomy. Clear about? That is important. If they say appendicular lump, then what is the treatment? Very good. So yaad rakhna beta, if they say the diagnosis is not appendicitis but the diagnosis is an appendicular lump beta, we know appendicular lump happens whenever there are adhesions. So due to appendicitis, whenever there are adhesions and the omentum gets adhered with the bowel beta, that leads to a formation of appendicular lump, PYQ again. And appendicular lump when the management is not surgery, it is rather conservative, because during adhesions beta, it is not feasible to go for a surgery regime. We go for a conservative management called as which regime? Ochsner-Schering regime. Okay? So only lump in the question beta can change your answer from surgery to conservative, and that is known as Ochsner-Schering regime. Hopefully clear. Next important, if I talk about beta, they are asking you that the first CMC joint or the first the first carpometacarpal joint is going to be an example of. Very good. Carpometacarpal joint is usually present beta at the level of the wrist over here. Okay? Important is beta. At the base of the thumb, we have the first CMC or the first carpometacarpal joint beta. And it is an example of option B, that is a saddle joint or a sellar joint beta. That is important. Now, we know important question from anatomy is going to be joints, always be aware of that. If they ask you about the structural classification of joints beta, joints can be classified into three groups. First is fibrous joints, second are cartilaginous joints, and third are synovial joints. Fibrous joints are going to be immovable joints or fixed joints beta. These fibrous joints which are immovable joints definitely beta, they are also called as synarthrosis beta. They are also called as synarthrosis. Next important is cartilaginous joints beta. These cartilaginous joints beta, which are partially movable joints. These cartilaginous or partially movable joints are called as amphiarthrosis beta. So cartilaginous joints or the partially movable joints are known as amphiarthrosis. And synovial joints, the freely movable joints which are there beta, they are called as diarthrosis. So cartilaginous joints or the freely movable joints are called as diarthrosis beta. Sorry, synovial joints or freely movable joints are called as diarthrosis. Now, if I talk about examples of the fibrous joints beta, we know fibrous joints ke examples will be, first is going to be the sutures. Sutures are the fixed joints present between the two cranial bones beta. We know definitely that coronal suture is going to be present between the frontal bone and the parietal bone. So this suture over here between frontal and parietal bone is coronal suture. The suture present between two parietal bones will be sagittal suture. So between two parietal bones we have the sagittal suture, and between parietal and occipital bone this suture will be lambdoid beta. The suture between parietal and the occipital bone is the lambdoid suture, and the suture within the frontal bone will be metopic suture beta. The suture inside the frontal bone is actually going to be a metopic suture. Clear? Next is gymphosis. Gymphosis is nothing else but a dentoalveolar joint or a joint between the tooth and its socket beta. The joint between tooth and socket is called as gymphosis. And the last is syndesmosis. Syndesmosis is a joint beta whenever two bones are attached or two bones are connected with the help of an interosseous membrane. So whenever two bones are connected with an interosseous membrane, that is called as syndesmosis. Like it is going to be the joints in forearm and leg. Jesse in forearm, it is the middle radioulnar joint beta. The middle radioulnar joint is going to be an syndesmosis beta. And second, inferior tibiofibular joint beta. Please remember that it is the middle radioulnar joint and the inferior tibiofibular joint beta. They are an example of syndesmosis. Next important, if I talk about cartilaginous joints, basically beta, these cartilaginous joints which are there, they are called as amphiarthrosis. They are partially movable. Cartilaginous joints can be of two types beta. One, they can be definitely beta the primary cartilaginous. They can be primary cartilaginous joints called as synchondrosis beta. Primary cartilaginous joints called as synchondrosis, or the secondary cartilaginous joints called as symphysis beta. The secondary cartilaginous joints called as symphysis. Now we know that primary cartilaginous joints or synchondrosis which are there beta, they are usually having hyaline cartilage inside them beta, and these are usually the joints like the growth plate or the physis beta. I hope all of you are quite aware. Growth plate of physis is present between the epiphysis and the metaphysis beta. That growth plate of physis is an example of primary cartilaginous joint. Or the second one will be the first sternocostal joint. That is a joint between the sternum and the first rib. That first sternocostal joint is also an example of primary cartilaginous joint. Secondary cartilaginous joints which are there, they are going to have which cartilage? Fibrocartilage. The secondary cartilaginous joints of symphysis have fibrocartilages in them, and the best example is pubic symphysis. Most repeated question of anatomy. They used to give pelvis beta, and on the X-ray of pelvis, they used to mark an arrow towards the pubic symphysis, and they used to ask that which kind of joint it is. Answer was secondary cartilaginous joint beta. That is important. Even the intervertebral discs which are there beta, the intervertebral disc between two vertebral bodies, that is also an example of secondary cartilaginous joint. Next is synovial joints beta. If I talk about synovial joints, definitely we know it is going to be of 6 types. The synovial joints are the freely movable joints called as diarthrosis. First are plain joints beta. Plain joints are definitely present between the plain joints which are there. They are definitely present between the two carpal bones or the two tarsal bones That is the intercarpal joint or the intertarsal joints They are the best example of plain joints So intercarpal and the intertarsal joints. Next important is hinge joint. We know hinge joints are the ones where the movement is possible in both directions or only in one direction. So those joints where the movement is only possible in one direction, those are called as the hinge joints One is the best example, that is elbow joint. So elbow is an example. Another is going to be the ankle joint. So elbow of the ankle joint are best examples of hinge joint. Apart from that, the interphalangeal joint the joints, that is the PIP and the DIP. Interphalangeal joints are also hinge joints Next is pivot joint. Pivot joint means when one bone rotates around the axis of another bone. So whenever one bone rotates around the axis of another, that is called as a pivot joint Pivot joint will be the it is the C1, C2 joint So the C1, C2 joint, that is nothing else but the atlantoaxial joint. So C1, C2 joint to the atlantoaxial joint that is an example of pivot joint. A second, definitely the superior and inferior radioulnar joint. The superior and the inferior radioulnar joints are also pivot joint Next is condylar joint or the condyloid joint. So condylar joint condyloid joint ellipsoid joint it is one and the same thing. So condylar, condyloid or the ellipsoid joint. The best example will be the atlanto-occipital joint So the joint between the atlas and the occiput which is there this atlanto-occipital joint is the best example of the condyloid or the condylar joint. Apart from that it is also going to be the knee joint. Knee may definitely there are two types of joints One is going to be the hinge joint which is present, and second is going to be the condyloid or the ellipsoid joint which will be present. Iसीलिए knee is actually called as a compound joint combination of joint therefore knee is called as a compound joint that is important to remember. Next is the saddle or sellar joint if I talk about. So that saddle or the sellar joint which is there definitely The best example we have studied right now, that is the first CMC joint called as first carpometacarpal joint Apart from that, it is the incudomalleolar or the incudostapedial. Incudomalleolar joint The joint between the incus and malleus, that is the incudomalleolar joint, is going to be a saddle or a sellar joint. Next, ball and socket joint. It is the shoulder and the hip joint. So we know that shoulder and the hip joint are definitely going to be the ball and socket joint. Apart from that, it is also the incudomalleolar or incudostapedial. So the incudostapedial joint, that is joint between the incus and the stapes That is important to remember. Hopefully that's clear to all of you. This is the basic classification that you have to remember Gliding joint is another name for plain joint. Question number 211 another important and easy topic that you are able to study. Which among the following statement is true They are asking you which among the following statement is true about the below given log dose response curve. We know log dose response curve is going to have which shape? Sigmoid shape So please remember the log dose response curve which is there it is sigmoidal shape definitely that you have to keep in mind And if I talk about this log dose response curve which is S shaped or which is sigmoidal in shape, please remember that they are asking you which is the most true statement. We know the log dose response curve we have to talk about three things First is the height of the graph. Height of the graph tells you about what? Efficacy of the drug. That means the drug having a taller graph will be more efficacious, a drug having a shorter graph will be less efficacious that has to be remembered to you. Okay, remembered. Next important is actually going to be about the side of the graph. Side of the graph tells you about the potency. Matlab the drug which is on the left side it is going to be the most potent, and the drug which is on the right side it is going to be the least potent drug. And third is going to be the slope of the graph. Slope of the graph tells you about the safety of the drug. That means if a drug is having a steep curve that drug is going to be a safe or unsafe. So if a drug is going to be having a steep curve, that is an unsafe drug and whenever a drug is having a flat curve, that is a safe drug. That is what is important to remember. Clear? Now we have to देखो पहले definitely here which drug is the most potent. So we know the most potent drug will be drug B because it is on the extreme left Which drug is the least potent? So drug D is going to be the least potent drug because it is on the extreme right Next, which drug is actually going to be least efficacious? So B is the least efficacious because it is having a shortest graph beta. Okay? That is important to be remembered. Most efficacious may definitely the ACD definitely. Okay, they are having almost a similar height as of now beta. Clear about that is what is important to be remembered. No issues with this. Now if they ask you D is going to be safe or unsafe? D is unsafe drug because it is having a very steep curve beta. Okay? Now important is option A says drug B is the most efficacious drug. No beta. Drug B is not the most efficacious, it is the most potent drug beta. It is rather the least efficacious drug. The most unsafe drug is drug D, that's true? Yes, answer has to be option D beta, because here you can see, if you compare all the graphs beta, the steepest slope which is there, it is of drug B basically, and therefore drug D is going to be the unsafe drug beta. Drug C is less potent than drug D? No, rather drug C is more potent than drug D beta because it was on the left side of the drug D beta. That is important to be remembered. And last, drug A is most potent drug. Is it true? No beta. Drug A is not the most potent. The most potent drug is drug B beta because it is present on the extreme left. Clear? So answer has to be option B. That is a true statement beta among the following. Next is question 212 beta. If I talk about the question number 212, which among the following they are asking you is not a part of the Marshall stride in the bomb blast injuries? So when this is a forensic question, whenever there will be bomb blast injuries beta, which among the following is not a part of that Marshall stride? Very good. We know beta Marshall stride mein patient will have bruise or the contusions beta. Patient definitely will have abrasions, which patient will also have lacerations. So bruise or contusions, abrasions and laceration is the classical feature of the Marshall stride. What is not a feature of Marshall stride? Answer would be fractures. Fractures are not seen in a Marshall stride beta. That is important to be remembered. Hopefully clear to all of you. If I talk about bruise, definitely beta, we know that bruise happens due to blunt trauma or penetrating trauma. Bruise happens due to a blunt trauma beta. It is nothing else but a subcutaneous or a superficial bleeding which is seen. It is a subcutaneous or a superficial bleed which is seen beta. Next important, abrasions which are there. Abrasions are going to happen due to friction beta, right? If there is any kind of friction with the skin beta, rough surface having a friction with skin, that is actually going to cause abrasions. And it is a superficial or deep injury? Superficial. Most common type of abrasions will be the grazed abrasions, also called as gravel rash beta. So grazed abrasions, also called as the gravel rash beta, which are seen in RTS. They are the most common type of abrasions beta that you have to remember. Clear about that is important to be remembered, which is. And if they ask you about the laceration beta, so we know laceration happen due to blunt or penetrating trauma. Laceration mainly happen due to blunt trauma beta. So whenever there is a blunt trauma beta, more commonly we are going to find laceration, which is, that is what is important to be remembered. Apart from that, you have to remember laceration agar hai, so there will be regular or irregular margins. So we know whenever there are lacerations beta, there will be irregular margins which will be seen. Apart from that, the tissues, nerves and the follicles will be cut or crushed. So there is crushing of the tissues, nerves and the follicles beta, that is important. If they say regular margins, if they say cutting of the tissues and the follicles, that is a case of incised wound beta. However, there regular margins with cutting of the tissues or the nerve follicles, that the nerves and the follicles, that is a case of incised wound or an incision beta. Clear beta? So do remember this. Next is question 213 beta. They are asking you over here, ketosis which is there beta, there are ketosis which occurs during starvation is mainly due to which of the following processes? Ketosis is what? Ketone body synthesis. So the ketone body synthesis is called as ketosis. We know it occurs during which phase? It occurs during the starvation phase beta. That is important to be remembered. Now important is, in starvation phase, why does ketosis occur? Because in starvation the blood glucose levels are very, very low beta. And if there are low blood glucose during the starvation state, the vital organs of the body need some of the other fuel beta, and that fuel is ketone bodies. Boro. Ketone body synthesis is done by liver. Very good. Ketone body synthesis which is there beta, it is done by liver and it is used by. So ketone body synthesis is usually done by the liver beta, and ketone body utilization, if they ask you, we know it is mainly done by brain and the heart. So brain and the heart are the organs for which we are going to produce the ketone bodies. So ketone body utilization is mainly done by the organs like brain and heart. Apart from brain and heart, which are the third organs which also utilize the ketone bodies beta? skeletal muscles. The third organ definitely which can utilize the ketone bodies in minimal amounts will be the skeletal muscles. That is what is important to remember. Clear है बात? अब if they ask you, यहाँ पे उन्होंने पूछा है कि why does ketosis occur? So I hope all of you are quite aware about the three states. First, 2 to 4 hours after the food intake is called as fed state. So initial 2 to 4 hours after the food intake is known as fed state. Fed state में the blood glucose level is more or less more, and that is maintained by which glucose? That is maintained by the dietary glucose. So all the glucose that you have taken from the diet will be maintaining the blood glucose in the fed state. Next is the fasting state. That is 12 to 18 hours without food is called as fasting. So 12 to 18 hours without food will be the fasting state of the body, beta. And in this definitely if they ask you, beta, that in the fasting state, what is going to be the source which will maintain the blood glucose level? So it is going to be glycogenolysis. So please remember, beta, glycogen breakdown or the glycogenolysis will actually help in maintaining the blood glucose level in the fasting state, beta. Now, in the starvation state, beta, in the starvation state definitely glycogen is also over, and if glycogen will also be over, beta, then what is going to help? Then gluconeogenesis, beta. Now if I talk about gluconeogenesis, here we are trying to make new blood glucose, and when we try to make new blood glucose, beta, we definitely need a lot of energy, because making one glucose molecule is going to need almost 6 ATPs or GTPs, beta. All that energy comes from where? The ATPs required for gluconeogenesis, they come from lipolysis, beta, or the fat breakdown. Barabar? That energy usually comes from lipolysis or nothing else but the fat breakdown. That is called as which oxidation? Beta oxidation of fatty acids. Now, if beta oxidation of fatty acids has been done, or if lipolysis has been done, beta, and obviously all the fats have got broken down. Now definitely the last option which is left is nothing else but ketone bodies, beta, and therefore the ketone body synthesis is going to start. तो आप यहाँ पे अगर ऑप्शन में देखेंगे तो ऑप्शन इज इंक्रीज ग्लूकोनेोजेनेसिस, प्रोटियोलाइसिस एंड प्रोलॉन्ग स्टार्वेशन, इंक्रीज रेट ऑफ बीटा ऑक्सीडेशन और डिक्रीज ग्लाइकोजेनेसिस. तो आंसर वुड बी option C, increased rate of beta oxidation. Reason, if there is increased gluconeogenesis, beta, please remember, if gluconeogenesis is happening, so definitely the organs are getting glucose, so why ketone bodies will be reduced. बराबर? तो gluconeogenesis अगर बहुत चल रहा है बॉडी में, तो the organs are getting enough amount of glucose ना, तो why there will be ketone body synthesis at first place. Option B says proteolysis and prolonged starvation. Yes, proteolysis is going to happen, but that proteolysis is not the cause of ketosis or ketone body synthesis. Clear? Decreased glycogenesis. Yes, decreased glycogenesis will be seen in starvation, but again it is not going to cause ketone body synthesis. Ketone body synthesis is basically seen to increase lipolysis or increase rate of beta oxidation, beta. Why? Because when there is increased rate of beta oxidation, we have a lot of acetyl coenzyme A. The breakdown product of beta oxidation of fatty acid is nothing else but acetyl coenzyme A, and that acetyl coenzyme A will get converted into ketone bodies. Hopefully clear? Yeah, that is important to remember. Answer has to be option C for this question. Understood? Next important, if they ask you question 214, beta, the pedigree analysis represented in the given picture, beta, okay, is followed by which among the following diseases? So if I talk about pedigree analysis, always remember that this is the symbol for a normal male, beta. This is going to be a symbol for a normal female, beta. Whenever they definitely give this kind of symbol, beta, it means the patient is a carrier, beta. Clear? Important. And whenever they say complete darkness, beta, that is what is disease patient, beta. The patient is suffering from the disease. Hopefully that's clear. Now important is to be remembered, beta, 2 or 3 things. First is, I always say, always look, beta, whether there are carriers or not. Because if carriers are present, beta, if carriers are present, it has to be recessive or dominant. So we know, beta, if carriers are present in the pedigree analysis, it has to be a recessive trait, beta, it cannot be dominant. Because there are no carriers in a dominant trait. That is clear. Second important, beta, you have to just check whether there is skipping of generation or not. Agar carriers nahi dikhai de rahe, because sometimes pedigree mein, beta, they don't show you any carriers itself. Okay? So in those conditions, another thing that you can look for is nothing else but skipping of generation, beta. Skipping of generation ka matlab, disease is present in one generation, but absent in the next one, and then again present in the third one, beta. That is important. तो skipping of generation, if it is present, it is going to be recessive or dominant? Recessive. So if skipping of generation is present, that means it is a recessive trait beta. Actually, disease is not absent in the second generation. In second generation, we are having carriers beta, but sometimes they don't show carriers in the pedigree. Therefore, you may get confused. Iसीलिए just remember, if there is skipping of generation, it has to be a recessive trait. And third important beta, if they say there is crisscross inheritance. Whenever I say crisscross inheritance, what do I mean by that? Yes, so crisscross inheritance means if the father is deceased, the disease will be transferred to son or daughter? Daughter's beta. So whenever father is actually having the disease beta, the disease will be transferred to daughter. That is basically called as crisscross inheritance beta. And if crisscross inheritance is basically present, then it is X-linked or autosomal? Then it is X-linked beta. Whenever crisscross inheritance is present in a pedigree analysis, it is always going to be X-linked inheritance. Whenever crisscross inheritance is absent, when I say crisscross inheritance is absent, that means what? Father is transferring the disease to both daughter as well as sons beta. तो जब father से disease दोनों में जाएगा, that means crisscross inheritance is absent and that is a feature of autosomal inheritance. Clear? तो आप यहाँ पे देख सकते हो picture में. First of all, are you able to see carriers? Yes, so that means it is a recessive trait, that is very clear. Second important, definitely beta. Are you able to see skipping of generation? Yes. In the first generation itself, there is no disease. Skipping of generation means disease should not be present. First generation, are you able to see any disease? No. So that is important. So skipping of generation is present. So it is surely a recessive trait beta. Now we know that it is a recessive trait. Now we have to find whether it is X-linked or autosomal beta. If I talk about crisscross inheritance, just check whether the father is affected beta. यहाँ पे. So if father was affected, the disease got transferred into the daughter only or both sons and daughters? So whenever the father was affected, the disease only got transferred to a daughter beta. That is crisscross inheritance is present. And if crisscross inheritance will be present, it is going to be a case of X-linked recessive trait. Hopefully clear. That is what is important. Don't try to jump directly to your diagnosis. You may get confused and you may not be able to find the correct one. So 3 steps में just analyze the pedigree properly. You will get answer surely. Clear? X-linked recessive trait it is. An X-linked recessive trait अगर है, तो which among the following diseases follows the X-linked recessive trait? Answer has to be option A. That is nothing else but hemophilia. We know which types of hemophilia follow X-linked recessive trait. Hemophilia type A and hemophilia type B. Both of them follow X-linked recessive trait. But hemophilia type C follows AR, that is autosomal recessive pattern of inheritance beta. That is important. And X-linked recessive का मतलब always who is going to be deceased beta? So only males or boys are going to be deceased beta. Females or girls are always going to be carriers. So females or the girls are always carriers beta. That is important to be remembered. That is the case of X-linked recessive trait. Can you see no female is affected? All females are only carriers beta maximum. Clear? Sickle cell anemia follows autosomal recessive pattern of inheritance. Alport syndrome follows. Very good. Alport syndrome can follow multiple patterns, but the commonest pattern it follows is X-linked dominant pattern of inheritance beta, and hereditary spherocytosis follows autosomal dominant beta. Hereditary spherocytosis follows autosomal dominant. Marfan syndrome follows autosomal dominant. Marfan syndrome is also autosomal dominant beta. Osteogenesis imperfecta, again autosomal dominant beta. Osteogenesis imperfecta also follows autosomal dominant pattern of inheritance only, and has to be kept in mind. Clear? Cystic fibrosis follows autosomal recessive. Recent need beta. So cystic fibrosis is going to follow the autosomal recessive pattern of inheritance. That is what is important to remember. Clear? We know beta. I'll just make a point over here itself from biochemistry. We know that all the mucopolysaccharidosis follows autosomal recessive pattern of inheritance except Hunter's disease. Very good. Hunter's disease is the only one beta which follows X-linked recessive pattern of inheritance beta. ठीक है? That is important to remember. Next important if I talk about that all the sphingolipidosis which are there beta, all lipid storage disorders, they also follow autosomal recessive pattern of inheritance except Fabry's disease beta. Fabry's disease also follows X-linked recessive pattern of inheritance. That has to be kept in mind. उसके अलावा 2 other biochemistry diseases which follows X-linked recessive pattern of inheritance are going to be, one is Lesch-Nyhan syndrome. That was a PYQ and FMG exam itself. Lesch-Nyhan syndrome का pattern of inheritance they asked. And second is copper deficiency called as Menkes disease, copper deficiency known as Menkes. These are also the ones beta which are going to follow XLR, that is X-linked recessive pattern of inheritance. Hopefully that's clear all of you now. Sure. So at least remember these 4 ones in biochemistry which follow X-linked recessive pattern of inheritance. Question 215 beta, they are asking you which among the following is an incorrect statement about breastfeeding beta in a patient. Now option A says maternal chemotherapy is a relative contraindication. Is it true? No. Maternal chemotherapy or maternal radiotherapy is an absolute contraindication beta. There are 3 absolute contraindications. One is maternal chemotherapy or radiotherapy. Second related to baby, that is galactosemia, and third lactose intolerance. Galactosemia, lactose intolerance, and maternal chemo radiotherapy are absolute contraindications of breastfeeding beta. Next is going to be breastfeeding should be initiated beta on the table following the delivery, following normal vaginal delivery. Is it true? Yes, beta. This is the best time to start the breastfeeding. I told you in normal vaginal delivery, if they ask you what is the best time to start or initiate the breastfeeding, answer can be on the table beta. Reason is if you give the baby for breastfeeding on the table itself, that will release oxytocin and that will decrease the risk of PPH or postpartum hemorrhage. On the table, followed by as soon as possible, followed by within 1 hour of delivery. These are the best options that you can mark. Clear? Frequent feeding is recommended beta in breastfeeding jaundice. Is it true? Yes, definitely beta. We know that frequent feeding is definitely recommended in a patient of breastfeeding jaundice. That is important beta. Next, baby's lower lip should be everted while breastfeeding. Yes beta. We know that the baby's lower lip should be turned outwards during breastfeeding, and that is what is called as everted. Which among the following is the incorrect statement? Answer has to be option A. Maternal chemo is not a relative but rather an absolute contraindication of breastfeeding beta. That is important. We know positioning theory, you want to remember that the baby's abdomen should touch the mother's abdomen beta. Okay? Baby should be in a supine position beta. Third important, that baby definitely should have the whole nipple inside the mouth beta, except the upper part, somewhat upper part can be visible beta. Another one, baby's lower lip should be everted beta. That is what is important to remember. And baby's mouth should be wide open. So these are the points that you have to keep in mind. Next important question for 216 beta, they are asking you. For a population of 10,000, this is a common question again I've got a lot of times. So for a population of 10,000 beta, sex ratio of more than 1,000 signifies what? So please remember one point beta. What is the formula of sex ratio? The formula of sex ratio is number of females upon number of males into 1,000. अब मुझे बताओ, just logically think, if the number of females and number of males are equal, let's say population is 10,000 now here, ठीक है? Let's say population is 10,000. So we know if the number of females and number of males are equal, मतलब let's say number of females are also 5,000 and number of males are also 5,000. So how much will be the sex ratio of that population? 1,000. So याद रखना, whenever the number of females and the number of males are going to be equal beta, the sex ratio of that population is going to be 1,000. That is called as an ideal sex ratio beta, because number of females and males are equal. अब याद रखना बेटा, when I say the number of females are lesser, okay, whenever number of females will be less than 5,000 beta, whenever the number of females are less than 50% or less than 5,000 बच्चे, ठीक है? So numerator is bigger or lesser? Lesser. And whenever the numerator will be less beta, the sex ratio will be more than 1,000 or less than 1,000? Less than 1,000. बराबर? तो whenever इतना याद रखना, that whenever the numerator is going to decrease, that is whenever the number of females is going to be less, ठीक है? Whenever the number of females is going to be less than 50% basically beta, obviously the sex ratio which is there, it is going to be less than 1,000. Hopefully clear? Whereas if they say the number of females, whenever the number of females, that is the numerator will be more than 50%, whenever the number of females beta or the numerator is more than 50%, obviously beta sex ratio is going to be more than 1,000. क्योंकि अगर number of females ज़्यादा है मतलब numerator बड़ा है, and whenever the numerator is going to be bigger beta, obviously the sex ratio is going to be more than 1,000. That is what is important to remember. यहाँ पे क्या बोला उन्होंने? They are saying that the sex ratio is more than 1,000 beta. And whenever sex ratio is more than 1,000, we know the number of females should be more than. 50%. How much is the total population? 10,000. Number of females more than 50%. Matlab number of females should be more than 5,000 beta. Either they will say number of females should be more than 5,000 or they should say number of males should be less than 5,000. मतलब number of females अगर 5,000 से ज़्यादा है तो number of males 5,000 से कम होगा because total population is 10. So therefore definitely what is the answer to this question? So definitely the answer has to be option D. Females are more than 5,000 in this population. Because when females will be more than 5,000 or females will be more than 50%, then only the sex ratio can be more than 1,000. That is important to remember. Clear? No issues with this? Done? See, याद रखना जब भी याद रखना number of females are less than 50%, that means definitely the numerator is smaller, and whenever numerator is smaller, sex ratio will be less than 1,000 beta. Whenever I say number of females are more than 50%, मतलब the numerator is bigger, and whenever the numerator is bigger, the sex ratio is going to be more than 1,000. तो यहाँ पे उन्होंने बोला है कि the sex ratio of the population is more than 1,000. Whenever sex ratio is more than 1,000, मतलब what is more, number of females or number of males? Number of females. So जब भी we know number of females is going to be more than 50%, then the sex ratio is going to be more than 1,000. उन्होंने बोला है कि sex ratio is more than 1,000, that means number of females should be more than 50%. How much is 50% of 10,000? 5,000. So that means number of females is more than 50%, so number of females is more than 5,000. Clear ever? Question number 217 if I talk about, it is a 5-year-old boy has been brought to you beta with an unknown immunization status. They don't know which vaccines have been given to the child yet. Now they are asking you which among the following vaccines should be given to the child. So which among the following vaccines shall be given? Answer should be option A, B, C, D. So please remember beta, answer to this question has to be C. And the reason is definitely answer has to be option C, that is MR, that is measles rubella, DPT, that is diphtheria, pertussis, tetanus, or the pentavalent. Pentavalent vaccine has 5 vaccines in it. One is DPT, diphtheria, pertussis, tetanus, plus it is going to be beta. Definitely it is going to be HIV which है, and it is going to be hepatitis B. अब यहाँ पे याद रखना, in cases whenever the patient is more than 1 year of age, we don't give the hepatitis B vaccine beta. But यहाँ पे अगर मैं options compare करूँगा, if I compare all the options over here, definitely option C seems to be the closest option. वैसे hepatitis B is not given, ठीक है? Here definitely you have to remember that we are talking about delayed immunization. मतलब till what age definitely beta a vaccine can be given. So please tell me, we know that which vaccines can be given up to 1 year of age. BCG vaccine, hepatitis B vaccine, and rotavirus vaccine. These are the 3 vaccines beta which can be given maximum up to 1 year of age beta. Which vaccines can be given up to 5 years of age? OPV vaccine and the MR or the measles rubella vaccine. These can be given maximum up to 5 years of age. Which vaccine can be given up to 7 years of age? DPT vaccine basically can be maximum given up to 7 years of age. And which vaccine can be given up to 15 years of age? JE, that is Japanese encephalitis, is the vaccine which can be given maximum up to 15 years of age beta. That is what is important to be remembered. Hopefully clear to all of you now. So याद रखना इस condition में option A says MR, DPT, BCG. BCG can be maximum given up to 1 year beta. Option B says MR, DPT, hepatitis B and rotavirus. Hepatitis B and rotavirus both can be maximum given up to 1 year of age. Option D says MR, DPT, OPV and hepatitis B. It can again maximum be given up to 1 year of age. Important is beta yaad rakhna. Yes, in pentavalent also hepatitis B is there, but you can definitely definitely beta not give the hepatitis B vaccine. And any which ways, the options which are closest over here is going to be the option C. That is what is important. Okay, so that is what is important to be clear. No issues with this. Question number 218 beta. Here they are saying a patient was complaining of hearing loss, and below given audiogram was found beta on audiometry. Which part of the cochlea would have been damaged in this condition? Which kind of audiogram is seen here? So you are able to see a very classical audiogram beta known as the sloping audiogram which is. And sloping audiogram is a feature of which condition? Pressed by accusis beta. So we know that sloping audiogram which is there, it is a classical feature of nothing else but presbyocusis. Beta, if I talk about presbyocusis, it is anybody. Presbyocusis is age-induced hearing loss. Beta, हमें पता है whenever there is a age-induced hearing loss, बच्चे, that is classically called as presbyocusis. That has to be kept in mind. Important in the early stages or in the initial stages of presbyocusis or age-induced hearing loss, there is hearing loss at higher frequencies or lower frequencies. So there is hearing loss at higher frequencies. Beta, and when there will be hearing loss at higher frequencies, which part of the cochlea will be damaged? The basal turn or apex? Very good. So answer has to be option D, that is basal turn. Why? Here basal turn has been damaged, beta, because patient is only having hearing loss at high frequencies. Beta, so whenever there is a high frequency hearing loss, that means the basal turn has to be damaged. If apex will be damaged, beta, patient will have a low frequency hearing loss. Apex is damaged, then patient will have a low frequency hearing loss. And if low frequency hearing loss will be there, the patient will have ulta audiogram called as rising audiogram. And rising audiogram will be a feature of linear disease. Beta, that is important to remember. Clear about? So यहाँ पे you are able to see the classical feature. Here there is hearing loss at which frequencies? Only lower frequencies. Beta, and that's the reason the patient is having a classical rising audiogram. बच्चे, the patient is having a classical rising audiogram, and हमें पता है that rising audiogram which is there, it is a classical feature of nothing else but Meniere's disease. Beta, hopefully clear. Apart from that, the two other audiograms that you are able to see. Beta, two other audiograms that you are able to see in the picture. The first one, what is seen over here? मुझे पहले बताओ, this is bone conduction or air conduction? The first line, bone conduction, and the lower one is air conduction. Here you can see definitely, beta, the air conduction is normal or poor? Poor. Beta, and bone conduction is normal. So bone conduction is less than 25 decibels, so it is normal. Air conduction is beyond 25 decibels, so it is poor. Beta, and we know whenever bone conduction is normal, air conduction is poor, and there is a significant AB gap between both the lines. It is CHL or SNHL? CHL. Very good. It is a classical picture of CHL or conductive hearing loss. Apart from that, you are able to see a dip at how many hertz? Whenever there is a dip in bone conduction at 2000 hertz, it is called as which notch? Carhart's notch. And Carhart's notch is a classical feature of which condition? Otosclerosis. Beta, so whenever the patient is going to have otosclerosis, बच्चे, we are going to see a dip in bone conduction at 2000 hertz. Beta, classically known as the Carhart's notch. Hopefully that's clear. Another picture is showing you another feature, beta, or another notch, and that is, यहाँ पे you are able to see, beta, there is a dip in bone conduction as well as air conduction. And how many hertz? 4000. So whenever there is a dip in air as well as bone conduction at 4000 hertz, we call it as which dip? Acoustic dip. Or which notch? Very good. So either you can call it as an acoustic dip or you can call it as a Boiler's notch, and that is a feature of very good. So we know acoustic dip or Boiler's notch at 4000 hertz, which is seen in both air and bone conduction. It is a classical feature of nothing else but noise-induced hearing loss. Beta, I'll come to that silent question. Next important, if I talk about, beta, question number 219. Which among the following local anesthetic is considered as the most cardiovascular unstable agent? Beta, so we know cardiovascular unstable पूछा उन्होंने, so we know answer has to be option B, that is bupivacaine. Beta, we know that bupivacaine, which is there, it is the most cardiotoxic or the most cardiovascular unstable agent, beta, among the local anesthetics. Which is the longest acting local anesthetic? Very good. The longest acting and local anesthetic is going to be, beta, Debucaine. Which is the shortest acting one? The longest acting is going to be Debucaine. What is the shortest acting local anesthetic? The shortest acting is chlorprocaine. Beta, so chlorprocaine, which is there, definitely it is the shortest acting local anesthetic that you have to remember. Clear about? Which is the commonest used local anesthetic? Beta, we know the most commonly used local anesthetic is going to be lignocaine. Beta, that is important to remember. Yesterday in the CMS itself there was a question. Maximum dose of lignocaine which can be given 7 ml per kg. Beta, that is important to remember. ठीक है, 7 ml per kg has to be the maximum, sorry, 7 milligram per kilogram is the maximum dose that you have to give beta. 7 mg per kg is going to be the maximum dose that you have to give beta. That is important to remember. No issues with this. Next is prilocaine. Prilocaine is one of the major side effects. Prilocaine is in the amla cream also beta. So prilocaine or amla cream most important side effect. Methemoglobinemia beta. We know that prilocaine or the amla cream which is there, it is actually known to cause methemoglobinemia beta. So prilocaine is also present in the amla cream, and this is actually known to cause the methemoglobinemia. That is what is important to be remembered beta. Now issues with this. Which was the first local anesthetic? It is going to be cocaine beta. It was a sympathomimetic or a vasoconstrictor beta. That is what is important to be remembered. No issues with this. At least remember these important points beta about the local anesthetic agents. Done with this. Apart from that, if I talk about inhalational anesthetics beta, I hope all of you are quite aware. Inhalational anesthetics are going to be of 4 types beta, and those inhalational anesthetics which are 4 types. One is going to be, let's start with halothane. Second is going to be isoflurane. Third is going to be sevoflurane, and the fourth is going to be desflurane beta. Important if I talk about which is the most potent out of all of them. So we know beta, the most potent out of all of them is actually going to be halothane. Why it is most potent? Because इसका MAC सबसे ज़्यादा है सबसे कम. So definitely beta, as it is going to have a least MAC basically, or a least minimum alveolar concentration. Therefore it is going to be the most potent agent. Which is the least potent out of them? So among them definitely the least potent you can ask beta, it is going to be desflurane, because it has having a maximum MAC beta or highest MAC among the local anesthetics. Among the inhalational anesthetics. So highest MAC is going to be highest minimum alveolar concentration is seen with desflurane. So it is going to be least potent. Now important is which is fastest acting beta. The most fast or the most rapidly acting will be desflurane beta. So desflurane is going to be fastest acting, but it is not used for induction. Why? Desflurane is fastest acting beta, but it is not used for induction. Because it is an irritant beta, it is an irritant basically, and therefore desflurane cannot be used basically for induction of anesthesia. Important is desflurane has a special vaporizer that is known as PYQ. Tex 6 vaporizer beta. So desflurane is actually going to have a special vaporizer beta, that is a blue color vaporizer known as the Tex 6 vaporizer beta. That was a PYQ. Do remember that. No issues with this anybody? The vaporizer of sevoflurane is going to be which color? Yellow color. The color of isoflurane vaporizer will be purple color, and the color of halothane vaporizer will be red in color. That is important. Which can be safer to be used in patients of bronchial asthma? Halothane. Halothane can be safe to be used in patients of bronchial asthma because it causes bronchodilation. As it causes bronchodilation, it is safe to be used in bronchial asthma. Which is safe to be used in cardiac patients? So please remember beta, isoflurane is definitely considered as cardio stable beta. It can be used in cardiac surgeries or in cardiovascular diseases beta. So cardio stable is going to be isoflurane, which is the inhalational anesthetic of choice in children. So we know beta, children with the inhalational anesthetic of choice is going to be considered as sevoflurane. Hopefully clear. At least remember these important points about the inhalational anesthetics. Des भी यूज कर सकते हैं definitely. The most cardio stable that we consider basically can be isoflurane. Desflurane is also used and isoflurane is also used definitely. Clear about? So that is what is important to remember. No issues with this. Then question number 220 beta. A patient has been diagnosed with contact dermatitis. So the below given test was performed. What is this below given test? So here you are able to see beta patch test. In this patch test beta, we are actually going to place multiple types of allergens on the patient's skin beta, and we are actually going to check the reaction which is going to happen beta in response to these allergens. So this patch test was performed. The reading was taken on which day? 4th day beta, that is after 96 hours. So reading was taken on 4th day after 96 hours beta to see the response to allergens basically. Now they are asking you this patch test will be an example of which type of hypersensitivity? Here we have to check the allergen to response, that's fine. Okay? So the response to allergen we have to check beta, but we are checking it after 3 days or after 4 days basically beta. So it is a delayed hypersensitivity, and delayed is nothing else but a type 4 hypersensitivity. We know now that almost all the tests are going to be type 4. All the skin related tests are going to be the type 4 of the delayed hypersensitivity itself. And we know that the delayed or type 4 hypersensitivity is mediated by T cells beta. So answer has to be option B, that is a T cell mediated hypersensitivity it is going to be. Clear? Just don't see the allergen and mark type 1. Please remember that. Clear? So we know beta that usually all the tests will be type 4 except sick में भी reading बात नहीं देते हो. Very good. Casoni's test. Casoni's test is done for hydrated cyst beta. So Casoni's test is the only test basically beta. Okay, Casoni's test is the test definitely that we do for hydrated cyst, and that is going to be a type 1 hypersensitivity. So Casoni's test is going to be a type 1 hypersensitivity. That is mainly done for a hydrated cyst or a hydrated disease beta. Hopefully clear to all of you now. So that is what is important to know. No issues with this. So we know that anaphylactic is going to be type 1 hypersensitivity. For all the allergic reactions and all the anaphylactic reactions will be type 1 hypersensitivity. Next is type 2 will be cytotoxic. So type 2 is cytotoxic, also called as antibody mediated hypersensitivity. So type 2 is cytotoxic or antibody mediated. Important examples to be remembered. याद रखना type 1 में all the allergies and all the anaphylactic reactions. Type 2 में important ones I am telling you, rheumatic fever or rheumatic heart disease. So rheumatic fever or rheumatic heart disease beta. Next is RH incompatibility beta. Next is RH incompatibility or RH isoimmunization. Third is ABO incompatibility beta. ABO incompatibility is nothing else but mismatched blood transfusion beta. So ABO incompatibility or mismatched blood transfusion is type 2 as well beta. Apart from that, if you want to remember one more thing, that can be the good pasture syndrome. The good pasture syndrome definitely beta can also be type 2 hypersensitivity, and last one you can remember is myasthenia gravis. Myasthenia gravis is mainly a type 5 beta. So please remember that. Yeah. Next important is going to be type 3 beta. If I talk about type 3 basically, type 3 is immune complex mediated or antigen antibody complex mediated. So immune complex mediated or antigen antibody complex mediated hypersensitivity is type 3. Type 3 hypersensitivity, most important is going to be SLE beta. We know SLE is type 3 hypersensitivity. With sickness? याद रखना सीरम सिकनेस. These are the unknown ones basically ना. अगर one liner आता है तो इनके नाम से आता है. वो SLE is which type of hypersensitivity, they don't ask. तो one liners इसलिए डिफिकल्ट होते हैं क्योंकि वो अजीबोगरीब होता है फिर थोड़े. ठीक है, तो सीरम सिकनेस पूछेंगे या फिर विच रिएक्शन, आर्थोस रिएक्शन. याद रखना सीरम सिकनेस एंड आर्थोस रिएक्शन विल बी द टाइप 3 और द इम्यून कॉम्प्लेक्स मीडिएटेड हाइपरसेंसिटिविटी. दैट इज इंपॉर्टेंट. इसके अलावा बहुत सारे पीएचडी इज आल्सो टाइप 3 इटसेल्फ बेटा. ठीक है. नेक्स्ट इंपॉर्टेंट इफ आई टॉक अबाउट लास्ट इज टाइप 4, दैट इज टीसीएल मीडिएटेड और द डिलेड हाइपरसेंसिटिविटी. ठीक है, ऑल द टाइप ऑफ टेस्ट एक्सेप्ट द कैसोनिस टेस्ट बेटा. अपार्ट फ्रॉम दैट इट इज गोइंग टू बी कॉन्टैक्ट डर्मेटाइटिस विल चेक. Apart from contact dermatitis, it is going to be which kind of graft rejection? Contact dermatitis is type 4 hypersensitivity. Which kind of graft rejection? Acute and chronic, because acute is type 2 as well as type 4. ठीक है, chronic is only type 4 hypersensitivity beta. That is what is important to be remembered beta. Clear enough? So that is what is important to be remembered. Apart from that, which test you have to especially remember? Tuberculin test, also called as a Mantoux test beta. That is going to be an example of type 4 hypersensitivity. At least remember these examples for hypersensitivity beta. Clear? Next is question number 221 beta. Young male has come to a psychiatrist as he is feeling depressed beta because his wife has filed a divorce case against him. She complains that he is not able to understand her emotions beta or even explain his own emotion. Now उसके emotions समझ पा रहा है ना, खुद के emotions definitely बेटा express कर पा रहा है या explain कर पा रहा है. What is this phenomena called as? Alexithymia. So not able to understand her emotions or explain his own emotions beta, that is classically known as option B, that is alexithymia beta. Okay, difficulty with expressing or understanding emotion is alexithymia. Important. What is anhedonia? Inability to derive pleasure beta. So inability to derive pleasure मतलब person is not able to enjoy in simple terms. Person is not able to derive pleasure beta. Previously he used to enjoy playing football. Now he doesn't like playing football beta. So that is what is important. Inability to derive pleasure is known as anhedonia. Anhedonia is a classical feature in which condition? So we know anhedonia is an important feature of depression. Alexithymia is more common. Schizophrenia beta. In patients of schizophrenia, alexithymia is going to be one of the important features that is important. Yeah. Prolixity is nothing else but prolixity is what? Decrease in the speed of thought. So decreased speed of thought which is there now, that is basically called as prolixity beta, and that is also a sign of depression. So prolixity is decrease in the speed of thought which is, that is a sign of depression. Increased speed of thought which is seen in mania, and that increased speed of thought is called as flight of ideas. So increased speed of thought is known as flight of ideas basically, and that is what is a feature of mania. The decreased speed of thought is a feature called as prolixity, and that is seen in depression beta. Neologism means coining a new word. Okay, the meaning cannot be understood by anyone beta. उसका dictionary में भी meaning नहीं मिलता, ऐसा नया word बनाओ. That is neologism. It is a classical feature of schizophrenia beta. Neologism is a classical feature of schizophrenia. That is important to remember. Important is, if I ask you, PYQs are definitely, we know that there are various types of disorders of thought. Okay, disorder of content of thought is going to be very good. So disorder of content of thought अगर आप पूछेंगे तो answer has to be nothing else but delusion. So delusion is a disorder of content of thought beta. Disorder of stream of thought or flow of thought. अभी जो मैंने बोले, so disorder of stream of thought or flow of thought can be increased speed called as flight of ideas, or decreased speed called as prolixity beta. That is important to remember. Apart from that, third can be disorder of form of thought or organization of thought. So disorder of form of thought or organization of thought will be the formal thought disorders like thought insertion, thought withdrawal, or thought broadcast beta. So thought insertion, thought withdrawal, or thought broadcast, they are the formal thought disorders or disorders in the form or position of disorders in the form of organization. Disorder in the organization of possession. Disorders in the possession of thought are these ones beta. So disorder in the possession of the thought. The thought is not mine basically. That is going to be thought insertion, thought withdrawal, or thought broadcasting. Disorders definitely of the form or organization of thought will be which ones? Both. Disorder in the form or organization of thought. Disorder in the form of organization of thought. So disorder in the form of thought or organization of thought. So it can be multiple conditions like derailment beta. Now what is going to happen in derailment? Obviously beta, that the thought which is there, it will get derailed or it will get off track basically. That is what is called as derailment beta. Second important is going to be yes, so it is going to be loosening. Next one is going to be loosening of association beta. So one is definitely derailment, second is loosening of association, third is going to be tangentiality beta. ठीक है, circumstantiality can also be considered over here. So all of these are nothing else but disorders of the form of thought or organization of thought. Here the organization of thought basically, the structure of thought has been disturbed. That is important. Which are the most common type of delusions anybody? The most common type of delusions which are there beta, those are delusion of persecution, where the person has a firm, fixed and unshakable belief that somebody is going to harm me or kill me beta. That is persecutory delusion, so the delusion of persecution, which is the most common type of delusion. And if they ask you beta, the delusion of persecution which is there, it is a feature of which condition? Schizophrenia. So schizophrenia and delusion of persecution is very commonly seen beta. That is important to remember. Next, if they ask you delusion of pathological jealousy or morbid jealousy is known as which syndrome? So delusion of pathological or morbid jealousy is known as Othello syndrome. And Othello syndrome matlab the person is going to doubt his spouse beta, and that is seen in mainly chronic alcoholics beta. That is important. Next, if they ask you beta, that delusion of infidelity is what is? Delusion of infidelity. It is going to be Othello syndrome again. Please remember that delusion of infidelity. मतलब my partner is cheating on me. That is nothing else but Othello syndrome. Delusion of negation is known as which syndrome? Delusion of negation or delusion of nihilism. Cotard syndrome. The delusion of negation or delusion of nihilism is known as Cotard syndrome. And Cotard syndrome is a feature of depression. So delusion of nihilism or delusion of negation called as Cotard syndrome is a feature of depression. सब कुछ खत्म होने वाला है. That is what is Cotard syndrome or delusion of nihilism. Hopefully that's clear to all of you now. So that is important. And delusion of love is a feature of. It is a feature of mania. The delusion of love, that is called as erotomania or the deep clairvoyant syndrome, is a feature of mania. That is a person of higher socioeconomic status loves me better. That is known as delusion of love, also known as erotomania. That is important. Hopefully clear. Question number 222 beta. A young patient comes to you who is a known case of type 1 diabetes mellitus. Presents with complaints of visual disturbances beta. Fundoscopic examination was done and it reveals the below given picture. What will be the earliest finding observed in this patient beta? They are asking. So we know it is the earliest finding will be very good. तो अभी है क्या ये case? A patient of type 1 diabetes mellitus coming to you with visual disturbances. It has to be a case of nothing else but diabetic retinopathy. So it is a classical case of diabetic retinopathy. We know in patients of diabetic retinopathy there are two phases beta. The early phases NPDR. The earlier phases definitely NPDR, that is non-proliferative diabetic retinopathy, followed by PDR, that is proliferative diabetic retinopathy. Clear about? Important is in NPDR beta there are various features which can be seen. The patient will have small dilatation of the vessels beta, and the small dilatation of the vessels which will be there beta, that is nothing else but called as microaneurysms. So answer has to be option D, microaneurysms. The earliest finding which is seen in diabetic retinopathy is nothing else but microaneurysms. This has been a PYQ, be aware of that. Clear? Which is the most specific finding in patients of diabetic retinopathy? So please remember, the most specific finding in diabetic retinopathy, answer is dot and blot hemorrhages beta. The most specific finding of diabetic retinopathy, answer is going to be the dot and blot hemorrhages. So dot blot hemorrhages are the most specific finding in cases of diabetic retinopathy. We know there can be cotton wool spots which can also be seen. There can be neovascularization, but neovascularization is only seen after proliferative diabetic retinopathy beta. It is not seen in the early stages. So definitely these small exudates are called as hard exudates, and these large exudates are the soft fluffy exudates called as cotton wool spots beta. That is important, and these are the dot blot hemorrhages. Hopefully clear to all of you now. If they ask me PYQ again, which is the most important risk factor in diabetic retinopathy, whether it will be poor glycemic control or duration of diabetes? Yeah, right now this was the PYQ that the most important risk factor is duration of diabetes mellitus followed by poor glycemic control. So duration of diabetes mellitus is always the most important risk factor followed by the poor glycemic control. Hopefully clear to all of you. In patients of proliferative diabetic retinopathy, which if the patient comes to you, we can initially give anti-VEGF drugs. Anti-VEGF drugs like bevacizumab or ranibizumab. But what is the final treatment? The best treatment in later stages. Yes, so it can be PRP. What is PRP? Pan-retinal photocoagulation. In a previous year question it has been asked. They have even shown you a picture. So pan-retinal photocoagulation beta is the final treatment which can be done in the patients of proliferative diabetic retinopathy beta, that is PDR. Hopefully clear all of you. Next important is question 223 beta. Easy. All the below given parameters beta are included in the Apgar score, except which one is not included, they are asking. So I hope all of you are quite aware beta. Apgar score is a prognostic or a diagnostic score? Apgar score is a prognostic score which will only tell about the prognosis of the outcome in the baby beta, whether the prognosis of the baby will be good or bad. That is what is important to remember. Clear about? Now we know Apgar score mein. Apgar is an abbreviation in itself beta, where A stands for appearance of the baby, P for pulse rate, G for grimacing, that is response to the insertion of OG tube beta, A for activity, and R for respiration. Now it is respiratory efforts or respiratory rate? It is respiratory efforts beta. So skin color, yes, appearance is there. Muscle tone, yes, activity is there. Pulse rate, yes, it is calculated. What is not a part of Apgar score? Answer will be option B, that is respiratory rate. This has been a common question, and exception is usually respiratory rate which is given in the exam. Clear about? So that is important to remember. If they ask you beta, we know that here the maximum score can be 2 and minimum score can be 0. So appearance की अगर मैं बात करूँ, if the baby appears completely pink, we give a score of 2. When the baby is having whenever the baby is having pink body and the blue extremities, that is given a score of 1. And when the baby is completely pale or blue, that is given a score of 0. Pulse rate, when it is more than 100 beats per minute, give a score of 2. Less than 100 beats per minute, give a score of 1. And if there is no pulse palpable, then give a score of 0. Next, grimacing, when you try to insert the orogastric or the OG tube beta. If the baby cries and pulls the tube away, it is a score of 2. If the baby is just going to grimace, that is odd facial expression, or just have a weak cry, that is a score of 1. And if there is no response to stimulation, give a score of 0. Activity, if the baby is actively moving all the 4 limbs, give a score of 2. If the baby's arms and legs are in a flexed posture, give a score of 1. And if there is no movement in the baby at all, give a score of 0. Respiration, if the baby is having strong cry or a strong respiratory effort, give a score of 2. If there is a slow and irregular respiration, give a score of 1. And if there is no respiration or no breathing at all, give a score of 0. Important, what is suggestive of a good prognosis? Whenever the baby's Apgar score is actually going to be beta between 7 to 10, that is what is suggestive of a good or a best prognosis beta. And what is suggestive of a poor prognosis? Whenever the child is having a score of, anybody? 0 to 3. So whenever the baby's Apgar score is 0 to 3, that is suggestive of a poor prognosis beta. Important, Apgar score is calculated how many times after birth? 2 times. Once it is calculated at 1 minute of life, and second it is calculated at 5 minutes of life beta. Hopefully that's clear to all of you now. Sure. Next important, if I talk about is question 224 beta, it states we are having a 25-year-old nulliparous female beta who has undergone a laparoscopic cystectomy, and the HPE or the histopathological examination beta, it reveals the below given picture. What shall be the next best step they are asking you? मुझे बताओ what is the feature on the histopathological examination? These are the calcified laminated bodies, and calcified laminated bodies are classically called as samoma bodies beta. So we know samoma bodies are seen in PSM. P for papillary cancers and prolactinoma. So P for papillary cancers and prolactinoma. S for serous cystadenoma and somatostatinoma. So serous cystadenoma and somatostatinoma. M for mesothelioma and meningioma. Mesothelioma and meningioma. These are the conditions where there are samoma bodies which are seen. PY2. Samoma bodies is an example of dystrophic or metastatic calcification. You all know beta that samoma bodies will be an example of dystrophic calcification. It is an example of dystrophic calcification. What are the stains of calcium? One is von Cosa stain and the second is azurine red. So von Cosa and azurine red, these are the stains that we use for calcium or for samoma bodies. Now which is the ovarian tumor they are asking you beta that is going to have the samoma bodies? The most common ovarian tumor, and most common ovarian tumor is serous cystadenoma beta. So serous cystadenoma is the most common ovarian tumor, and that is actually going to be characterized by samoma bodies on the histopathological examination beta. Hopefully that's clear to all of you now. So if they ask you definitely, if the patient is having the classical samoma bodies beta on the histopathological examination, we know it is a case of serous cystadenoma. For that, they have said we have gone for a laparoscopic cystectomy. That means we have removed the tumor already beta. We have removed the ovaries already, and therefore only the histopath has been done, right? So what is the next best step? We know beta. What is the tumor marker for ovarian cancers? We know the tumor marker for ovarian tumors, ovarian cancers is CA125. So here we should definitely go for option D, that is regular CA125 and follow. Regular CA125 and follow has to be done. Okay? Option A says chemotherapy for epithelial ovarian tumors beta. We don't need chemotherapy after surgery. We can just remove the tumor and then go for follow up with CA125. If in case you find that the CA125 levels are rising, then you may go for a chemotherapy. Next important, hysterectomy with salping oophorectomy. No beta, salping like removal of uterus or fallopian tube is insensible beta doing in patients of ovarian tumors. Clear. Radiotherapy, again ovarian tumors are radio resistant. So all ovarian tumors are radio resistant except the only radio sensitive ovarian tumor is teratoma. The only radiosensitive ovarian tumor is a germ cell malignancy called as dysgerminoma beta. Only radiosensitive ovarian tumor. Clear है बात? यहाँ पे कौन सी bodies दिख रही है? Very good. The tumor cells are arranged around beta in a rosette-like fashion that is classically known as the Karl-Exner bodies. Anybody? Karl-Exner bodies on histopath is a classical feature of which ovarian tumor? So please remember beta, Karl-Exner bodies on histopath is a classical feature of granulosa cell tumor beta. And granulosa cell tumor, we know it is characterized by Karl-Exner bodies and a coffee bean nucleus. What is the tumor marker for granulosa cell tumor? So tumor marker for granulosa cell tumor is nothing else but inhibin E or B? B. So the tumor marker for granulosa cell tumor is nothing else but inhibin E beta. That has to be remembered. Next important, if I talk about the bodies which are able to see beta, and that is this one. There is a blood vessel in the center, and the cells are surrounding the tumor, blood vessel. That is called as Schiller-Duval bodies. So whenever there is a blood vessel in the center beta and the tumor cells are surrounding that blood vessel, it is a classical appearance of Schiller-Duval bodies. And I hope all of you are quite aware. Schiller-Duval bodies are a feature of yolk sac tumor. So germ cell tumor called as yolk sac tumor beta. In that we are going to have the Schiller-Duval bodies. Anybody, what is the tumor marker for yolk sac tumor? We know beta, the tumor marker for yolk sac tumor is nothing else but AFP called as alpha fetoprotein. So AFP or alpha fetoprotein is the tumor marker for the yolk sac tumor beta. Clear about? So at least remember these. And lastly, if they ask you which is the ovarian tumor, which has derivatives of all the three germ layers, mesoderm, endoderm, as well as teratoma. So teratoma is the ovarian tumor beta, which is going to have all the germ cell derivatives like endoderm, mesoderm, ectoderm, that is bone, teeth, blood, hair, everything. And that is also called as dermoid. Very good. So mature teratoma is also known as dermoid cells because they give you the picture of teratoma to identify it. But a lot of people are confused that teratoma is not an option. So please remember, mature teratoma is also called as a dermoid cyst beta. Question number 225. Which among the following statement beta they are asking you about physiological jaundice is false? So which among the statement about physiological jaundice is false if they ask you beta? Now let's see the basic differences. Physiological and pathological jaundice if I talk about. We know physiological jaundice never appears in the first 24 hours. It will never appear in the first day of life beta. Pathological jaundice may appear even on the first day of life. Next important, we know physiological jaundice is mild or severe? Mild, and therefore it will not stain the palms and soles. But pathological jaundice may be severe beta, and therefore it can stain the palms and soles beta. Next, we know as the physiological jaundice is mild, here the urine does not stain the diapers basically because physiological jaundice is always conjugated or always unconjugated. So याद रखना, physiological jaundice is always unconjugated jaundice or unconjugated hyperbilirubinemia. Therefore, the urine will never be dark in color or the diapers will never be stained yellow. But in cases of pathological jaundice beta, we know it could be a conjugated jaundice beta. And as pathological jaundice can be a conjugated jaundice beta, therefore there will be a high colored or a dark colored urine, and therefore the diapers will be stained yellow beta. So please remember, pathological jaundice means the urine can be dark in color and therefore the diapers can be stained yellow in color. Important is physiological jaundice never persists beta beyond 2 to 3 weeks beta. It does not persist beyond 2 to 3 weeks, but definitely the pathological jaundice even persists beyond 3 weeks beta. ठीक है, तो physiological jaundice will disappear within 2 to 3 weeks. Pathological jaundice may stay even after 3 weeks beta. तो यहाँ पे they are asking you which among the statement about physiological jaundice they are asking you is false beta. Option A says it never appears on day 1 of life. Is it true? Yes, we know it never appears on day 1. Caput succedaneum predisposes to neonatal jaundice. Is it true? Absolutely not. Caput succedaneum is what? Caput succedaneum beta is edema between the scalp layers. So caput succedaneum is edema between the scalp layers beta. It can cross the suture lines beta. It is going to be of maximum size at birth. It does not grow after birth beta, and it usually disappears by 48 to 72 hours. So हमें पता है it is going to be maximum size at birth beta, and it usually disappears by 48 to 72 hours after birth. ठीक है, तो 48 to 72 hours में it is going to disappear. That is an important feature of caput succedaneum, and it is only a edema beta. It cannot cause jaundice. Jaundice is caused by cephalhematoma. Cephalhematoma is going to cause a neonatal jaundice beta, and cephalhematoma will definitely increase in size up to 48 to 72 hours beta. After birth, it will increase in size up to 48 to 72 hours, and it will disappear by 4 to 6 weeks of life. It will disappear by 4 to 6 weeks of life beta. Cephalhematoma which is there, it does not cross the suture line. It is a hematoma beta, so it will never cross the suture line, and it is commonly associated with forceps or vacuum. So cephalhematoma is associated with vacuum delivery commonly beta. Cephalhematoma is associated with vacuum delivery, and caput succedaneum is more commonly associated with forceps delivery beta. Okay, caput succedaneum is more commonly associated with forceps delivery. Hopefully that's clear all of you. Now, palms and soles are never stained yellow. Is it true? Yes, in physiological jaundice, palms and soles are never stained yellow because it is always mild. It should disappear by 3 weeks in preterm units. Is it true? Yes, it should disappear by 2 weeks in term units and 3 weeks in preterm units. That is a true statement. The answer has to be option B. That is a false statement. Caput succedaneum does not increase the risk of jaundice. It is cephalhematoma which increases the risk of jaundice beta in the neonate. Question number 26. Easy. A 28-year-old married female beta presents to you with complaints of a lot of itching called as pruritus, and there is also which kind of discharge? A greenish frothy vaginal discharge she is having. Colposcopy was done and the relevant picture is observed. Which kind of cervix? So you are able to see a classical strawberry cervix beta, or a strawberry vagina would be seen. This is the strawberry cervix which is seen. So we are able to see strawberry cervix or a strawberry vagina, also called as colpitis maculosus. So strawberry cervix along with a greenish frothy discharge has to be a diagnosis of which vagina it is. We know the diagnosis of this case is nothing else but trichomoniasis, which is caused by a flagellate trophozoa called as Trichomonas vaginalis. Important is trichomoniasis का अगर diagnosis suspect कर रहे हैं हम लोग, तो what should be done next? So next best step in management if they ask you beta, so we know the next best step has to be nothing else but perform a KOH mount beta on the discharge. So collect the discharge and definitely perform a KOH mount on the discharge, and that KOH mount on the discharge will give you a classical motility beta called as. So on that KOH mount you are able to see the classical twitching motility or the jerky motility beta. So twitching or jerky motility will be found definitely beta, and that will confirm that the organism causing this infection or this vaginitis is nothing else but Trichomonas vaginalis. And once it is confirmed it is a case of trichomoniasis, what is the treatment? The drug of choice has to be metronidazole beta 500 mg BD to female or to both partners. So we know as trichomoniasis is definitely beta, the sexually transmitted disease. That's the reason definitely we will start metronidazole to both the partners. Management is diagnosis plus treatment. Management is how you are going to manage the patient. Treatment is very specific basically. ठीक है, मैनेजमेंट का मतलब होता है इसी में नहीं, किसी भी कंडीशन में मैनेजमेंट में फंसते लोग. मैनेजमेंट करना, मैनेज करना पेशेंट को इज नॉट ओनली ट्रीटिंग द पेशेंट. फर्स्ट नेक्स्ट बेस्ट स्टेप इन मैनेजमेंट पूछा ना, तो पहले डायग्नोसिस कंफर्म करेंगे और उसके बाद डेफिनेटली आई ट्रीट द पेशेंट. बराबर? सो दैट इज मोर. मैनेजिंग पेशेंट इज डिफरेंट एंड ट्रीटिंग पेशेंट इज डिफरेंट. ट्रीटमेंट इज अ पार्ट ऑफ कंप्लीट मैनेजमेंट. Colposcopy में दिख रहा है definitely बेटा, but just to confirm our diagnosis we will do a KOH mount further. Reason is colposcopy में definitely it is angular looking vagina, but that is not sure. Inflammation of cervix can be seen in multiple conditions, right? Yes, हमने बस उतना ही पढ़ा है कि trichomoniasis is going to be a classical case जिसमें there will be a strawberry cervix or inflamed cervix. But inflamed cervix can also be seen in cervicitis. Okay, it can also be bacterial infection. That's the reason at least try to do a KOH mount once and definitely then go for a treatment. Yes, देखो practice में तो will directly start treatment. That's obvious. ठीक है, practice में nobody does the KOH mount वगैरह, but theoretically if they ask you questions के हिसाब से if they ask you, you have to go for a stepwise management of the patient. Yeah, that's the reason. तो कल्चर के लिए नहीं भेजेंगे because we are not suspecting any bacterial infection as such. Fluconazole to both the partners. Fluconazole is given in vaginal candidiasis and other trichomoniasis. That is important. Clear? So that is important beta. अगर candidiasis होता तो which kind of discharge would have been there? A curdy white discharge would have been there basically, and there will be excessive pruritus or excessive itching which is there beta in candidiasis. Vaginal candidiasis may be KOH mount is done, but in patients of vaginal candidiasis, when a KOH mount is going to be done, what is going to be observed? Pseudo-hyphae. Pseudo-hyphae are going to be observed in vaginal candidiasis of the KOH mount beta. And what is the drug of choice? Fluconazole 150 mg stat is given basically to the female partner and to the male partner only if symptomatic beta. Most common type of vaginitis will be bacterial vaginosis beta. So we know in bacterial vaginosis the normal bacteria of the vagina is killed. What is the normal bacteria? Lactobacillus, also called as Dodelies bacilli beta. So the normal bacteria are called as Lactobacillus or the Dodelies bacilli is killed, and the pathogenic bacteria like Gardnerella vaginalis is going to grow beta. What is the criteria used for the diagnosis of bacterial vaginosis? So the criteria used for the diagnosis of bacterial vaginosis is the Amsel's criteria. pH of the vagina discharge should be more than 4.5. So pH of vagina discharge should be more than 4.5 beta. Second important, the whiff test should be positive. Whiff test is definitely you'll get a fissure or a ammonia-like odor beta after adding 10% KOH. Next important, the flu cell should be seen on microscopic examination beta. And last one, there should be a whitish watery discharge beta which should be present. Here about drug of choice. The drug of choice in patients of bacterial vaginosis is also metronidazole beta 500 mg BD, but only to the female. Only female partners are going to be treated if it is a case of bacterial vaginosis. Question 227 beta. A patient had to undergo a surgery beta, so he had been given a muscle relaxant beta. His LFT is found to be deranged. The liver function test of the patient is deranged beta, that means liver disease can be there. Which among the following agent beta will you prefer as a muscle relaxant in this patient? Very good. So here definitely the agent that I am going to prefer as a muscle relaxant, answer is going to be option D, cis-atracurium. हमें पता है cis-atracurium and the second one is atracurium. So cis-atracurium and atracurium are considered as the muscle relaxants of choice beta whenever a patient is suffering from any liver or kidney disease beta. The reason is the cis-atra and atracurium, are they metabolized by liver or kidney? No. As they are not metabolized by either the liver or the kidney beta, therefore we can safely use them in patients of liver or kidney diseases. So liver or kidney diseases mein we can use either atracurium or cis-atracurium in the patient. Atracurium when broken down, it leads to production of a metabolite called as lodanosine beta. And when this lodanosine collects inside the patient's body, the patient will have increased risk of seizures or epilepsy. So atracurium when it is broken down beta, it leads to production of lodanosine, and when a lot of lodanosine collects in the body, that is known to cause seizures or epilepsy beta. This was asked basically which metabolite of atracurium increases the risk of seizures. Apart from that, basically if they ask you beta that the atra and cis-atracurium are metabolized by which mechanism? The enzymatic degradation called as Hoffman's elimination beta. The enzymatic degradation known as the Hoffman's elimination. This is the mode of metabolism beta in these drugs. Hopefully clear to all of you now. So that is what is important to remember. Next, if I talk about name the osteochondritis of navicular bone. Answer has to be option A, that is Kohler's disease beta. The osteochondritis of the navicular bone which is there, it is called as the Kohler's disease. So here you can see definitely the important ones. See, the osteochondritis of navicular bone will be Kohler's disease beta. Next important I am marking only. Osteochondritis of lunate bone will be Kienbock's disease. The osteochondritis of lunate bone is going to be Kienbock's disease beta. Next important, osteochondritis of the patellar tendon insertion is going to be called as the Osgood-Schlatter disease beta. Patellar tendon insertion basically, that osteochondritis is called as the Osgood-Schlatter disease. That is important. Okay. And lastly, you can remember for metatarsal heads. For metatarsal heads, it is known as the Freiberg's disease. So at least remember these important osteochondritis beta which have been asked. Clear? Mainly it is the lunate and the navicular that are commonly asked in the examination. Clear? Next important, we know Perthes disease is what? Panner's disease is osteochondritis of the capitulum. Whenever there is a osteochondritis of capitulum, that is Panner's disease. Perthes is? Very good. So it is a bilateral idiopathic avascular necrosis beta of femoral head. So it is bilateral idiopathic avascular necrosis of the head of femur beta, and it is seen in children or adults? Children. Perthes is the bilateral idiopathic avascular necrosis of the head of femur in children. Adults it will be called as Chandler's disease beta. Adults it is known as the Chandler's disease. बच्चों में it is going to be Perthes disease. P for pediatrics. Clear about? So that is important. Done with this? Next important question number 229 beta. Here we are having a 32-year-old patient beta who was driving a bike. Okay? And that person has met with an accident beta and has been brought to the casualty or the emergency. Bruising and tenderness was observed. Okay, and a blunt abdominal trauma was suspected beta. We are suspecting a blunt abdominal trauma. His blood pressure is 90 by 50 millimeters of mercury and pulse rate is 116 beats per minute. Hemodynamically stable or unstable? Patient is hemodynamically unstable beta because BP and heart rate or the pulse rate are not normal. FAST was done beta. FAST is nothing else but focused assessment by sonography in trauma, and it was done and which comes out to be negative. So there is no findings on FAST which have been seen beta. What shall be the next best step?
Repeat fast 30 minutes later.
So I hope all of you are quite aware beta. Whenever we go for a blunt abdominal trauma, please remember there are two options definitely. So one is always I say beta, patient is stable or unstable, check that. If the patient is stable, then it's very easy. If the patient is stable, the first line investigation is fast beta. First line investigation is a fast beta. And once fast is positive, then what we have to go for? So fast agar positive aa jata hai beta, then we have to go for a CT as the next step, which is considered as the best or gold standard investigation. But agar fast negative hai, then I don't do anything. I just keep the patient under observation. Because the patient is stable, I don't need any further treatment. I just keep the patient under observation. Clear about? If they say when the patient is having blunt abdominal trauma and the patient is hemodynamically unstable. The blunt abdominal trauma, whenever the patient is hemodynamically unstable, the first line investigation to be done is always a fast or e-fast beta. So fast or e-fast jo bhi karna karo. After that definitely beta, you have to check whether the patient will have positive or a negative fast. Agar patient ka fast positive hai, directly take the patient for a surgery, that is exploratory laparotomy. Directly take up the patient for a surgery or exploratory lap. If fast is negative, then repeat a fast or e-fast beta, usually 30 to 45 minutes later. So repeat a fast 30 to 45 minutes later. Reason, CT can never be done if my patient is hemodynamically unstable. I cannot do a CT if my patient is unstable. Basic resuscitation chal raha hai, but if my patient is not stabilized, I cannot send my patient for a CT. That's clear. Clear? I'll repeat a fast or e-fast after 30 to 45 minutes because maybe in the initial phase the bleeding was not visible. Blood will be visible after some time. To check it after some time. If the repeat fast is positive, immediately take the patient for surgery. If the repeat fast is also negative, so if definitely the repeat e-fast is negative, go for a serial PCV and hemoglobin monitoring beta. So go for a serial PCV and a hemoglobin monitoring of the patient. If that serial PCV and hemoglobin monitoring, okay, if that serial PCV and hemoglobin monitoring is actually showing you a normal trend beta, then just continue observation. If it is showing you a normal trend, matlab there is no active bleeding as such. Okay? But if it is showing you a decreasing trend, then definitely that means there is an active bleeding. And if there is an active bleeding, I have to go for a surgery. That is an exploratory laparotomy. Hopefully clear, this is the protocol that we follow for blunt abdominal trauma. So as it is a blunt abdominal trauma and they have said the fast comes out to be negative. So blunt abdominal trauma, patient hemodynamically unstable, fast comes out to be negative. The next option is repeat a fast beta 30 minutes later. Answer has to be option D. Okay, hopefully clear. I would have definitely gone for observation and monitoring beta. Condition, the patient was hemodynamically stable. If the patient would have been stable, I would have gone for observation if the fast was negative beta. Barabar but that is important to remember. CCT abdomen cannot be done because my patient is hemodynamically unstable. Exploratory laparotomy would have been done if the fast was positive. Fast है ही नहीं positive, blood दिख ही नहीं रहा, कहाँ surgery करूँगा? That is important. Question 230 beta. A person has been brought into the emergency room after a road traffic accident. The patient has been brought to the emergency room after a road traffic accident and he has sustained a head trauma beta. His GCS or the Glasgow coma scale was assessed and they are saying he opens his eyes to the painful stimulus beta. Along with that, the patient withdraws on pain and the patient appears confused. What is the GCS score of the patient? So if I talk about basically GCS score, GCS is nothing else but Glasgow coma scale beta. Glasgow coma scale is usually checked to see the severity of head injury, how severe head injury the patient is having beta. So here we have to check for three responses. First is the eye opening response, second is the verbal response, and third is the motor response. These are the three responses I need to check for. First, if the patient is spontaneously opening the eyes, I will give a score of E4. When the patient opens the eyes to speech or to vocal stimuli beta, then we give a score of E3. If the patient is opening the eyes to pain or to pressure, then we give a score of E2. And if the patient does not open the eyes at all, then we give a score of E1 beta. Next is verbal response or speech response. So if my patient appears to be alert and oriented to time, place and person, मतलब my patient answers all the questions correctly beta, सही से जवाब देता है, then my patient is oriented to time, place and person and I will give a score of V5. If my patient appears to be confused or disoriented beta, I will give a score of V4. If my patient is giving incorrect answers or appears confused, then V4. If my patient is abusing, गालियाँ दे रहा है बेटा, if my patient definitely abuses a lot or speaks inappropriate words, give a score of V3. If my patient is just making incomprehensible sounds beta, so if my patient just makes incomprehensible sounds, मतलब दर्द में कराता है, that is a score of V2. And if my patient does not make any sound, that is a score of V1. Motor response beta, if my patient follows or obeys all my commands beta. If I say raise the hand, my patient raises the hand. If my patient is able to follow all or obey all my commands, that is a score of M6. If patient cannot obey the command beta, but patient can localize the pain, matlab he is not able to follow all your commands, but he can tell you where exactly he is having the pain beta, then it is a score of M5. Next, person is not even able to localize the pain. He is not even able to tell you where is the pain beta, but he can withdraw on pain. Withdraw on pain means if you pinch the patient pulls his hand away beta. That is the patient withdraws on pain or performs a normal flexion. That is the score of M4. If the patient is having abnormal flexion, that abnormal flexion is called as decorticate posture, and decorticate posture or abnormal flexion is the score of EM3. If the person is lying in extension, that is called as decerebrate posture. The extension or decerebrate posture is given a score of M2. And if the person is showing no response at all, that is a score of M1. Minimum motor response is going to be 3. So please remember beta, minimum motor response, if they ask you, answer has to be 3. Minimum GCS is going to be 3 beta. Minimum GCS is going to be 3 and maximum GCS is going to be 15. Maximum GCS will be 15. If I say my patient is having a GCS of 13 to 15, that is a case of mild head injury. In moderate head injury, what will be the GCS score of the patient? 9 to 12 beta. Please remember, moderate head injury, my patient GCS is going to be between 9 to 12. And whenever my patient GCS is between 3 to 8, that is suggestive severe head injury. Never remember that more than, less than, equal to फालतू की चीज़ है, because that tends to make you tend to make a mistake due to that. Clear है बात? So do remember it is PZ. 13 to 15 is mild, 9 to 12 is moderate, and 3 to 8 will be severe head injury beta. That is what is important to remember. Hopefully clear. So here the patient is opening the eyes to painful stimulus beta. When patient opens the eyes to painful stimulus, that is E2 beta. Next, the patient is appearing confused. When the patient is appearing confused, that is a score of V4 beta. And whenever the patient withdraws on pain, that is a case of M4 beta. So total score is going to be option B, that is 10. That is which head injury? Moderate head injury beta. Hopefully clear all of you now. Question 231. Which structure provides the major support to the uterus and cervix, beta? So the maximum support or the major support to the uterus and cervix, answer has to be option B, that is levator ani muscle. So the strongest support to the uterus and the cervix is given by the levator ani muscle, which forms the perineal diaphragm. अगर वो ये पूछते हैं that which is the most important ligamentary support, then my answer would have been Mackenrod's ligaments, beta. So Mackenrod's ligament is going to be the most important ligament support, beta. The most important support overall is going to be levator ani muscle. Most important ligamentary support, answer has to be the Mackenrod's ligament, also called as transverse cervical ligament or cardinal ligaments, beta. So Mackenrod's are also called as transverse cervical or the cardinal ligaments also. Important is round ligament helps in maintaining what? It maintains the axis of the uterus, beta. Barabar? It is going to actually maintain the axis of the uterus, beta. Which kind of axis is there in the uterus? Antiverted or retroverted? Antiverted. Antiflexed or retroflexed? Normal axis of uterus is going to be antiverted and antiflexed, beta. So the antiverted and antiflexed axis of the uterus is mainly maintained by nothing else but the round ligament, beta. That is important. Broad ligaments do not provide any support and they do not even maintain the axis of the uterus, beta. Clear? Next is question 232 over here, beta. Here we are having a 24-year-old G1P0 presents to the OPD at how many weeks of gestation? 6 weeks of gestation, beta, with a beta SCG of almost 16,000 international unit per ml. And the patient is having a mild left lower quadrant pain, beta. Transvaginal ultrasound was done and this transvaginal ultrasound confirms the presence of an unruptured 3 cm fetal mass, beta, within the ampulla without fetal cardiac motion, without the fetal cardiac motion, beta. Which of the following is the best management option for the case? What is the diagnosis? So we know, beta, patient is definitely coming to you with 6 weeks of gestation. So it is a case of pregnancy. Okay, beta SCG levels are also high. Okay, but ultrasound confirms that it is a pregnancy definitely, but within the ampulla, beta. And if there is a pregnancy within ampulla or outside the uterus, it has to be an ectopic pregnancy, beta. So it is a classical diagnosis of ectopic. Now ectopic pregnancy can be either ruptured or unruptured. Here they are saying it is an unruptured ectopic pregnancy. Now मुझे बताओ, if it is an unruptured ectopic pregnancy, we can go for either medical management or a surgical management. We can either go for a medical or a surgical management, beta, and that completely depends on what? First is the size of mass. Whenever the size of mass is less than 4 cm, go for medical management. More than 4, surgical management. Second is SCG levels. Beta SCG levels less than 5,000, go for medical management. More than 5,000, surgical management. And third is cardiac activity. If cardiac activity is present, go for surgical management. Absent, go for medical management. यहाँ पे बताओ क्या करोगे, surgical या medical? Surgical. Why? Very good. So we know the size of the mass is 3 cm. Okay, and there is no cardiac activity also, beta. But the important thing that they have mentioned, it is the beta SCG level. Beta SCG level is more than 5,000 international unit. It is going to be 16,000, beta. So here we have to go for nothing else but surgical management. And surgical management when we decide, so obviously surgical management of choice क्या होगा? Medical में क्या करते हो? It is injection of methotrexate, beta. So medical management of unruptured ectopic is injection of methotrexate. Surgical management में we have to go for salpingotomy or salpingostomy. We should go for a surgery, beta, and that is called as a linear salpingostomy. Salpingostomy means I am going to remove the mass, beta, but do I suture it back? No, I don't suture the tube back. That is known as a linear salpingostomy. And as it is a case of surgical management, we have to go for a laparoscopic linear salpingostomy. Answer has to be option C for this question, beta. Clear about? Methotrexate would have been given if the beta SCG levels would have been less than 5,000 international units. Cardiovascular is not done over here, beta. Laparotomy with salpingectomy will be done for which kind of ectopic? Very good. So if it would have been a case of ruptured ectopic pregnancy, then I would have removed the tube beta, and for that we have gone for laparotomy along with salpingectomy. Important is beta ruptured ectopic pregnancy mein when the patient comes to you, what is the first line management? Very good. Ruptured ectopic mein patient may be hemodynamically unstable. To stabilize the patient first, airway, breathing, circulation has to be taken care of. Clear? No issues with this. Done with this? Question number 233 beta. If I talk about question number 233, here they are saying beta, we are having a 52-year-old person who comes to you with complaints of nasal fullness. Along with that, patient is also having bleeding. Inspection reveals there are enlarged cervical lymph nodes as well as the FNSC of these lymph nodes which are there beta. It confirms that it is a case of carcinoma. What is the best management strategy for the patient? What is the diagnosis? Very good. हमें पता है whenever a patient more than 50 years of age beta comes to us with complaints like nasal fullness or bleeding, okay, and definitely it metastasizes to the cervical lymph nodes, causing a metastatic painless cervical lymphadenopathy, and that confirms it is a cancer. It is now no other cancer except NPC or nasopharyngeal carcinoma. Nasopharyngeal carcinoma is commonly associated with which viral infection? We know beta, NPC is commonly associated with EBV or Epstein-Barr virus infection. याद रखना, Epstein-Barr virus infection is usually seen with nasopharyngeal carcinoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma, hairy cell leukemia, Burkitt's lymphoma. These are the common ones beta that you can remember. These are the common malignancies or cancers associated with Epstein-Barr virus infection beta. NPC mein if they ask you definitely beta, please remember patient will have which triad? The patients of NPC mein the patient will have a classical Trotter's triad. Trotter's triad can be remembered with the same mnemonic NPC. N for neuralgia beta will be a severe pain due to involvement of which nerve? Fifth cranial nerve. P for palatal palsy. And palsy or paralysis of palatal muscles is due to involvement of 10th cranial nerve, that is the vagus nerve. And C for unilateral conductive hearing loss, okay, that is due to unilateral glue ear beta. These are the features that you have to remember in the NPC, that is Trotter's triad beta in a patient of nasopharyngeal carcinoma. Commonest site, that is a common picture in your examination. As you can see, a tumor arising from the fossa beta, and this is classically called as fossa of Rosenmuller. Bolo treatment for Peruvian patients of nasopharyngeal. You know, single best answer if you have to mark beta for a case of nasopharyngeal carcinoma, then answer has to be chemo radiation beta. Answer has to be option A, chemo radiation. Otherwise, I have told you stage wise also T1 and T2 goes for radiotherapy and T3 and T4 goes for chemo radiation. Clear about? Reason because majority cases of NPC directly presents to us in the metastatic stages. इसीलिए we only go for chemo radiation and not a surgery. ठीक है? Angioembolization followed by surgical resection is done for angiofibroma. Very good. Juvenile nasopharyngeal angiofibroma beta. Sarkari question of FMG examination. A juvenile nasopharyngeal angiofibroma. What is the common site? Most common site for juvenile nasopharyngeal angiofibroma. So it is the spinopalatine foramen beta. याद रखना spinopalatine foramen is considered as the commonest site for the juvenile nasopharyngeal angiofibroma. We know here the child is going to be 12 to 14 years of age. So a 12 to 14-year-old boy comes to you beta with two complaints. One is the nasal mass and second is recurrent epistaxis because angiofibroma is a vascular tumor beta. Important. Patient may have other features like the frog face deformity and all. Important. Which investigation is contraindicated? We know biopsy is absolutely contraindicated in patients of angiofibroma. Investigation of choices. And CCT shows you which sign. Angiofibroma beta, the CCT or the contrasonal CT scan shows you the classical Hallman-Miller sign, also called as antler sign. The Hallman-Miller sign or the antler sign is classically seen on the CCT. In name of staging. Name of staging for angiofibroma. Very good. One is fish classification. Second is Radkovsky staging beta. So fish classification and Radkovsky staging. Recent FMG question. Here the fish classification of the Radkovsky staging is used for juvenile nasopharyngeal angiofibroma beta. And the treatment which is there, that is going to be surgery beta. But before surgery, we should go for preoperative embolization. Very good. So first do a preoperative embolization and block the blood vessel, and then go for surgical removal so that the bleeding is going to be lesser. Question number 234. Your patient presents beta with a complaint of mass on her right cheek beta, which has been slowly enlarging or growing in size. FNSC reveals that it is a case of parotid gland tumor called as pleomorphic adenoma. We know the most common the most common salivary gland tumor or the most common parotid gland tumor is a pleomorphic adenoma, and the treatment will be a superficial parotidectomy beta. The treatment is superficial parotidectomy. He experiences now the patient after the superficial parotidectomy experiences what? Loss of sensations or anesthesia over the angle of jaw. So while shaving, the patient will experience there is no sensations over the angle of jaw or over the angle of mandible. What is the likely nerve injury? So the most common nerve that is injured over here is classically option B, that is greater auricular nerve injury. Very good. Okay? So it is option B beta, that is a नीचे वाला picture देख के आंसर मार्किंग करना. ठीक है? So please remember it is a greater auricular nerve injury definitely, that has to be kept in mind. Clear? तो याद रखना, sensations from the whole face are carried by fifth cranial nerve, that is trigeminal nerve, except angle of mandible. Lastly, the sensations are carried by the greater auricular nerve beta, and that is damaged in superficial parotidectomy. Auriculotemporal nerve, if damaged, patient is going to have Frey syndrome. So, जब भी auriculotemporal nerve is damaged, patient has the classical Frey syndrome. And I hope all of you are quite aware, beta. Whenever the patient is actually going to have the classical Frey syndrome, beta, patient will have a classical presentation. Patient, whenever he eats beta, he complains of what? Very good. So please remember, on eating food, basically beta, patient will have excessive sweating and excessive flushing, that is redness beta. So on eating food, if the patient will have excessive sweating and flushing like this, it is a classical feature of Frey syndrome, and that happens, yes, after a superficial parotidectomy and the nerve injury is auriculotemporal. But here the description in the question is not of Frey syndrome beta, that has to be kept in mind. Clear? Marginal mandibular nerve is the most common nerve injured after superficial parotidectomy. So it is the most common nerve injury beta after a superficial parotidectomy surgery. And if marginal mandibular nerve is damaged, patient will complain of drooping of mouth. So drooping of mouth is seen, but no other features of facial palsy will be there. So if they only say drooping of mouth after the parotid gland surgery, beta, no other features of facial palsy. It has to be a marginal mandibular nerve injury. Clear? But lingual nerve is not damaged in parotid surgeries, beta. Lingual nerve is usually damaged in the ranula surgeries. So whenever you are going to treat the ranula, at that time lingual nerve is going to be damaged, beta. Hopefully clear. Marginal mandibular lingual nerve को ज़्यादा दिखता है. Reason is marginal mandibular nerve यहाँ होती है. It supplies the corners of the mouth, the angles of the mouth. इसीलिए तो submandibular excision भी करोगे तो floor of mouth surgery है. And floor of mouth surgery में lingual nerve is most common. ठीक है? तो कोई भी floor of mouth surgery होगा, the most common nerve injured is always the lingual nerve. Very common question of nothing else but your anatomy. And whenever lingual nerve is damaged, patient has palsy of the tongue or loss of sensations in the tongue. Lingual nerve जब भी damage है, patient will have loss of sensations in the tongue. General sensation or taste sensation? So whenever the lingual nerve is damaged, beta, patient will have loss of general sensations from anterior 2/3 or posterior 1/3.
Anterior 1/3, 2/3.
So please remember, whenever the lingual nerve is injured, patient will have loss of sensations or loss of general sensations, beta, from the anterior 2/3 of the tongue. That is what is important. From the anterior 2/3 of the tongue. Loss of taste sensation from the anterior 2/3 of the tongue is due to chordae tympani nerve injury. Loss of taste sensation from the anterior 2/3 of the tongue is basically due to chordae tympani nerve injury. Important. If they ask you, ipsilateral deviation of tongue is due to hypoglossal nerve injury or 12th cranial nerve injury. So hypoglossal or 12th cranial nerve injury causes ipsilateral or same-sided deviation of Done. All of these are PYQ. Question 235 beta if they ask you. Here we are having a 29-week-old previously healthy male infant beta presenting to you with complaints like fever along with abdominal distension along with feeding intolerance. Matlab, whenever you feed the child immediately vomits that out beta. And there are bloody stools at 3 weeks of age beta. The patient undergoes an X-ray and an ultrasound examination for possible which condition? Necrotizing enterocolitis. We know necrotizing enterocolitis is commonly seen in premature infants beta. Which of the following findings on imaging is an indication of surgical management? Again a PYQ. We know beta that which among the following is an indication of a surgery beta. So yaad rakhna, we know in necrotizing enterocolitis or NEC beta we have a Bell's staging or a Bell's classification. According to that, at least remember stage 1A which is there, here the patient will have all the symptoms beta with no additional finding as such. Stage 1B which is there beta, here the patient will have all the symptoms along with additional finding, and that is bloody stools. So bloody stools basically like melena which are there, they are seen in stage 1B. Stage 2A which is there beta, stage 2A mein the patient will have all these features along with the additional feature, and that is pneumatosis intestinalis, that is gas inside the intestinal wall, that is pneumatosis intestinalis seen in stage 2A. Stage 2B mein patient will have all these features, along with that patient will have a gas inside the portal vein beta. So portal vein gas can be seen in stage 2B as well. Next is stage 3A beta. So stage 3A mein patient will have all these signs along with portal venous gas also beta. Patient will become hemodynamically unstable and the patient is also having a portal venous gas, that is stage 3A. And last is stage 3B beta. Stage 3B mein everything is seen along with bowel perforation, and whenever the bowel perforates beta, the child is going to develop pneumoperitoneum beta. That will give which sign classically? Football sign beta. So pneumoperitoneum which is there, that is football sign, is due to bowel perforation and it is usually seen in stage 3B. And अगर bowel perforate हो चुका है बेटा, तो obviously you need a medical or surgical management. So the only stage of necrotizing enterocolitis which always needs a surgical management is option A, pneumoperitoneum, because pneumoperitoneum is suggestive of bowel perforation, and that is the stage of necrotizing enterocolitis. That is going to be stage 3B. The only stage which always needs a surgery is going to be stage 3B beta. Baki stages can be managed by antibiotics beta or medical management, but not stage 3B. Hopefully clear to all of you now. So do remember this. Next is question 236 beta. Here we are having a case which says a person had a penetrating eye injury beta. Which area is the most susceptible for injury to develop sympathetic ophthalmitis? We know now, this was a PYQ, that penetrating trauma to the eye is actually known to cause which among the following conditions? We know penetrating trauma to the eye is known to cause a condition called as sympathetic ophthalmitis. And what happens in sympathetic ophthalmitis? Patient will have a bilateral granulomatous panuveitis beta. Patient is actually going to have a bilateral granulomatous panuveitis. Matlab, if the patient is having a penetrating trauma to the right eye, patient will also develop a loss of vision in the left eye of the normal eye as well. Clear? So please remember, here there is injury only to one eye, but the vision loss is also seen in the opposite side of the normal eye beta. That is a case of sympathetic ophthalmitis or bilateral granulomatous panuveitis. Panuveitis means inflammation of the whole uvea beta, that is iris, ciliary body and the choroid as well. अब मुझे बताओ that which among the following sites पे if there is injury beta, then there is highest risk of sympathetic ophthalmitis. बोलिए. Ciliary body beta. So ciliary body पे if there is an injury or a penetrating trauma, obviously the infection can easily go into the posterior segment of the eye as well. Ciliary body is a partition we can say between the anterior and the posterior segments. So if there is a damage or injury at the ciliary body, patient may develop a panuveitis. Okay? That is what is important. Limbus is nothing else but the corneoscleral junction. यहाँ पे if there is an injury, there will only be an anterior uveitis beta, not a panuveitis. Clear? Same with cornea definitely. ठीक है? And same with extraocular muscles. The answer has to be option C, ciliary body. In patients of sympathetic ophthalmitis or bilateral granulomatous panuveitis, you are having this classical nodules called as these are the classical Dallen-Fook nodules beta. Dallen-Fook nodules, which is there, it is a very classical feature in a patient of nothing else but sympathetic ophthalmitis, which is, that is what is important to be remembered. Clear? So Dallen-Fook nodules are seen in sympathetic ophthalmitis. If they ask you what is the treatment of sympathetic ophthalmitis, anybody? Direct? Initially intravitreal, so bacterial infection नहीं बताइए. Intravitreal steroids should be given. If intravitreal steroids won't help, then we have to go for a surgery called as PPV. What is PPV? Pars plana vitrectomy. And if that also doesn't help, then you have to go for enucleation. Please tell me, enucleation of the normal eye or the affected eye? Enucleation of the affected eye. दूसरी बच्चा नहीं है ना. Enucleation of the affected eye so that the infection doesn't spread to the normal eye. So inflammation doesn't spread to the normal eye. इसीलिए we have to do an enucleation of the affected eye. Clear है बात? Question number 237 beta. Here we are having a 3-month-old child beta who presents to us with complaints like fever, cough, breathing difficulty, and the child is not able to feed beta. On examination, the respiratory rate of the child was 48 breaths per minute and chest retractions were also present beta. What is the likely management? We know it is a case of which condition? So yaad rakhna beta, there are 3 important findings. One is the no pneumonia, that is which category? Green category beta. The first is the no pneumonia, that is nothing else but green category beta, that you have to remember. Then we have pneumonia beta, that is which category? Yellow category beta. Then we have a case of pneumonia, that is yellow category. And last we have a pink category, that is severe pneumonia beta. So we have a pink category called as severe pneumonia. Now important is, यहाँ पे definitely बेटा there is a child. Tachypnea कितना होता है और fast breathing कितना होता है? So a child less than, so whenever the child is less than 2 months of age beta, obviously the respiratory rate of more than 60 breaths per minute will be considered as tachypnea beta. Next, whenever the child is between 2 months to 1 year of age, we will consider tachypnea if the respiratory rate is more than 50 breaths per minute. And whenever the child is more than 1 year of age, then tachypnea will be considered if the respiratory rate is more than 40 breaths per minute beta. But hopefully that's clear, that is fast breathing or a tachypnea. And important is, here is there tachypnea, 3-month-old child, more than 50 breaths per minute, ठीक है, तो tachypnea तो नहीं है. Let's see other features. Is there chest retraction? Yes. Chest retraction can send this condition into a case of pneumonia beta and not severe pneumonia. Chest retraction and fast breathing are only a sign of pneumonia and not severe pneumonia. Why there will be severe pneumonia? The reason will be 2 important findings. One is breathing difficulty, that is respiratory distress, and second is not able to feed. If the child is having any general danger sign, when I say general danger sign, that means child is lethargic or unconscious. The child is not able to feed at all. Child is having persistent vomiting beta. Child is actually having seizures or convulsions beta. Fourth, the child is having breathing difficulty or respiratory distress. And fifth, the child is definitely having a stridor. These are the danger signs, and then only the child will come in the pink category of severe pneumonia. Chest retractions or chest indrawing or a fast breathing or tachypnea can only classify the child into pneumonia, that is a yellow category beta. That is important to remember. Clear about? So यहाँ पे due to these 2 features beta, the child is in a case of severe pneumonia, and severe pneumonia में what is the treatment we have to give? The first dose of referral antibiotics to the child, and we have to immediately refer the child to a hospital or to a higher center beta. Answer has to be option A for this question. Hopefully clear. Very severe disease. See, very severe pneumonia तो कोई category नहीं थी. Very severe disease was a category earlier, but which has been clubbed with the severe pneumonia to pink category now. So it is not a separate category any which ways now. Okay, pneumonia, if they would have only said tachypnea and chest retractions, I would have gone for pneumonia yellow category beta. And then we give oral antibiotics or antibiotic syrup like amoxicillin for a span of 5 days beta, and we do a follow-up after 2 days. If it would have been a case definitely when there was no signs of severe pneumonia or pneumonia beta, then I would have classified the child into the green category of no pneumonia, and then the treatment would have been only symptomatic, that is soothe the throat of the child beta. Hopefully clear? Chalo. Question 238. A dead body was sent beta for an autopsy. Okay, that is postpartum examination, and examination reveals there is a wound beta on the neck of the patient. Okay, with which kind of edges? Clean cut edges beta, and there is crushed tissues also which are seen over here with the vertebral body disruption. Identify the type of wound. So we know definitely why it is a chop wound. So one thing definitely beta, please remember patient is having crushed tissues beta, ठीक है, and definitely there is a vertebral body disruption. याद रखना crushed tissues are also seen in laceration. Crushed tissues are also seen in laceration beta, but the differences will be in laceration we have irregular edges and not clean cut edges. Second important, vertebral body disruption or bone fractures are never seen in laceration. Clear? Bone fractures or disruption of the bones beta, it is only seen if it is a very deep wound, and that deep wound is nothing else but option B, chop wound. Chop wound happens due to a heavy cutting weapon or a light cutting weapon.
Heavy cutting.
We know beta that chop wound happens due to a heavy cutting weapon, something like an axe beta, kulhadi. Yes. So heavy cutting weapon or an axe, definitely it is going to cause a chop wound. Anybody, incised wound will be due to light cutting weapon beta. So incised wound or incision is due to a light cutting weapon, something like a surgical blade or a knife beta. Surgical blade which is there, it is known to cause a incised wound which is. That got it? And we know incised wound agar hota, so the tissues are crushed or cut. So there is cutting of tissues basically beta, okay, which is going to be seen over here. No issues with this? Sure. Laceration, as I've told you, there will be no vertebral body disruption or no bone damage will be seen beta in a case of a laceration, and it will have irregular edges beta. Avulsion is nothing else but when the skin flap gets separated beta from the underlying tissues, that is known as an avulsion. Next, what is this picture? Very good. So these are nothing else but suicidal wounds which are multiple superficial incised wounds beta. And these multiple superficial incised wounds are only seen on the accessible parts of the body beta. These are called as hesitational cuts, also called as tentative cuts. So either they will be called as hesitational or the tentative cuts beta. Hopefully clear to all of you now. So that is what is important. Done with this? Sure. Next is question number 239 beta. Here they say we are having a 28-year-old girl beta who got married, and the husband and in-laws beta. Okay, her husband and the in-laws have been arrested. The husband and in-laws have arrested and assaulted her beta. Sorry, harassed and assaulted her. She committed suicide beta, and therefore the police arrested her husband and the in-laws. The inquest will be conducted by. मुझे बताओ, if definitely a married female beta, okay, if a married female has been harassed and assaulted by her husband and her definitely beta, the family members or the in-laws, and due to that she has committed a suicide or they have murdered her, then it is a case of dowry death. And if it is a case of dowry death beta, okay, then definitely in this condition the inquest will be conducted by whom? The inquest which is there or the panchnama which is there will be done by dowry death mein. Executive magistrate beta, that is important to be remembered here. So dowry death is one of those conditions where executive magistrate has the power to conduct an inquest. See, judicial magistrate can conduct, but executive magistrate has been given the power. Now, judicial magistrate he कब required होगा? Judicial magistrates will be required in cases like custodial death or custodial rapes beta. Custodial rape or custodial deaths अगर होते हैं in police custody, then definitely a judicial magistrate will always be required beta. Hopefully clear to all of you. That is what is important. बाकी सब conditions में both can do definitely, but dowry death is one of those conditions where executive magistrate has been given the discretionary power beta to conduct an inquest. That is important. Okay, not a medical examiner, not a police inspector. Then you can have judicial magistrate also, but as executive magistrate was there in the option, that therefore a better option which is there, or a specific option is going to be executive magistrate beta for conditions like dowry death. No issues with this, anybody? That is important. Next important, if I talk about question number 240 beta, a man continues to call various females, but a man continues to call various females and achieve sexual gratification or get sexual pleasure by talking obscenity. Obscenity means ashleelta. Okay? So by talking obscenity and sharing obscene pictures, this is known as. Very good. So this was the feedback in your FMG examination, and it has to be option A, that is scatologia. So by speaking obscene words or by showing obscene pictures, if the person is actually getting sexual gratification, it is a case of scatologia, that is a sexual paraphilia. Next important what is coptophilia? Coptophilia. Coptophilia is going to be peeping Tom, also called as voyeurism. So we know that coptophilia is known as peeping Tom or voyeurism, and that is achieving sexual gratification or achieving sexual pleasure by watching private acts of others. If you watch the private acts of others and then that gives you sexual gratification, that is coptophilia. Okay? Stalking is definitely following a person, definitely. And what is frotteurism? Frotteurism is nothing else but rubbing private parts of others. So if you try to rub private parts of others, and definitely that is actually going to give you sexual gratification, that is what is called as frotteurism. Excessive sexual desire in males is known as satyriasis. We know Buddha satya jata hai beta, so please remember excessive sexual desire in males is known as satyriasis. Excessive sexual desire in females is known as nymphomania. Excessive sexual desire in females will be called as nymphomania. That is important to be remembered. Clear about flashing private parts in public. Exhibitionism. Flashing the private parts in public will be called as exhibitionism. At least remember these common ones. Break चाहिए तुम लोग अभी क्या करना है? Take a break of 5 minutes and then we will continue.
इसमें जो है मस्त क्लिनिकल फीचर्स
Chalo, let's start now. Question number 241 beta. Child presents to you with complaints of. So question number 241, a child presents to you beta with a history of severe sunburn beta after only few minutes in the sun. Okay. The child also presents with freckling beta in the sun exposed areas along with dry skin and changes in the skin hyperpigmentation. What is the likely reason to develop this disease? What is this disease? Let me know first of all. What is the disease? Very good. It is a classical case of xeroderma pigmentosum. We know dryness of skin is there along with freckling and definitely a severe sunburn beta or a rash on the body. This bacha is going to be there with in the examination. So it is a classical case of xeroderma pigmentosum, and we know beta that xeroderma pigmentosum is due to a nucleotide excision repair beta. So it is due to a nucleotide excision repair defect. Barabar? The patient who is suffering from xeroderma pigmentosum is due to a defect in the nucleotide excision repair beta. So nucleotide excision repair defect is the cause of xeroderma pigmentosum. Answer has to be option D. If there is a mismatch repair defect beta, mismatch repair defect is known to cause which problem? Mismatch repair defect is known to cause HNPCC beta. We know that the mismatch repair defect which is there, it is known to cause HNPCC, that is hereditary non-polyposis colon cancer beta. That is important to remember. Okay? The hereditary non-polyposis colon cancer is caused by a defect in the mismatch repair mechanism of DNA beta. Next, non-homologous end joining repair defect is known to cause. A defect in the non-homologous end joining repair mechanism is known to cause SCID beta. What is SCID? Severe combined immunodeficiency. So severe combined immunodeficiency which is there beta, this is a condition which is caused due to a defect in the non-homologous end joining repair mechanism. SCID is also caused by deficiency of which enzyme? Very good. It is caused by deficiency of an enzyme called as adenosine deaminase. That was also PYQ beta. So due to deficiency of an enzyme called as ADA known as adenosine deaminase beta, we can have SCID in the patient, that is severe combined immunodeficiency. Next is homologous recombination defect. If there is a defect in the homologous recombination or the homologous repair mechanism, then it is going to cause which problem? Very good. The defect in the homologous recombination or the homologous defect beta is known to cause Bloom syndrome. It can also cause ataxia telangiectasia. At least remember the important ones. The Bloom syndrome or ataxia telangiectasia beta. These are the conditions which are associated with a defect in the homologous recombination or the homologous repair beta. Clear about? So these are the 4 DNA repair defects that you have to remember beta. No issues with this? Chalo. Done with this? The next one is question number 242. We are having a 55-year-old man beta who has been on the bed rest beta for the past 10 days now. After a major surgery, now the patient starts complaining of breathlessness and chest pain beta. The chest x-ray appears to be normal in the patient beta. Okay, the next line of investigation should be, what are you suspecting? Very good. We are suspecting a case of pulmonary embolism. Why? So as the person was on bed rest for 10 days beta, the patient might have developed DVT. Due to prolonged immobilization, the patient might have developed DVT, that is deep venous thrombosis. Due to which beta, now what has happened? The thrombus from the deep veins of the leg might have got dislodged beta, and now the patient is having breathlessness and chest pain. So now the patient is actually going to have please remember the patient is actually going to have pulmonary embolism beta. So whenever the patient is going to have DVT, due to that there can be a complication of pulmonary embolism, and due to that the patient is having breathlessness or chest pain like symptoms beta. Now as the patient is going to have pulmonary embolism beta, they are asking you what is going to be the next line of investigation. We have done chest x-ray already, and that chest x-ray appears to be normal in the patient beta. So what is actually going to be the next line of investigation? So answer has to be option C beta, that is a D-dimer assay. Why? Because we know for pulmonary embolism the screening test that we do beta is nothing else but D-dimers beta, and D-dimers are elevated in patients of thrombosis or embolism. Clear about? That is important. If they ask you investigation of choice to confirm the diagnosis will be तो CT angiography बेटा याद रखना the investigation of choice to confirm the diagnosis of pulmonary embolism has to be a CT angiography or a CT pulmonary angiography बेटा called as CTPA. Whereas gold standard investigation, if they ask you, answer would be pulmonary angiography. Pulmonary angiography will be the gold standard investigation. When they only write pulmonary angiography, that means they are talking about the invasive angiography where you are going to inject a contrast or a dye beta. Clear hai? That is important. CTPA is a non-invasive or a minimally invasive technique, but pulmonary angiography is a invasive or a dye wala angiography that you are going to do. Clear? Screening test definitely is the initial test over here, definitely that we are going to do. Screening is definitely the definition of screening that you might have learnt in PSM is different, but you have a screening test definitely which we can do whenever we are suspecting it to be a case of pulmonary embolism. The initial step I can send is definitely a D-dimer, and then therefore to confirm the diagnosis further I will do a CT angiography, and if CT angiography doesn't give me a diagnosis, then only I will go for a pulmonary angiography. Samjhe baat? That is important. Yeah, if X-ray would not have been done, then the first step or the next management would always have been an X-ray first. Okay? Any patient who comes to you with chest pain and breathlessness, first two investigations are ECG and chest X-ray. So ECG or chest X-ray has to be a first two investigations to be done in case of chest pain. But here as chest X-ray has been done and ECG is not an option. Therefore, we have to go for D-dimers basically as the next one. Clear? Echocardiography is also done. Lung ventilation and perfusion scan is also checked. Okay? Echocardiography is basically checked in patients of pulmonary embolism. Reason is pulmonary embolism is actually known to cause core pulmonale at times beta, and therefore you are able to see a right ventricular wall hypokinesia on echocardiography. That is called as a McConnell sign. So screening test definitely it is more likely sensitive, not always specific. Because screening test can be non-specific, it can be done in multiple conditions. Same screening can be done in multiple conditions. इसीलिए क्या ECG option में कहाँ है? ECG is not an option. If ECG would have been there an option, I would have marked ECG as the next one. Okay, because ECG was not done. But as ECG is not in option, definitely echocardiography is an option. So पहले D-dimer कर लो, then you can go for a echo also. No issues with that. Clear? That is important. In some cases of massive pulmonary embolism mein beta, you are able to see the two classical signs on the chest X-ray, important ones. So the two classical signs, one is definitely a triangular opacity which is seen in the lungs beta, and that triangular opacity is called as Hampton-Hum sign. So massive pulmonary embolism mein I am able to see the classical sign. One is the Hampton-Hum sign beta, and second is going to be a dilated right descending pulmonary artery, and the dilated right descending pulmonary artery is known as the Pallas sign beta. The Hampton-Hum sign and the Pallas sign which are there. These are the two important signs on the chest X-ray in a patient suffering from massive pulmonary embolism. And ECG shows you which pattern. Massive pulmonary embolism mein ECG if done, it shows you a very classical pattern called as S1Q3T3 pattern beta. S1Q3T3 pattern means a deep S wave in lead 1, a deep Q wave in lead 3 and inverted T wave in lead 3 beta. That is S1Q3T3 pattern on the ECG in a patient suffering from massive pulmonary embolism. Which is clear about important is in patients of pulmonary embolism, what is going to be the treatment? The treatment for pulmonary embolism is going to be thrombolysis. If it is a massive pulmonary embolism, we have to go for a thrombolysis beta. Along with that, you have to do anticoagulation. Thrombolysis and anticoagulation has to be done. Thrombolysis can be done with drugs like altiplase or retiplase beta. So drugs like retiplase or altiplase can be used for thrombolysis beta. That has to be remembered. And for anticoagulation, you can use low molecular weight heparin. For anticoagulation, you can use low molecular weight heparin. Hopefully that's clear to all of you now. चलो if अगर वो बस ये बोलते DVT का केस, DVT के केस में क्या होता, patient would have pain and swelling only in the calf region. So if they would say a history of prolonged immobilization of bed rest along with pain and swelling in calf region, then I will suspect a case of DVT, and then the investigation of choice would be duplex scan. So DVT is a peripheral vessel, that is going to be a duplex scan or a color Doppler that has to be done beta. Clear? Question 243. Here there is a question beta which says a female was diagnosed with cervical cancer and she was planned for a treatment beta. Now she is saying she is having a 16-year-old daughter beta who is not sexually active. What will be your advice to her daughter basically? So very good. Please remember beta, her daughter is definitely 16 years of age. Is she having a risk of cervical cancer? Yes. The mother has been diagnosed with cervical cancer, so she is having a very high risk of cervical cancer beta. So what you should do if she is not sexually active beta? So option A says start pap smear screening 3 yearly. Will we do that? No. First, according to Indian recommendations beta, we start the pap smear screening after 3 years of first sexual intercourse. One thing. According to the ACOG guidelines, we start the pap smear between 21 to 65 years of age. According to ACOG, we should do it between 21 to 65 years of age, or according to WHO, we have to do it between 30 to 50 years of age beta. So that is out of question because the patient is definitely only 16 years of age beta. Okay, the pap smear will not be done in this female. Next important, take HPV vaccine after 3 years of sexual intercourse. Will that be done? No beta. Cervical cancer vaccine or the HPV vaccine beta can be even given before the sexual intercourse, so it is not necessary to be taken after. Rather better give it before. Okay? Perform co-test and if negative repeat after 5 years. Yes, co-test can be performed and that can be repeated after every 5 years. But once the screening has started, and screening will start by that age beta. So यहाँ पे the female is definitely 16 years only and even not sexually active. So I will not definitely start the screening. So answer has to be option D. That is the Cervavac vaccine should be given beta 2 doses. Clear? So Cervavac vaccine should be given to this female beta, which is the indigenously developed vaccine in India. Clear? Cervavac. That is important. क्या? It is between 9 to 5 years of age. Minimum 9, maximum 45 years of age तक you can give the CS cervix का vaccines beta. That is what is important to be remembered. Clear about? No issues with this? Chalo. Next important is question number 244 beta. They are asking you over here. A mother brings a 4-day-old newborn beta to you, concerned that a bluish patch which is there is present on the baby's buttocks beta, which she refers to as the birthmark. It is present in the lower lumbosacral area. Your advice will be, what is going to be seen beta? What is this? So this bluish spots in the lumbosacral area beta of the child is nothing else but the Mongolian spots. And this bluish spots or Mongolian spots in the lumbosacral area, do they need any kind of treatment beta? No, they are self-limiting condition. The Mongolian spots are going to be self-limiting beta, and therefore no treatment is usually required for Mongolian spots. Only reassurance has to be done. Now, option A says definitely ultrasound should be performed to rule out the renal anomalies. Is it associated with any renal anomalies? No beta. So that's out of question. Inquire about family history of such birthmarks. No, it is not required. Reassure that it will disappear by 1 month. Does it disappear by 1 month? No. We know beta. Option D has to be the answer. We will reassure the parents that this Mongolian spots are going to disappear by 1 year of age. In majority children it will disappear by 1 year of age. Answer has to be option D. That is what is important. Just why I have given similar options, because in examination there would be some questions beta jahan pe the options are very similar to each other. You will just read the first few parts and you will immediately mark. Don't do that. Don't jump onto the answers immediately. Clear? Read the options carefully. Question number 245 beta. Here we have a child who is below the 3rd percentile beta for the height according to the children of same age and same sex beta. His growth velocity is also normal, but the chronological age which is there beta is more than the skeletal age of the baby. Chronological age is going to be more than the skeletal age of the baby beta. The most likely diagnosis in this condition is going to be. So, if I talk about the basic differences between familial short stature and constitutional delay in growth and puberty beta, important is familial short stature can be seen in both the sexes beta, males as well as females, but constitutional short stature which is there, it is more commonly seen in boys. Next important is familial short stature mein there will be a family history of short stature, that is the mother and father both are going to have a short stature beta. But in cases of constitutional delay beta, the family history will be of delayed puberty. Either the mother or father would have had a history of delayed puberty beta. Height velocity which is there, okay, there is normal in both the conditions beta. Puberty which is there, it is normal in familial short stature but delayed in CDGP beta. तो constitutional delay में the puberty gets delayed. That is important to be remembered because it is not only a constitutional delay in growth, it is constitutional delay in growth and puberty beta. Clear about bone age which is there. We know bone age is going to be normal in case of familial short stature, but it is going to be less than the chronological age or less than the actual age in case of CDGP. So CDGP or constitutional delay में बेटा the bone age is less than the actual age or the chronological age. If the child is 15 years of age, the bone age is only 10 or 12 years of age. That is important. Clear? And the final height in familial short stature is going to be short, but it is normal according to his target height beta. It is normal according to his target height. मतलब according to his mother's and father's height, it is absolutely normal. ठीक है? But in case of CDGP beta, the target height is absolutely normal. It is delayed, but it is not short stature. Clear? तो यहाँ पे उन्होंने क्या बोला बेटा? Growth velocity is normal, that's fine. But the chronological age is more than the skeletal age, or the bone age is less than the chronological age. Whatever you say. Answer has to be option A. That is constitutional delay in growth and puberty beta. Because we know that whenever they say that the bone age or the skeletal age is less than the chronological age, it has to be nothing else but CDGP or constitutional delay in growth and puberty beta. Familial short stature में the chronological age is equal to the bone or the skeletal age beta. Clear? Primordial dwarfism is not this. Hypopituitarism will again definitely beta that can cause all like chronological age to be more as compared to the skeletal age, but important is it is not common. The more common ones are going to be CDGP beta. Question number 246 now. A baby has been delivered बच्चे by emergency cesarean section beta. A baby has been delivered by the emergency cesarean section or by emergency LSCS beta. That is what is important to be remembered. And they have a meconium stained amniotic fluid. So baby was delivered by emergency cesarean section or emergency LSCS. For what reason? Because there was a meconium stained liquor beta. So meconium stained liquor or meconium stained amniotic fluid was there. Matlab baby has passed the meconium inside the uterus itself beta. Okay? The baby did not cry immediately beta after birth. The baby haven't cried immediately after birth. Okay, and the child was also hypotonic. The child was also hypotonic or decreased muscle tone was there. Heart rate of the baby was definitely less than 100 beats per minute beta. What will be the immediate treatment modality in this baby? What you will do? Bolo. Answer has to be option A, that is start PPV, positive pressure ventilation. Reason? Yes, heart rate less than 100 beats per minute beta is an indication to start the positive pressure ventilation according to the neonatal resuscitation protocol. So according to NRP beta, we have to immediately start a PPP whenever the heart rate or the pulse rate of the child is less than 100 beats per minute. I'll start the CPR whenever the heart rate is less than. So whenever the heart rate or the pulse rate is less than 60 beats per minute beta, in those conditions I have to immediately start chest compressions or I have to immediately start the CPR beta. Hopefully that's clear to all of you now. At least remember these 2 points, they are important. If they ask you drying and stimulation, yes, that would be done beta in the baby. Take a suctioning the residual meconium from the hypopharynx. Yes, that is also going to be done beta. Intubating and suctioning meconium from lower airways. Yes, that will also be done. Intubation will be done if definitely the positive pressure ventilation doesn't help. Okay? In those conditions, I will go for intubating the child also beta. That is important to be remembered. Hopefully clear to all of you now. So do remember these 2 points beta. Heart rate less than 100, we go for a positive pressure ventilation, and heart rate less than 60, we go for a CPR or a chest compressions beta. Hopefully clear. Suctioning PYQ sequence was asked. Mouth followed by nose or nose followed by mouth? Mouth followed by nose beta. That is important. M followed by an alphabetical order mein jao. Mouth followed by nose beta. That is what is important to be remembered. Another Sarkari question. PPV or positive pressure ventilation or any kind of bag and mask ventilation is contraindicated in. So bag and mask ventilation, we all know beta, it is absolutely contraindicated in a child suffering from CDH. What is CDH? Congenital diaphragmatic hernia. We know beta that most common type of congenital diaphragmatic hernia is going to be the Bogdalic hernia. Bogdalic is seen on the right or the left side? Left side beta. Anteromedial or posterolateral? Posterolateral. The left side, posterolateral side mein beta, we are going to find the Bogdalic's hernia. Morgagnis is seen on the right side in the anteromedial part. Clear? Chalo. Next important is question number 247 beta. We are having an infant who had repeated episodes of bluish discoloration of lips beta, that is cyanosis what was there, which were relieved by squatting position, which a chest x-ray is shown below. What is the likely diagnosis? So we know beta, here you are able to see that the child is having cyanosis beta, so it is a case of cyanotic congenital heart disease. And if you see the shape of the heart on the chest x-ray, it is a classical appearance of boat-shaped heart. Boat-shaped heart is also called as Coron Sebo beta, yes. So Coron Sebo which is there, definitely that is nothing else but the boot-shaped heart which is going to be seen. And Coron Sebo appearance or a boot-shaped heart on a chest x-ray is a classical feature of which congenital heart disease? It is a classical feature of a congenital heart disease known as TOF, called as TOF. So answer has to be option D, tetralogy of Fallot. Tetralogy of Fallot has 4 parts in it beta. The first one, the child is actually going to have a ventricular septal defect beta. The child is also going to have a right ventricular hypertrophy. So the child will have a RVH or a right ventricular hypertrophy. Patient is also going to have overriding of, so there is a overriding of aorta which will be seen. And fourth important beta, the child will have the pulmonary stenosis. So pulmonary infundibular stenosis which is there beta is going to be seen. Which is the most important one out of all of them? So please remember beta, the most important one out of them is nothing else but pulmonary stenosis. That's the most important out of the tetralogy of Fallot. If they say beta, patient is definitely having all these features along with ASD, then that is called as pentalogy of Fallot. So if all these features are going to be seen beta along with definitely ASD, that is called as the pentalogy of Fallot. That has to be kept in mind. No issues with this. Important is, if it was a case of hollow viscous perforation beta, then what would have been seen on the X-ray? Gas under diaphragm beta. So gas under diaphragm called as the called as the cupula sign or the Mostach sign beta. VSD with severe pneumonia beta. If it was a case of pneumonia, so obviously chest retractions along with tachypnea, fever, these signs should have been there beta. Okay. Next is TAPVC. TAPVC is total anomalous pulmonary venous connection. So total anomalous pulmonary venous connection में which appearance? Figure of 8 appearance, also called as snowman appearance. So figure of 8 appearance or snowman appearance is a classical feature of TAPVC beta, also called as definitely the total anomalous pulmonary venous connection. Important is beta, scimitar sign is seen. Scimitar sign is seen. Very good. PAPVC beta. So whenever there is a PAPVC, that is partial anomalous pulmonary venous connection. So partial anomalous pulmonary venous connection means scimitar sign is going to be seen. Next is egg on string appearance. That is very clear beta. We know egg on string appearance is a feature of TGA, that is transposition of great arteries. And egg in cup appearance, where egg in cup appearance is a feature of constrictive pericarditis, when the pericardium is calcified beta. Money bag heart or water bottle shaped heart? Cardiac tamponade. So massive pericardial effusion or cardiac tamponade mein we will have a money bag heart or a water bottle shaped heart beta. That is what is important to be remembered. Inferior rib notching or figure of 3. Coarctation of aorta. So inferior rib notching on chest x-ray or a figure of 3 appearance is a feature of coarctation of aorta beta. Hopefully that's clear to all of you now. So that is important. Next important is question number 248 beta. They are asking you, a multigravida female presented to the clinic at 36 weeks of gestation beta, and she was found to have which kind of presentation? Breech presentation. Which body part of the baby goes into the pelvis for a breech presentation? Buttocks. So the baby's buttocks are going to go inside the pelvis beta, then we call it as breech presentation. So the baby was found to have found to be in breech presentation clinically and on sonography. Which of the following is not an indication beta for a cesarean section in this type of presentation? They are asking you in which among the following condition we don't need a cesarean section. We can do a normal vaginal delivery or we can do a breech delivery beta. So can we definitely do a breech delivery in a hyperextended breech? Can we do a vaginal delivery in hyperextended breech? No, beta. It always needs a cesarean section. Okay, so hyperextended breech. Next, can we do a normal vaginal delivery in footling? Never. Footling breech always needs a cesarean section. Can we do a normal vaginal delivery in knee breech? No. Knee breech may definitely beta. We cannot do a normal delivery. We have to go for cesarean section. Answer has to be nothing else but option C, that is flexed breech. Flexed breech is also called as complete breech, when all the four limbs of the baby are flexed. Can we go for a normal vaginal delivery? Yes, we can do a LVD or a normal vaginal delivery in a flexed breech beta. Hopefully that's clear to all of you now. So flexed breech is not an indication of cesarean section. यहाँ पे देख सकते हो, this is the complete breech beta, where all the four limbs are going to be flexed. So this is also called as flexed breech. Second one is definitely beta, incomplete breech which is seen. That incomplete breech can also be called as a extended breech, also called as a frank breech beta. So extended or frank breech. Okay, so ये incomplete frank होगा, and the next one which is there beta, this will be a complete frank breech. This is also extension. यहाँ पे one leg is extended, यहाँ both legs are extended. That is the only difference. Clear है बात? So complete breech, incomplete breech, and frank breech is there. Most common type of breech, frank breech beta. The completely extended breech or frank breech which is there beta, it is actually going to be the most common type of breech that you have to remember. We know in all these types of breech beta, we can go for a NVD or a normal vaginal delivery. We cannot go for a NVD in case of footling breech, knee breech, or hyperextended breech beta. Hopefully clear. Sure. Next is question number 249 beta. If they ask you which among the following is the correct order of endometrial blood supply, तो endometrial blood supply का sequence पूछा था एक बार in the examination. What is the correct order beta? It is last artery. इतना तो पता होगा last artery कौन सी होती है? Spiral. Last artery is always the spiral artery beta towards the fetus. So obviously these two options will get ruled out beta. Now is it ARBS or it is ARSB? Sorry, is it ARBS or the RBAS? Answer is ARBS beta. That is nothing else but arcuate artery is the first artery, followed by the radial artery, followed by the basal artery, and last one to the fetus is going to be the spiral artery. So the artery that actually participates in the feto-placental barrier or the materno-placental barrier, which is called as the spiral artery. Hopefully that's clear to all of you now. So ARBS sequence याद रख लेना. Another sequence जो तुम्हें गायनी से याद रखनी है, and that is after the delivery there is a discharge beta per vaginum called as lochia, and that lochia का discharge which is there beta, it is in the sequence of RSA. What is RSA? Lochia rubra, lochia serosa, and lochia alba. This have been a question in your examination. So lochia rubra, serosa, and alba. This is the sequence of lochia beta, which will be a vaginal discharge after delivery in the pulpurium period. Hopefully clear to all of you now. क्या rubra usually see, please remember, for the first 2 days or for first 48 hours beta, you are able to see the lochia rubra which is there. Next, definitely for the 1 week, matlab up to after 48 days up to 1 week beta, you are able to see the serosa usually, and after 7 to 10 days you are able to see the whitish discharge, that is the alba. Question number 250, if they ask you identify the given anomaly based on the HSG image. So the given anomaly based on HSG beta, I have always told you, yes, just based on the HSG or hysterosalpingography, it is extremely difficult beta to identify whether it is a septate or a bicornuate uterus. If you look at this one over here beta, here the angle which is seen definitely between both of them is less than 90 or more than 90. So here the angle is usually less than 90 degrees, so acute angle beta that can be seen. Next important, the distance which is there between the two horns which is there beta, it is going to be less than 4 centimeters beta. So it is nothing else but a case of which uterus? Septate uterus beta. Whenever there is an acute angle and the distance is lesser, it is actually going to be option B, that is a septate uterus that has to be remembered, which is the most common Mullerian defect beta which will be seen. This is the one. ये क्या है? Here it is a bicornuate uterus. You can see the angle which is there beta. Angle is less than 90 or more than 90. Obviously we know beta, the angle is more than 90 degrees or it will be more than 105 degrees beta. That is an obtuse angle will be there. Apart from that, the distance is less than 4 or more than 4 centimeters. the distance is more than 4 centimeter beta. This is a very classical picture of nothing else but bicornuate uterus beta. This is a classical picture of bicornuate uterus. Hopefully clear to all of you now. Okay. So septate uterus में acute angle and distance less than 4 centimeter. Bicornuate में obtuse angle and distance more than 4 centimeter. And the third picture is very good. Here you are able to see 2 uterus, 2 cervix, 2 vagina, and therefore 2 which cannulas? Leach-Wilkinson cannula. So it is a picture of uterine diadelphys. And I hope all of you are quite aware about the unicornuate uterus. In unicornuate, only how many horns will be seen? Only one side of the uterus is seen, beta. That is a unicornuate uterus. That is easy, so I have not included. Hopefully clear. Question number 251, beta. Okay, that was a recent FMG question. Ye wala. A 32-year-old woman, beta, comes with mass inside her right breast, beta, for the past 5 months. On examination, beta, a firm, freely mobile mass, okay, which is not attached to the overlying skin or even to the underlying tissue, beta, that was palpable, and there was no tenderness, that is no pain was there, beta, in the patient as well. Histopathological examination has been given below. What is the likely possible diagnosis? What is the histopathological examination showing you? ये जो दिख रहा है बेटा, ये क्या है? Excess amount of fibrous stroma, right? We are able to see an excess amount of fibrous stroma which is seen, and due to that excessive fibrous stroma, the glandular tissue or the glandular structure has got compressed, beta. Looks like the horns of a reindeer or an antler. So that is a classical antler sign. Whenever the histopathological examination of a breast mass shows you the classical antler sign, beta, or excessive fibrous trauma, has to be a case of fibroadenoma, beta. Now important is, okay, one thing you will be like, so fibroadenoma 32-year-old, yes, can be seen. Fibroadenoma is more common in females between 15 to 25. That doesn't mean it can never be seen in older females. It can be seen in older females, one thing. Second important, she was having a mass inside her right breast, beta. That mass was firm due to excess fibrous tissue, and it was freely mobile, called as the breast mouse, and it was not even attached, beta, so not a cancer. So as it is not attached with the underlying tissues or overlying skin, it is not a कार्सिनोमा और कैंसर, बेटा. इनवेसिव कार्सिनोमा होता तो कौन सा पैटर्न दिखता? वेरी गुड. देन इट वुड हैव बीन द क्लासिकल इंडियन फाइल पैटर्न और द सिंगल फाइल पैटर्न, बेटा, दैट वुड बी सीन. ठीक है, तो इंडियन फाइल पैटर्न और सिंगल फाइल पैटर्न वुड बी सीन, एंड विद जीन म्यूटेशन ही कैथरीन, बेटा. वेरी गुड. ठीक है, फाइलॉइड्स ट्यूमर अगर है तो फाइलॉइड्स ट्यूमर में दिस इज द क्लासिकल पिक्चर, विच अपीयरेंस लीफ लाइक स्ट्रक्चर्स, बेटा. This was the recent NEET PG, so please remember that if it would have been a case of phylloids tumor, then obviously the patient would have had, beta, the classical leaf-like appearance. So phylloids tumor mein there is a classical leaf-like appearance which is going to be seen, beta. Hopefully clear. Apart from that, fibroadenosis agar hota, so I hope all of you are quite aware, beta, that fibroadenosis which is there in this kind, fibroadenosis is going to cause cyclical mastalgia or non-cyclical mastalgia. The fibroadenosis is the commonest cause of cyclical mastalgia, beta. This fibroadenosis is also called as fibrocystic disease, beta. It is also called as a fibrocystic disease. Clear? So that fibroadenosis or fibrocystic disease causes cyclical mastalgia. So there would have been a tenderness, but in the question they have clearly mentioned patient is having no tenderness, beta. Clear? Next important question, number 52, beta, 252. It says a 3-year-old child has been brought to the pediatrician for the evaluation of a lateral neck mass, beta. On examination, they are saying a painless, soft, fluctuating mass is found on the lateral side of the neck, biche, as shown over here. The slip sign is going to be negative, and the swelling is brilliantly transilluminant, beta. Okay? Which among the following will not be a treatment option for this child? Bolo. So very good. We know that a 3-year-old child hai having a lateral neck mass, beta, or a lateral neck swelling definitely, and that swelling is brilliantly transilluminant. Matlab it contains fluid inside it, beta. Any kind of fluid it can be there. Clear? So they are asking which among the following is not a treatment option. Answer has to be cyst trunk surgery, beta. I will not do a cyst trunk surgery for any lateral neck swelling. It is only done for a thyroglossal cyst, and thyroglossal cyst is a midline neck swelling, beta. Thyroglossal cyst is going to be a midline neck swelling बच्चे. For thyroglossal cyst, I do a cyst trunk surgery, not for any other swelling beta. That is important to be remembered. The answer has to be option A, which is not the treatment. Can we do injection of sclerosants? Yes. Once you aspirate all the fluid or drain all the fluid, उसके बाद you can inject a sclerosing agent or sclerosants beta to close the cavity. Can I do aspiration of swelling? Yes. Can I do excision of the cyst? Yes. So all these three treatments can be done, but cyst trunk surgery will not be done beta for this lateral neck swelling or this lateral cystic swelling which is going to be seen beta. Clear? It is not likely to be a case of cystic hygroma. Reason cystic hygroma is present since birth, and definitely beta, it is a marker of some aneuploidy or some chromosomal anomaly. Apart from that, it is not anterolateral, it is a posterolateral neck swelling which is present. यहाँ पे the swelling which is shown, it is an anterolateral neck swelling, more likely to be a case of branchial cyst. Okay, more likely. Posterolateral is cystic hygroma, anterolateral is going to be a branchial cyst beta. Clear? This is a classical picture of thyroglossal cyst beta. This is a classical picture of a thyroglossal cyst that has to be remembered. No issues with this? Question number 253, if they ask you, a person met with a road traffic accident beta, following which he was brought to the emergency room, wherein he was having hypotension, that is low BP, tachycardia and cold peripheries beta. His GVP or the jugular venous pressure was quite high beta. With which kind of heart sounds? Muffled heart sounds. Which among the following shock best describes the condition of the patient? मुझे पहले बताओ diagnosis क्या होगा? So we know hypotension, tachycardia along with muffled heart sounds beta, along with the GVP which was high. It is a classical case of cardiac tamponade beta. ठीक है, it is a classical case of cardiac tamponade बच्चे. And I hope all of you are quite aware. Cardiac tamponade जब होता है, there is a classical triad called as Beck's triad beta. We know in patients of cardiac tamponade there is a classical Beck's triad. One is the patient will have low BP, that is hypotension. Second, the patient is going to have pulsatile or non-pulsatile rise in JVP. Cardiac tamponade mein there is a non-pulsatile rise in JVP or a non-pulsatile rise in jugular venous pressure. And third important, the patient will have a muffled heart sounds beta. So all these three features are given. That means it is a case of Beck's triad and it is a diagnosis of cardiac tamponade itself. So which among the following shock will be seen in cardiac tamponade? Cardiogenic shock. Definitely here what is going to happen beta, as there is a lot of fluid around the heart, it will collapse the heart beta. And if heart chambers are collapsed beta, will it be able to pump the blood? No. That is the reason definitely beta, it has to be nothing else but option C. That is a case of cardiogenic shock beta. Hopefully that's clear to all of you now. So that is what is important to be remembered. अगर hypovolemic shock होता है बेटा, तो definitely we know hypovolemic shock में there is hypotension, there is tachycardia, but GVP is also low and no muffled heart sounds are seen. So JVP is also low beta, no muffled heart sounds will be seen. Neurogenic shock होता, तो we know beta along with hypotension the patient is going to have bradycardia beta in case of neurogenic shock. ठीक है, so that is important to be remembered. And septic shock होता बेटा, तो yes in the patient अगर cold peripheries बोल रहे हैं तो let's consider it to be a case of cold septic shock. तो cold septic shock अगर होता definitely hypotension is fine, tachycardia is fine, cold peripheries is fine. But again JVP which is there beta is not high in patients of septic shock beta. Clear? So answer has to be option C, that is cardiogenic shock basically. Here what happens? As the heart is not able to pump the blood beta, there is pooling up of blood, and due to that pooling up of blood, the JVP of the patient may increase. That is what is the case of cardiogenic shock. Hopefully clear to all of you now. So JVP was the most important feature in all of this, along with the along with the muffled heart sounds as well beta. Here you are able to see the classical, which appearance I have told you? Yes, the money bag heart, also called as the water bottle heart beta. So money bag appearance or the water bottle heart which is there, it is seen in patients suffering from cardiac tamponade beta. Hopefully clear to all of you. In patients of cardiac tamponade beta, here it is a traumatic case of cardiac tamponade, that is after a road traffic accident definitely. If they ask you first line investigation will be fast beta. The first line investigation will be a fast focused assessment by sonography in trauma. Investigation of choice will be echocardiography will be the investigation of choice for cardiac tamponade. Treatment क्या करोगे? One is basic resuscitation, उसके बाद definitive treatment will be pericardial stenosis और thoracotomy. I have told you beta that traumatic cardiac tamponade which are there, in that condition we never go for a pericardiocentesis. According to recent edition of Bailey, it clearly mentions pericardiocentesis will not be done if the patient is having a traumatic cardiac tamponade. It has to be directly a surgery, that is thoracotomy. Please remember, in patients of non-traumatic cardiac tamponade means yes, pericardiocentesis will be done, but not in trauma. Clear about the surgery wale cases mein there is no pericardiocentesis which will be done with them. Hopefully clear. Next question number 254, if they ask you, a 35-year-old female beta with a history of intermittent pain in the right side of her upper abdomen beta for the past 6 months now. She presents in the emergency room beta with complaints like crampy abdominal pain along with vomiting and abdominal distension for the last 1 day. A plain abdominal x-ray was done which reveals there is dilated loops of small bowel and air inside the biliary tree is also present beta. Which among the following triad best explains the patient's condition? So let's see one by one. First of all, patient is having pain in the right upper abdomen beta. Along with that, emergency mein she comes to you with pain, vomiting, distension. All of these are features of bowel obstruction beta. So all of these are features of bowel obstruction. That is important. Okay? Next important, you are able to see the dilated loops in bowel. Those dilated loops in the small bowel definitely beta are confirming that okay, it is a case of small bowel obstruction beta. Second important, definitely you are also able to find air inside the biliary tree. Air in the biliary tree is called as pneumobilia. Very good. So air in the biliary tree is known as pneumobilia beta. And tisra, you may find definitely a shadow inside the right iliac fossa. And what is that shadow? Yes, it is going to be a gallstone beta. You may find a gallstone in the right iliac fossa or in the terminal ileum. This is which triad? This is the classical regular stride beta. And we know that option C, regular stride, which is there. It is usually seen in which condition? The classical regular stride which is there beta. It is usually seen in patients of gallstone ileus beta. So we know gallstone ileus mein it is going to be seen. That is important. Pain, fever and jaundice is going to be which stride? Charcot stride. And pain, fever and jaundice or the Charcot stride is a feature of which condition? Cholangitis beta. That is important to remember. Clear about? So that is what is important. Question. Same stride is usually associated with bowel obstruction, but in patients of same stride definitely apart from bowel obstruction, the patient is going to have other features. The patient will have cholelithiasis over there, but no gallstone obstructing the bowel. That is the case of smaller same stride. Question number 255 if I talk about here, there will be a 49-year-old alcoholic woman beta who presents to you with complaints of weight loss and there will be a persistent rash on her lower abdomen and the perineum as well beta. She was diagnosed with which condition? Necrolytic migratory erythema. So this rash that they are telling you beta, it is nothing else but a necrolytic migratory erythema. On additional workup, she is found to be having diabetes mellitus beta. Along with that, she is also having anemia and a mass inside her pancreas beta which is seen. Which among the following is the most likely diagnosis of the patient? Very good. We know beta necrolytic migratory erythema along with diabetes mellitus is commonly associated with a case of nothing else but option B, glucagonoma, which is nothing else but a neuroendocrine tumor arising from the pancreas beta. It is the neuroendocrine tumor arising from the alpha cells of pancreas. That is what is important to be remembered. And here the patient will have excessive rise in the glucagon levels causing increase in the blood glucose levels, so diabetes mellitus. Patient will have dermatitis, classically known as necrolytic migratory erythema, as you are able to see. Patient will have DVT, that is deep venous thrombosis, and patient will have depression. So these are the 4 Ds of glucagonoma beta which will be seen. Next is the case of VIPoma beta. VIPoma which is there, it is definitely going to have a watery diarrhea. The watery or a secretory diarrhea will be seen in the patients along with hypokalemia and metabolic acidosis. WDHA, watery diarrhea, hypokalemia, acidosis. These are the features in patients of VIPoma, the Werner-Morrison syndrome. Somatostatinoma which is there, here there is excess production of somatostatin and due to that beta, the amount of growth hormone in the patient is actually going to decrease basically. Okay? And last is insulinoma, which triad? So please remember, in patients of insulinoma beta, which arises from the beta cells of pancreas, the patient will have the classical Whipple stride beta. So Whipple stride is seen in insulinoma. What is the investigation that we can do? Fasting insulin levels beta. The fasting insulin levels can be done, or we can go for an insulin by glucagon ratio. तो either fasting insulin levels check कर दो या फिर check for the insulin by glucagon ratio बेटा. ठीक है? No issues with this. That is what is important to be remembered. What is the drug of choice for insulinoma? Diazoxide beta. The drug of choice in the management of insulinoma is diazoxide beta. That is what is important to be remembered. Clear? Next, if I talk about beta, done with this? Next important, if I talk about beta, 256. So question number 256, if they ask you beta, they are asking you that identify basically the type of ulcer. Okay, identify the type of ulcer in the patient who has been immobilized beta for a prolonged period of time post paraplegia. So after a paraplegia paralysis beta, patient has been immobilized for a very long duration of time, for a prolonged duration. This ulcer which is there basically is known as what? It is usually known as a pressure sore or a bed sore. So on the pressure points of the body beta, there will be decreased blood supply, and due to that those sites are going to develop an ulcer beta called as a pressure sore or bed sore. So मुझे बताओ pressure sore or bed sore seen on the pressure points of the body due to prolonged immobilization or bed rest is also called as option C beta, that is a decubitus ulcer. Please remember, Martyrus ulcer is also seen in the leg of the, it is usually seen in the leg of the patient beta, and it is going to be associated with a lot of pain. That is a Martyrus ulcer. Marjolin ulcer which is there. Yes, so this is a classical picture of Marjolin ulcer, repeated image based question in FMG examination. This is the Marjolin ulcer beta, and Marjolin ulcer is seen over the site of burns. तो जहाँ पे burns होता है बेटा, over the site of burns we are able to see the Marjolin ulcer, and Marjolin ulcer is going to be pre-malignant. The Marjolin ulcer is one of those ulcers which is pre-malignant. It can further develop into a squamous cell carcinoma. The Marjolin ulcer can further develop into a squamous cell carcinoma beta. Therefore, it is considered as pre-malignant in nature. Clear? Trophic ulcer is usually seen in the foot of the patient beta. Trophic ulcer is seen in the foot of the patient, and it is extremely painless beta. Trophic ulcer will be extremely painless ulcer because it is associated with neuropathies like diabetes mellitus or leprosy. It can be seen in patients of neuropathies like diabetes mellitus or leprosy beta. That is a case of trophic ulcer. Clear? So that is what is important to remember. Next is question number 257 beta. It states, we are having a 45-year-old man who complains of non-tender swelling beta. In which region? In the inguino-scrotal region. And the cuff impulse is felt over which ring? The cuff impulse is felt over the deep inguinal ring beta. He has undergone which repair? Bassini's repair beta. But in the post-operative period, the patient starts complaining of loss of sensation over the right scrotum as well as on the medial right thigh. Damage to which of the nerves beta would cause such kind of symptoms? I hope all of you are quite aware. What is this case of, first of all? So this is, jaldi se batao, this is the deep inguinal ring. It is the opening in which layer of the abdomen? Fascia transversalis. And this is the superficial inguinal ring, which is the opening in which layer of the abdomen? External oblique aponeurosis beta. It is the opening in the external oblique aponeurosis. We know above that we have the, above and behind the inguinal canal we have the which triangle? Hasselbalch triangle. Any herniation from the deep inguinal ring is called as indirect inguinal hernia. Any herniation from the Hasselbalch triangle is called as the direct inguinal hernia. To differentiate both of them, we have a set of vessels beta. Those vessels are called as inferior epigastric vessels beta. That is important to be remembered. So lateral to the inferior epigastric vessels beta, we are actually having a indirect inguinal hernia, and medial to the inferior epigastric vessels we are having a direct inguinal hernia beta. That is what is important to be remembered. Clear about? So that is what is important beta. Clear? So that is what is important. Okay? Please remember, questions kitne aayenge isme se, all of that. More important is basically to clear your topics, as he said basically. That is what is more important. I am not a person who claims anything basically. ठीक है ना? मेरा कोई चाचा नहीं बैठा हुआ एनबी में जो मुझे आगे बताता है. Nobody's person is there over there. Clear? So better is to focus on the most important topics and just get these topics clarified. Yes, the topics, the previous year topics है बेटा, so the probability of these topics is higher. That's the reason I've included them. Clear है बात? So please remember that. So hernia that is lateral to inferior epigastric vessels will be the indirect inguinal hernia. Medial to inferior epigastric vessels will be a direct inguinal hernia. We know beta for inguinal hernias, the surgeries that we can do. For congenital hernia, what is the surgery of choice beta? Very good. For congenital hernia beta, the surgery of choice is nothing else but herniatomy beta. That is important. And herniatomy should only be done after what time? So herniatomy should only be done after 3 years of age beta. Up to 3 years of age, no surgery is done in congenital hernia because majority of them resolve spontaneously. Clear hai baat? Next important, if they ask you the herniorrhaphies that we do, beta, for a case of inguinal hernia, what are the herniorrhaphies done? Herniorrhaphy matlab kya? When you close the defect with the help of sutures. So whenever I close the defect with the help of sutures beta, that is what is herniorrhaphy. And those surgeries are going to be Bassini's repair, it is going to be Shouldice repair, or it is going to be the modified Shouldice repair. So Bassini's Shouldice and the modified Shouldice repair are the types of herniorrhaphies beta that we do for inguinal hernia. And last is hernioplasty surgery that we do for inguinal hernia will be hernioplasty matlab whenever we close the defect with the help of a mesh. So whenever you close the defect with the help of a mesh, that is a hernioplasty surgery. And the hernioplasty surgery that we do beta is known as the Lichtenstein's repair beta. That is basically called as the Lichtenstein's repair. So Lichtenstein's mesh hernioplasty or a Lichtenstein's repair is done. That is a better surgery beta that we know. Now important is over here they are saying the person has undergone a herniorrhaphy surgery called as Bassini's repair beta. And definitely they are saying in the post-op period patient is having loss of sensations over the right scrotum and the medial right thigh. Which of the following nerves would have been damaged? Now we know beta, if there is an open inguinal hernia surgery, the most common nerve damage is always the option C, that is ilioinguinal nerve. So ilioinguinal nerve is most commonly damaged beta in which kind of surgeries? In open surgeries. And most common nerve damage in laparoscopic surgeries will be? It will be lateral cutaneous nerve of thigh. The most common nerve that is damaged in laparoscopic inguinal hernia surgeries beta is nothing else but the lateral cutaneous nerve of thigh beta. That is what is important to remember. Clear about? So laparoscopic inguinal hernia surgeries mein the most common nerve damage is going to be lateral cutaneous nerve of thigh beta. Hopefully that's clear to all of you. So do remember that. So if these kind of symptoms are seen and a open hernia surgery history is given, you have to think about ilioinguinal nerve injury beta. Important is, what is this condition? It is which type of hernia beta? Cuff impulse was felt over the deep inguinal ring. Very good. It is a case of indirect inguinal hernia. So whenever cuff impulse is felt over the deep inguinal ring, it is a indirect inguinal hernia. Question number 258, they are asking you. We are having a 55-year-old female beta who has undergone a mastectomy for CA breast or carcinoma breast. After mastectomy, patient is not able to extend beta or person is not able to adduct and internally rotate the arm. Nerve supply to which among the following muscle? Nerve supply to which among the following muscle has been damaged? So first of all, person is not able to extend the arm, person is not able to adduct, that is bring the arm close, and person is not able to internally or medially rotate the arm beta. Now let's rule out one by one. Option A says pectoralis major. Pectoralis major definitely is a muscle beta which can help in adduction of the arm. Pectoralis muscle can also help somewhat in internal rotation of the arm. But pectoralis muscle cannot help in extension of the arm. So why there is difficulty in extension of the arm? So pectoralis major is not paralyzed over here beta, that is gone. Teres minor. We know teres minor doesn't help in external rotation beta, it doesn't help in internal rotation beta, it helps in external rotation. So if the patient had difficulty in external rotation or the lateral rotation, then I would have said it is a case of teres minor muscle palsy beta. Clear? Now long head of triceps. Long head of triceps tuning. Reason, yes, long head of triceps or triceps muscle will help in extension, but it doesn't help in adduction basically beta, okay, or doesn't help in internal rotation. So definitely patient would have difficulty in extension, but no difficulty in adduction or internal rotation can be explained. So the better answer has to be option C, that is latissimus dorsi, because this latissimus dorsi muscle helps in adduction of it helps in adduction of the arm, internal rotation of the arm, as well as extension of the arm beta. That's the reason definitely all these functions are affected whenever there is a latissimus dorsi muscle palsy beta, and latissimus dorsi muscle palsy is due to injury to which nerve? Thoracodorsal nerve. So whenever there is injury to the thoracodorsal nerve or to the nerve of latissimus dorsi beta during the axillary lymph node dissection or during a modified radical mastectomy beta, we know the patient will have latissimus dorsi muscle palsy which is. Hopefully clear. If they ask you beta in MRM or in a modified radical mastectomy, which is the most common nerve damage? Bolo. Most common nerve damage muscle. The most common nerve that is damaged beta in MRM or modified radical mastectomy. Yes, it is. Bolo. ICBN. What is ICBN? Intercostobrachial nerve. We know beta that the intercostobrachial nerve is actually going to be the most common nerve that is damaged or injured beta in a modified radical mastectomy. Easily a patient will experience chest pain which is radiating to the arm. So after the modified radical mastectomy or a surgery beta, when patient experiences chest pain radiating to arm, that is due to injury to which nerve? ICBN or the intercostobrachial nerve. That is the most common nerve injury. It is not axillary. Please remember that. Clear enough? Next important is a question number 259 beta. Question number 259 states, in the following figure, the surgery that has been shown is going to be which one? This is the easiest one beta. You can see this is the fundus of the stomach which has been pulled upwards beta, and you have wrapped this fundus of the stomach all around the lower end of esophagus. Whenever I completely wrap the fundus all around the esophagus beta, 360 degree or a complete wrap, it has to be a case of option A, that is Nissen's fundoplication. So Nissen's fundoplication is a complete 360 degree wrap beta, that you have to remember. If they say beta a partial wrap, we know there are two types of partial wrap mainly we do. One is Dors fundoplication. Dors fundoplication is 180 degree anterior or posterior. So Dors fundoplication is a 180 degree anterior wrap beta. So 180 degree anterior wrap is going to be called as a Dors fundoplication, and Taupet's fundoplication will be 270 degree posterior wrap beta. We know that the Taupet's fundoplication is actually going to be a 270 degree posterior wrap. That is what is called as the Taupet's fundoplication. Hopefully clear. Nissen's fundoplication, yes, it can be done in the treatment of GERD or hiatal hernia beta. So two conditions jahan pe the surgery of choice can be the Nissen's fundoplication beta. One is definitely a case of GERD. Second is a case of hiatal hernia. Please remember these are the conditions jahan pe the surgery of choice is going to be fundoplication beta. Hopefully clear to all of you. Next important, identify this picture. This has been shown in a PYQ. So what we have done here, we have separated a part of the stomach, or we have created a gastric pouch, and to that gastric pouch we have directly connected our jejunum beta, so that the food is not going to pass via the stomach. This time the food will directly pass via the patient's intestine beta. Okay, so definitely what we are doing, we are bypassing the stomach. So this is classically called as Roux-en-Y gastric bypass surgery. This is nothing else but a Roux-en-Y gastric bypass surgery done for the purpose of weight loss. Very good. It is a bariatric surgery beta, or the most effective bariatric surgery which is done for the purpose of weight loss beta. That is done for the purpose of weight loss. Why? Because now if the food directly goes into the jejunum, the patient's appetite is going to decrease. Normally, whenever the patient's food goes into the stomach beta, it can be stored. But now as the food cannot be stored in the jejunum beta, and if the patient tries to eat a lot, patient will immediately develop epigastric pain, fullness, nausea, vomiting like symptoms called as early dumping syndrome beta. That is the reason patient will avoid eating a lot of food beta. Clear about? Next important, what is this surgery? Again a PYQ. Yes, it is Whipple surgery. Please remember you are able to see a pancreatic cancer in the head of pancreas. So you have removed the head and neck of pancreas along with duodenum, along with CBD, along with the gallbladder. And now you are going to perform three anastomosis. One is pancreatico-jejunostomy. Second is hepatico-jejunostomy. And third is gastro-jejunostomy beta. These three anastomosis have been done. It has to be a picture of nothing else but Whipple surgery beta. And Whipple surgery is done for which cancer? पैनक्रियाटिक कैंसर, तो कार्सिनोमा हेड ऑफ पैनक्रियाज और पेरिएम्बुलरी कैंसर के लिए बेटा वी गो फॉर अ विपल सर्जरी, दैट हैज टू बी रिमेंबर्ड. इफ दे आस्क यू व्हाट इज द मोस्ट कॉमन कॉम्प्लिकेशन ऑफ विपल सर्जरी, the most common complication of Whipple surgery beta is a impaired gastric emptying. ठीक है, तो please remember difficulty in gastric emptying or impaired gastric emptying is actually considered as the most common complication after Whipple surgery beta. Clear? Kasai surgery is done in biliary atresia beta. In that condition we do a portoenterostomy, but there are no other anastomosis then. There is only a connection of jejunum to the porta hepatis, not the common hepatic duct. That is Kasai surgery. Question number 260, if they ask you beta, it is which among the following is incorrect beta, they are asking you regarding the structures which are removed in the radical neck dissection. So which structure is not removed in radical neck dissection, ultimately they are asking you. So radical neck dissection is done in whenever a patient is going to have a thyroid cancer or a laryngeal cancer. So whenever the patient will have a CA thyroid or a CA larynx, we tend to do a radical neck dissection where we tend to remove the lymph nodes and the other structures involved in the neck beta. So please tell me, option A says, do we remove the sternocleidomastoid muscle in radical neck dissection? Yes beta. Do we remove the submandibular gland in radical neck dissection? Yes, we remove the submandibular gland also in radical neck dissection. Do we remove the accessory nerve in radical neck dissection? Yes, we do. But do we remove level 1 to 6 cervical lymph nodes in radical neck dissection? No, it is level 1 to 5. So please remember, level 1 to 5 cervical lymph nodes are removed beta in radical neck dissection. Level 6 lymph nodes ka removal. Level 6 lymph nodes ka removal is a separate one called as central neck dissection. We remove the level 6 lymph nodes separately beta called as the central neck dissection. It is not a part of radical neck dissection. Yeah, that's not. Apart from these structures, the other structures that are removed in radical neck dissection is the IJV called as the internal jugular vein. We can also remove a tail of which gland? Parotid gland. And we can also remove which muscle? Omohyoid muscle beta. ठीक है, we can also remove omohyoid muscle. तो याद रखना 2 muscles, 2 glands, 5 lymph nodes and 1 nerve, 1 vein. So 1 to 5 lymph nodes beta, 2 muscles that is sternocleidomastoid and omohyoid, 2 glands submandibular and tail of parotid, and 1 accessory nerve and 1 internal jugular vein. These are the structures that we tend to remove which in a radical neck dissection. That has to be kept in mind beta. As I have told you, level 6 lymph nodes को अगर remove करना है, level 6 lymph nodes removal which is there beta, it is done separately and that is called as the central neck dissection beta. That is called a central neck dissection, commonly done in patients of thyroid cancer beta. Yes, commonly done in thyroid cancers. Papillary में भी करते हैं. Hopefully clear. Next important, if I talk about question 261 beta, that says over here we are having a 23-year-old female beta who presents to you with complaints like fever, pain and swelling in the thigh region. Patient is having fever, pain and swelling in the thigh region beta. On asking history, she is found to have a microcytic anemia beta, which is a result of point mutation at the 6th position. अब पहले मैं बता रहा हूँ. हाँ. I am telling you first itself. Please remember that this controversy of 6th and 7th which is there basically, it has been since a very long time now. ठीक है, and that is basically why biochemistry textbooks have not updated and why only pathology textbooks have updated. Reason is beta, in biochemistry textbooks like Harper's, whenever we see the beta globin gene, so beta globin gene में beta the codon which is the beta globin gene में beta the amino acids which is the first one, that is methionine. And please remember, when we count beta, we don't count methionine as the first amino acid. Okay, methionine is not a part of the chain and therefore methionine is not counted as the first amino acid. We start counting from the second amino acid beta, and that's the reason the glutamic acid comes on the 6th position. Clear about? So according to that, whenever we don't count methionine as the first one, because it is not a part of chain, it is outside the chain. That's the reason definitely the glutamic acid comes on the 6th position. Please remember, if you count methionine as the first amino acid, then glutamic acid will be the 7th one beta. Clear about? So only pathology textbooks are saying it to be 7th beta. That too, not all the textbooks, a few textbooks basically. Okay? Apart from that, definitely beta, Harper's or any other Harrison's or even pediatrics textbooks beta, they still say 6th position itself. Okay? So that is important. So Here there is going to be a result of point mutation. It is a result of point mutation at the 6th position beta of the beta globin chain. Which organism is actually responsible beta? Which organism is responsible for her current condition? They are asking you. Now मुझे बताओ. Here first of all they are asking you beta. A young female presents to you with fever, pain and swelling in the thigh region beta. On asking history, they have also saying that the patient is having a microcytic anemia. This microcytic anemia due to a point mutation at 6th position on the beta globin gene is which anemia? Sickle cell anemia beta, which is a type of hemoglobinopathy. So it is a type of sickle cell anemia beta. Okay, it is a type of sickle cell anemia, which is a hemoglobinopathy that you have to remember. Clear about which organism is responsible for causing this condition? मुझे बताओ पहले फीवर पेन एंड स्वेलिंग इन थाई रीजन. व्हाट आर यू सस्पेक्टिंग? Fever, pain and swelling in the thigh region, you are suspecting an infection in the bone, and that infection in bone is called as osteomyelitis. Okay, so it is a case of osteomyelitis. Now they are asking you that what is the cause of osteomyelitis beta in a patient who is suffering from hemoglobinopathies. We know most common cause of osteomyelitis. अगर वो पूछते, if they would have asked you most common cause of osteomyelitis, my answer was straightforward, Staph aureus or Staphylococcus aureus beta. Straightforward answer would have been Staph or Staphylococcus aureus. But if they say any hemoglobinopathy like sickle cell anemia, this has been a PYQ beta. Okay, sickle cell anemia, अगर ऐसा पिक्चर दे देंगे कोई sickle RBCs का, which was given in the recent NEET PG as well, then the cause is going to be option A, that is salmonella. So salmonella is the leading cause of osteomyelitis if it is any kind of hemoglobinopathy. The leading cause of osteomyelitis and hemoglobinopathy is salmonella beta. Clear about? In cases of osteomyelitis beta, if there is an acute osteomyelitis, I am just able to see which reaction. एक्सरे पे क्या दिखेगा? acute osteomyelitis होगा तो I am just able to see periosteal reaction beta. I am just able to see periosteal reaction in case of acute osteomyelitis. अगर chronic osteomyelitis है बेटा तो I am able to see the dead bone, and that dead bone is called as sequestrum beta. I am able to see a dead bone बच्चे, that is classically known as the sequestrum बच्चे. That is important to be seen. Around that dead bone beta we are able to see the new bone which is going to form, and that new bone which is going to form is basically called as involucrum beta. So the dead bone which is going to form is sequestrum. Along that the new bone that is going to form is involucrum beta, and then there will be a opening to drain the pus, and the opening to drain the pus in bone is called as cloaca. So these are going to be the three findings beta which you are able to see. Clear? So this definitely you are able to see beta, a growth of new bone which is seen, that is nothing else but called as the involucrum which is there. Clear? So sequestrum is the inner dead bone surrounded by a new bone called as involucrum, and then an opening on the bone for pus drainage is called as cloaca, and opening on the skin for pus drainage will be called as sinus. Opening on the skin for pus drainage will be called as sinus. Treatment is obviously antibiotics. ठीक है? तो overall most common is Staph aureus. In hemoglobinopathies, answer it as salmonella. Next important, if I talk about beta, it is going to be question number 262 which is, here there is a question which states, a chronic smoker presented to you with complaints of intermittent discharge from bilateral nipples beta for the past few months. On compression of the breast beta during the examination, which kind of discharge comes out? A pultaceous greenish nipple discharge. That is the keyword of the whole question. ठीक है? Which of the following is the most likely diagnosis? We know beta, a pultaceous greenish nipple discharge which is there. A pultaceous greenish nipple discharge which is there beta. Here it is usually seen in patients having a duct ectasia beta. The answer has to be nothing else but option D beta. So duct ectasia is going to be the cause of this condition, where there is dilatation of the lactiferous duct, and due to dilatation of the lactiferous duct there is stasis of secretions beta, which can actually cause all the problem. Clear about? Duct ectasia is usually seen in older females beta, and it is going to be investigated with the help of an ultrasound beta. And what is the treatment? Conical excision of the lactiferous ducts, and that conical excision of lactiferous duct is known as, very good, Hadfield surgery or Hadfield's operation beta. So Hadfield surgery or Hadfield's operation is done in the treatment of duct ectasia. If they would have said beta, bloody nipple discharge from a single duct, so bloody nipple discharge from a single duct, then the answer would have been इंट्रोडक्टल पैपिलोमा बेटा. तो इंट्रोडक्टल पैपिलोमा जो होता है, इट कॉजेज बेसिकली अ ब्लडी निपल डिस्चार्ज बेटा, एंड दैट टू फ्रॉम सिंगल और मल्टीपल डक्ट, सिंगल डक्ट बेटा. And in patients of duct papilloma, what you will do for investigation? I can go for investigations like ductography and ductoscopy beta. So ductography and ductoscopy can be done. Treatment will be, I am going to insert a wire and I am going to remove that duct beta, called as microdocectomy beta. The microdocectomy is the treatment that we do for nothing else but intraductal papilloma. Paget's disease is nothing else but Paget's disease of nipple, which is an eczema-like condition of the nipple. There is no discharge usually in patients of Paget's disease beta. Okay, that is important to be remembered. Paget's disease is associated with ductal malignancies or ductal cancers in the breast. Clear about fibroadenosis? I have told you it is fibrocystic disease, and fibrocystic disease causes a cyclical mastalgia or a breast pain, along with which kind of discharge? Serous discharge beta. So serous discharge is seen in fibroadenosis or fibrocystic disease. Question number 263 beta, it states we are having a patient who presents to us with complaints of chronic urine retention, and the patient is also having history of recurrent UTIs beta. So there is a chronic retention of urine with recurrent UTIs in the patient, and the IVU or the intravenous urography shows the below given picture. What shall be the next best step in the management of this patient? They are asking you beta. First of all, what is seen over here in the picture? Yes, there is retention of urine in the pelvis and the calyces, which is going to cause hydronephrosis. That's fine. But what is the cause of that hydronephrosis? Arrow mark करके दिया गया. Yes, it is a case of urethric stricture. Very good. It is a classical diagnosis of urethric strictures. And if there is a case of urethric stricture beta, what is the treatment that you are going to do? Yes. So please remember, whenever there will be urethric strictures beta which are not letting the urine flow out, we have to definitely go for double J stent beta. So answer has to be nothing else but option C. A DJ stenting or a double J stenting has to be done to open up that urethric strictures bache. Please remember, urethroplasty, will you do it via buccal mucosal graft? No. Urethroplasty is done via buccal mucosal graft beta. Why? Because buccal mucosa and the urethra has the same epithelium, that is stratified squamous epithelium beta. Ureter mein the epithelium is transitional beta, and therefore I cannot use buccal mucosa as a graft. Boris flap is done when the ureters have been damaged. Short segment or long segment? Short segment. The short segment of the ureter, whenever it is damaged beta, we create a flap from the urinary bladder, and then we definitely connect it to the ureter beta. That is the Boris flap, which is done when a shorter segment of ureter has been damaged or it is missing. Okay, and suprapubic catheterization will be done over here beta. Okay, but important to be remembered is, even if you do suprapubic catheterization, will it help? No, because suprapubic catheter is inserted in the bladder beta. Bladder tak hi nahi aa pa rahi na urine. The problem is the urine is not even able to come till the bladder because the ureters are having the stricture beta. Therefore, a suprapubic catheter is not going to be useful. Neither a Foley's nor a suprapubic will be useful. You have to open up basically beta the ureters first, and that is done by double J stenting. Double J stenting. क्या क्या? किस में? क्या बोलूं? एक में ही यूरेटर दिख रहा है definitely. The reason can be, sometimes it could be a patient who is having a unilateral kidney itself. That can be a case. In a PYQ in NEET PG एक बार दिखाया था, एक ही साइड का दिख रहा था सब कुछ, and they asked you what is the diagnosis. Answer was nothing else but a patient post nephrectomy. So that is what is important. एक ही किडनी थी उस पेशेंट में. Clear? So that is important. That can be seen at times. ठीक है? Next important, because IVP जब करते हो, that definitely both the kidneys are usually visible because intravenous dialysis. ठीक है? So that is important. Next important, if I talk about beta, is question number 264. A young female beta presents to you with neck swelling. When her neck was palpated beta, a midline solitary nodule was palpated in the neck. What shall be the initial step in this case? A recent NEET PG question. We know midline solitary nodule or any kind of thyroid nodule whenever it is there. So whenever there is any kind of swelling arising from the thyroid gland beta, whenever there is any kind of thyroid swelling or a thyroid nodule beta, we know the first investigation that you should do is always a TFT. What is TFT? Thyroid function test. And in thyroid function test, you have to check for the serum TSH. So the first step that has to be done with the initial step is nothing else but option D, that is serum TSH you have to check. And depending on the serum TSH levels beta, you are going to decide the next step. Clear? Okay, depending on that, you will decide the next step, and that next step is usually ultrasound neg beta. The first step is always serum TSH, followed by that we go for an ultrasound neg beta. If definitely beta, in cases of serum TSH, when it is going to be low beta, that means whenever it is suggestive of hypothyroidism, along with ultrasound neg, I can also go for a radioactive iodine scan. So radioactive iodine scan is usually done whenever definitely it is a case of hypothyroidism. So अगर hypothyroid state है तो we can go for radioactive iodine scan. Otherwise, after TSH, the next best is always ultrasound beta. FNSC is only done if the ultrasound is showing you any problem. If ultrasound shows you definitely any issue beta, then only you go for a FNSC or a fine needle aspiration cytology. हाँ क्या हाँ किसके लिए किसके लिए in thyroid nodule basically beta, it can be a ultrasound neg itself. If definitely you are able to see decreased TSH levels, definitely decreased TSH levels में radioactive iodine scan is done. Protocol के हिसाब से definitely if the TSH levels are high, I don't need a radioactive iodine scan. Clear? That is important. Next is question number 265 beta. Here there is an adolescent patient who presents to the gastro OPD beta with features of bloating, watery diarrhea and vomiting beta since a very long duration of time. We know bloating, watery diarrhea and vomiting, they are all the features of malabsorption beta. Barabar? All of these are definitely features of malabsorption. Along with that beta, they are saying that upper GI endoscopy and biopsy was done and it reveals the below given histological picture. What is seen on the histological picture? Recent need PGA. Here, very good. I am not able to see any finger-like projections in the intestinal mucosa, and whenever there is no finger-like projections in the intestinal mucosa, we know there is loss of villi or atrophy of villi, and I hope all of you are quite aware. A malabsorption syndrome, whenever there is atrophy or loss of villi, has to be a diagnosis of celiac sprue beta. We know that celiac sprue or celiac disease is a gluten sensitive enteropathy. Matlab whenever the patient will eat any gluten containing food, the patient will have malabsorption beta. Celiac sprue is associated with, answer is option D, that is HLA-DQ2 or HLA-DQ8. So HLA-DQ2 or DQ8 basically beta is it is the HLA beta which is commonly associated with celiac sprue. Recently in PG it was important to be remembered beta is going to be celiac sprue की अगर मैं बात करूँ, in this case is definitely beta. What is going to be the antibody seen? The most sensitive antibody will be sensitive. The most sensitive or the most common antibody will be ATTG beta, that is anti-tissue transglutaminase antibody. Whereas if they ask you which is the most specific antibody beta, so we know the most specific antibody which is there beta, it is going to be the anti-endomysial antibody. So most specific antibody will be the anti-endomysial antibody which is seen in patients of celiac sprue. Investigation of choice, as you are able to see, it is the intestinal biopsy, and treatment should be what? Avoid all the gluten containing food, and that gluten containing food is bro beta, that is barley, rye, oats and wheat. What you can give? We can give rice and quinoa to the patient beta. Clear? So that is important. This is a picture where I am able to see PAS positive macrophages in the mucosa. Whenever I am able to find PAS positive macrophages in the intestinal mucosa beta, these are the macrophages which have engulfed the bacteria. So PAS positive macrophages on intestinal mucosa is a feature of which malabsorption syndrome? Very good. It is a classical feature of Whipple's disease beta. And we know Whipple's disease is actually going to have malabsorption along with other features, and that is malabsorption, you know. Patient will have malabsorption along with arthritis and dementia. So whenever they say patient is having arthritis, dementia and malabsorption syndrome, I will definitely think about nothing else but Whipple's disease. It is a bacterial infection caused by Trophorema Vipelli, and therefore the treatment has to be nothing else but antibiotics beta. Hopefully that's clear to all of you now. Sure. We know HLA-B27, which is there beta, it is usually associated with arthropathies like ankylosing spondylitis, reactive arthritis beta. So reactive arthritis basically, or psoriatic arthritis. At least remember the important ones beta. So ankylosing spondylitis, reactive arthritis or psoriatic arthritis is क्या? HLA-B27 is commonly associated. HLA-B51 is associated with Behçet's disease beta. So HLA-B5 and HLA-B51 is commonly associated with Behçet's disease, and HLA-CW6 is associated with psoriasis. HLA-CW6 is associated with psoriasis beta. Hopefully clear. Question number 266 beta. We are able to see definitely, okay? A young woman who presents to us beta, a young woman presents to us with the below given feature as shown below, and these complaints are triggered by cold temperature or by emotional stress beta. Episodes usually affect the fingers and the toes beta, along with pain and numbness in the affected areas. There is no underlying comorbidity, no other disease beta. What is the diagnosis? Very good beta, we know they are saying no underlying comorbidity is there. Matlab this condition is not associated with any other disorder. And what is this? Here you are able to see a change in the color of fingers in the sequence, and that is going to be white, blue and red beta. So the sequence of color change in this condition is going to be white, blue, red bache, and that happens due to the vasospasm. So whenever there is vasospasm beta in the fingers or the toes, that is going to cause this. Two important risk factors. One is going to be the cold exposure, and second is a prolonged vibration. So cold exposure and prolonged vibration are considered as the two important risk factors. And whenever this is a classical case of Raynaud's phenomena beta. But when Raynaud's phenomena is not associated with any other disease, we call it as primary Raynaud's phenomena. So answer has to be option A for this question. Primary Raynaud's phenomena is also called as Raynaud's disease. Very good. Primary Raynaud's phenomena is also known as Raynaud's disease, so be aware of that. Secondary Raynaud's phenomena will be associated with which condition? Secondary Raynaud's phenomena will be associated with definitely rheumatological conditions beta. And when I talk about rheumatological conditions or the connective tissue disorders like scleroderma, Kress syndrome, Sjogren's syndrome, all of them. So rheumatological conditions or connective tissue disorders के साथ, if they would have said that the female is a known case of scleroderma, then I would have said it is a case of secondary Raynaud's phenomena. Then clear about what is the drug of choice for Raynaud's phenomena? We know beta treatment में we have to avoid the risk factors, that is lifestyle modifications, but the medical management of the drug of choice will be CCBs, that is calcium channel blockers beta, the vasodilators like calcium channel blockers, Nifedipine and all. Hopefully clear? याद रखना. Sjogren's syndrome, इसमें the patient will have a keratoconjunctivitis, sicca, dry mouth and dry eyes will be there beta. Clear? Buerger's disease में there is Buerger's disease में beta, the patient is actually going to have a history of smoking. Apart from that beta, there will be gangrenous features which are going to be seen beta. Question 267. A patient who is a known case of RA or rheumatoid arthritis presents with complaints of dyspnea and chest pain. Chest X-ray has been given below, which reveals the below given picture. All of the following are the characteristics beta they are asking you found in a aspirate analysis of this case, except which is not a feature they are asking you. Important is पहले देख सकते हो यहाँ पे what is seen over here, which is the sign. We are able to see beta there is a whitish appearance or a whitish opacity seen, and there is a curve or a line. Curve, and that curve is classically called as which curve? Yes, it is a classical feature of Ellis curve beta. Second, apart from Ellis curve, you are able to see blunting or deepening of the costophrenic angle. So Ellis curve is seen beta along with blunting of the costophrenic angle. No costophrenic angle is visible over here. So blunting of CP angle is going to be seen beta. Whenever there is blunting of CP angle and Ellis curve, that is a classical diagnosis of which condition? Pleural effusion. That is a classical condition of pleural effusion, also called as hydrothorax. So pleural effusion or hydrothorax is actually going to be the diagnosis of this case beta. And we know pleural effusion or hydrothorax is of two types beta. It is non-inflammatory called as transudative or inflammatory called as Exudative. Rheumatoid arthritis is a cause of exudative pleural effusion. We know rheumatoid arthritis is an inflammatory condition, so it is actually going to cause an exudative pleural effusion. And we know exudative pleural effusion or transudative pleural effusion को differentiate करने के लिए the criteria that we use is called as Light's criteria. Transudative pleural effusion is mainly due to conditions like congestive heart failure or acute kidney injury, whereas exudative pleural effusion is mainly due to conditions like pneumonia, TB or rheumatoid arthritis. Important is beta exudative is inflammatory fluid. So obviously the amount of proteins and enzymes will be more or less? More. So whenever you check the pleural by serum protein ratio, it is less than 0.5 in transudative and more than 0.5 in exudative. If you check the pleural by serum LDH levels, then the ratio is less than 0.6 in transudative and more than 0.6 in exudative beta. Or in exudative pleural effusion, the pleural fluid LDH levels will be more than 2/3 of the serum LDH levels. So from the serum LDH levels, they are going to be more than 2/3 beta. That is a feature of exudative pleural effusion. Now important is, we know these are the conditions. Any condition which is causing low protein levels beta, that is hypoalbuminemia, like cirrhosis or nephrotic syndrome. Most common cause is going to be congestive heart failure, or another cause can be constrictive pericarditis. In patients of exudative pleural effusion, causes can be autoimmune disorders, that is nothing else but rheumatoid arthritis. It could be esophageal rupture, it can be infections, which is pneumonia, that is called as paraneumonic effusion, that is the most common cause. Other causes can be TB beta, or it can be lung cancers or lung malignancies as well, or it can be even acute pancreatitis. तो और मुझे बताओ डेफिनेटली exudative है मतलब inflammatory fluid है बेटा. तो let's see one by one. Which among the following is not seen? They are asking you. So option A says RA factor will be positive in the fluid. Yes, so RA factor will be positive in the fluid because it is a case of rheumatoid arthritis. Cholesterol crystals can be seen in the fluid. Yes, it is an inflammatory fluid, and inflammatory fluid may have cholesterol crystals inside it beta. High glucose, will it be seen in the fluid? No. Low glucose is usually seen beta whenever there is inflammation. याद रखना. High LDH, will it be seen? Yes, the enzyme levels are going to be high. Answer has to be option C. So C is an exception beta. It is not seen in exudative pleural effusion. Exudative में the glucose levels are going to be extremely low. Question number 268 beta, it states a patient is suffering from fever along with chest pain and tachypnea beta. X-ray chest has been given over here. What is the likely finding? Easy. हमें पता है fever, chest pain, tachypnea is a classical feature of pneumonia. And in this patient of pneumonia, we are having a whitish opacity in the lung, and that whitish opacity in the lung is a case of consolidation. So they are asking you that the consolidation is seen in the which lobe of the lung? Very good. Here you are able to see it is in the right lobe beta, the whitish opacity of the consolidation. In which lobe? Right middle lobe beta. Answer has to be option A, that is right middle lobe consolidation will be there. If it would have been over here, then left lower lobe, middle lobe or upper lobe? Left upper lobe beta. If it would have been on this side, then it would have been a left upper lobe because there is no middle lobe on the left side beta. Clear enough? That is what is important to remember. No issues with this? Answer has to be option A to this question. Easy. Question number 269 beta, it states we are having a 60-year-old male patient presented to you with complaints of severe low backache or severe low back pain. Lab shows there is a grossly elevated ESR or erythrocyte sedimentation rate. X-ray skull shows multiple punched out lytic lesions beta. Which is the most important investigation to be done for this case? What are you suspecting? We know that elderly patient complaining of low back ache and punched out lesions in the bone or features like anemia or renal failure, we know has to be a case of multiple myeloma, which is a plasma cell malignancy beta. And if we are suspecting a case of multiple myeloma, we know beta for diagnosis 3 things are necessary in multiple myeloma. What are those? First, bone marrow biopsy is the most important thing beta. Rather, bone marrow biopsy is going to be the investigation of choice. And when we do this investigation of choice of bone marrow biopsy, it should show more than 10% of plasma cells beta. Okay, it should show more than 10% plasma cells. Second, the electrophoresis, matlab serum or the urine electrophoresis should show you more amount of immunoglobulins or gamma globulins, shown known as the spike, M spike beta. ठीक है, तो M spike is going to be seen. And definitely third important, any one of the which features, Kraft features beta. So please remember, any one of the Kraft features should be there. Kraft stands for C for hypercalcemia, R for renal failure, A for anemia, and B for bony lytic lesions. So any one of the Kraft features should be there for a multiple myeloma. Just like you know pheochromocytoma, make sure you know each and everything about multiple myeloma, one of the favorites of your FMG examiners. Clear है बात? तो अब मुझे बताओ, which is the most important investigation बेटा? Is bone marrow biopsy an option? No. So bone marrow biopsy is not an option. Then what is the second best? Option D, that is serum electrophoresis beta. So serum electrophoresis should be done, which should show excess rise of gamma globulins beta, and that is this excess rise in the gamma globulin level is going to be called as the M spike. Samjhe baat? This is important. In the recent examination itself, there has been a question on this. Clear? याद रखना, सीरम बीटा 2 माइक्रोग्लोबुलिन is going to be considered as the best diagnostic or prognostic marker. So please remember, multiple myeloma के लिए best prognostic marker is serum beta 2 microglobulin beta. It is not used for diagnosis basically. It is used for prognosis of the outcome of the patient. ठीक है? PET scan is not done over here. Serum acid phosphatase levels definitely you can check beta, okay, due to bone damage, but again they are not the important investigation. Clear? Next is question number 270 beta. Easy. A 70-year-old man collapsed in his house beta and was rushed to the hospitals. On arrival, his ECG tracing was done beta. Then it has been as shown below. Which among the following is the best intervention to be done for this patient? Very good. What is this case? What is this case? So here definitely if you are not able to feel the pulse beta, you can call it as pulseless electrical activity, and when there is a straight line, that is known as a asystole beta. So it can be either a case of pulseless electrical activity or asystole beta, and we know whether it is pulseless electrical activity or asystole, whatever it was, both of them are shockable or non-shockable rhythms. Both of them are non-shockable rhythms, and if both of them are non-shockable rhythms, can we give a DC shock or can we go for a defibrillation? No beta. Rather than that, we should continue CPR in the patient beta. We should definitely continue CPR in the patient, and we should give which drug? Adrenaline beta. We should continue CPR beta and definitely give IV or IM adrenaline. We should give IV adrenaline or IV epinephrine. Okay, how much dilution? 1:10,000 dilution beta, that has to be given. Hopefully clear. So as it is a non-shockable rhythm beta, we have to definitely continue CPR and give IV adrenaline. Now let's see what is the option that suits. Option A says start CPR. Yes, it will be started. Defibrillate? No. Defibrillation cannot be done because it is a non-shockable rhythm. Option B says IV amiodarone. No, here there is not a tachyarrhythmia. कौन सा IV amiodarone? वो तो और heart rate कम कर देगा. Please remember that. ठीक है? Carotid sinus massage. Is it a case of PSVT or what? So in PSVT it would have been a carotid sinus massage, not in case of asystole. Answer has to be option D, that is IV adrenaline 1 milligram beta. Clear? So that is what is important to remember. Here the best option that will be there will be option D, that is IV adrenaline. Clear? Question 271 beta. It states we are having a young HIV positive patient who developed a sudden onset fever along with headache, and the patient is also having an agitated behavior beta for the last 2 days. So 2 days matlab a chronic onset or an acute onset? Acute onset. The Kernig sign was elicited beta. I hope all of you are quite aware. Kernig sign is a sign of meningitis. That was elicited, and the CSF analysis was done. Okay, and that shows 150 cells are seen beta with a predominance of PMN cells. What is PMN? तो polymorphonuclear cells nothing else but neutrophils. So CSF analysis is showing you neutrophils and a low CSF glucose, because CSF glucose is only 20 milligrams per deciliter. It should be 2/3 of the plasma glucose beta. ठीक है, and proteins are 55 milligram percent, that is elevated because normal proteins are 15 to 45. Clear? Which drug should be started in this case? What is the diagnosis? Very good. So the diagnosis has to be a case of acute bacterial meningitis. Why acute bacterial meningitis? So we know, so acute bacterial meningitis because of neutrophils beta. We know that only one type of meningitis जहाँ पे the neutrophils are going to be found beta, and that is a case of acute bacterial meningitis. In all other meningitis we are always able to see lymphocytes only beta. ठीक है, so that is important to be remembered. So it is a case of acute bacterial meningitis. The most common cause of acute bacterial meningitis will be Streptococcus pneumoniae. The leading cause of acute bacterial meningitis will be a Streptococcus pneumoniae or a pneumococcus beta, that you have to remember. Clear? If they say patient is unimmunized and the patient is having meningitis along with a purpuric rash, then the diagnosis will be very good. Neisseria meningitis. ठीक है, तो meningitis plus a purpuric rash and unvaccinated child, then it is Neisseria meningitis beta. That is important to remember. Clear? So here, as it is a bacterial infection and strep pneumonia is the cause, treatment has to be option B, that is IV ceftriaxone, which is a broad spectrum antibiotic. ATT and dexamethasone like steroid should be given in a tubercular meningitis. Tubercular meningitis will have acute or chronic onset? Chronic onset. It will have neutrophils or lymphocytes? Lymphocytes will be there. Clear about? Next important is acyclovir should be given if it is a case of viral meningitis. Viral meningitis is mainly caused by enteroviruses beta. Enteroviruses are the leading cause of viral meningitis. Viral meningitis may have an acute onset beta, but again the cells found are going to be lymphocytes, and most important, glucose is going to be normal beta. So glucose is actually going to be normal. So normal CSF glucose will be found. ठीक है, liposomal amphotericin B is the drug of choice for fungal meningitis. HIV positive patient है तो fungal meningitis के chances है, but definitely beta here they have given a case of neutrophils. We know that in fungal meningitis the patient is going to have lymphocytes again beta. Again there will be 10 to 20 lymphocytes which are going to be seen. Hopefully Cryptococcus neoformans is the leading cause beta. Question number 272 now. We are having a 25-year-old female who is a known case of hypothyroidism, presents to you with complaints of thyroid swelling beta. Histopathological examination is going to show you the below given finding. Which gene mutation? BRAF gene mutation was present. What is the most appropriate management? अब मुझे तो पहले diagnosis बताओ. Hints. First of all, the patient is a young female between 20 to 40 years of age. Patient is having a history of hypothyroidism. That is suggestive of which thyroiditis? Hashimoto's thyroiditis, which is an important risk factor for papillary beta. Next, patient having the gene mutation, BRAF gene mutation. That is confirmatory almost. And histopathology showing you finger-like projections called as papillae. नाम कहाँ से आया उसका? So please remember, the finger-like projections called as papillae beta, those are going to be seen. These finger-like projections known as papillae are seen on the histopath. Hopefully clear. So it is nothing else but a case of which thyroid cancer? It is a case of papillary thyroid cancer, which is the most common thyroid cancer beta. Now important is papillary thyroid cancer में सरकारी question of FMG exam. शाबाश. So please remember, papillary thyroid cancer में you are able to see the nucleus which are empty basically beta, just like the eyes of a cartoon called as Orphan Annie. So papillary thyroid cancer में there will be a Orphan Annie nuclei appearance beta, along with which bodies? Samoma bodies beta. Orphan Annie nuclei appearance along with Samoma bodies can be seen because it is a papillary cancer. Hopefully clear to all of you now? Sure. And we know when it is a case of papillary thyroid cancer, what should be the treatment that you should do? Chalo. So option A, B, C or D. So the better answer is going to be option B beta, that is a total thyroidectomy along with central neck dissection. Radical neck dissection is only and only done if there is involvement of level 1 to level 5 lymph nodes. Thyroid mein the commonest lymph nodes which are involved are the level 6 lymph nodes beta. So papillary thyroid cancer mein the treatment should be option B, that is total thyroidectomy plus removal of the level 6 lymph nodes called as central neck dissection. Radical neck dissection is not done in all cases, only in few cases. Clear? That is important to be remembered. ठीक है? And radical neck dissection तब होगा जब level 1 to 5 है, उसके पहले 6 involve हो जाएगी. Clear? So that is important. Hemithyroidectomy can be done in a patient of papillary thyroid cancer, conditions being if it is going to be only involving one lobe. Apart from that, patient is very young, less than 40 to 45, size is less than 4 centimeter, and there is no lymphovascular invasion. Only in those conditions. Otherwise, we go for a total thyroidectomy. And radioactive iodine therapy is not done for a case of thyroid cancer beta. Question number 273, if they ask you, we are having a 30-year-old male beta who comes to us with complaints of kidney failure, and we are about to start hemodialysis. He has a background of progressive chronic kidney disease beta along with a bilateral sensory neural hearing loss or bilateral sensory neural deafness, along with hypertension and a family history of kidney failure and deafness beta. Okay, the family history is there positive for this disease. What is the expected eye abnormality in this patient beta? What are you suspecting? Very good. Patient is having kidney failure along with a bilateral sensory neural hearing loss. I hope can't pee and can't hear, so is there. Can't see, they are asking you. So it is a classical diagnosis of which syndrome? Alport syndrome beta. So kidney failure along with hearing loss beta, it is only seen in patients of Alport syndrome. Alport syndrome occurs basically due to mutation in alpha 5 chain of collagen type 4 beta. So alpha 5 chain of collagen type 4 mein beta, there is a mutation which is seen in this condition. And the patient will have a classical triad of can't see, can't pee, can't hear. Kidney biopsy shows you a very classical appearance called as basket view appearance beta. So kidney biopsy which is there beta on electron microscopy, it shows you a classical basket view appearance. And important is in patients of Alport syndrome, the pattern of inheritance that we follow is X-linked dominant beta. So X-linked dominant is the pattern of inheritance followed by Alport syndrome. Hopefully clear. So here the eye abnormality that is seen beta is going to be nothing else but option D, that is anterior lenticonus. So anterior lenticonus is the reason for can't see, and glomerulonephritis or kidney disease is the reason for can't pee, and sensory neural hearing loss is the reason for can't hear. Clear? And family history will be positive. Bolo. So please remember, usually मैंने क्या बोला है कि in cases of Alport syndrome, yes, most commonly it is X-linked dominant, ठीक है? So yes, more commonly it will be seen in females, but it also follows all other patterns of inheritance. It also follows AR, it also follows AD, it also follows XLR. That is the reason. Clear? That is important to be remembered. Anterior uveitis, उसमें तो the patient will have a painful loss of vision along with keratic precipitates. Clear? Ectopia lentis में the history should have been of Marfan's syndrome. Tall stature, arachnodactyly, arm span is greater than the height. All these features होते तो Marfan syndrome बोला होता हमने. And then ectopia lentis would have been a feature. Pulsatile proptosis is a feature of cavernous sinus thrombosis. So cavernous sinus thrombosis होता, so then I would have said it is pulsatile proptosis. Hopefully clear. Question 274 beta, it states, we are having a 60-year-old female beta who presents to us with complaints of left-sided weakness for more than 1 hour beta, and the patient is also having right-sided facial weakness. BP of the patient is 160 by 100 millimeters of mercury, and CT head of the patient appears to be normal. CT head of the patient appears to be normal beta. What shall be the next best step in management of the patient? So we know beta, she is a elderly female coming to us with left-sided weakness beta along with right-sided facial weakness. ठीक है? CT of the patient appears to be absolutely normal. When CT of the head appears to be normal in a patient of weakness, it is more likely a case of TIA or stroke. It is a classical case of nothing else but TIA beta. What is TIA? Transient ischemic attack beta. So it is more likely to be a case of TIA or a transient ischemic attack because the CT head is appearing to be normal. If it was stroke beta, CT head should have shown you an infarct or should have shown you a blackish appearance, that is hypodensity beta. Clear? So option A says start thrombolysis. Will we do a thrombolysis in a case of transient ischemic attack? No. Next, option B says give aspirin and clopidogrel. Yes, that can be done beta. Aspirin and clopidogrel, that can be given. It is a dual antiplatelet therapy. That is a treatment for transient ischemic attack itself beta. Next, only manage the BP and monitor the patient. Please remember beta, if I want to manage the BP, yes, I can manage the BP beta. But please remember, unless and until you are not going to give an antiplatelet therapy, the thrombus is not going to be relieved. Clear about? So that is what is important. And the thrombus may increase further and the patient of TIA may go into stroke. Clear? So that is important. No intervention is required. No beta, obviously intervention will be done over here, and that is nothing else but option B. If option B was not there, I would have gone for still option C as a probable answer, but as option B is there, which is a dual antiplatelet therapy, which is a treatment for a transient ischemic attack. Clear about? Next important, if I talk about question number 275 beta. Here you are able to see that we are having a 10-year-old child beta who has been diagnosed with acute rheumatic fever. What will be the earliest valvular lesion found in this patient? Easy. तो हमें पता है in a child, okay, or in a case of acute or active rheumatic fever, the earliest and the most common valvular lesion is always mitral regurgitation. Answer has to be option A beta. ठीक है, mitral regurgitation. याद रखना, mitral valve is the most common valve affected in infective endocarditis as well as rheumatic heart disease beta. Important is, अगर वो बोलते हैं that the patient is having an active rheumatic heart disease or the patient is a child beta, the answer has to be mitral regurgitation. But whenever they say most common valvular lesion overall, most common valvular lesion in a adult patient or most common valvular lesion in a chronic rheumatic heart disease, then my answer will be mitral stenosis. So most common overall पूछा होता and the patient would have been an adult, I would have marked it as mitral stenosis beta. Clear? Hopefully clear to all of you beta. That is important. Yes, dual antiplatelet therapy is given in both MI as well as in patients of transient ischemic attack beta. Clear? Next is question number 276. They are asking you which among the following leads to a prominent X descent and a prominent Y descent beta in the jugular venous pressure. Very good. हमें पता है बेटा prominent X descent as well as a prominent Y descent अगर दोनों हैं तो it has to be a case of nothing else but option D, constrictive pericarditis, when there is a calcification of the pericardium around the heart. Important. Cardiac tamponade में क्या दिखता है? So we know beta cardiac tamponade में I am able to see a steep X descent along with the absent Y beta. So steep X and absent Y होता, then my diagnosis would have been cardiac tamponade beta. Clear है बात? Tricuspid regurgitation में क्या दिखेगा? Tricuspid regurgitation में there can be a cannon A wave or a giant A wave beta. So cannon or a giant A wave which is there, it is actually going to be a feature of tricuspid regurgitation. And अगर complete heart block होता तो क्या दिखता? Again the same, that is cannon A wave or giant A wave beta. Reason is in complete heart block there is a AV dissociation, and any case of AV dissociation will always cause a cannon or a giant A wave beta. I hope all of you are quite aware basically that JVP or jugular venous pressure में there are various types of waveforms. The first one which is there beta, it is the A wave which happens due to atrial contraction beta. Then we have the C wave which basically happens due to a atrial valve closure, tricuspid valve closure beta. So please remember beta, whenever there is a tricuspid and the mitral valve closure, that is going to cause the C wave beta. Okay? That is actually due to the bulging of the tricuspid valve into the right atria. Next is the X descent beta. X descent happens due to ejection basically. So whenever there is an ejection from the heart, matlab whenever the valves are going to open up and the blood will be thrown out of the heart beta, that ejection is actually going to cause the X descent. Next, V wave is due to the atrial filling by the vena cava. So whenever the vena cava are going to fill up the atria beta, there will be a positive wave called as the V wave. And last is Y wave is due to atrial emptying beta. Okay, the Y wave happens due to the atrial emptying. Apart from that, absent A wave, repeated question of FMG and PG exam. Very good. So yaad rakhna beta, absent A wave if they ask you, then it is a classical case of nothing else but atrial fibrillation. Atrial fibrillation में the rhythm is irregularly irregular. So irregularly irregular rhythm or irregularly irregular pulse of atrial fibrillation. In this condition, as the atria doesn't contract, the airway is completely absent. Question number 277, easy. So a 42-year-old patient beta is going to have immunodeficiency and complaints of dysphagia or difficulty in swallowing beta. His upper GI endoscopy was done, which reveals multiple ulcers beta inside the distal esophagus beta. There were multiple ulcers in the distal esophagus. The biopsy picture is shown over here beta. What is the likely diagnosis? The biopsy picture is showing you a classical which appearance? Aula cells or inclusion bodies? So please remember beta, I am able to see aula inclusions or the aula inclusion bodies beta, and whenever aula inclusion bodies are seen, it is a classical case of cytomegalovirus infection, and we know CMV is actually known to cause esophagitis, and when cytomegalovirus causes esophagitis in the immunodeficient patient will have multiple ulcers beta. So herpes also causes esophagitis, CMV also causes esophagitis, and Candida also causes esophagitis. Clear about? ये तीनों infections are known to cause esophagitis beta. So herpes simplex virus, when it causes esophagitis beta, obviously the aula inclusion bodies are not seen over there, and herpes में which kind of ulcers will be seen? यहाँ पे थोड़ी आई में herpes में dendritic दिखता है. Esophagus में volcanic ulcers are going to be seen beta. Volcanic ulcers or volcanic eruptions are going to be seen. ठीक है, Candida albicans या candidal infection was the cause of esophagitis, then there would have been a whitish curdy patch inside the esophagus beta. Clear? So that is important. Who shows with this drug of choice for? Please remember in patients फोटो तो उन लोगों को देना पड़ेगा बेसिकली, या फिर उनको एटलीस्ट मेंशन करना पड़ेगा टाइप ऑफ अल्सर. So in CMV definitely the ulcers which are there, they are seen in distal esophagus. Herpes may it can be seen in the body of the esophagus, but still most likely in your examination they will give you the photo or at least some kind of history. That is important. Transplant वगैरह कोई भी history दे देंगे, one type of history they will give. Now important is aula inclusion are seen in CMV, and CMV का drug of choice is another PYQ of FMG exam beta, that is nothing else but ganciclovir. So ganciclovir is actually going to be the drug of choice in patients of CMV or cytomegalovirus. Acyclovir is the drug of choice for herpes simplex virus beta, volcanic ulcers. Question number 278. A patient has been given an IV anesthetic agent beta, but in the post-operative period, the patient experiences features of Addisonian crisis beta. They are asking you which among the following agent would be responsible for causing this problem. Addisonian crisis होता क्या है? Addisonian crisis is going to be deficiency or increase in the adrenal hormones. So whenever there is sudden decrease in the adrenal hormones beta, sudden decrease in adrenal hormones is basically called as Addisonian crisis. Which is the IV anesthetic agent known to suppress the adrenal gland? Etomidate. Straightforward one-liner question, answer has to be option D, that is etomidate beta. So we know that etomidate is actually known to cause adrenal suppression, and as it is known to cause adrenal suppression, it will decrease the production of adrenal hormones beta, causing a Addisonian crisis. Hopefully clear. So aldosterone and cortisol levels are going to suddenly decrease beta. Ketamine which is there beta, important points now. Ketamine which is there, it is known to increase all the pressures in the body beta. यहाँ पे लिख लेता हूँ. Ketamine के बारे में important points that you have to keep in mind, and that is it is known to increase all the pressures in the body. That is, it increases the blood pressure, so contraindicated in hypertensive. It increases the intracranial pressure, so contraindicated in head injury patients. It increases intraocular pressure, so contraindicated in glaucoma. But it causes bronchodilation and therefore used in patients of asthma beta. Next important, it is known to cause which type of anesthesia? PYQ. Which kind of anesthesia is caused by ketamine? Dissociative anesthesia. This is the keyword of ketamine. याद रखना. Dissociative anesthesia is basically caused by ketamine beta. And ketamine is used for adults or kids? Kids. So ketamine for kids beta, that is what is important to be remembered. Clear? So that is important. If they ask you thiopentone or sodium thiopentone is used for narco analysis beta, that is true detector test basically. ठीक है, तो lie detector test में As a truth serum, we can use thiopentone. Apart from that, it is used for which surgeries? Neurosurgeries, but absolutely contraindicated in patients of important porphyria. Yes, it is cardiovascular unstable also, but it is mainly contraindicated in patients of porphyria. ये याद रखना. तो acute intermittent porphyrias में thiopentone will be contraindicated beta. Next is, what is the daycare surgery choice? So please remember, the agent of daycare surgery is nothing else but propofol beta. ठीक है, daycare surgery में propofol is used. Important is, what is the most common side effect? Nahi, and that is the only thing I wanted. So please remember, propofol is the only agent beta which is anti-emetic. All other anesthetic agents can cause nausea and vomiting except propofol. Propofol का यही अच्छा बात है that it doesn't cause vomiting, rather it is anti-emetic beta. The most common side effect is pain at the injection site. Pain at the injection site basically beta is going to be a side effect of propofol. Hopefully clear. So these are the important points that you need to remember about the IV anesthetic agents. समझे बात? तो अगर किसी को माइनर सब्जेक्ट्स टच करना है, क्या टच करना होता है? टेबल ऑफ IV anesthetic agent, टेबल ऑफ इनहेलेशनल anesthetic agents, एक बार द important one liners of local anesthetics and one difference about spinal and epidural. That's it. That is what is important. ओके, बाकी चीजें तुम्हें आती है यूजुअली, होपफुली, ठीक है? तो पिन इंडेक्स रखते बैठोगे, पाइपलाइन रखते बैठोगे, ठीक है? बाकी 10 चीजें रखते बैठोगे, ठीक है? सो इफ यू वांट, यू कैन डेफिनेटली, इफ यू आर नॉट अवेयर ऑफ मलनपट्टी स्कोरिंग, इफ यू आर नॉट अवेयर अबाउट द पिन इंडेक्स, यू आर नॉट अवेयर अबाउट द कलर ऑफ द सिलेंडर्स, देन यू कैन डू दैट, ठीक है? बट अदरवाइज दीज आर द इंपॉर्टेंट पॉइंट्स दैट यू हैव टू टच इन एनेस्थीसिया. Question number 279. We are having a 40-year-old woman beta who presents to you with a 2-year-old history of papillopustular lesions on the convexities of the face. Convexities of the face, like it is the nose and the cheeks of the patient beta. In the background of erythema, that is redness and telangiectasia. So there is redness and dilatation of the blood vessels beta, erythema and telangiectasia is seen. Okay, what is the most likely diagnosis of the case? We know beta, it is a classical diagnosis of option C, rosacea beta. So it is a classical diagnosis of rosacea. We know rosacea में there are 3 types beta. One is the telangiectatic type, that is where the patient will have only redness and telangiectasia beta. Second is the papillopustular variety, and the third one is phimosis variety. Phimosis variety, rhinophyma. So rhinophyma is a type of acne rosacea itself. Clear है बात? That is important. Acne vulgaris होता बेटा, तो acne vulgaris में patient is actually going to have comedones बेटा, ठीक है, in grade 1, or the patient may have papules in grade 2, patient may have pustules in grade 3 बेटा, ठीक है, but they are not associated with erythema and telangiectasia. There will be papules and pustules but not associated with erythema and telangiectasia beta. And last one is going to be nodulocystic. The grade 4 is nodulocystic. What is the drug of choice for nodulocystic acne? PYQ. Very good. The drug of choice for nodulocystic acne or a grade 4 acne is a vitamin E analog called as isotretinoin. Can be given in pregnancy or what? No. Isotretinoin is highly teratogenic, therefore avoided in pregnancy beta. What is the causative organism for acne vulgaris? Propionibacterium acne. Another PYQ, Propionibacterium acne is the causative agent of acne vulgaris beta. SLE hota, so definitely there is only a malar rash. So there is a malar or a butterfly rash which is photosensitive in nature. Apart from that, no papules, no pustules, no telangiectasia. Only erythema or redness would have been seen. Clear? Polymorphic light eruption definitely beta. Again, it is usually photosensitive in nature after the patient only goes out in sun. Okay. Next important, if there is a blackish pigmentation of the nose and the cheeks, that is called as melasma beta, also called as cloasma. So melasma or cloasma, it is usually seen in, so cloasma is basically a melasma of pregnancy beta. So cloasma is nothing else but the melasma of pregnancy that we know. Okay? So melasma or pelasma is nothing else but a hyperpigmented macule on the face. So whenever there is a hyperpigmented lesion beta on the convexities of the face, that is called as melasma or cloasma. Question number 280, easy. A female patient beta presents to you with a diffuse alopecia or a diffuse hair loss, that is hair loss from throughout the head beta over the last few days. She had suffered from typhoid fever 3 months ago. So history of illness 3 months ago basically. ठीक है, for which she was also admitted to the hospital. Beta, what is the most probable diagnosis? We know whenever there is a history of any illness, beta, and after 3 months the patient starts having hair loss, it is a classical case of option C, telogen effluvium, beta. Anagen effluvium, what will be the history? Very good. So in patients of anagen effluvium, beta, the patient will have history of chemo or a radiotherapy. So after chemo or radiotherapy, if the patient is having hair loss or alopecia, that is called as anagen effluvium, beta. Androgenetic alopecia, which is there, here there will be only a history of family. So family history हो सकती है androgenetic alopecia में, otherwise there is no history that is present in androgenetic alopecia. And we know beta, it is basically a classical pattern. In females there will be thinning of the central scalp, beta, called as Ludwig's pattern, beta. And in males definitely there can be frontotemporal recession or the vertex balding, beta. So balding of the vertex or the frontotemporal recession is going to be seen in males. That is called as the also now the Hamilton pattern, beta. Also now the Hamilton pattern can be seen. That is important to be remembered. Clear? So as you can see, frontotemporal recession and the balding of vertex in male pattern androgenetic alopecia or male pattern hair loss. Female pattern hair loss or female pattern androgenetic alopecia mein there is a central thinning of the hairs, basically. Central scalp mein thinning hota hai. This is called as the Ludwig's pattern, beta, and this is known as the also now the Hamilton pattern, beta, of hair loss. Clear? What is the drug of choice for both this androgenetic alopecia? Minoxidil, beta. So minoxidil is actually considered as the drug of choice. Minoxidil is a potassium channel blocker, beta, and it is actually considered as the drug of choice for both the types of androgenetic alopecia, but 5% in males and 2% in females. Clear, beta? What is this? A classical picture where there is a patchy hair loss, and within the patch you are not able to see any hair, beta. Along with that there is graying of hair which is seen. Alopecia areata. So whenever there is a gray hairs, beta, and the patient is having a patchy hair loss, it is a classical case of nothing else but alopecia areata, which is an autoimmune disorder, beta. Important is alopecia areata mein, if I take the follicular biopsy, what will be seen? Yes, exclamation mark is seen due to the broken down hairs. But follicular biopsy अगर करूँगा तो क्या दिखेगा? Around the follicle, swarm of bee. Swarm of bee. Follicle के आसपास there are a lot of lymphocytes. Yeah. So there will be an exclamation mark which is going to be seen, beta. Exclamation mark sign in the broken hairs, and there will be a classical swarm of bee appearance. That is a feature of nothing else but alopecia areata. If there is a patchy hair loss, beta, in a young female, but there are hairs seen within the patch, beta, then it is a case of trichotillomania. Patchy hair loss with hair inside the patch, beta, it is a case of nothing else but trichotillomania. Question number 281, beta. It states we are having a middle-aged person, beta, who comes to us with complaints of excessive worries about all the domains of life. हर चीज के बारे में चिंता है इसको, बेटा. ठीक है, तो excessive worries about all domains of life. He is always restless, beta, and has muscle tension and a feeling definitely that his parents are going to die one day, beta. The patient will have a constant feeling that somebody is going to die one day, and he will have sleepless night due to that. Which among the following disorder describes this condition? So we know, beta, if the person will have tension or worries in all the domains of life, उठे बैठे खाए पिए सोए हर चीज में टेंशन है इसको, ठीक है, and always restless, it has to be a case of option A, that is a generalized anxiety disorder. Patient is always anxious in everything he does, that is generalized anxiety disorder. याद रखना, the keyword of this question is always going to be which kind of anxiety? Free floating anxiety, beta. That is important to remember. Have they given any history of trauma? No. So if they have not given any history of trauma, it cannot be a case of PTSD. हमें पता है post traumatic stress disorder और PTSD में there should be history of a major or minor trauma. Major trauma, beta. Major trauma, like there can be an accident, there can be death of a loved one, beta. That kind of major trauma should be there. If it is just changing a job basically, beta, or changing a place, then it can't be a PTSD, then it will be an adjustment disorder. Clear about that is important. So major trauma should be there, and after that the patient should definitely get anxiety. or stress. That is a classical feature of PTSD. Hopefully clear. Next, severe depression में बेटा obviously severe depression में patient is actually going to have a depressed mood or a sad mood along with anhedonia. At least one of that feature should be there. Along with that, there can be other features also: sleep disturbances, appetite disturbances, suicidal thoughts or suicidal tendencies. Nothing such as seen. Adjustment disorder, I have told you beta, there is only a minor stress like patient losing the job, patient shifting the job, changing to a new place, this kind of stress. Uske baad patient having anxiety or stress beta. That is a classical case of nothing else but adjustment disorder. What is the drug of choice for all the anxiety disorders के लिए बेटा? All anxiety disorders के लिए, we know anxiety disorders are the most common group of disorders beta worldwide. The most common psychiatric group of disorders worldwide is the anxiety disorder. What is the drug of choice? So short term we can give benzodiazepines and long terms we have to give SSRIs. Please remember, benzodiazepines cannot be given on a longer term. Reason? They will develop tolerance beta. As there will be definitely tolerance बच्चे of benzodiazepines. इसीलिए benzodiazepines should not be given on longer term. Question number 282. A patient had a long-standing history of recurrent peptic ulcers beta, so he was operated. But after the surgery, after the surgery has been done, the patient started complaining of symptoms like bloating, nausea, vomiting and diarrhea within 15 minutes of food intake. As soon as the person takes food beta, within 15 minutes of food intake, patient has all these features like bloating, nausea, vomiting and diarrhea beta. Okay, what will be your next step in this patient? What is the diagnosis? So we know beta, after the peptic ulcer surgery, what is the surgeries that we do for peptic ulcer? Either we can go for the Billroth surgeries beta, okay, or we can go for the vagotomy surgeries, and we can also go for a Roux-en-Y. But here it is more likely to be a Billroth surgery beta, after which the patient is having these symptoms within 15 minutes of food intake, and that is nothing else but a complication known as early dumping syndrome. So within 10 to 15 minutes of food intake, if the patient has complaints like epigastric fullness, nausea, vomiting, diarrhea, has to be a case of early dumping syndrome. Late dumping में क्या होता है? After 45 minutes to 1 hour, patient has symptoms of hypoglycemia. So after 45 minutes to 1 hour, if there are symptoms of hypoglycemia like dizziness, tachycardia, palpitation, tremors, then that is a diagnosis of late dumping syndrome beta. Early dumping syndrome में what should be your advice? Answer has to be option D, advised dietary modification. Early dumping syndrome avoid करने के लिए what you are going to recommend to the patient? Yes, so you are going to recommend the patient to take small and frequent meals beta, because if the patient is going to dump a large amount of food, obviously the patient will have these symptoms. So patient should take small frequent meals. Second, patient should avoid which kind of food? Hyperosmolar food or highly concentrated food like sugar rich food. ठीक है, तो hyperosmolar food should be avoided beta in the patient. Clear? That is what is important to be remembered. Clear? So this kind of food. So advised dietary modification if the patient is having early dumping. अगर इससे काम नहीं चलता, then we can give IV octreotide beta. And if octreotide also doesn't help, then we can convert the Billroth surgery to a Roux-en-Y surgery. ठीक है, PPI is for recurrence. Is it a case of recurrence? No. If it was a case of recurrence beta, patient would not have symptoms like bloating, nausea, vomiting and diarrhea. Patient will have complaint of epigastric pain. Clear? Reassurance as these problems are self-limiting. Please remember, early dumping will be self-limiting if dietary modifications are done. ठीक है, patient ज़्यादा खाता रहेगा और definitely symptoms नहीं होंगे, ऐसा नहीं होता है. ठीक है, so that is important. With time they are not going to subside. Patient has to do some dietary modifications beta, that has to be kept in mind. Important is one clarification from my side. Most common complication in peptic ulcer disease, answer is bleeding. Most common complication in duodenal ulcers is bleeding. Most common complication in gastric ulcers is bleeding again. Clear na? It is bleeding again, not perforation. Yes, perforation is more common in gastric ulcer, but doesn't mean that perforation is the most common complication of gastric ulcer. That is the point that I had to clarify. Clear about? So do remember this. Question number 283. Here we are having a 44-year-old alcoholic man beta who has presented to us with complaints like hematemesis, that is upper GI bleeding, along with abdominal distension and asterixis. What is asterixis? Flapping tremors. Flapping tremors are suggestive of metabolic encephalopathy. Matlab, due to some metabolic disturbances, if there is a brain damage, in those conditions we are able to find asterixis beta. On examination, ascites was suspected. Obviously, patient who is an alcoholic having hematemesis and abdominal distension, you are going to suspect ascites beta. And as ascites was suspected, shifting dullness sign was appreciated beta. So please tell me beta at how much fluid level? Okay. What is the level of fluid beyond which shifting dullness is positive? Very good. So we know that shifting dullness sign will be positive when the amount of ascitic fluid in the abdomen will be more than 500 ml beta. Next, puddle sign is positive when the amount of fluid in the abdomen is more than 100 ml. So puddle sign is positive beta whenever the amount of fluid in the peritoneal cavity is more than 100 ml. And what is this sign over here, August? Whenever you definitely, whenever you are going to beta flicker from one side and you are going to feel the waves on the other, it is classically called as the fluid thrill sign. And fluid thrill is positive whenever the amount of fluid inside the abdominal cavity is going to be more than 1000 ml beta. Whenever more than 1000 ml of ascitic fluid is there, we know that the fluid thrill sign is going to be positive. And what is the treatment of massive ascites? We know fluid thrill sign जब भी positive होगा मतलब the patient is having a massive ascites, and massive ascites का treatment will be क्या करोगे? Will you do paracentesis, ascitic tapping? Yes, but as we have to do a large volume paracentesis, before procedure give IV salt-free albumin, IV salt-free albumin, and then I will go for definitely a large volume paracentesis. If I don't give albumin beta, the patient will have leakage and the patient will land up into hypovolemic shock. So इसीलिए बेटा, whenever I have to remove more amount of ascitic fluid beta, I should always give IV salt-free albumin first, and then only I should go for a ascitic tapping or a paracentesis for the large volume beta. Hopefully that's clear to all of you. So that is what is important. Why there was hematemesis in this patient? Ascites develop in which patients? Ascites develops in patients suffering from liver cirrhosis. What is the commonest cause of cirrhosis? ALD. हमें पता है ALD, that is alcoholic liver disease, is considered as the most common cause of cirrhosis beta. So we know the patient of cirrhosis who is there, he is going to develop a complication known as portal hypertension, and due to portal hypertension this patient is going to develop esophageal, and due to esophageal varices the patient is having this hematemesis, and as the liver is damaged, therefore there is also brain damage beta causing metabolic encephalopathy leading to asterixis. Hopefully clear. Question number 284, we are having beta an elderly female who is a known case of COPD or chronic obstructive pulmonary disease presented to the casualty beta with complaints of severe breathlessness, and the SpO2 of the female is only 58% on oxygen beta, only 58% on oxygen. She was intubated beta, and ABG analysis was performed which reveals pH of the female is 7.2. PaO2 is only 40 millimeters of mercury, that is low. PCO2 is 75 millimeters of mercury. Bicarbonates are 32 milliequivalents per liter. Which among the following setting shall be done beta in the ventilator, they are asking. पहले तो मुझे बताओ, definitely it is a type of which metabolic or acid base disorder. So pH is 7.2, where normal pH is 7.35 to 7.45. Whenever pH is less than 7.35, it is a case of acidosis. Now let's see beta the CO2 and bicarbonate value. CO2 value is low or high? High beta over here. CO2 value is normally 35 to 45 millimeters of mercury. Here it is 75. Whenever CO2 levels are high, that will cause acidosis or alkalosis. Because CO2 is acidic in nature, so whenever it will increase, that will cause acidosis. And CO2 causing acidosis is respiratory or metabolic? So it is a case of respiratory acidosis beta. Now bicarbonate values अगर देखो मैं, तो bicarbonate values are normally 22 to 26 milliequivalents per liter. Here bicarbonate values are 32. So they are high. And when bicarbonate values are high, that is metabolic acidosis or alkalosis? That is a metabolic alkalosis. Why is there metabolic alkalosis? For the purpose of compensation. As the patient is suffering from respiratory acidosis beta, so to compensate we should cause a metabolic alkalosis to bring back the pH to normal. Okay, is it partially or totally compensated? Why only partially? Because the pH is still in the abnormal range beta. So as the pH is still abnormal, it has to be a case of partially compensated. If the pH will return back to the normal range, I will call it as fully compensated case beta. Hopefully clear to all of you now. So if they ask you respiratory acidosis, it is which type of respiratory failure? Type 1 or type 2? Respiratory acidosis is seen in. Respiratory acidosis is seen in due to high amount of CO2. मुझे बताओ in which cases of respiratory failure there is high CO2? Type 2 beta. So type 2 respiratory failure में what is the problem? Patient will have a decreased respiratory rate or hypoventilation. Due to that, all the CO2 is collected in the body, it is not thrown out. And when a lot of CO2 collects in the body, the patient will develop respiratory acidosis. Type 1 में क्या होता है? Type 1 respiratory failure में the patient has an increased respiratory rate. And as the patient will have increased respiratory rate, all the CO2 gets thrown out of the body, causing low CO2 levels. And if there will be low CO2, that will cause respiratory acidosis or alkalosis. So type 1 hota, so there would have been a respiratory alkalosis beta. That is important to remember. So it is a type 2 respiratory failure because it is acidosis. So what should be the treatment? We know that CO2 is collecting in the body because the respiratory rate is low. So treatment has to be increase the respiratory rate beta. That is what is the treatment of type 2 respiratory failure. This was a PYQ and FMG examination, though rare. But these kind of questions have come earlier. याद रखना, decrease in PEEP is not done beta, rather we have to increase the PEEP बच्चे. ठीक है, we don't decrease the PEEP, rather we have to increase the PEEP. And we have to increase the FiO2 also. But both of that is done for which type of respiratory failure? Type 1. So type 1 respiratory failure में there is less oxygen delivery beta. And therefore we have to increase the oxygen delivery. Therefore I increase the FiO2 or I increase the positive and expiratory pressure called as PEEP. Clear? So that is what is important. Question number 285 beta. It states we are having a boy who is aged 12 years beta and presented to your clinic with a several year history of chronically productive cough and associated with shortness of breath and wheezing as well. He had been screened for tuberculosis with a negative Montauk's test beta. So it is not a case of TB. Patient has a history of cough beta, which developed soon after birth. So cough developed soon after birth beta and has suffered from meconium ileus also. Okay, at birth. What shall be the best step for diagnosis? What are you suspecting? What you are suspecting is a case of cystic fibrosis. Why? A small child having meconium ileus, definitely having beta a chronically productive cough. That is more likely to be a case of cystic fibrosis. Because in cystic fibrosis, as the chloride channels are defective beta, all the secretions of the body are thick or thin? Extremely thick beta, and as these secretions are thick, they are not able to clear off completely, and as they are not able to clear off completely beta, that's the reason why the child will have recurrent infections. There will be recurrent lung infections causing bronchiectasis. Okay, the patient will have recurrent sinusitis. The patient may definitely have pancreatic insufficiency because pancreatic enzymes cannot drain. There will be decreased drainage of bile as well beta in the patient, and there can be a hard stool causing meconium ileus. All these features are a feature of cystic fibrosis. Cystic fibrosis is due to which mutation? We know it is due to a CFTR gene mutation on chromosome number 7. So CFTR gene mutation on chromosome 7, pattern of inheritance, recent need. Autosomal recessive. So cystic fibrosis follows autosomal recessive pattern of inheritance. So what should be done? The best investigation for diagnosis. Answer has to be option D, that is nothing else but beta, the DNA sequencing for the CFTR gene. What better than seeing the gene mutation directly? Barabar? So DNA sequencing for CFTR gene will be the best investigation. If option D was not there, then my second best answer had to be sweat chloride concentration beta more than 60 milliequivalents. So whenever the sweat chloride concentration is more than 60 milliequivalents, then my second best answer had to be sweat chloride concentration. But as here there was DNA sequencing, I will go for DNA sequencing as the best beta. Upper GI endoscopy and biopsy doesn't make any sense over here. Fecal elastase levels again can be done, but not the best. Clear? नेक्स्ट अगर होता तो स्वेट क्लोराइड कॉन्सेंट्रेशन आई वुड हैव चेक्ड, ठीक है. इन द स्वेट क्लोराइड द कॉन्सेंट्रेशन इन द स्वेट द कॉन्सेंट्रेशन ऑफ सोडियम क्लोराइड इज वेरी वेरी हाई एंड देयरफॉर द स्वेट ऑफ द बेबी टेस्ट्स salty. So salty sweat of the baby. Next is a case beta, a patient presents to you with complaints like fever. Along with that, the patient is having a severe calf pain. On examination, there is a conjunctival suffusion or conjunctival redness which is seen. Along with petechial eruptions beta, petechia are seen on the skin and thrombocytopenia. Per abdominal examination reveals a tender hepatomegaly beta and the patient is also having icterus. KFT of the female, KFT of the patient, that is kidney function test, is absolutely normal beta. And urine microscopic examination which is there, it is showing hematuria. What is the likely diagnosis of the patient? So please remember beta, whenever the patient is having fever along with calf pain beta, along with conjunctival suffusion, petechial eruption, thrombocytopenia, ठीक है? See all of these along with icterus beta. ठीक है, और हेपाटोमीगली बेटा इट कैनॉट बी डेंगी बिकॉज डेंगी में हेपाटोमीगली एंड इक्ट्रस और जॉन्डिस इज नॉट सीन, ठीक है. सो आंसर हैज टू बी लेप्टोस्पायरोसिस. तो लेप्टोस्पायरोसिस कैन कॉज थ्रोम्बोसाइटोपेनिया, इट कैन. तो प्लीज रिमेंबर बेटा, इंपॉर्टेंट इज इन पेशेंट्स ऑफ, वही बात है ना कि पेशेंट दे हैव नॉट सेड द पेशेंट हैज बीन अंडर ट्रीटमेंट टिल नाउ, ठीक है. सो दैट इज व्हाट इज इंपॉर्टेंट टू रिमेंबर. तो इसीलिए प्लीज रिमेंबर द बेटर डायग्नोसिस विल बी ऑप्शन ए, दैट इज लेप्टोस्पायरोसिस. वी नो लेप्टोस्पायरोसिस हैपेंस when we come in contact with the infected rat urine. So whenever there is a contact with infected rat urine beta, then the patient will have leptospirosis, and therefore for infected rat urine they can give you a history of floods or paddy fields. Yes, rice fields beta, paddy fields का history देंगे. They will say a farmer working in the paddy field, or they will say a person who was stuck in the floods beta. So because he has come in contact with the infected rat urine, patient will have features like dengue beta, that is fever, myalgia, arthralgia. Along with that, petechia, thrombocytopenia is seen, along with liver involvement. So liver involvement is an important feature beta in patients of leptospirosis beta. That is what is important. Dengue में it is not seen in the early stages. It can only be seen when the multiple organ dysfunction starts. तो अगर organ dysfunction start हुआ है तो definitely liver, kidney, all of that starts getting damaged in dengue. ठीक है. Until and unless that is not seen, we are not able to see hepatomegaly or jaundice, a common feature in dengue beta. Hepatic encephalopathy, no, because hepatic encephalopathy होता तो liver damage की वजह से brain damage start होता है बेटा. brain damage का कोई भी symptom नहीं है इस condition में, ठीक है. चिकनगुनिया fever with joint pain is the most classical feature, along with a hyperpigmented lesion on the nose, ठीक है. dark lesion on the nose is a feature. Question number 287. If they ask you beta, 68-year-old male patient beta comes to you or presents to you with complaints like fever, weight loss and malaise beta. On examination, lumps are actually palpable in the neck, and the lab workup reveals there is an elevated TLC count or a total leukocyte count with predominantly lymphocytes beta. Lymphocytosis is there. Peripheral blood smear has been given below. What is the most appropriate diagnostic modality for the patient? So first of all, patient is elderly, having symptoms like fever, weight loss, malaise beta, and patient is having lumps in the neck, that is nothing else but cervical lymphadenopathy. The patient is having elevated TLC count. So TLC count में mainly it is lymphocytes which are high beta. So could it be a case of lymphocytic leukemia? Yes. So it is a case of chronic lymphocytic leukemia, that is nothing else but CLL. Elderly patient having lymphocytosis, recurrent infections, features of anemia like fatigue and pallor, ठीक है, along with cervical lymphadenopathy and category B symptoms. All of these features are more likely suggestive of CLL or chronic lymphocytic leukemia. Confirm कैसे होगा diagnosis? क्या दिख रहा है? क्या दिख रहा है ये peripheral blood smear पे? Smudge cells. The B lymphocytes which are present beta, these malignant B lymphocytes are immune incompetent. So whenever you try to make a smear, these lymphocytes will get ruptured beta, causing a classical smudge cells over here beta. There will be classical smudge cells which are going to be seen. That is important to be remembered. So smudge cells, also called as parachute cells or basket cells, are seen. And when we know that smudge cells are seen beta on the peripheral smear, it is a classical case of nothing else but chronic lymphocytic leukemia. To confirm the diagnosis further, I have to go for an investigation, and that is option C, that is flow cytometry. cytometry beta. The flow cytometry has to be the investigation of choice. FISH and PCR would have been done if it was a diagnosis of CML, that is chronic myeloid leukemia beta. Bone marrow biopsy would have been done if it was a case of acute leukemias beta, like ALL or AML. दोनों में, in both the acute leukemias, the investigation of choice is a bone marrow biopsy beta. ठीक है? Lymph node biopsy is done whenever it is a case of lymphoma. Any kind of lymphoma beta, doesn't matter whether it is a Hodgkin's, non-Hodgkin's, any kind of lymphoma, I would have gone for a lymph node biopsy. समझे बात? यहाँ पे what is this appearance classically called as? Very good. Very, very different types of cells are seen. Neutrophils, basophils, eosinophils, monocytes, okay, RBCs, a lot of them is seen, and that is nothing else but a case of college girl appearance, also called as garden party appearance beta. And whenever college girl or garden party appearance is seen on peripheral blood smear or in the bone marrow biopsy, has to be a feature of CML. What is CML? Chronic myeloid leukemia. And when I talk about CML or chronic myeloid leukemia, what is the translocation? We know CML mein there is a translocation of chromosome number 922, called as which chromosome? Philadelphia chromosome. And the gene translocated are going to be BCR-ABL1. So BCR-ABL1 gene translocation is seen. Investigation of choice, I told you it is FISH plus PCR to be done beta. And a keyword of the question is going to be massive splenomegaly beta. A massive splenomegaly. Massive splenomegaly is seen in three conditions. One is CML, second Gaucher's disease, and third is Kala-Azar. So Gaucher's, Kala-Azar and CML are the three conditions where there is a massive splenomegaly to be seen beta. Clear about? If they ask you what is the treatment, the drug of choice. So drug of choice in patients of CML or chronic myeloid leukemia is going to be imatinib mesylate, which is a tyrosine kinase inhibitor. So treatment of choice is also imatinib beta. Clear? Question number 288 beta. They are asking you, a female who is a known diabetic beta presents to you with complaints like tingling sensation in the hands and the feet, along with generalized weakness, and she is having easy fatigability, jaldi thak jati hai patient, pallor and ataxia. The peripheral blood smear has been given. Which among the following nutrient supplementation can help improve the symptoms of the patient? If I talk about the peripheral smear, what is seen? The size of the RBC is large or small? Large. So definitely these are nothing else but macrocytes beta or macrovalocytes. Next important, the number of lobes inside the neutrophils is more or less. So the nucleus definitely is more than 5 lobes. And whenever the nucleus of the neutrophil is more than 5 lobes, that type of neutrophil is called as hyper-segmented neutrophil beta. Hyper-segmented neutrophil is going to be seen. ठीक है, तो macrocytes and hyper-segmented neutrophil has to be a feature on peripheral blood smear for which anemia? Megaloblastic anemia beta. We know megaloblastic anemia is due to deficiency of two vitamins beta. One is vitamin B9, that is folic acid, and second is vitamin B12, that is cobalamin beta. This is a case of B12. Why? We know beta that the symptoms which are given, that is tingling sensation in the hands and feet, or definitely beta, these symptoms are suggestive of peripheral neuropathy, and peripheral neuropathy cannot be seen due to folic acid, it is seen due to vitamin B12 deficiency only beta. That has to be kept in mind. We know homocysteine levels are elevated in which condition? Both the conditions mein homocysteine levels are going to be elevated beta. That is important to remember. ठीक है? Apart from that, what is the main feature to differentiate? MMA, methyl malonic acid. So methyl malonic acid or methyl malonic levels can definitely beta, they can differentiate. They are normal in B9 deficiency and elevated in B12 deficiency. Very good. That is the important difference beta. Either peripheral neuropathy or elevated MMA levels are the features which can differentiate B9 from B12 beta. The patient having tingling sensation and ataxia, these kind of neurological features has to be a case of B12 deficiency. So answer has to be option D, that is vitamin B12 or cobalamin supplements are going to help beta. Hopefully clear. Agar iron deficiency hota, to peripheral blood smear will show small RBCs called as microcytes beta. Vitamin B6 maybe there would have been microcytes or small RBCs beta. That is important. Okay? Why not B9? I have told you that. Clear? Question number 289 beta, it states we are having a HIV positive patient who presents to the OPD with a complaint of recent onset generalized edema, that is anasarca, along with hematuria. Lab work of previous there is a gross proteinuria in the patient beta, and the RBC casts are also seen. So we know RBC casts are nothing else but a case of hematuria in the patient beta. Okay? And proteinuria is the reason for edema. Patient is also having elevated plasma cholesterol levels, which is, so plasma cholesterol levels are elevated, that is hyperlipidemia is there. Which among the following finding will be seen on renal biopsy? मुझे ये बताओ पहले तो, if they say patient is having a gross proteinuria along with the generalized edema along with elevated plasma cholesterol levels, it is nephrotic or nephritic syndrome? It is a case of nephrotic syndrome beta. Hematuria is seen more commonly in nephritic syndrome, but doesn't mean that it is only seen in nephritic syndrome. Few cases of nephrotic syndrome may have a hematuria beta, but more importantly they are saying there is a generalized edema, they are saying there is a massive proteinuria, they are saying there is a hyperlipidemia. So three features are in favor of what? Nephrotic syndrome. So it is a nephrotic syndrome beta. And nephrotic syndrome in adults is going to be mainly FSGS beta. Now they are asking you which variety of FSGS is commonly associated with HIV positive patients. Which variety of FSGS is commonly associated with HIV positive patient? The collapsing variety. So answer has to be option D, that is collapsed glomerulus, which is there beta. I will be able to see on the renal biopsy. Wire loop lesions are seen in lupus nephritis. So SLE patients having lupus nephritis, there will be wire loop lesions. Kimmel-Stein-Wilson nodules are seen in diabetic nephropathy. So whenever there will be diabetic nephropathy, that will show the classical Kimmel-Stein-Wilson nodules beta. And crescents and glomerulus are seen in RPGN, so rapidly progressive glomerulonephritis or crescentic glomerulonephritis mein crescents are seen beta. Hopefully clear. If I talk about this pictures beta, kya dikh raha hai? The first one is what is seen, these are the classical wire loop lesions beta. So these which are there na, they are classically known as the wire loop lesions beta. Here you are able to see again. So classical wire loop lesions are seen in patients of lupus nephritis. Commonest type of lupus nephritis will be type 4, that is a diffuse lupus nephritis. What is this picture? Crescents basically beta. Crescents inside the glomerulus on kidney biopsy is a classical feature of RPGN or crescentic glomerulonephritis. And what are these? A fibrotic nodule called as Kimmel-Stein-Wilson nodules. So fibrotic nodules called as the Kimmel-Stein-Wilson nodules beta seen in diabetic nephropathy. Hopefully clear. Next important if I talk about is question number 290 beta, that states we are having a 2-year-old child beta presented to you with acute onset respiratory distress along with stridor, fever along with chills and drooling of saliva. X-ray of the child has been shown below. What is the next step in management? Small 2-year-old child having respiratory distress along with stridor, fever and drooling of saliva, and X-ray is showing you the classical which sign? So it is a classical case of which condition? Yes, so we are able to see the classical thumb sign beta on the lateral X-ray. So मुझे बताओ definitely what is the classical diagnosis? Acute epiglottitis. And if acute epiglottitis is the cause, what has to be the next step? Acute epiglottitis is a bacterial infection we have discussed beta. So we have to give IV antibiotic, but emergency management has to be yes, intubation or airway management beta. So answer has to be option D, intubation followed by IV ceftriaxone. पहले IV ceftriaxone दोगे क्या? नहीं, पहले airway management करेंगे. Racemic epinephrine nebulization, yes, it will be given beta, but पहले manage the airway of the child as well beta. Fiber optic laryngoscopy, it is usually done just for intubation beta. Question number 291. A 10-year-old boy beta presented to you with complaints of recurrent epistaxis or nosebleeds along with pain and swelling in both the knees as shown below. Coagulogram shows there is a normal bleeding time, prothrombin time, but a prolonged APTT or a prolonged activated partial thromboplastin time. What is the likely cause? Very good. A small child coming to you beta, especially a boy, with complaints of excessive bleeding like epistaxis or pain and swelling in both knees due to bleeding inside the knee joint. I have told you now that hemarthrosis beta. So pain and swelling in both joints is due to bleeding, that is known as hemarthrosis. Patient having petechia or ecchymosis on the skin beta. And important to be remembered is the patient is having normal bleeding time, but the platelets are absolutely normal. Normal prothrombin time, that is clotting factor 7 is absolutely normal. Which Time is prolonged. APTT. APTT is activated partial thromboplastin time. And I hope all of you are quite aware that whenever there is a problem with activated partial thromboplastin time, there is problem with the intrinsic pathway. So clotting factor 12, 11, 9 and 8. So 12, 11, 9 and 8, these are the clotting factors which are having a problem. So what is the likely cause? We know the likely cause is hemophilia, and the most common type of hemophilia, hemophilia A, is due to deficiency of clotting factor 8, and hemophilia type B is due to deficiency of clotting factor 9, and C is due to deficiency of clotting factor 11. So answer has to be option C, deficiency of clotting factor 8 or 9 beta. Von Willebrand factor deficiency hoti, so my patient would have definitely beta a prolonged bleeding time along with prolonged APTT. So bleeding time and APTT both are prolonged beta if it is a case of von Willebrand disease. That is important to be remembered. Next important, immune thrombocytopenic purpura. If it would have been a thrombocytopenia or a platelet deficiency, then only bleeding time would have been prolonged beta. Okay? And if there was a defect in glycoprotein 2b3a receptors, that is a case of which condition? Glanzmann's thrombasthenia beta. Here also platelet defect, so it was going to be only a prolonged bleeding time beta. Clear baat? So that is what is important to be remembered. याद रखना एक बात, all those who are not aware about coagulogram, याद रखना bleeding time is always going to tell you any problem in the platelets. So whenever there is deficiency or a defect in platelet, bleeding time is prolonged. ठीक है? PT or the PT-INR, that is prothrombin time or INR, that will tell you about any problem in the clotting factor number 7. So if there is any problem in the clotting factor 7, prothrombin time is prolonged. And third is APTT or activated partial thromboplastin time. That tells you about any problem in clotting factor number 12, 11, 9 and 8. If there is any problem in these clotting factors number 12, 11, 9 and 8, the patient's APTT will be prolonged. Hopefully that's clear. Question 292 beta, a 40-year-old patient was brought to the emergency after a road traffic accident with a lot of knee swelling and tenderness beta. X-ray has been given below in the patient. What is the appropriate management of the patient? What is the diagnosis beta? Very good. The kneecap or the patella has been fractured. It is a case of patellar fracture. Displaced or undisplaced? The fractured fragment have moved away now from each other. So it is a displaced patellar fracture. अगर undisplaced होता तो क्या करते हैं? Yes. तो अगर undisplaced होता, if it would have been an undisplaced patellar fracture, I would have just given a above knee cast to my patient beta. अगर displaced patellar fracture है, then I have to bring all the fractured fragments together. And whenever I will bring all the fractured fragments together, then I am going to definitely beta do open reduction and bring all the fractured fragments together and fix them together with the help of a tension band wiring. So open reduction, internal fixation with TBW, that is tension band wiring will be done. As it is a case of a displaced fracture beta, my treatment has to be open reduction, internal fixation with tension band wiring. Answer has to be option A beta. Okay? No issues with this. Plating is not done for patellar fracture. Plating is usually done beta for fractures like femoral nailing is more commonly done beta. Plating is more commonly done for the fractures like fibula. Clear? So that is important to be remembered. Nailing is done for fractures like femur beta more commonly. That is important to be remembered. Apply above knee cast. Yes, that would have been done if it was a undisplaced fracture beta. Now, which fractures are treated by tension band wiring? First, patellar fracture. Second, olecranon fracture. So patellar and olecranon fracture, they are treated by tension band wiring beta. Okay, that is important because they are attached with muscles. Important is that. Which are the fractures of necessity? Galeazzi fracture, Monteggia fracture, and all the intra-articular fracture. So Galeazzi, Monteggia, and all intra-articular fractures are fractures of necessity. What do I mean by fractures of necessity? Those fractures which should always be treated by, very good, open reduction and internal fixation. Those fractures which always need an open reduction and internal fixation are called as fractures of necessity. Galeazzi, Monteggia, and all the intra-articular or the joint wala fractures. Question 293. A 60-year-old woman beta comes to you with a history of Colles fracture. How many months ago? 8 months ago. She has attained menopause at the age of 52. So she is in the post-menopausal age group beta. She comes to you with a T-score of -2.5 and on which scan DEXA scan and she is currently asymptomatic beta. ठीक है, her serum calcium and the serum phosphate levels are normal. What is the most appropriate treatment? What is the diagnosis first of all? So we know beta, old female definitely who is in the menopausal age group beta, okay, having a history of Colles fracture beta and a T-score on DEXA scan almost of -2.5 and the serum calcium and phosphate levels are absolutely normal. Has to be a diagnosis of. And this is the important thing to be remembered, that serum calcium, serum phosphate, serum vitamin D, everything is absolutely normal in osteoporosis. Clear about? Rickets mein those can be low, not in osteoporosis. Osteoporosis is not a problem with mineralization. Osteoporosis is a problem with bone mineral density. ठीक है, so it is not a problem that calcium नहीं body में बेटा, it is not मतलब it is not depositing inside the body. That is the problem. Clear about? So osteoporosis is a problem or a decreased bone mineral density beta. We know diagnosis of osteoporosis is done with the help of a scan, DEXA scan, that is a dual energy X-ray absorptiometry scan, and on that if the score is more than -2.5, it is considered as a diagnosis of osteoporosis. So what should be the treatment? Answer has to be option C, that is start alendronate, start beta. Alendronate is nothing else but bisphosphonate beta. That is important to be remembered. That has to be kept in mind. Bisphosphonate. ठीक है, important is C. Two things to be told. First is bisphosphonates are the drug of choice for osteoporosis of any reason beta. One thing to be remembered. And whenever it is a diagnosis of severe osteoporosis मतलब T-score more than -2.5 and a history of Colles fracture, you have to start bisphosphonates. You have to give dronate group of drugs beta. One thing, HRT is only done between 50 to 60 years of age, and again it is not the first line management. It is osteoporosis के लिए it has to be bisphosphonates beta, which is going to be the first line management. Reason is this case will not be treated by a gynac. This case will be treated by an orthopedician. So you have to follow the orthopedics guidelines that have been given. Clear about? Orthopedics वालों के पास जाते हैं fractures, not in cases of gynecology. Clear? That is very common. Only logical reason to answer this question is orthopedics has to be followed, nothing else. Clear? So please remember beta. HRT can be given. I am not saying HRT cannot be given, but only in 50 to 60 years of age, and again not a first line choice, because not orthopedician is not going to start HRT at all. ठीक है? Doesn't matter whatever is the cost. Calcium and vitamin D supplementation, yes it is given, but is it the most appropriate? No. It is an adjuvant treatment that we will give. Repeat DEXA after 3 months. कम हो जाएगा क्या उससे? नहीं होने वाला. तो there is no use. DEXA is already done. And which kind of vertebra will be seen in osteoporosis? Very good. So fish mouth or the cord fish vertebra beta. Fish mouth or the cord fish vertebra are usually seen if the patient is suffering from osteoporosis. And therefore most common bones that are fractured in patients of osteoporosis, answer would be lumbar vertebra. So vertebral fractures or spine fractures are the most common type of fractures beta. Vertebral fractures are the most common type of fractures in patients of osteoporosis. Yes, Colles is common, but more commonly they will have vertebral fractures beta. Clear about? Question number 294 beta, it states we are having a 32-year-old alcoholic male patient beta who was brought to the hospital when he fainted down after an episode of binge drinking beta. The patient has fainted down, ठीक है, after an episode of binge drinking. His friends gave a history of excessive retching episodes or excessive vomiting episodes beta along with chest pain. His vitals are going to be BP is 88 by 60 millimeters of mercury and pulse rate is 125 beats per minute. मतलब patient is hemodynamically unstable beta. They are asking respiratory rate is 28 breaths per minute. Palpation of the chest reveals there is a crepitus beta. What is the most probable diagnosis? Very good, shabash. Answer has to be option D, that is Boerhaave syndrome. Why? So patient is alcoholic beta, having definitely a lot of binge drinking and a retching episode. This would be a common history for both Boerhaave syndrome and Mallory-Weiss. Other features like first one is going to be chest pain, which is not seen in Mallory-Weiss. Patient is hemodynamically unstable, can be seen in both, but palpation of chest causing crepitus is suggestive of subcutaneous emphysema. And subcutaneous emphysema is only a feature of Boerhaave syndrome, which is esophageal tear or perforation. We know Bohrhaft syndrome is nothing else but esophageal perforation. And which triad is seen in Bohrhaft syndrome? Very good. So in patients of Bohrhaft syndrome, beta, we are able to see the classical macular striate, beta. Macular striate is CVS. C for chest pain, B for vomiting, and S for subcutaneous emphysema, beta. We know pneumoperitoneum होता है, pneumomediastinum होता है after perforation. Pneumomediastinum. Pneumoperitoneum is usually seen, beta, in cases of nothing else but hollow viscous perforation. Hollow viscous perforation means when the stomach or the intestine is going to perforate, beta. In those conditions, the patient is actually going to have pneumoperitoneum. Yes, there would be a history of either NSAID or the patient will be a known case of peptic ulcer disease. So either history of NSAID intake or history of peptic ulcer disease will be classical for hollow viscous perforation or pneumoperitoneum, and that will show you a classical features of peritonitis along with the which side? Gas under the diaphragm. So they will show you classical features of peritonitis, beta, that is severe abdominal tenderness, guarding, rigidity, and definitely, beta, the gas under diaphragm. Clear? Next, bleeding varices mein the patient will have a history of CLD. What is CLD? Chronic liver disease or cirrhosis. So either a history of CLD or a history of portal hypertension should be there, beta. And there will be no binge drinking, no vomiting. Without that, the patient has a upper GI bleeding, beta. Malarious tear mein same history, but only patient will have hematemesis. No chest pain, no subcutaneous emphysema, nothing is going to be there. Clear? Question number 295, easy. A person presented to the OPD, beta, with complaints of abdominal pain and a brownish black melanotic spots, beta. Colonoscopy revealed multiple polyps and the biopsy was suggestive of hematomatous origin, beta, which have been given. Which cancer has the strongest association with the disease? तो मुझे बताओ definitely, beta, if they ask you brownish blackish melanotic spots, these brownish blackish melanotic spots which are there, beta, they are called as lentigens or freckles? Lentigens. These brownish blackish melanotic spots are called as lentigens. Lentigens around the oral cavity. And when I see definitely, beta, colonoscopy pe there are multiple jejunal or intestinal polyps. Which kind of polyps? Hematomatous polyps. Which kind of pattern? Arborizing pattern, also called as filigree pattern, beta. So filigree or the arborizing pattern is seen in the polyps, beta. Okay, so filigree or the arborizing pattern is seen on the histopathological examination of this hematomatous polyps. It is a diagnosis of which condition? Peutz-Jeghers syndrome. And we know Peutz-Jeghers syndrome, which gene mutation? STK11, beta. Peutz-Jeghers syndrome is a classical feature due to STK11 gene mutation. Pattern of inheritance? Autosomal dominant, beta. It is going to be autosomal dominant pattern of inheritance. And which is the commonest cancer associated with it? Please remember, strongest association अगर पूछा जाए तो answer would be pancreatic cancer. Strongest association with pancreatic cancer, 100 times higher risk of pancreatic cancer in a patient, beta. That is what is important. Yes, colorectal cancer is going to be common, but it is not having the strongest association. Pancreatic cancer ka risk increases by 100 times higher risk will be there, beta, in a patient of Peutz-Jeghers syndrome. Clear? So that is important. Ovarian cancers are not seen, renal cell cancer is not seen. Clear? Next important question number 296. We are having a 40-year-old alcoholic male patient, beta, who presented to the emergency with complaints of acute abdominal pain. Patient is having an acute abdominal pain, beta, and there is abdominal distension. A fluid-filled lesion is usually present, beta, in the epigastrium of the patient, which among the following parameter is raised. What is the diagnosis? Alcoholic patient presenting to you with acute abdominal pain and distension, beta. If they ask you what is the feature, there is a collection of fluid inside the epigastric region. That collection of fluid in the epigastric region is due to pseudocyst. So pancreatic pseudocyst has developed, and that pancreatic pseudocyst has developed due to acute pancreatitis. So patient may have had pancreatitis, beta, and due to that definitely the patient will develop a pseudocyst. So the diagnosis of the case is more likely a pseudocyst. We know pseudocyst develops in the epigastric region. Yes, it is going to be a fluid-filled lesion, beta. What is going to be the answer? आंसर हैज टू बी ऑप्शन बी बेटा, दैट इज नथिंग एज बट लाइपेज। जीजीटी किस हिसाब से बता रहे थे तुम लोग? अगर लिवर डिसीज होता देन आई वुड हैव थॉट अबाउट जीजीटी और गामा ग्लूटामेट ट्रांसपेप्टिडेज बेटा, बट इट इज द केस ऑफ पैनक्रियाटाइटिस, सो इट हैज टू बी सीरम लाइपेज और सीरम अमाइलेज बेटा। क्लियर है बात? क्वेश्चन नंबर 297, a postpartum female beta presented to the OPD with complaints of pain, fullness and swelling in the breast. She gives history that the child refuses the feed beta but does not give a history of fever. ठीक है, what is the best treatment option in this patient? What is the likely diagnosis? Diagnosis क्या? engorgement या abscess? Why? I know that definitely the fever is not there, which is a very common feature, but can be seen at times, and that is a case of breast abscess. Swelling is not seen in cases of engorgement beta. Pain and fullness is fine. Swelling क्यों होगा basically? A localized swelling, why it will develop in breast engorgement? Yes, there can be fullness, there can be heaviness, there can be pain. These are the accepted features in engorgement. But definitely swelling is not a feature which is usually seen in patients of breast engorgement beta, and that's the reason. Best treatment पूछा first time, best treatment है तो option D, that is incision and drainage along with antibiotics beta. First line पूछा होता तो an ultrasound guided aspiration beta. Yes, commonly it should be fever beta which should be present, but even if times अगर fever नहीं, but if they say swelling, redness over the breast beta, then that would be going into a case of abscess beta. ठीक है, so that is important. Reason is कभी कभी हमें पता है fluctuant swelling which is there beta, it is an early sign or late sign. Late sign, तो till the time she has developed the swelling beta, उसको पहले हो चुका होगा fever. The time she comes to you, वो बोल भी चुकी कि fever था. ठीक है, so she is not giving a proper history. That is the reason definitely beta. A lot of times this happens. ठीक है, the antibiotics and analgesics would have been given if it was a case of mastitis beta. ठीक है, an expression of milk with warm moist compresses will be done if it was a case of breast engorgement which in cases of engorgement beta, the patient will have only fullness or heaviness in the breast with pain, that's it. ठीक है, patient will have no other signs. There will be no fever, there will be no fluctuant swelling, there is not going to be any kind of ultrasound showing fluid collection, there will be no such signs like redness or warmth over the site. Clear? So swelling which is there basically, a localized swelling is more classical of a abscess than a case of engorgement beta. Clear? Question number 298. An intern was asked beta to deliver the placenta, for which he gave a sudden traction. Normally we know beta placental delivery should be done by this method called as controlled cord traction, known as Brandt and Andrews method. So this is the Brandt and the Andrews method beta, called as the controlled cord traction, that has to be used for delivering the placenta. But बच्चे ने क्या कर दिया? So definitely beta he gave a sudden traction, and if you give sudden traction तो क्या हो जाता है? Either the uterus gets outside, that is uterine inversion, or the umbilical cord is going to break. So here the umbilical cord has broken beta, leading to excessive vaginal bleeding. Which among the following is the most appropriate step? The answer has to be nothing else but option D, recent NEET PG PYQ, manual removal of placenta. I have told you two conditions जहाँ पे you have to do a manual removal of placenta. One, if the umbilical cord breaks, and second, if it is a case of retained placenta. In both these conditions, the management is manual removal of placenta under general anesthesia beta. We know arranging blood is fine. Are you going to perform a Creed's method? What is Creed's method? Uterine squeezing. Do you do uterine squeezing nowadays? No. If you try to do uterine squeezing, the placenta will not get completely separated, causing retained bits of placenta, leading to a secondary PPH. Clear? But that is important. The Creed's method is obsolete nowadays, not done at all. Uterine massage, yes, uterine massage will be done, but is it the most appropriate step or what in this condition? It is not the most appropriate step beta. IV oxytocin, yes, it is given, but again it is not the most appropriate step. The most appropriate step has to be option D, manual removal of placenta beta. Now, नेक्स्ट भी पूछते बेटा तो भी आंसर ऑप्शन जितने भी अवेलेबल डेफिनेटली उसमें भी मैनुअल रिमूवल ऑफ प्लेसेंटा आई वुड हैव डन अर्लियर. Question number 299 definitely. Here they are saying beta a 37-year-old male complains of episodes of ringing sensation in the ear beta along with vertigo, nausea and hearing loss. Patient avoids going to noisy areas as he experiences vertigo in noisy areas called as Tullio's phenomena. Right? Experiences vertigo in noisy areas is classically called as the Tullio's phenomena beta. So patient is having a classical triad. What is the triad? Ringing sensation in ear called as tinnitus, vertigo along with nausea and vomiting, and hearing loss. It is a classical triad of Meniere's disease. And Meniere's disease means the patient will have Tullio's phenomena during an episode beta. Okay? There are also other phenomena like the recruitment phenomena or diplocusis beta. What is the best investigation to confirm the diagnosis of Meniere's disease? Meniere's disease may we know beta there is an increased endolymphatic pressure which is going to cause a cochlear damage beta, and due to cochlear damage patient will have a sensory neural hearing loss. So investigation of choice for Meniere's disease is option D, that is the electrocochleography. So electrocochleography is the investigation of choice for a case of Meniere's disease which can confirm the diagnosis. Glycerol test is done along with electrocochleography. It is not the best test to confirm the diagnosis. Impedance audiometry which is there, it will show you the curves beta. Curves का क्या ही करोगे? Meniere's में कोई अलग टाइप का curve नहीं दिखता है. क्लियर? जल्दी से बता दो. AS curve, autosclerosis beta. AD curve, ossicular dislocation beta. Type B curve, glue ear and tympanic membrane perforation beta. And type C curve, stitch tube blockage beta. Clear about? CCT scan is of no use in Meniere's disease. Question number 300, last one. A patient comes to you beta with complaints of decreased visual acuity and the patient is having dryness of the eyes. He was diagnosed as a case of chlamydial follicular conjunctivitis. What is chlamydial follicular conjunctivitis? Trachoma. That is important. In a previous year question definitely they gave this same option. The option में था. So please remember bhai, trachoma is caused by a bacteria called as Chlamydia trachomatis. So can be called as chlamydial conjunctivitis. Most characteristic feature of trachoma will be follicles. So can be called as follicular conjunctivitis. Sanjay Bal, so that is what is important. In patients of trachoma beta, follicles are the most important feature. The follicles on upper limbus are called as the Herbert pits beta. On the upper limbus they are called as Herbert pits, and on upper palpebral conjunctiva are called as Sago-grain beta. On the upper palpebral conjunctiva will be called as the Sago-grain. Single most characteristic feature, Herbert pits. Herbert pits are the single most characteristic feature of trachoma beta. That is important. Okay? That is going to be seen in this patient. Apart from that beta, these are the Sago-grain follicles, the whitish follicles which are seen beta. Apart from that, which line is seen? Whenever these Sago-grain follicles will definitely undergo fibrosis beta, that leads to this fibrotic or the scarred line beta, and this fibrotic or the scarred line is classically called as Art's line bache. That is important to be remembered. We know it is a case of follicular conjunctivitis or trachoma beta. They are asking you which among the following is incorrect about the management of trachoma. Trachoma के management के लिए which strategy is used? Safe strategy is used beta. Okay, we know if I talk about safe strategy, S stands for surgery for trichiasis. Is it true? Yes. A stands for antibiotics, where the drug of choice will be. So the drug of choice is azithromycin for treatment beta, not penicillins. Okay. So even for prophylaxis, the drug of choice will be tetracycline beta and not penicillin. So neither penicillins are used for treatment nor they are used for prophylaxis beta. It is azithromycin for treatment and tetracycline for prevention beta. That is important to remember. This is a wrong statement. F stands for facial cleanliness and E stands for environmental change or sanitation beta. The answer has to be option D for this question. If they say beta patient is actually having a history of some mechanical trauma like a contact lens, okay, very good. तो अगर patient में definitely contact lens है and then they say patient is having papillae beta, that is a classical feature of GPC. What is GPC? Giant papillary conjunctivitis, where the papillae are more than 1 millimeter. If they say patient is a young boy beta and that young boy having definitely a lot of pruritus or a lot of itching in the eyes beta. Usually in which season? Summer season beta. It is a classical case of VKC. Here also papillae are seen beta called as the, so the small papillae less than 1 millimeter in size beta, those are known as cobblestone papillae. What is the drug of choice for VKC? Olopatadine beta. So olopatadine is considered as the drug of choice for